Hey guys, what's up? This is Stephanie. Welcome back to my channel. So in the video today, I'm going to be doing an emergency medicine end of rotation exam review. And for those of you who are not familiar with me or my YouTube channel, I have other EOR videos for your other topics, for your other blueprint topics. So I have an EOR video for internal medicine, OBGYN, pediatrics, etc. So you can actually go to my playlist list, and that's where I have all the other YouTube videos. So hopefully these videos are helpful for you guys. Just real quick, a little bit about me. I am currently, you would say, like a third year PA student. So I've already completed my second year of clinical rotations. I've completed all of my end of rotation exams. I've taken all of them. And I'm currently in my capstone. So capstone, not all PA schools have capstones. My PA program does. That's why it's 2.5 years. Basically, you rotate 3 months, 3 to 4 months in a rotation where you want to specialize in. So I'm currently rotating in the burn unit. So it's a very, very interesting rotation. And like I said, I've completed all my end of rotation exams. So hopefully this video is helpful for you guys. Basically, in this video, I'll be going over tips, anything high yield that I remember when I was studying. Also, any questions that I saw that kept repeating, or topics that kept being repeated when I was studying, or when I was taking practice questions, or when I even took the end of rotation exam. So hopefully this video is helpful for you guys. I decided to make these videos because I'm currently studying for my PANCE. I'll be taking that in December, so pretty soon. And I want to make sure that I'm studying. And also I made this video because when I was studying for the end of rotation exam, I didn't know what to use or how to study, so I used YouTube a lot, and I saw that there was a lot of medical students that did like their shelf exams for shelf reviews, and I saw there wasn't any for PA students or PA schools. This is why I decided to do this video. So hopefully it is helpful. Also, I have added the timestamps in the bottom, so if you want to skip to a specific topic on the blueprint, you can do so below. So just make sure that you check the description box. So before I start, I always like to get into what my study habits were, because like I said, when I was studying for the EORs, I didn't know how to study. So hopefully if you use the study schedule, you don't have to use my study schedule. You're more than welcome to. It is helpful, and hopefully you can use it if you think it's helpful for you. So first off, my rotations are about 5 weeks for each rotation. Now, I know rotation length tends to depend on the PA program you're attending. During my psych rotation, I rotated with a student from another university, another PA program, and her rotations were 6 weeks when mine were 5 weeks. And so it just depends on how long your rotation is, but you're more than welcome to use it. So what I did is that the first 3 weeks, I studied the information. So I made sure that I knew the information. I went through every topic on the blueprint list. So once again, the blueprint list, you get that off of nccpa.org. And then once you go to the nccpa.org, you'll see the blueprint, and they have a blueprint for every end of rotation exam, and it gives you topics and it tells you what to expect for the exam. Sometimes the topics are specific, like you'll get something like cholelithiasis. Sometimes they're very broad, like acute abdomen, and this is where you really have to add more things to that topic. So you have the blueprint. What I did is I studied the topic for the blueprint topics for the first 3 weeks, and then the last 2 weeks, what I did is that I did a bunch of practice questions. I did a bunch of practice questions. I used Rosh review. So Rosh reviews are great questions. They're very similar to what you're going to see on your end of rotation exam. So I really recommend Rosh review. So I did their questions. My program has Exam Master, so I made sure that I took advantage of Exam Master, which are a lot of practice questions also. And then another thing that I used was Smarty Pants. So Smarty Pants has also your EOR exams, and so I always make sure that I did their questions, and then on top of that I did their EOR exams, which are just questions made specific for the EOR. And that's what I used for the questions last 2 weeks. And this helped me because you would see that topics repeated over and over again. And this repetition helped me a lot because you'll see, once again, the topic that is repeated over and over again, whether it's cholecystitis, cholelithiasis, and then it's asked in a different way, and you're seeing patterns. So whenever you see you're taking the exam, I was taking it, I was like, oh my gosh, I already took this question, or I remember taking a practice question similar to this, because they're asking the same topics over and over again, even though it might be in a different form. So I really recommend questions. And then what helped me is that those last 2 weeks, if I did questions and I saw that I was missing questions, for example, for OBGYN, I kept missing OBGYN questions and I knew that I needed to go back and focus, and then I would go back and focus on whatever were my weaknesses. Okay. In the first 3 weeks, what I use is that I use the PA rotation exam review book, which I will be adding the link below. I really recommend that book. It basically has everything set out for you for what you need to study. Sometimes though, I'll be honest, it may be a little bit overwhelming, but it's better to overstudy than understudy. So I use that, and then on top of that, I supplemented it with, of course, PANS Prep Pearls. So I really recommend PANS Prep Pearls also, and that is what I studied. And then on top of that, I also used osmosis. I'm a visual person. If you're a visual person, I really, really recommend osmosis. It's a subscription that you can purchase. I purchased it during my didactic year, and so I bought it for 2 years. I still have it, and I'll add the link below. They have a lot of videos over diseases, even anatomy, physiology. Sometimes I needed to go up and brush up on the anatomy and physiology if it had been a while since I had gone over it, especially cardio, since cardio is a huge percent of your PANS. I need to go back also and make sure that I was fresh on the physiology and anatomy of how the heart works. So I used osmosis for that. And then another thing that I recommend is flashcards. I can't recommend flashcards enough. Flashcards are amazing. Repetition is a key. Like I said, repetition, repetition, repetition. And so what I did is that on day 1, I started doing flashcards. I used osmosis flashcards. So osmosis has already pre-made flashcards. And so what I did is that I would go through osmosis, and then I would add the flashcards that were on the blueprint. So for example, if cholecystitis was on there, I would go and add cholecystitis to my deck on osmosis. And so I would do that. To be honest with you, like on the first day, I probably had like 5,000 flashcards I needed to go through. But think about this, you're going to go through all those 5,000 flashcards from day 1 to day 30. So it's very, very doable. If you do at least 100 flashcards a day, even less, you should be good by the time you get to day 30. Well, maybe you probably need to do a little bit more than 100, right? So I did that. Day 1, I would go through flashcards, and the good thing is that they repeat every day, and it sees what your weaknesses are, and it'll repeat those flashcards that you kept missing over and over again. So by the time you get to day 30, I've already done all the flashcards, and I've repeated the information that I am dusty on or not very strong on. So that's how I study. Okay, guys. So further ado, let's get into the topics, okay? So once again, cardiovascular is going to be your 20% of this, and then the next one's going to be your orthopedics. So why don't we go into orthopedics, 15%, then I'll go back to your cardiology. So orthopedics, rheumatology. So bursitis, so known as a bursa, this is where you have the bursa fluid-filled sacs near the joints. So the purpose of the bursa is to prevent friction on a tendons, right? So the tendons can slide. It acts as a cushion, and then bursitis is just inflammation of this bursa. So it's inflammation of the bursal sac of a joint. The most common location is going to be in the shoulder. You can also see it in the elbow and hip, and it's usually due to repetitive motion. So if you're using that area over and over again, if you're doing overhead lifting, leaning on your elbows also, okay, extensive kneeling, and sometimes it can be autoimmune. How is this patient going to present? So they're going to be presenting with a pain, achy, or stiff joint, tender to palpation. It's going to be inflamed, so you'll see edema and erythema also, and the patient will have decreased range of motion. How are you going to diagnose this? It's usually a clinical diagnosis, okay? If you think that it's septic, okay, or has some type of bacterial component to it, then you can go and do a fluid aspiration, but it's usually a clinical diagnosis. Treatment is going to be RICE, right? It's going to be your rest, your ice, compression, elevation. You can also do kneeling pads if it's in the knees. Weight loss for patients that are overweight, tell them to exercise. Physical therapy, you can also do NSAIDs, steroid injections if it's not something that's infectious. And then surgery is going to be your last line. Okay, surgery is going to be your last line. You're going to do a bursectomy. Okay, And also if it's recurring, then you want to think about bursectomy. The thing about your end of rotation exam, guys, is that the first line treatment is always going to be something that's conservative. So you don't want to jump into medications first. So if it's something, for example, for hypertension, the first line usually for that is to put them on the DASH diet. Tell them to exercise, to stop smoking if they smoke, to lose weight if they're overweight. So it's always going to be your non-pharmacological treatment. Say that they've done that, then the second line would be your pharmacological treatment. Your pharmacological treatment is not working, then you jump into surgery. Obviously not surgery for hypertension. But for example, like bursitis, it's going to be your rest, ice, compression, elevation, kneeling pads. And then if they're not, of course, responding to that, then you can do something like a steroid injection, and then bursectomy is going to be your last line. And this is if this patient has tried everything and it keeps recurring, then you want to think about bursectomy. So next one's going to be tendinitis. This is going to be an inflammation of the tendon. It's most common in the shoulder, and the patient usually, if they do have it in the shoulder, they're going to be complaining. It's going to be a diagnosis of rotator cuff tendinitis. It can also happen in the elbow, and this is also known as your tennis elbow or your golfer's elbow. It can happen in the ankle, so this is going to be your Achilles tendinitis. So it just depends where it's located. How's this patient going to present, or what is the cause of this? Usually it's going to be an injury, repeated activity. So patients that are presenting with your tennis elbow, right? They're constantly doing this, or your golfers, okay? I had a patient that came in, I remember during my family medicine rotation, he would help his neighbor repeatedly remove things, and so he came in and he was having that pain over the forearm right here. Okay, so for example, for him, we ended up diagnosing him with your tennis elbow. So these patients don't have to specifically be doing something that like a tennis. They can be doing anything, but they'll be presenting with pain over a certain area of your forearm, which will lead you towards a diagnosis of tennis elbow, which I'll go into more detail in a few minutes. So another thing, once again, so some of the causes of this, also manual labor jobs, okay? Musicians are more prone to getting tendinitis if the patient is an athlete, if they're older, and also which type of antibiotic is associated with your Achilles tendinitis or Achilles tendon rupture. It's going to be your fluoroquinolones. So fluoroquinolones are very, very highly associated with your risk of tendon rupture. How's this patient going to present? They're going to be presenting with pain that's worse with movement. It's going to be tender to palpation. It's going to be a stiff joint, edema, and then erythema also. Diagnosis is usually going to be a clinical diagnosis. You can do an ultrasound or an MRI, but we usually don't do that because it's expensive. For example, like this gentleman that we came in that we diagnosed with, they had tennis elbow. We're not going to go and send him for an MRI. So usually we don't do that unless if it's been going on for a long time or we suspect some type of tear is going on. Treatment for this is going to be your RICE, so rest, ice, compression, elevation, NSAIDs, also physical therapy, splinting, and steroid injections. So usually treatment for this is something that is not very invasive. So in regards to costochondritis, that's going to be our next topic. This is going to be an inflammation of the cartilage connecting ribs to the sternum, usually at the costosternal joint. The most common cause is going to be a blow injury, heavy lifting, or pushing. Also, patients that have fibromyalgia usually will complain of costochondritis, or patients that have osteoarthritis or rheumatoid arthritis. Patients are going to be complaining of pain that's worse with movement, tender to palpation, joint stiffness, edema, and erythema. Sometimes they'll be saying that they have like chest pain, and then usually when we go and we palpate, it's tender, and that's how usually you can differentiate that between a myocardial infarction. And I've had some questions on this, so just make sure that you know this. I had a question asking me, how can I rule out that this is costochondritis and not myocardial infarction? And it's going to be that it's tender to palpation. Okay. They can also be complaining for these patients of sharp chest pain. Like I said, it's going to be tender to palpation. It's going to be worse whenever they cough, whenever they sneeze, the pain, and then whenever they breathe in deeply. We're going to diagnose this patient since they present similar to a myocardial infarction. We're going to do something like an EKG, we want to make sure that we get our cardiac enzymes, right, or troponins to rule out myocardial infarction. And treatment for this is usually going to be with your NSAIDs, muscle relaxer, your tricyclic antidepressants, rest, moistening heat, and pad and ice. Okay. Next one is going to be our shoulder fractures. Okay, shoulder fractures. So the most common cause of shoulder fractures is going to be your Fuchs injury, right? So falling on the outstretched hand, and it's very commonly found also in older adults. How is the patient going to present? So they're going to be presenting by holding their arm close to their body. They're going to have decreased range of motion due to pain. It's going to be tender to palpation in the shoulder area. You might see some ecchymosis, some deformity, some crepitus, and you always want to make sure that you're checking neurovascular status on these patients, okay? How are we going to diagnose a shoulder fracture? We're basically going to do a shoulder x-ray, and then we're going to treat it with immobilization with a sling. Sometimes we can refer them to physical therapy also. If it's displaced though, or if it's comminuted, then that's when we would go and consult ortho or surgical repair. So next topic is going to be shoulder dislocation. So shoulder dislocation is where the shoulder, basically the shoulder joint is less stable than the hip. So this allows greater movement and action. So the most common type of shoulder dislocation is going to be your anterior shoulder dislocation. What is the mechanism of injury for your shoulder dislocation? These patients are going to be falling on an outstretched and abducted arm. And then we have our posterior. This one is not as common as your anterior dislocation. For your posterior, this one is usually due to falls from height, seizures, or electric shocks. So I've had questions on this where the patient presents with either an anterior posterior, which we're going to discuss on how you need to know what's the difference between both of them and how they're going to present. And then if it's a posterior one, it'll ask you what is a common cause that this patient had or what may have happened, and you want to know that's associated with your posterior dislocation. Since it's not very common, it's if the patient fell from a height or if they've had a seizure. Okay, so how is this patient going to present? So if it's an anterior dislocation, they're going to have pain or apprehension with unstable shoulder that is abducted. So it's going to be abducted and externally rotated. So abducted and externally rotated. That's how it's going to present if it's an anterior dislocation. And you're going to see also obvious deformity. For your posterior, the patient's going to hold the arm in an internally rotated position, okay? And this is usually less obvious, and this patient's usually going to have difficulty pushing open a door. So once again, the most common type is going to be anterior, okay? It's usually when the patient falls on an outstretched and abducted arm. The posterior is less common. When you think about a posterior, you want to think about seizures, electrical shock, if the patient fell from a high height. And how is the patient going to present? If it's anterior, it's going to be abducted and externally rotated. So abducted and externally rotated. If it is posterior, then it's going to be internally rotated. The test that you can do for these patients is that you can do an apprehension test. This is usually going to be positive, and then a load and shift test. This is going to be positive, and then an O'Brien test. These are going to be positive also. Diagnosis, we're going to do an x-ray for these patients. You're going to see Hill-Sachs lesions associated with anterior shoulder dislocations. You can do an MRI also, usually though it's not really needed. So in MRI, you'll see labral tears or ligament structures. And then you can do a CT, and then you'll see bone loss. But usually your first line is going to be your x-ray. Treatment is that we want to make sure that we reduce this as soon as possible. We can do the Stinson procedure, and then sling immobilization for about 2 to 4 weeks. We want to make sure that these patients are going to physical therapy and telling them to avoid any type of risky sports. Okay, so let's go into supracondylar fracture. This is the most common elbow fracture in children, most commonly found in children between the ages of 3 to 6. It occurs after falling on an outstretched hand. Signs and symptoms, you'll see some elbow deformity, pain, decreased mobility, arm swelling, also the OK sign. And then your diagnostic test for these patients, it's going to be a lateral x-ray. You're going to see a posterior fat pad sign or the cell sign. Okay, so you'll have the elbow on your x-ray, and you're going to see a posterior fat pad sign or the cell sign. And then treatment for this, it usually tends to have high morbidity because it's proximal to the brachial artery and median nerve. So that's why with these patients, they have to have a mandatory orthopedic consultation, and these should not be reduced by ER physicians. Open reduction is usually required for these patients. Usually they have to pin them, and then if it's any type of displaced fracture, we want to make sure that we admit these patients. Some of the complications of a supracondylar fracture is going to be absence of distal pulse, such as a brachial artery injury. And then we have radial head fracture. This is the most common elbow fracture in adults. Usually the cause is falling on an outstretched hand. Usually the patient's going to be complaining of localized swelling, tender to palpation, and decreased range of motion. There's going to be pain to the lateral elbow, and the patient's going to be unable to fully extend their elbow. We can diagnose this by also doing a lateral x-ray, and we're also going to see posterior fat pad sign or the cell sign. And then treatment for these patients is that if it's non-displaced, it's just going to be supported with immobilization and early range of motion exercise. So the next one is going to be your Coles fracture. This is going to be a distal radius fracture. The most common cause of this is also going to be a Fuchs injury. So you're falling on an outstretched hand injury. Patient's going to be complaining of pain, swelling, tender to palpation at the distal forearm. They'll have some palmar paresthesias, usually if the median nerve is involved, and it's going to be a dinner fork deformity. So they're going to have dorsal displacement. So how I memorize this is that for your Coles fracture, call you for dinner. So that's how I memorize it. Call you for dinner. Coles fracture, you're going to see a dinner fork deformity, and it's going to be your dorsal displacement. This is how you're going to differentiate it from a Smith's fracture. Okay, so once again, call you for dinner, dinner fork deformity, dorsal displacement for your Coles fracture. It's going to be your distal radius fracture. Diagnosis for this, we're going to do an x-ray. And we want to make sure we're also performing weekly x-rays because the fracture is at greatest risk of displacement during the first 3 weeks. So make sure that you know this. This is something that's very, very highly tested. So with Coles fracture, we're doing weekly x-rays because fracture is at greatest risk of displacement during the first 3 weeks. Treatment for this is that if it's impacted or if it's minimally displaced, this can actually be treated by a primary care physician. We can just immobilize them, do a vulvar or sugar tongue splint. Okay, we can also put a brace or cast. Sometimes they do need to be referred by ortho. Complications of this is median nerve compression, and they can also have extensor paucis longus tendon rupture damage. So the next fracture is going to be your Smith's fracture. This is going to be the reverse Coles fracture. And with these patients, they have ventral angulation of the distal radius. So remember we said for our Coles fracture, it's going to be a dorsal displacement. And then we said it's going to be a dinner fork deformity, call you for dinner. Right? Smith's fracture, it's going to be the reverse of that. And it's going to be ventral angulation of the distal radius. Usually, some of the causes of this is that the patient will fall or have a direct blow on the dorsum of the hand or the wrist. And this patient's going to be presenting with a garden spade deformity, okay, displaced palmar. And on the x-ray, we're going to see basically a volar angulated and displaced. That's how it's going to look. And it's going to have that garden spade deformity. Treatment for this is going to be similar treatment to Coles fracture. So if needed, we can also reduce it. And the complication is going to be the same thing for these patients, which is going to be median nerve compression. So once again, Coles fracture is going to be a distal radius fracture. They're going to have the dinner fork deformity, call you for dinner, right? Dorsal displacement. Smith's fracture, it's going to be the reverse Coles fracture. It's going to be ventral angulation of the distal radius, and they're going to have that garden spade deformity. So next one's going to be scaphoid fracture. This is very, very highly tested, so make sure that you're familiar with this one. This is the most common carpal bone fracture. Some of the causes of a scaphoid fracture is that the patient will fall. They'll have forceful hyperextension of the wrist. Okay, usually falling on an outstretched hand with wrist dorsiflex and radially deviated can cause this. And this patient is going to be presenting with snuff box tenderness. They're going to have painful wrists, swelling, paresthesias, ecchymosis, limited range of motion. They'll have pain with radial deviation and axial compression. And we want to make sure that we do an x-ray on these patients. Okay, we're going to look at the scaphoid bones. And then if the treatment for these is If it's non-displaced, we want to make sure that we immobilize it, so we can do a thumb spica splint or a cast. And then if it's displaced for these patients, we can do open reduction and internal fixation. So next one's going to be your metacarpal neck fracture, also known as your boxer's fracture. This is most commonly found in the little finger, but it can happen in any finger. It's usually caused by a direct blow. Usually a patient will like hit an object with their closed fist, like they hit another person or they hit the wall because they were mad. So it's very commonly found in men for metacarpal neck fractures. The patient's going to be presenting with knuckle tenderness, swelling, decreased grip strength, decreased range of motion, bruising, and abrasion. Diagnosis, we want to do an x-ray. Usually we want to get 3 views. And treatment for this is usually your RICE, right? Rest, ice, compression, elevation. We can also give him some NSAIDs. We can brace it. But if it's non-displaced, then this patient needs splinting. And if it's displaced, then surgical fixation. So next one's going to be your mallet finger. So mallet finger, this is the one that's commonly found in your basketball players, right? This involves the extensor digitorum tendon avulsion fracture or rupture. So it's over the DIP joint. Like I said, it's most common in ball handling sports like baseball, football, volleyball, basketball. You have forced flexion against an extended finger. Okay, so forced flexion against an extended finger. And the patient's going to be complaining of the distal interphalangeal joint. So the DIP flexion contracture, they're going to be unable to extend the distal phalanx. And they're going to have pain and they won't be unable to straighten that distal finger. We're going to diagnose these patients with an x-ray. Treatment, we want to make sure that we refer these patients to orthopedics. We do an extension splint for these patients, 4 weeks, and then 6 to 8 weeks if there's tendon rupture that we see. Usually some of these patients may or may not require surgery, so it just depends. But that's going to be your mallet finger, so it'll be like this usually. Now, next one, we're going to have the Corbin tenosynovitis. This is thickening of the abductor pollicis longus and the extensor pollicis brevis due to myxoid degeneration. Most commonly found in women between the ages of 30 to 50 years old. Usually if the woman is postpartum, if they're new mommies, daycare workers, if they especially are frequently lifting babies, or if they're just like overusing it. Usually the patient's going to be complaining of radial wrist pain, pain that's worse with thumb or wrist movement. You're going to have a positive Finkelstein test. So basically the patient will have pain with thumb flexion and ulnar deviation. And diagnosis for this is usually clinical diagnosis for these patients. And treatment for this is going to be a thumb spica splint. Usually they have it on for 6 weeks. We can also give them NSAIDs, so we can do some glucocorticoid injection if needed. But most of these tend to go away within 1 year. So about 90% resolve within a year. If it's severe, then we can do basically a surgical release. Okay. So once again, the Corbin tenosynovitis, this is very highly tested. Usually on your question stem, it'll be a female that's coming in and they're having like this thumb pain and wrist movement with thumb pain with wrist movement. And you're going to do your Finkelstein test. Okay. And usually it's going to be positive for these patients. And it's very, very painful for your Finkelstein test for these patients. So next topic we're going to go over, next one is going to be your sciatica. This is neuralgia following sciatic nerve along its distribution path. Some of the most common causes of sciatica is going to be your spinal disc herniation, right? Some of their causes can be spinal stenosis, pregnancy, nerve tumors, something that is growing is just impeding that sciatic nerve. Infection, if it's present in a younger individual. This patient is going to be presenting with sudden shooting pain from the low back down to the leg to the back of the knee and distally. They might be presenting with numbness, muscle weakness, and then also a burning sensation for these patients. Diagnosis, we're going to do an X-ray, we can do an MRI, and usually these patients are going to have the positive straight leg test. So this is when they're laying down and we raise their leg, that's going to be positive, and they're going to have that shooting pain in their lower extremity. So they're going to have a shooting pain that goes towards their lower extremity. Treatment for this is going to be with NSAIDs, muscle relaxers. They may or may not need spinal disc report depending on how severe it is. But usually with these patients, we recommend them to just go with their normal activity. Spinal stenosis is going to be the next topic. This is going to be a narrowing of the spinal canal due to osteoarthritis of the lumbar spine or large disc herniation. It occurs most commonly in older patients. With this one, with spinal stenosis, you're going to think about a patient that has pain that's worse with back extension and it's relieved by sitting. So once again, it's going to be pain that's worse with back extension and it's going to be relieved by sitting. They also are going to be complaining of neurological claudication symptoms whenever they're walking, and that's because you're compressing on the spinal artery, right? Usually treatment for this is going to be conservative. We can do physical therapy, corticosteroid injections also, and then we can refer these patients to ortho if, for example, they have radicular or claudication symptoms that have been going on for more than 12 weeks. And then in these patients, we want to make sure that we do an MRI and CT to confirm that the patient does have spinal stenosis. And then last resort is going to be surgery. We'll go in there and we'll do spinal decompression. Okay, so it's going to be spinal stenosis. Once again, don't confuse this with ankylosing spondylitis, which I will go over. So spinal stenosis is commonly found in older people. Like I said, they're going to have pain that's worse with back extension, and it's going to be better by sitting. What happens is that these patients have a narrowing of the spinal canal, okay? And usually with these patients, treatment's usually going to be conservative. Like I said, it's going to be found in older patients versus ankylosing spondylitis. You're going to expect a younger individual. Usually it's going to be a male. They'll have HLA-B27 that's going to be positive, and then usually they're going to have other type of things going on also with them, like they can have uveitis, etc. So once again, spinal stenosis, it's going to be an older patient. Next one we're going to go is going to be your lumbar disc herniation. This is a compression of the sciatic nerve that causes radicular pain. Usually the L5 to S1 disc is affected. Make sure that you know this. This is very highly tested. So lumbar disc herniation, the L5 to S1 the discs are more commonly affected. So your lumbar 5, sacral 1. Okay. What is some of the causes of this? Usually bending or heavy loading with back inflection. And then also degenerative disc disease in patients that are between the ages of 30 to 50. This patient is going to be presenting with back pain, pain with back flexion or prolonged sitting. They can also have radicular pain into the leg. They can have lower extremity numbness and weakness. And then they can have this electric shock like pain that radiates down the back of their leg to below their knee. And it's worse with back flexion, like if they're sitting or driving. And then if it's significant disc herniation where it's severely impeding that nerve, the patient can be presenting with numbness, weakness, or have plantar flexion of the foot if it involves the L5 and S1. But if it involves the L4 and L5, then the patient can have dorsiflexion of the toes. So it'll be affecting this, the dorsiflexion of the toes. But like we said, what was the most common one? L5 to S1. So usually the plantar flexion of the foot will be weak for these patients. My dad actually had this. He had that shooting pain that goes down his extremity, and we didn't know what it was. This was me before going to PA school. He went to a chiropractor. They did all these like back things, and he wasn't getting better until finally he decided to go see my primary care physician, and then she referred him. They got an MRI, and then he went into surgery. But it's very, very, very painful, like I said, and usually it's due to compression of the nerve, usually by a disc that's just compressing on that nerve. And then the thing we want to worry about this is that cauda equina syndrome, this is a surgical emergency. With cauda equina syndrome, this is severe compression where the patient is having this perianal numbness, bowel, and bladder incontinence. So sometimes these patients won't even be able to feel the toilet paper. So whenever they wipe, they won't feel the toilet paper. And they'll be saying that they've been progressively having trouble urinating or incontinence. So that's when we want to think about cauda equina syndrome. They'll have, like I said, the perianal numbness, bowel, bladder incontinence, and this is severe compression. This is an emergency. Like they need to get surgery ASAP for these patients. So going back into lumbar disc herniation, diagnosis for this is going to be, we can start with an x-ray, but the best way to assess how severe the herniation is going to be with an MRI. Treatment, we try to do, once again, if it's conservative, unless it's something severe, like I discussed, or like your cauda equina syndrome. This isn't a surgical emergency, but usually for these patients, we will do conservative treatments, so modified activities, NSAIDs, physical therapy. Like I said, we can do surgery, and that's what happened with my dad. He was having very, very severe symptoms, so he went in and he had surgery. All right, guys, so now we're going to go into hip fractures. This is very, very highly tested, so make sure that you are familiar with your hip fractures, okay? So hip fractures, you have different types. You have your intercapsular and you have your extracapsular. So this just depends what part of the bone is affected. So intracapsular usually involves a femoral neck fracture, and extracapsular involves the intertrochanteric hip fracture. Some of the causes of this is going to be a fall, high velocity trauma, usually if it involves a younger patient, but usually with these patients, it tends to involve older patients. And if it's an older patient, it'll be a trauma. Usually these patients that are older, right, they have a history of osteoporosis, or they have osteoporosis, or they're more prone to getting these type of fractures because they have these thin, brittle bones. Like I said, younger, it's usually going to be velocity trauma, like a motor vehicle accident, okay? Also very commonly found in athletes. This patient is going to be presenting with pain in the groin that's going to be radiating to their hip, their buttock, or the knee. They're going to have shortening of the leg, and the leg is going to be externally rotated and abducted. This is how you're going to differentiate from a hip dislocation, because when I was studying, I always got these confused. So the mnemonic I have is C, S-E-A. So shortening of the leg for the S, for your hip fractures, externally rotated for your E, and then A is going to be abduction, okay? Sometimes it can also be presenting displaced. The patient's not going to be able to bear any weight on them. They're going to have pain with depalpation, pain with internal rotation of the hip. This is actually the most sensitive test. And then we're going to diagnose these patients by doing, we can do a Trendelenburg test, okay? And we can do an X-ray or CT or an MRI. Usually we'll do an X-ray for these patients. Treatment for this is usually going to be a surgical repair. We want to make sure that we do this within 24 hours. We can also do the surgical repair, which is going to be your hemiarthroplasty or total hip replacement. So we're going to refer these patients to orthopedics, and of course we're going to do pain control in these patients. If there's treatment that's delayed, then basically if the patient does not get surgery within 48 hours, more than 48 hours, and there's a lot of complications this patient can develop, and it has high increased mortality. The most common complication is going to be your avascular necrosis, especially if it involves an intracapsular fracture, okay? And this is because it affects the medial femoral circumflex artery. So make sure that you know that once again. So these patients have to have repair, they have to go to surgery within 24 hours. And the reason why is if they have delayed treatment, and there's necrosis of the there can be necrosis of the intracapsular fracture, and that's because it involves the medial femoral circumflex artery. So next topic I'm going to go into is going to be hip dislocations. So this is where the femoral head is displaced from the acetabulum. This is commonly found in patients that are younger. Sometimes it can be found in motor vehicle accidents, high energy trauma also. And there's different types. You have your anterior and posterior. Posterior is going to be the most common. So remember how we talked about shoulder dislocations? We said the shoulder dislocation most common is going to be anterior. If it's a posterior shoulder dislocation, we want to think about a seizure, right? Or if the patient fell from a really, really high height. Well, for hip dislocations, the most common one is going to be posterior. Okay, but we have posterior and anterior, but posterior is going to be the most common one. How's the patient going to present? They're going to have, if it's posterior, which is the most common one, their hip is going to be shorter. It's going to be fixed in flexion. It's going to be adducted and internally rotated. So once again, the hip is going to be shorter. It's going to be fixed in flexion, and it's going to be adducted and internally rotated. Okay? Versus when we were talking about our hip fractures, right? we said this was going to be externally rotated. With hip dislocations, it's going to be, for posterior, which is the most common one, it's going to be internally rotated and adducted. Usually this is the one you're going to commonly see because it's the most common one on your exams. Now, you can have anterior, like we said, but it's not as common. With anterior, the hip is going to be in mild flexion. It's going to be abducted and externally rotated, okay? How are we going to diagnose these patients? We're going to do an x-ray. So when we look at an x-ray, we're going to see that posterior appears smaller than the opposite side. So anterior appears larger than the opposite side. So whenever we see an x-ray, posterior is going to look smaller and anterior is going to look larger whenever you're looking at that acetabulum. I'm sorry, the femoral head. So in regards to treatment for this, we want to reduce these patients as soon as we can. Of course, we're going to do it under conscious sedation. And then usually these patients will need crutch-assisted ambulation with limited weight bearing until they're pain-free. And the complications of this, just as we had discussed with hip fractures, is going to be your avascular necrosis. So what is avascular necrosis? So avascular necrosis is osteonecrosis of the bone. It results in death of the bone tissue of the femoral head. There's different types of avascular necrosis. So we have the idiopathic one, the leg cap Perth disease. This is the one that's commonly found in children, which we will discuss later on. Some of the causes of avascular necrosis is going to be trauma to vascular supply. Usually the most common one involved is going to be your medial femoral circumflex. Usually it's commonly found in patients between the ages of 30 to 50. If the patient has sickle cell disease, if they have SCFE, right, the ones found in children, slipped capital femoral epiphysis, trauma, rheumatoid arthritis, and this patient is going to be presenting with acute or insidious onset of dull or throbbing pain to the groin, okay? They're going to be limping, and they're going to be having pain with internal, external rotation, and decreased range of motion. Usually that's how they usually present in your patients that have SCFE, like your obese children. They're going to be presenting with this pain, and they're going to be limping. Diagnosis, best one is an x-ray. We're going to do an AP and frog leg lateral. And then we can also do an MRI or bone scan, but usually it's going to be an x-ray, right? It's going to be the least expensive, and it's going to be the least radiation. Treatment for this is usually going to be protective weight bearing, and we can refer these patients to orthopedics. Actually, we will refer these patients, to orthopedics for a surgical consult, and they're going to have a hip arthroplasty, especially if they have femoral head collapse. So now we're going to go into our open fractures. So open fractures occur whenever bone penetrates through the skin. Some of the causes are going to be high energy injuries like car crash, fall, sports injuries. We're going to diagnose this doing the Gustello-Anderson classification, and we're going to treat this by controlling the bleeding. We're going to do an open reduction and internal fixation, give them antibiotics, and then sometimes these patients may need some amputation for extensive vascular injury or muscle tissue ischemia that's been going on for more than 8 hours. Okay. Now we're going to go into dislocation of the patella. This is a complete patellar dislocation that always dislocates laterally. Usually the femur and the tibia are not articulating. And that's usually a very commonly scientific concept that is tested, so make sure you know that. So dislocation of the patella, usually the femur and tibia are not articulating. And that's because you have a dislocation, right, of the patella. It's going to be a complete patellar dislocation. Some of the causes of this is usually for dislocation of the knee, about 3/4 of the ligaments have to be ruptured. So your ACL, your PCL, MCL, and LCL to have a dislocation of your patella. And we want to make sure that with these patients, we're cautious because it can involve the peroneal nerve and the popliteal artery. How is this patient going to present? They're going to be presenting with severe pain. The patient's going to be presenting with their knee that's flexed, and you're going to feel like a bony mass that's going to be lateral to the knee. And it's going to be flat over the anterior knee. Diagnosis for these patients, we want to make sure that we do an x-ray. We're going to confirm it with an x-ray, and then we're going to reduce it. But once we reduce it, we're also going to do an x-ray because we want to make sure that we did reduce that. The thing about dislocation of patella also is that they can have subluxation, so they have subtle symptoms. Sometimes they'll be complaining that the knee is giving out or it jumps out of place. And like I said, the treatment's going to be, we're going to reduce it as soon as we can. So we're going to do traction. We're going to extend the knee with slight pressure on the patella. And then we're going to splint this, give them NSAIDs, and then of course tell them to put some ice on it, and then immobilization for your dislocation of the patella. So next one's going to be your common peroneal nerve palsy, also known as your foot drop. This is where the patient is unable to dorsiflex their foot. They have sensory loss and motor loss to the lateral leg. The most common cause of this is usually going to be your proximal tibial injury. It's going to be injury to your peroneal nerve from L4, L5, or S1, S2. Usually these patients also can have knee injury or sciatica that can cause this common peroneal nerve palsy. How is this patient going to present? They're going to be presenting with a foot drop. Basically, the patient cannot raise their foot because they have this weakness or paralysis of the tibialis anterior muscle. They're going to have this high steppage gait, okay, or these foot slaps onto the floor whenever they're walking. We're going to diagnose this by doing an EMG study or a nerve study. And usually with these patients, we'll have numbness or pain across distribution with the straight leg test. How are we going to treat these patients? We'll do an ankle splint or bracing. We can also do electric stimulation and then common peroneal nerve decompression also. Usually with these patients, big toe is going to be the last one that's going to recover. So now we're going to go into gouty arthritis, okay? So gouty arthritis is crystal deposition arthritis. The most common joint that is involved, it's going to be your first metatarsal phalangeal joint. So it's going to be your big toe, also known as podagra. What happens is that you have an increased, you have hyperuricemia. So this involves the uric acid. Basically, there's an ultra-purine metabolism for your gout. Usually, it's going to be monoarticular, so it'll usually just involve one joint. And it's most commonly found in men that are greater than 50, also in postmenopausal women. Sometimes these patients can be presenting with recurrent attacks, so they'll be treated for this and they'll be fine. And then they'll have another attack later. The most common site is going to be the big toe, and in females, it's usually the thumbs. But in general, for arthritis, your gout, it's going to be your big toe. Some of the triggers for gout is that you can have trauma, especially also if the patient has high purine diet. So if they eat a lot of red meat, shellfish, beer even, they're more prone to getting gout. Also, if they're taking certain medications that causes them to be more, have more hyperuricemia. So drugs like your diuretics, hydrochlorothiazide is one of the huge ones, and then your loop diuretics like furosemide. These are really big in causing gout. Also aspirin. Make sure that you know that because this is very highly tested. I've had so many questions where you're reading a vignette and you're like, okay, it's an older man, they're having this like painful toe, and it's so painful that even just having like a blanket on top of that toe is just like painful, or anything that brushes on the toe is just extremely painful, and you see, and it's like this inflamed gouty toe. And then you're reading the vignette and it tells you that this patient is on all these medications and they have a history, for example, of hypertension or some type of cardiac disease or kidney disease, and they're on a loop diuretic or a thiazide, so your hydrochlorothiazide, like I said, or furosemide. Then it asks you which one of these medications is a culprit of gout, or which one of these medications would you like to discontinue. Then you want to think about your diuretics, okay, your aspirin. So this is very highly tested, and make sure that you know that. How is this patient going to present? They're going to have this rapid onset of exquisite pain, warmth, edema, and erythema. So podagra, like I said, it's going to be most commonly found in the first metatarsal joint, so it's going to be that big toe. They can or cannot present with fever, chills, malaise, and usually these patients, it's so painful that they can't stand any weight on it. How are we going to diagnose this? Usually they're going to have a hyperuricemia. The gold standard is going to do an arthrocentesis, right? We're going to go in there and look at the crystals, and you're going to see monosodium urate crystals. They're going to be birefringent negative, and they're going to be needle shaped. Make sure that you know this because you need to differentiate it between your pseudo-gout. So with pseudo-gout, it's most commonly involved in the knee, okay? And on these, you're going to see rhomboid, okay? You're going to see rhomboid shaped versus your gout. This one involves your uric acid, okay? And this is going to be what? It's going to be needle shaped, and it's going to be birefringence negative. You're going to see monosodium urate crystals. How are you going to treat these patients? So you're going to treat an acute attack with NSAIDs usually. That's usually first line, okay? So once again, NSAIDs. Also, make sure that if you're reading the question stem and it tells you that the patient has a history of acute renal failure, which I've had so many questions on, like I'm reading the question, I'm like, oh my gosh, this patient has gout. And then I go straight to the answer, and then I choose NSAIDs. But then it tells you, if you keep reading, this patient has a history of renal failure, which, it's usually commonly associated with gout. Then for these patients, you want to choose something else. So we're not going to choose your NSAIDs. You can choose another thing. So make sure that you know that. So acute attack, NSAIDs, colchicine. You can also do glucocorticoids. We also want to make sure that we instruct them on their diet to decrease the amount of meat that they're taking, right? Have a low purine diet, increase water. We can also do rest, ice, and then if it's chronic, then these patients will have allopurinol. So as you can see, we don't jump straight to allopurinol for these patients. We will start with NSAIDs, okay? And then if NSAIDs don't work, we can do colchicine or glucocorticoids. Allopurinol is usually if it's chronic, if it's recurring, okay? Then that's the only reason we use allopurinol. And real quick, what is usually associated with allopurinol? A really, really bad side effect. This is very highly tested, so this is why I'm bringing it up. I'll probably bring it up later. Allopurinol is usually associated with your Stevens-Johnson syndrome. And the reason why I bring this up is because I'm currently doing my rotation, like I said, in a burn unit. We don't only see burns, but we see also extreme skin disorders or diseases. So we also see a lot of TENS, so toxic epidermal necrolysis. We see a lot of SJS, your Stevens-Johnson syndrome. We see our pemphigus vulgaris, so these skin disorders where the skin is just sloughing off and they make the patient very immunocompromised. So I actually was taking care of a patient today, and she was giving allopurinol for her gout, and she developed SJS. So make sure that you are familiar with that. And I'll probably discuss her later when I get to the dermatology part. Okay, so now we're going to go into inversion ankle sprain. This affects the lateral ligaments. And the most common cause of this is going to be inversion and plantar flexion sprain. And it's going to be an injury to the anterior talofibular ligament. Make sure you know that this is very highly tested. So once again, your inversion ankle sprain, most common involved is going to be your inversion and plantar flexion sprain. It's going to involve the anterior talofibular ligament. Signs and symptoms are going to be presenting of localized pain and swelling over the lateral aspect. They'll have poor weight bearing. It's going to be limiting. They'll have this positive anterior drawer test and then a positive subtalar tilt test. We're going to diagnose this by doing the Ottawa ankle rules. So the Ottawa ankle rules tells you whether you need to get an x-ray or not on these patients depending on where they're presenting on the pain on their lower extremity. So if this patient has malleolar pain or deformity, then we're going to do an ankle x-ray. If they have any type of bony tenderness on their foot, then we're going to do a foot x-ray. That's basically what your Ottawa ankle rules are. And I use this a lot during my family medicine rotation. Whenever I see a patient, pull out my Ottawa ankle rules to tell the doctor I was rotating with whether I thought this patient needed an x-ray or not whenever they're presenting with like ankle pain or foot pain. Treatment for this is usually your elevation, right, compression, ice. We usually will also do protective weight bearing. We can put them on a brace. And we want to make sure that this patient is having early motion. It's very essential whether they're doing home exercise or physical therapy. If it's chronic instability, then that's when they go into surgery. So now we have eversion ankle sprain. This is going to be a high ankle sprain. Once again, a high ankle sprain. It involves the anterior tibiofibular ligament. So we said for our inversion, it involved the anterior talofibular ligament. How I memorize it is that your inversion ankle sprain always tears first, okay? So angular talofibular ligament. That's how I memorized it. And then, like I said, eversion ankle sprain is going to involve your anterior tibial fibular ligament. Some of the most common causes of this is usually where the patient has a foot that's turned out or it's externally rotated and everted. And the patient's going to be presenting with severe and prolonged pain. They'll have limited range of motion, mild swelling, difficulty with weight bearing. They might have a myozonoid fracture. How are we going to diagnose these patients? We're going to diagnose them by doing an external rotation stress test. We're also going to do an x-ray. And then usually our test of choice is going to be an MRI. Treatment for this is going to be conservative cast or boot walking for 4 to 6 weeks. If it's severe, then our gold standard is going to be our screw fixation. So now we're going to go into osteoporosis. This is loss of bone mass and deterioration of architecture of the cancellous bone with increase in bone fragility, and this patient is usually susceptible to fractures. Most commonly found in older patients. If they're aging, also if they have some type of endocrine disorder, they're more prone to getting osteoporosis. If they have malignancy, usually found also in our postmenopausal women, right, because they're not producing estrogen like they used to. Also, with these patients, usually patients that have sedentary life, if they're not moving as much as they used to, or they just don't move enough, if they're calcium deficient, if they have high protein diet, if they drink a lot of alcohol, or if they smoke, are usually some of the causes of osteoporosis. Some of the risk factors are going to be if the patient is white, if they're older, so an aging female, if they have a small bone structure, like I said, postmenopausal, if they have a family history. Diagnosis for this, we're going to do our bone mineral density assessment, but usually what you'll see on the exam is going to be your DEXA scan, okay? So we'll do a DEXA scan of the L-spine and hip, and usually the T-score, that anything that's greater than negative 2.5, we want to think about osteoporosis. And we want to make sure that we screen patients with DEXA scans for osteoporosis at the age of 65 for females especially. So start at the age of 65 for screening with a DEXA scan for women at age 65 for osteoporosis. For males, we start at age 70. So why do we start earlier with females? Because like I said, postmenopausal, they won't produce estrogen as much as they used to, so they're more prone to getting osteoporosis. Treatment for this is usually weight-bearing exercises. We can give them pharmacological treatment. So the first line is going to be your biphosphonates, right? Your alendronate. And with biphosphonates, we always want to educate that they sit up at least 30 minutes whenever they drink this medication. So they take the medication, they're going to take it with a full glass of water, and they have to remain upright, okay, with your biphosphonates. And then supplementation, we want to make sure that these patients are also taking vitamin D and calcium. And if they're smoking, tell them to stop smoking. So once again, with osteoporosis, you have these brittle bones that are more prone to fracturing, commonly found in older individuals, especially like your older women, right? Because these women are postmenopausal, they're not producing estrogen like they used to. Another thing you need to know about this is that we do a DEXA scan for them, right? Anything that's greater than negative 2.5 is usually diagnostic for osteoporosis. We start doing the DEXA scans, especially screening for osteoporosis in women that are older than 65, and then men, it's going to be older than 70. Usually your treatment, like I said, whenever they're asking you for the first line, it's always going to be a conservative. So you want to make sure that these patients stop smoking if they're smokers. Tell them to do weight-bearing exercises. And then if they do need medication, we're going to give them something like a biphosphonate, like your alendronate. And with your biphosphonates, these patients have to remain upright and they have to drink a full bottle or a glass of water with the medication, okay? All right, so now we're going to go into compartment syndrome. So this is a swelling of the compartment due to an injury. So any type of injury, like I said, I'm probably going to say this over and over again, guys, and I'm sorry. It's just that when I'm learning, the best way for me to learn something is if I think about a patient case, and that's how it stays in my mind. So hopefully this is helpful for you guys. So once again, I'm rotating to my burn unit, and the thing about burns, the first thing that we want to rule out is compartment syndrome in these patients. So Compartment syndrome, like I said, this is swelling of compartment due to any type of injury, fractures, your burns. They have increased pressure that compresses the blood vessels and nerves. It causes ischemia, and this is why it's an emergency. The most common cause is going to be your long bone fractures. Other ones can be your circumferential burns. So your circumferential burns, especially if they are found in your lower extremities with these patients, what happens whenever a burn occurs is that as the body starts healing, sometimes it'll create some type of contracture, or sometimes it'll be, if it's circumferential, it'll start scarring down. And if it's circumferential, it will usually clamp down, right? And this can cause increased compartment pressure. So that's why with these patients, we want to make sure that if it's like a full thickness burn, that we go and we take them to surgery, because we want to prevent things like compartment syndrome. Crush injuries, also penetrating wounds, can cause compartment syndrome. The thing about compartment syndrome is that you need to know your 6 Ps, right? So this patient is going to be presenting with pulselessness, pallor, paresthesias, paralysis, pain out of proportion to the physical exam, poikilothermia. So today we went to go see a patient that came in, and this patient had a circumferential burn on his lower extremity. So it involved the entire calf, and it extended up to below his knee. And so with these patients, the first thing that we told him was if he was having any of these symptoms, and to let us know if he starts having any type of paralysis or paresthesias, because we want to make sure that this patient is not developing compartment syndrome. So once again, compartment syndrome is just when they're having this increased pressure in their muscles, okay, in their muscles. So how are we going to diagnose this? Usually a normal pressure is between 0 to 10, and compartment syndrome is anything greater than 30, okay? So if you read a question, this patient had some type of crush injury, and they're having all these symptoms, sometimes it'll ask you, well, what is going to be the pressure for these patients, the compartment pressure measurement that's going to be abnormal, anything greater than 30, okay? Treatment for this is usually an emergent fasciotomy. If it's greater than 30, we want to relieve that pressure, and conservative if needed, we can do immobilization. And the complications of this is going to be your vocal contraction, like I mentioned, your permanent nerve and muscle damaged. So next topic we're going to go into is going to be your osteomyelitis. This is going to be an infection of the bone and bone marrow. The most common bacteria involved in your osteomyelitis is going to be your Staph aureus. Other bacteria is Mycobacterium tuberculosis also, but the most common one is going to be Staph aureus. Make sure that you know that. Other causes of osteomyelitis is going to be if the patient is post-operative. This is something that we look for a lot in our patients that come in with burns, especially if they're like deep, full thickness burns. We're worried about osteomyelitis. Also, if they have any type of open wounds, especially like your diabetic ulcers. Some of the risk factors for osteomyelitis is if the patient is a diabetic, if they had fractures, splenectomy, if they have any type of orthopedic procedures. This patient is going to be presenting with local redness, swelling, pain to the site. They might have a sinus that is connecting to the abscess. Systemic symptoms may also be present, so weakness, fever, headache, chills. We're basically going to do an x-ray for these patients to diagnose them. We're going to see cortical bone breakage. We're going to do an MRI. We'll see edema and cortical loss. And we can do a CT scan. With a CT scan, we're going to see our Codman's triangle, which means that the patient has a very aggressive infection for your osteomyelitis. And then we're going to do fine needle aspiration. This is going to tell us what type of antibiotic treatment we can give, and will also let us know what type of bacteria is involved. Usually for osteomyelitis, you're going to have to be on long-term IV antibiotics, and then surgical removal of dead bone is required. If it's a severe case, then they have to go in there and amputate it. So another thing about osteomyelitis that you need to know, that in patients that have sickle cell anemia, the most common bacterial cause is going to be Salmonella. So make sure that you're reading your question stem. If it's a regular patient, Staph aureus. If it's a patient with sickle cell, Salmonella. So now we're going to go into septic arthritis. This is an infection and damage to the joint that's due to a pathogen that's in the bloodstream. The most common bacterial infection is going to be your Staph aureus once again, but if the patient is sexually active, if they're younger, then you want to think about Neisseria gonorrhea. Some of the risk factors for septic arthritis is going to be your diabetes mellitus, trauma if they have an artificial joint, if they're HIV or IV drug abusers, alcohol abuse, if they have an open fracture. The most common joint associated with septic arthritis is going to be your knee, okay? Usually they're going to have unilateral joint involvement. They'll have limited range of motion. They'll have this painful joint that's warm to touch. It'll be inflamed, and they can also present with fever and weakness. So once again, this is very highly tested. I've actually had some questions on this, and the one I had, that I remember, was a gentleman that was presenting in. It was a younger patient, and they're sexually active. They're presenting with like this swelling to the knee that was not consistent with osteoarthritis or rheumatoid arthritis, because rheumatoid arthritis is usually like nodular, right? And it was red, it was inflamed, and you wanted to think that it was septic arthritis. So diagnostic test is going to be, we'll do our CBC, we're going to see leukocytosis, we can do an X-ray, an MRI or CT, we're going to see edema, increased synovial fluid, narrowing of the joint. But what we want to do for these patients is going to be an arthrocentesis, right? We're going to go in there and do a fluid culture. Okay, so once again, arthrocentesis, synovial fluid culture. First line treatment for this is going to be IV empiric antibiotics. So we're going to give them Vanc, right? Plus any type of third generation cephalosporin. Okay. Usually once we get the fluid culture back, then that's when we can give specific antibiotics. We're also going to give pain medications like our NSAIDs. We're going to go and surgically drain it, and then we want to make sure that we're cleaning that joint also. So once again, septic arthritis, it's infection or damage to a joint. Most common one is going to be your Staph aureus. If it's a younger patient and they're sexually active, we want to think about Neisseria gonorrhea. So next topic we're going to go into, which is going to be the last one for our MSK, is going to be our labral tear. This is a commonly found in the shoulders and hips, and it's usually due to repetitive microtrauma. Some of the individuals who usually have labral tears are going to be your athletes, weightlifters, footballers, swimmers, gymnastics. They're going to be presenting with vague, non-specific pain in the joint. They're going to have this clicking or popping sensation of instability, tender to palpation. If it involves the shoulder, they'll have posterior apprehension, positive shift and load test. If it involves the hip, they're going to have pain with internal rotation and adduction, okay, especially if it involves the anterior hip. If it involves the posterior hip, it's going to be presenting with pain with external rotation and abduction. Okay. Diagnosis, we're going to do an X-ray. Usually it's normal, right? So we're going to go more specific. We're going to do an MRI. It'll show us that there's a tear present. Usually with these patients, they'll have a positive O'Brien test or an empty cam test, right? Or empty cam test is when they go like this. And then basically they'll have pain or popping during internal rotation for these tests. Treatment for this first line is going to be make sure that you educate them on their activity modification. So if there's something that aggravates it, to just prevent from doing that. We give them NSAIDs also. If they need to be referred to physical therapy, they can do so. We can give them steroid injections, but we want to make sure that we stray away from steroid injections because it can actually worsen and degenerate the joint, right? And if operative, if needed, that's last line. Once again, that's going to be, we can do an arthroscopic label repair or debridement if needed. Okay, so we are done with our musculoskeletal. So let's go into our next topic, pulmonology. So let's start with acute respiratory distress syndrome. So this is due to, it's also known as ARDS. This is the most commonly one that we're seeing, right, in our patients that have COVID-19. This is a common complication of COVID-19. So what it is sudden respiratory failure following a systemic or pulmonary insult. So it's not always associated with COVID-19. Once again, I'm in the burn unit. I see this a lot in burn patients, especially if they have extensive burn wounds. Usually these patients have hypoxia and hypercapnia. It's usually due to an underlying condition. What happens is that you have a neutrophil activation in the systemic or pulmonary circulation, and there's massive intrapulmonary shunting of the blood. They have severe hypoxemia, and they have pulmonary edema. They'll have widespread atelectasis, collapse of the alveoli, and surfactant dysfunction. The most common risk factor for these patients is going to be sepsis, okay? Right now we're seeing COVID is causing a lot of that, but for your textbook, for your exams, the most common one is going to be your sepsis. So infections like pneumonia, urosepsis, wound infections. Also, these patients can have aspiration, trauma, fractures, pancreatitis, transfusions, drowning, overdose, toxic inhalations, intracranial hypertension, cardiopulmonary bypass. And then burns also. Any of these can cause acute respiratory distress syndrome or failure. This patient is going to be presenting with dyspnea. They're going to have tachypnea, tachycardia. They'll have retractions whenever they're breathing. You'll hear some crackles and rails. They'll be agitated. They won't be able to speak. They'll be cyanotic. They'll have impaired mentation, which makes sense, right? Because they're having hypercapnia. They're basically having all this increase of carbon dioxide in their body because they can't expel it out. So of course they're going to have ultramental status. Diagnosis, we're going to do a chest x-ray, a CT, and then we're also going to do an ABG, right? So our arterial blood gas. So what we're going to see is we're going to see respiratory alkalosis first, and then it's going to go into respiratory acidosis. So respiratory alkalosis, they're trying to get that air in, and then once they progress, they have respiratory acidosis where they just cannot get oxygen in, and this is why they're hypercapnic, because they're retaining all that carbon dioxide. They're not able to get rid of it because they're not breathing appropriately. They're also going to be, another thing we're going to do is a pulmonary artery catheter, usually anything that's less than, and then we're also going to do a PCWP. Anything less than 18 is going to be normal, and then we can do a bronchoscopy also with a lavage. Treatment for this is going to be oxygenation. We want to make sure that our O2 stat goal is going to be greater than 90%. We're going to intubate it and do fluid management. We want to avoid volume overload, and we want to make sure that we treat the underlying cause of this patient, of course. Okay. If it's a burn that's causing it, treat the burn. Now we're going to go into asthma. Asthma. What you need to know is that it's a type of obstructive pulmonary disease, okay? What happens is that the airways are narrowed, so the patient has difficulty breathing. Usually there's a triad with this. They'll have airway inflammation, hyperactivity, and reversible obstruction. So once again, it's going to be reversible versus our COPDers, like our emphysema. This is usually irreversible obstruction, but with asthma, it's reversible. Usually asthma, if a child has it, usually it tends to go away, and as adults, they want to have it. Although I've seen patients that have asthma as adults. But that's why it's called reversible versus your COPDers, it's usually irreversible obstructions. So remember, when we talk about our pulmonary disorders, we have our restrictive and our obstructive type, right? Asthma falls under the obstructive umbrella. So with asthma, they have trouble getting air out, right? So they can get air in, but they can't get air out. Versus restrictive, and that's the same for anything obstructive. Versus restrictive, they have trouble getting air in, but they can get air out. Okay, so going back into asthma. Some of the triggers that can cause it, usually a trigger is that there's excessive reaction from your immune cells. Cytokine release histamine, leukotrienes, prostaglandins, and this causes spasms that narrow the airway. This causes increased mucus secretion, increased vascular permeability, and then if this patient has this ongoing on for years, they can have edema, scarring, and fibrosis. Some of the common environmental triggers for this, some of the common causes of this is your environmental triggers, usually genetics also. During an attack, air is trapped in the alveoli, the wall gets inflamed and it gets thickened. Okay, and then we have our extrinsic and intrinsic. So intrinsic tends to develop early, and it's the most common type. Usually this is a type 1 basically reaction where the IgE antibodies are involved. This patient will usually have allergic asthma. So if there's any pollen, house dust, mold, pets, or if they have a strong family history, then we're prone to getting the extrinsic, right? Versus our intrinsic causes, this tends to develop later in life, and with these patients, some of the triggers can be aspirin, infections, cold, inhaled irritants, smoke, stress, exercise, usually commonly found in older females, or if the patients have GERD also. So like I said, intrinsic, I've had some patients that are diagnosed later at an age, and so this is what I want to think about an intrinsic cause of asthma. So versus extrinsic is going to be anything that's outside that's causing it. So your pets, your pollen, your dust. Okay. So symptoms, this patient, usually we have different types, right? So which I will be discussing, but usually with their symptoms, they'll have shortness of breath. They'll have this wheezing, chest tightness, cough. It's going to be typically worse at night. And usually they're going to have wheezing on expiration. So whenever we have a patient that comes in, like I said, this older patient that we had, she said that she just has this cough that didn't go away. And she was like wheezing whenever we auscultated on her. And we told her, like, do you have a history of asthma? And she's like, no, not that I know of. And we ended up doing a pulmonary function test on her, and she ended up having asthma. So once again, this can be diagnosed at an older age. It doesn't have to be necessarily be a young patient. Of course, like during my pediatric rotation, we saw this a lot on children that were just coming in and they're like wheezing and just coughing like nonstop, and coughing so much that they're like gagging. So there's also acute exacerbations of asthma. This patient can present with, if they're having an acute exacerbation, they're going to have tachypnea, right? They're going to be breathing really fast. They're going to be diaphoretic. They're going to be wheezing, incomplete sentences where they can't even talk. Okay. They'll be using their accessory muscle use. So you'll look at them and they're like using their accessory muscles. They'll have intercostal retractions, diminished breath sounds, fatigue also. So diagnosis for these patients, we want to do our PFT, or peak expiratory flow rate for these patients. We can also do a chest x-ray. Usually we get a chest x-ray for our first-time wheezers. So if it's a new patient and they have like a first event of wheezing, that we'll do these tests, an x-ray. But usually we start with our PFTs, pulmonary function tests. If we do an x-ray, what are we going to see? It's usually normal. We'll just see like some hyperinflation of the lungs, right? Because this type of obstructive pulmonary disorder. And we can also do a spirometry, PFT. We're going to see decreased forced expirational volume, so decreased FEV1, which makes sense, right? Because we said it's an obstructive. They're able to get air in, but they can't get air out. They'll have a decreased FVC and decreased FEV1/FVC. It's going to show us an obstructive pattern, and they'll have an increased TLC, or total lung capacity. So, which makes sense once again, right? Total lung capacity, because they can't get air out. They can get air in, but they can't get air out. Okay? So another thing that we can do for these patients is that we can do an albuterol test. So basically, we'll give them albuterol, we'll help them with their constriction, and then once we give them albuterol, we're going to see an increase in their forced expirational volume by more than 12%. So we give them this, and you see an increase in how much air they're expiring, right? Or forced expirational volume, increase more than 12%. This is usually diagnostic of your asthma. Now, another thing that we can do is that we can do a methacholine or histamine test, which basically makes them worse, okay? So if we see a decrease in their forced expirational volume, more than 20%, then it's also diagnostic of asthma. And usually we do this once again with methacholine or histamine. It's a little cruel because we're making them worse, but it's diagnostic of asthma. So another thing that you need to know is the stages of asthma, okay, and how you treat these. So stages of asthma, make sure you know this is very, very highly tested, okay? So we have our 4 different stages. So start with the first one. Intermittent is going to be when the patient has symptoms less than 2 days per week, okay? Less than 2 days per week. And they use their rescue medication, whether it's their albuterol, which is the most common one. They use it less than 2 days per week, and they have night symptoms less than twice a month, okay? So day symptoms less than twice a week, and night symptoms less than 2 times a month. Their forced expirational volume is going to be greater than 80%. And the treatment for these patients is that we're going to do step 1. We're going to give them albuterol as needed. Okay, so once again, intermittent, they're going to have less than 2 symptoms, less than 2 days per week. They're going to have symptoms less than 2 times per month. And usually their first expirational volume is going to be greater than 80%. And first line for this is going to be your SABA, your short-acting beta agonist, which is going to be your albuterol. Now the next one is going to be, so we're going into the next one, it's going to be mild persistent. This patient is going to have symptoms more than 2 days per week. They're going to be using the rescue medication more than 2 days per week, and they're going to have night symptoms about 3 to 4 times a month. The forced expirational volume is going to be greater than 80%. And treatment for these patients is that we're also going to do albuterol, but we're going to add a low dose inhaled corticosteroid. Okay? Moderate persistent, it's going to be a little bit worse. They're going to be having daily symptoms. They're going to be using their medications, so their albuterol daily, like every day. They're going to have night symptoms more than once a week. And their forced expirational volume, their FEV1 is going to be greater than 60%, but less than 80%. Treatment for this is that we're going to do a SABA. We're going to add a low dose inhaled corticosteroid. Okay? And a long-acting beta agonist, so something like salmeterol. Okay, so albuterol, your SABA, plus a low-dose inhaled corticosteroid, plus a LABA like salmeterol. Or you can do something like a short-acting beta agonist like albuterol plus a medium-dose inhaled corticosteroid. Now, next one is going to be your severe persistent. This is where the patient has symptoms like all the time. So they're going to have continual symptoms. They're going to use their rescue medication several times throughout the day. So not only once, they're going to be using it several times throughout the day. With these patients also, they're going to have nightly symptoms more than 7 times a week, and their forced expirational volume is going to be less than 60%. Treatment for this is that we want to do a SABA, so once again, our short-acting beta agonist like albuterol, plus a medium inhaled corticosteroid, plus a long-acting beta agonist. Or we can do a SABA plus a high-dose inhaled corticosteroid, plus a long-acting beta agonist. What you need to know is that, as you can see, every patient with asthma gets albuterol. Every patient gets a short-acting beta agonist. You're just adding on things depending on how severe it is. And you need to educate this patient also to avoid anything that triggers. If they see that whenever they exert themselves to avoid this, if they see it's worse whenever they're around their pets and they're going to have to get rid of their pets, anything that worsens it, you want to make sure that you tell them to avoid this. And also make sure that you educate them on how to use their inhaler. Use your inhaler, use your inhaled corticosteroids. Brush your teeth after using your inhaled corticosteroids. Why? Because it can give you secondary fungal infections. So another thing that you need to know is that you can step down for your medications if the patient is controlled for 3 months. Okay, so say if the patient is on your LABA and they've been getting better, then you can step down from the LABA. If the patient is having an acute attack, the best medication to start is going to be your short-acting beta agonist. Okay, so your short-acting beta agonists are usually the best ones for acute attacks. Also, we're going to do our ABCs, right? We're going to protect the airway, breathing, circulation. Supplemental oxygen also we give, and then IV terbutaline also. If they have an exacerbation in the hospital, then we can give them oral prednisone. So it's going to be asthma. Make sure it's an obstructive disorder. You diagnose it with PFTs, and make sure that you know your different types or your different stages. And then everyone gets a SABA, right? So now we're going to foreign body. This is a placement of a foreign body in the trachea or bronchi. It's more commonly found in children. It can also be found in patients that have any type of like swallowing disorder. Also, you have patients that have type of mental disorder also. So most commonly found in children, and the most common type is usually going to be inorganic things like clips, pins, toys, and coins. In regards to organic things, the most common food is going to be your nuts, and it tends to most commonly lodge into the right bronchus, okay? So it'll go usually in your right bronchus, and that's just because of just how anatomy is. Make sure you know that's very commonly tested, right bronchus for foreign body. This patient is going to be presenting with respiratory distress, choking, cyanosis, mental status changes. There's different types of obstructions. We can have a partial obstruction and then our complete obstruction. Partial obstruction, they're going to be coughing, gagging, wheezing, drooling, diminished breath sounds, tachypnea. They're going to have stridor, usually dyspnea. Complete obstruction is a medical emergency. These patients are going to be presenting with stridor, wheezing, dyspnea, hoarseness, and they're going to be in acute distress. Diagnosis for this is going to be a chest x-ray and a chest CT. Usually we'll do the CT if the x-ray comes back negative. Since this is commonly found in children, we usually want to avoid CTs, right? Because anything that has high radiation, so that's why we usually do an x-ray. That's usually what we start with. And treatment for this is going to be a rigid bronchoscopy. This is usually going to be our gold standard for diagnostic and treatment. We're going to go in there and remove the foreign body. What you need to know about foreign bodies is that the bad ones are going to be like our batteries, because those can go through the esophagus and they can actually tear the esophagus. And during my surgery rotation, we had a child that came in and she ended up dying from that. She swallowed a button battery. So these are very, very dangerous. So if you read a question stem and there's anything with a button battery or any type of battery, we have to remove this ASAP, no matter where it's at. So now we're going to go into pneumothorax. Pneumothorax is air that's in normally airless pleural space, and usually due to spontaneous rupture of blebs. So with our pneumothorax, the primary cause is usually idiopathic. With pneumothorax, it's usually found in your tall, lean, young males. So if you notice, we're talking about our spontaneous pneumothorax, right? Pneumothorax. Not our tension pneumothorax, which is what I'm going to go into next. Tension pneumothorax is something else. So our spontaneous pneumothorax, like I said, this is spontaneous rupture of blebs. The primary cause is idiopathic. Usually on your question stem, it's going to be a tall, lean, or skinny young male. There's also other secondary causes. Any patient that has any type of lung disease like COPD, asthma, interstitial lung disease, cystic fibrosis, tuberculosis, and this is life-threatening. This patient's going to be presenting with ipsilateral chest pain. It's going to be sudden on onset, so it'll be just like quick. They're going to have dyspnea, cough, decreased breath sounds on the affected side. They're going to have a hyperresonance, right? So you're going to go in percuss and it's going to be hyperresonant for these patients. They're going to be having decreased and absent tactile ephrematus. And then on diagnosis, we're going to do a chest x-ray for these patients, and we're going to see medial Stein shift that's towards the same side of the pneumothorax. Okay, so once again, we're going to see medial sternal shift towards the same side of the thorax. Pneumothorax. This is going to tell us that the patient has our spontaneous pneumothorax. Treatment for this, usually if the patient's asymptomatic, we just observe them. We can do a small chest tube. We can also give him oxygen, and then we'll usually give him oxygen. But if the patient is symptomatic, we'll give him oxygen. We'll do needle aspiration and then a chest tube usually. And then we'll do a chest tube drainage. So now we're going to go into our tension pneumothorax. This is a severe one. This is usually due to some type of trauma. You'll have accumulation of air in the lungs where the air can get in, but the air cannot get out. So that's why you're having this increased pressure in the lung cavity. You have increased pressure, collapse of the lung, and then the mediastinum will shift because there's all this pressure there. Some of the causes, like I said, usually a trauma like a gunshot wound. Mechanical ventilation is very commonly associated with our tension pneumothorax. So this is something we're always looking for these patients whenever they are mechanically ventilated. They're going to be presenting with hypotension. This is an emergency. They're going to be presenting with jugular venous distension. They're going to be presenting with the trachea that's going to be shifting away from the affected lung. They're going to have decreased breath sounds and hyperresonance. And like I said, this is a medical emergency. We will usually diagnose this by clinical findings. And we can get a chest x-ray, but usually, we're going to go in there and treat them as soon as we can because this is a medical emergency. Our treatment is going to be immediately decompression of the pleural space with a large bore needle, followed by a chest tube placement. So we're going to go in there, do needle decompression, and then we're going to go in there and do a chest tube placement. Okay? So once again, spontaneous pneumothorax, it's going to be a tall, thin, young man complaining of like chest pain, dyspnea. They can be asymptomatic or they can present with symptoms. Usually we'll do a chest x-ray with these patients, and then with these patients, what you'll see on chest x-ray, the trachea is going to be towards the affected side versus retention pneumothorax, which is going to be your gunshot wounds, any type of trauma. This is in a medical emergency. So on this one, you're going to see the trachea opposite from the affected side, okay? So it's going to be away from the affected side. With these patients, we have to do a large bore needle for decompression, and then we'll do chest tube placement after that. So now we're going to go into pulmonary embolism. Pulmonary embolism, this is very, very highly tested. So this is a thrombus that embolizes into the pulmonary vasculature via the right ventricle and pulmonary artery, okay? The most common cause is going to be a DVT, so deep vein thrombosis. Some of the signs and symptoms is going to be dyspnea. They're going to be complaining of pleuritic chest pain, cough, hemoptysis, so blood whenever they're coughing, syncope. They can present with a low-grade fever, cardiogenic shock, also tachypnea, rel, tachycardia, dullness on percussion, decreased breath sounds. Another thing I learned today during rounds is that it can also present with atrial fibrillation, but the most common EKG change you'll see on these patients is that they're going to be tachycardic for these patients. Okay, and then what you need to know is that they have a pulmonary saddle. Basically, that means if it gets large, they can have instant death because that's just they're not getting perfusion to any of their lungs. So this is very, very deadly. How are we going to diagnose this? We'll usually do a PERC score. We want to rule out criteria for pulmonary embolism. Okay, if none of the 8 criteria are present, then pulmonary embolism can be ruled out. So for PERC score, it's going to be blood in the sputum, hemoptysis, R, room air saturation greater than 95%. E is going to be for estrogen or hormonal use. A is going to be for age greater than 50. T is going to be for thrombotic events. DVT. H is going to be for heart rate greater than 100. S is going to be for surgery in the past 4 weeks. And that's usually our what we want to think about for the rule out criteria for pulmonary embolism. Our initial test is going to be a spiral CT, spiral CT, and then the most accurate test is going to be our pulmonary angiography for these patients. We want to make sure that we're doing acute anticoagulation therapy. We want to start with heparin, right? Okay, because warfarin takes longer, so we're going to start heparin because that's immediate. I usually start with low molecular weight heparin because it's not associated with our heparin-induced thrombocytopenia like our fractionated heparin is. So we usually start with heparin, either one, but usually like where I work, we start with our low molecular weight heparin. So we're going to start this immediately. We're going to give them oxygen because we want to correct that hypoxemia. If they're severely hypoxemic, then we're going to do intubation or mechanical ventilation. And then long-term treatment, usually with these patients, we're going to go oral anticoagulant with either warfarin or rivaroxaban. And then we want to make sure that we're keeping the INR on these patients or on these anticoagulants between 2 to 3, okay? Usually these patients will be on anticoagulants for like 3 to 6 months. Like where I work at, they'll be at, where I'm rotating at, they'll be on it for 3 months. And we want to make sure that we are monitoring the INR. Once again, has to be between 2 to 3, okay? Another thing that we can do is we can do an inferior vena cava interruption, like a ICV filter placement. We can also do a pulmonary embolectomy, but usually we'll do heparin with these patients unless we have any type of contraindication to use heparin, like the patient has a history of like subarachnoid hemorrhage or a brain bleed, or for example, they just had like a GI bleed like a week ago. Then we can go and do this, your inferior vena cava interruption, your ICV filter placement, or a pulmonary embolectomy where we go in there and we get the embolus. But usually we start with our heparin. So once again, pulmonary embolism, usually the patient's going to be tachypnic, right? They're going to have trouble breathing. We want to think of pulmonary embolism whenever a patient has been immobilized for a long time. So say if they're post-surgery, especially your orthopedic surgeries where they can't really get up and move. If the patient is also on any type of, for example, hormonal replacement therapy. So if they're on birth control also, especially pregnant women, want to think about pulmonary embolisms if they're presenting with this. Tachycardia, sinus tachycardia is very commonly associated with our pulmonary embolism. So we have a patient that has sinus tachycardia, their oxygen levels just decreased. We want to think about pulmonary embolism, especially if they're like post-surgical. During the burn rotation I'm at, A lot of patients that we have, they have burns. If they have extreme burns, especially to their lower extremities, it's very painful for them to walk. So this is why on these patients, we always put them on DVT prophylaxis. We'll put them on either heparin or we'll put them on our enoxaparin. So we'll put them on these. And actually had a patient the other day on Tuesday who actually had a pulmonary embolism. And so we did a CTA, ended up having a pulmonary embolism, and then we put them on their heparin. And then, so just make sure that you know that. First line, we're going to do a CTA, and it's commonly associated with DVT. You have your saddle embolism, and that's very, very deadly. All right, guys, so now we're going to go into viral pneumonias, or just pneumonias in general. So I'll be discussing each one. So let's go into viral pneumonia. Viral pneumonia, how is this patient going to present? They're going to have this insidious onset. They're going to have this dry cough, low-grade fever, wheezing, rhonchi, crackles. How can we prevent this? Of course, if the patient gets their flu vaccine, right? Also, if they get their pneumococcal vaccine, they can prevent the usually viral pneumonia. On diagnosis, we're going to do a chest x-ray. We're going to see diffuse infiltrates. We'll see it concentrated in the perihilar region. We'll see these reticular line-shaped opacities. Treatment for this is usually supportive, right? Because it's a viral pneumonia. It's caused by a virus. We can do also oxygen monitoring and supplementation. We can give them antipyretics for the fever and also analgesia. Make sure that they're hydrating themselves, so increasing their fluid intake, and then having good diet and activity for our viral pneumonia. So let's go into our bacterial pneumonia. This is an infection of the lung due to microbes. It brings water into the lungs. It makes the patient trouble breathe, so it makes it difficult to breathe. The microbes will basically colonize the alveoli. This will cause an inflammatory response because you have these white blood cells, red blood cells, protein, and fluid in the alveoli. And then we have our lobar pneumonia. This is congestion, usually with these patients. And some of the most common causes of bacterial pneumonia is going to be your strep pneumonia. That's going to be by far your most common cause of bacterial pneumonia. It's going to be your streptococcal pneumonia, especially for your typical community-acquired pneumonias. Other causes are going to be Staph aureus. Now, if it's a neonate, we want to think about group E strep. And then if it's an elderly patient, we want to think about Legionella for bacterial pneumonia. Okay. And then Klebsiella is going to be for our alcoholics. Legionella is usually our organ transplant patients, or if they were exposed to like air conditioning, right? Mycoplasma is going to be our atypical pneumonias, right? This is going to be college students or teens. So depending on the question stem and how it presents, sometimes it'll ask you what is the culprit or what is the bacterial cause of this, and it'll give you all the type of bacteria. So make sure that you know that if it's a young, like college student, we're thinking about our atypical mycoplasma pneumonia, also known as our walking pneumonia, right? If it's an elderly patient, Legionella, especially if they're having neuro and musculoskeletal symptoms. If it's a baby, like a neonate, group E strep. But the most common cause by far is going to be our streptococcus pneumonia. Once again, like I said, alcoholics or current jelly sputum is going to be our Klebsiella. What are some of the risk factors for pneumonia? If the patient smokes, if they have any type of fluid in the lungs, if they have splenectomy, right? These patients don't have a spleen, like your sickle cell patients where they auto-infarct their spleens, or if they had some type of like stab wound or injury where they just don't have a spleen, or some type of hematological disorder or oncology where they had to have their spleen removed, they're more prone to getting these encapsulated bacterial infections, right? So that's why it's really important that these patients get vaccinated with your pneumococcal, because they're more prone to getting these things like pneumonia, because pneumonia most commonly associated with streptococcus pneumonia, right? And then also their immune status, right? If they're immunologically compromised and we're prone to getting pneumonia, we're thinking about our HIV patients or AIDS patient, which I'll be discussing after this in a few minutes. Another thing is patients that are older than 60, and then of course alcohol consumption, they're more prone to getting the bacterial pneumonia. So how is this patient going to present? They're going to have dyspnea, shortness of breath, chest pain. They're going to have this productive cough. Okay, they're gonna have fatigue, fever, chills, tachycardia, tachypnea. When we do our physical exam, you're gonna see dullness to percussion, right? Because they have all this gunk in their lungs. You're gonna hear increased tactile ephemeris. Remember, that's when we do the E. So it's gonna be increased because why? Because sound goes better through anything that's solid, and since you're gonna have a lot of junk in there, that's why it's gonna be increased. You're gonna have late inspiratory breath sounds, arousal bronchi, bronchial breath sounds, bronchophony, oregophony. Also, like I said, Klebsiella is gonna have your current jelly sputum. And then how are we going to diagnose these patients? We're going to do a chest x-ray. We're going to see these patchy areas throughout. And then we're going to see fluid that's going to be localized to a single lobe. Usually consolidation is associated with streptococcus pneumonia, so make sure that you know that. We'll also see leukocytosis. We'll do a sputum culture for these patients also. The thing you need to know about mycoplasma, we said it's associated with what? It's usually associated with our students, right? Our college students. Mycoplasma, we'll see a cold agglutination assay, and we're going to treat usually with macrolide. So once again, mycoplasma, it's going to be a cold agglutinin assay, and we're going to treat these patients with a macrolide. With Legionella, we can do urine antigen, and usually a treatment for Legionella pneumonia, which is going to be that current jelly sputum. You're going to treat them with doxycycline or macrolides. Now, treatment, like it depends on the severity and, of course, the types, like we discussed. But usually we'll give them antibiotics, cough suppressants, pain relievers. And we want to admit any type of patient that has respiratory compromise or sepsis. Or, of course, we have our CURB 65, right? So if they have confusion, if they have urea, a respiratory rate that's greater than 30, if they have a increased blood pressure, if they have a decreased blood pressure, systolic blood pressure less than 90 or diastolic blood pressure less than 60. And then, of course, if they're older than 65, then if they have a score that's 3 to 5, we want to admit these patients for this, okay? So each one of these have a point, CURB 65. So once again, confusion, uremia, the blood pressure, it's usually going to be for these patients low, like we discussed. And then 65, if their age is greater than 65, each one of these have a point. If it's points between 3 to 5, then we want to make sure that we admit these patients because they can have severe complications from their pneumonia. If it's an emergency, then for these patients, we want to make sure that we give them oxygen and fluid resuscitation. We monitor their oxygen. And then another thing is that you also want to admit any type of patient that has any type of immunological suppression, right? So if they have HIV, if they have COPD, if they have a cancer, if they don't have a spleen, right? Like I said, we want to make sure that we admit these patients, okay? Outpatient treatment is usually going to be with a macrolide like azithromycin or clarithromycin. You can also do your fluoroquinolones or like moxifloxacin or levofloxacin. But remember we said we like to avoid our fluoroquinolones because we're learning a lot more about them and they're associated with a lot of side effects. The common one's going to be your tendon ruptures, right? And you don't want to be in trouble for causing a patient to have a tendon rupture, Achilles tendon rupture, right? So for inpatients, if they need to be treated as an inpatient, then we're going to do ceftriaxone, and then we're going to do a macrolide like azithromycin or fluoroquinolone. And then if you want to cover for Pseudomonas, we're going to do our piperacillin or tazobactam for these patients. Okay, so once again, we have our typical, right? The most common cause of typical is going to be Streptococcus pneumonia. We have our atypical also. The mnemonic I have is my clamoring lesion. So it's mycoplasma, your chlamydia, your Legionella. For these, for Legionella, it's usually going to be a patient that has an organ transplant, right? Or if they were exposed to any type of air conditioning. Also, for Klebsiella, it's going to be your alcoholic. So Klebsiella is going to be your current jelly sputum, right? And then we said that mycoplasma is going to be in your college students. Okay, but the most common one for typical is going to be your Streptococcus pneumonia. All right, guys, so let's go into our next one. It's going to be our fungal pneumonia. This is very, very rare, but we still need to know about this. So we have our different types. So it's going to a blastomycosis. This is usually going to be found on the east of Mississippi. So Central America, also soil and rotten wood. Usually these patients will get this from inhalation, soil and rotten wood, like I said. They're going to be presenting with fever, night sweats, weight loss, skin and lung granulomas. We're going to diagnose this by doing a histology and culturing it, and we're going to treat them with amphotericin B and itraconazole, right? Because this is a fungal infection. Next one's going to be coccidiomycosis, commonly found in California, southwestern USA, and Latin America. The arthrospores are usually inhaled. This patient is going to be presenting with mild lung infection, usually asymptomatic. Mild pneumonia. Dissemination will lead to bone granulomas or meningitis. They can also be presenting with erythema nodosum. We're going to diagnose this by doing a serological testing and also getting some chest x-rays, some imaging. Treatment for this is going to be similar to blastomycosis, which is going to be amphotericin B or itraconazole. Sorry guys, these are antifungal medications. Next one's going to be histoplasmosis. This is commonly found in Ohio, Mississippi River. It's usually found in bird or bat droppings in soil. Usually they inhale this. It's spread very quickly. So how I memorize it is that it has histo and then it's Ohio. That's how I memorize it. So histoplasmosis, Ohio. This patient's going to be presenting, usually they can have an asymptomatic infection or they'll have mild atypical pneumonia symptoms. It's usually disseminated in patients that are immunocompromised. We're going to diagnose this. We're going to see budding yeast within macrophages. And once again, treatment is going to be amphotericin B and itraconazole. So amphotericin B, has a lot of side effects. So just remember that also, right? It's called the amphoterrible. Cryptococcosis. This is anywhere in the soil, U.S. It's found anywhere in the U.S. Okay, it's usually found in soil with bird droppings. Humans will usually inhale this yeast. These patients can be asymptomatic, but it can cause pneumonia. They'll have these if they do have symptoms, they'll have these bone or skin granulomas, and this can also cause cryptococcal meningitis if it's disseminated. Usually, for these patients, we're going to do a fungal culture, histology, serum, cryptococcal antigen, and radiology, and then treatment's going to be with amphotericin B and fluconazole. Next one's going to be aspergillosis. This is airborne. It's going to be saprophytic molds. It's an invasive necrotizing pneumonia, especially in patients that have AIDS or even patients that are immunocompromised. I had a patient that had like more than 90% burn injury. Can you imagine? It's more than 90% of their body is burned, and they had both deep partial thickness wounds and full thickness burns throughout their body. He came in August, like August 20 something, and we had been treating him since August. He was in the OR back and forth because we were grafting him with skin to the areas, or we were cutting out necrosed tissue, or we're having to amputate limbs. But I thought he was going to make it, and unfortunately, this week he passed away, and he passed away because he got a really bad aspergillus infection. And so once again, aspergillosis is very, very deadly, especially in those patients that are immunocompromised, like in this patient. We were rooting for him. He would get these recurrent bacterial infections. We were treating them. He's fine. And then he got this aspergillosis and he passed away from it. So this is very, very deadly. We're going to diagnose this with a sputum culture or fungus ball and chest x-ray or CT. Treatment for this requires surgery. You can give them itraconazole or voriconazole, but like I said, this is very, very deadly with aspergillosis. So now we're going to go into our HIV-related pneumonia. This is very highly tested, so make sure that you're familiar with this, okay? This is opportunistic infections on a patient that has a weak immune system, right? That have HIV or even AIDS. So AIDS is characterized as a CD4 count that's less than 200, right? So the most common bacterial pneumonia that's found in these patients with AIDS is going to be your Pneumocystis jirovecii, your PCP, okay? Pneumocystis jirovecii, commonly found in patients that have HIV, but not only patients that have HIV or AIDS, it's commonly also found in patients that are immunocompromised, especially your organ transplant patients. We saw this a lot during my nephrology rotation in patients that had kidney transplants. So any type of patient that has also any type of organ transplant, they're prone to getting this type of bacterial infection. These patients are going to be presenting with fever, dyspnea, a dry cough, wheezing, shortness of breath, fatigue, chest pain. They're going to be very hypoxic. The best initial test is going to be a sputum culture, okay? We're also going to do a chest x-ray. On chest x-ray, we're going to see bilateral diffuse infiltrates, and the most accurate test is going to be a bronchoalveolar lavage. And treatment for this is usually going to be a Bactrim. Usually we also give Bactrim as prophylactic, especially if a patient has a CD4 count less than 200. We want to give them prophylaxis for your PCP, for your pneumocystis jirovecii pneumonia. So we usually give them Bactrim as a treatment and Bactrim as prophylactic. Now, if the patient is allergic to Bactrim, then we can give them a dapsone. Okay. So now I'm going to go into acute bronchitis. So this is an inflammation and infection of the bronchi. It involves the upper airway. And with these patients, the most common cause, or some of the common causes, are smoking, COPD, cystic fibrosis, if they have alpha-1 antitrypsin deficiency. Some of the common causes, if it's a bacterial cause associated with acute bronchitis, is going to be your Streptococcus pneumonia, Haemophilus influenza, Mycoplasma catarrhalis. Okay. This patient is going to be presenting with cough with or without sputum for 1 to 2 weeks. They're going to have dyspnea, chest pain, shortness of breath. They may or may not present with a fever. On your physical exam, on your pulmonary exam, you're going to hear normal, or you might hear some bronchi, but you're going to hear wheezing, and it's usually bilateral. Diagnosis is usually clinical. You can do a sputum culture, but we usually don't. If we do a chest x-ray, though, it's going to be normal. And then our treatment for these patients, we want to give them something like amoxicillin or a macrolide, like azithromycin, and then cough suppressants and bronchodilators. So next one's going to be our aspiration pneumonia. This is an introduction to foreign materials into the lungs. Some of the risk factors are altered mental status, if the patient has an impaired cough reflex, impaired swallowing. Okay. Also, I've seen this in patients that were like vomiting for a long time. They just like aspirated this. And some of the common causes of this is alcoholics, if they have some type of alcoholism history. Also, patients that have like any type of like acid reflux, also a severe like GERD. The most common organism involved in aspiration pneumonia is going to be your Fusobacterium. This is usually mixed anaerobes from the oral flora. And these patients are going to be presenting with cough, fever, decreased oxygen, and increased tactile firmness. So now we're going to go into influenza. So influenza, the flu, we have 3 different types of influenza. We have A, B, and C, okay? And this usually tends to spread via droplets. The influenza comes from the orthomyxovirus family, and type A is actually the most severe one. So the most common ones we see are type A and type B, right? Usually during the flu season. Type A is usually the one that's usually has more severe symptoms, and it's one that most commonly can cause mutations, and it can cause pandemics also. Usually the incubation for this is 1 to 4 days, and it causes fever, chills, headache, malaise, sore throat, cough, coryza, runny nose, myalgia, aching. These patients are going to be leukopenic. Diagnosis, we're going to do a rapid influenza diagnostic test. Right? It's going to tell us the patient has strep, but it won't tell us which strain. We can do a viral culture PCR. Treatment for this is usually bed rest, right? Tell them to increase their fluids, to stay away from people, if to avoid going outside, right? Because we want to make sure we're not spreading this to other individuals. If you need to give him treatment, you can give him also Tamiflu, but you only give him Tamiflu if this patient has been having symptoms for less than 48 hours. If the patient is coming to you and they're on the 3rd day, we don't give them also Tamiflu, okay? Because it's not going to do them any better. So usually on your question sim, I actually had a question on this the other day. It gave me 3 different patients, and it asked me who would I give this to. So if one of the patients had symptoms for more than like 3 days, then I wouldn't give him also Tamiflu. We want to make sure that we're giving this within 48 hours for our oseltamivir or Tamiflu. Okay. Usually these patients will get better in a week, and they don't really need any type of treatment. If we do give them treatment, we can give them something like an antitussive, right, for their cough. Of course, we want to stay from antibiotics, right, because it's a viral infection. So we can give them also something for their fever, so antipyretics, but it's usually just symptom treatment, usually just rest for these patients, and tell them it's going to go away in a week. Prevention for this, of course, is that the flu vaccine, right? We want to make sure these patients get their flu vaccine. So tuberculosis is going to be the next one. This is a bacterial disease that primarily affects the lungs, commonly found in patients that are like immigrants, especially if they're immigrants from a third world country. The most common pathogen is going to be your Mycobacterium tuberculosis, and it's transmitted through respiratory droplets. Patients that are high risk for tuberculosis are your IV drug users, any individual that had contact with a patient that was diagnosed with tuberculosis, your immunocompromised patients like our HIV, diabetes mellitus, if they're in prison, nursing homes, alcoholics, homeless shelters. These patients are going to be presenting with this chronic productive cough, hemoptysis, fever, fatigue, night sweats, weight loss. So whenever I read a question set and I see all that, I want to rule out cancer and tuberculosis for these patients. But if I see in the question set that they're an immigrant, they're in prison, then I'm leaning more towards tuberculosis. How are we going to diagnose this? We're going to start with the PPD. It's positive, then we're going to send them for a chest x-ray. We're usually going to see cavitation, especially in the apical region of the lungs for these patients. And then we're going to do a sputum culture, right? We're going to do our acid-fast bacillus for these patients. All patients that are positive are going to get a chest x-ray and a sputum stain, right? You're going to stain for the acid-fast bacillus. Another thing that you need to know is that if you get a PPD test, it's positive if what? Like how big does it have to be positive and in what individuals? This is very highly tested. So if it's greater than 5 millimeters, it's going to be your patients that are HIV, recent TB contact, organ transplant, and immunosuppressed. This is going to be positive, okay? So anything greater than 5 millimeters is going to be positive in these individuals. Anything greater than 10 millimeters for your PPD is going to be positive for any patients that are your immigrants, your IV drug users, any individual that works in healthcare, right? So for example, us that are rotating, children under 4 also, which is interesting. I didn't know that, but children under 4 more than 10 millimeters is positive for tuberculosis if they get a PPD. Next one's going to be greater than 15 millimeters is going to be positive with any person that has no known risk factors for tuberculosis. So make sure you know this is very highly tested. Treatment for this is going to be our RIPE therapy, right? Our rifampin, isoniazid, our pyrazinamide, and our ethambutol. We're usually going to give this for 6 months, and we want to make sure that we supplement with vitamin B6, right? Because which medication can cause your neuropathies? It's going to be, which one from the RIPE? It's going to be our isoniazid. So isoniazid, we always want to make sure that we're giving vitamin B6 because it can cause neuropathies. This is very highly tested. So make sure that you know this. I had a question the other day that gave me a patient that had tuberculosis. I knew they were on the RIPE therapy, and it told you what could have, this neuropathy could have been prevented if the patient received what? And it was vitamin B6. If they received this, they would have not had this neuropathy because that's what isoniazid is associated with. Okay. So like I said, they're usually on RIPE therapy for 6 months, and we want to make sure that we report to local and state agencies. We repeat the chest x-ray and sputum test to confirm the treatment. Okay. If they have latent tuberculosis, usually they're going to be presenting with bacteria in the body, but they're not going to have any symptoms and they're not contagious. So another thing that you need to know is what are some of the things that the drugs are associated with. So our ethambutol is going to be our red and green eye discoloration, right? And then we have our rifampin, which is going to be like our orange, like urine discoloration, okay? So make sure that you know that. We said that our isoniazid is neuropathy, so we want to make sure that we give these patients vitamin B6. So now we're going to go into our pertussis. So pertussis is going to be that whooping cough, right? This is very preventable if the patient gets vaccinated. That's why we vaccinate with DTaP or Tdap. And it's due to the bacteria called Bordetella pertussis. It's very highly contagious for these patients. They're going to be presenting with whooping cough. They'll have this paroxysmal coughing fits, and they'll have this post-tussive emesis. So basically they'll cough and then they'll vomit. And there's different phases, so make sure you know this. This is very highly tested. So you have your catarrhal phase, which is 1 to 2 weeks. Basically, these patients have an early cold-like symptoms like cough, rhinorrhea, and fever. You have a paroxysmal phase, which is 2 to 6 weeks. They'll have these coughing fits of whooping cough. They're like, so this is where they have that whooping cough. They'll have vomiting, and they'll have this inspiratory stridor. So once again, the paroxysmal phase is where you're going to have the whooping cough and the stridor. This is very highly tested, so make sure you know that. The convalescent phase is going to be 2 to 3 weeks. They're going to be susceptible to other infections, and usually with this one is where they're gradually recovering. Okay, this is be after the paroxysmal phase. So diagnosis, we're going to do a CBC, we're going to see lymphocytosis, we're going to do culture of the nasopharyngeal aspirate, and chest x-ray, which is going to show us atelectasis during the paroxysmal stage. Treatment, infants less than 2 months, we want to make sure that we treat and vaccinate these children, right? Vaccination is a prevention for Bordetella pertussis. If they need to be treated, we're going to give them antibiotics like azithromycin, clarithromycin, and or erythromycin, but usually your antibiotic of choice is going to be your erythromycin, and make sure that we're monitoring these patients close. So now we're going to acute bronchiolitis. So acute bronchiolitis is an inflammation of the smaller airway, okay? Usually there's increased mucus production that causes like this thicker walls, and the airway becomes narrow. There's bronchospasms and airway obstruction, and this is very contagious. It can cause atelectasis, air trapping, and then it can lead to hypoxia. The most common cause of acute bronchiolitis is always going to be a viral cause, and the most common cause is going to be your RSV virus, right? This is the most common cause of acute bronchiolitis. So this is very highly tested. Make sure you know this. There's other causes like your adenovirus and your rhinovirus, but the most common one by far is going to be RSV. I think it's respiratory syncytial virus. Correct me if I'm wrong, but it's going to be your RSV. Commonly found in children and infants under 2, and it peaks at 2 to 6 months, especially during winter months. So very commonly found in children, winter months, and I was actually reading an article the other day. Babies are premature are also very commonly associated or more commonly prone to getting acute bronchiolitis. How's this patient going to present? Like I said, it's going to be a baby, right? An infant, child. They're going to have coughing, sore throat, congestion, wheezing, crackles. They're going to have clear rhinorrhea. They're going to have fever, dyspnea, otitis media, and they'll have prolonged expiratory phase, and they also have clubbing. They'll have the nasal flaring. So whenever I see that, it's because the baby is really in distress when they're breathing, and they're really trying to breathe. So whenever I read a question stem and I see that they have the nasal flaring, they have these retractions, grunting, then I think about RSV, especially if it's during the winter and if it's a baby, newborn, an infant, then I want to think about RSV or bronchiolitis, okay? They'll also have a hyperresonance of the lungs, they'll have apnea. How are we going to diagnose this? It's usually a clinical diagnosis. We want to make sure that we avoid, right, any type of imaging because usually these are infants or children. We do a pulse ox. If we do a chest x-ray, we'll see the atelectasis, air trapping, diaphragm flattening. We can also test them for any viral caused by ELISA, PCR, CBC, right? We do our CBC to see if they have, how's their white blood cell count. And then treatment for this is usually supportive, hydration, fluids. We'll do nasal suctioning, control fever. We'll give them oxygen. And if it's severe, depending on how the child is presenting, and also if they have any type of past medical history, like if they have a history of some type of congenital, like heart defect, like the ventral septal defect or anything like that, or if they're a history of preemie babies, right? We want to make sure that we admit these patients. We give them hospital IV fluids and oxygen. How can we prevent acute bronchiolitis? So we can actually do palivizumab monthly injections. So we can do this, especially in patients that are more prone to getting this, like patients that have a history of any type of lung disorder, like if they're preemie babies, right? If they have any type of cardiac condition, then we can do these type of monthly injections. Some of the complications of acute bronchiolitis is going to be our dehydration, apnea, aspiration, pneumonia also. So now when we discuss RSV, right? Because we said RSV is going to be the most common cause of acute bronchiolitis. So let me try to pronounce this again. It's a respiratory syncytial virus. It's transmitted via droplets when someone sneezes or coughs, and it targets respiratory epithelial cells. It's from the family of paramyxovirus, and it's a leading cause of hospitalization in children under 5, right? Because that's what we discussed, and it causes acute bronchiolitis, commonly found during the winter. These patients are going to be presenting with low-grade fever, tachypnea, rhinorrhea, coughing, wheezing, dyspnea, cyanosis, retractions, hyperinflated lungs. Diagnosis, we'll do a nasal watch, we'll do pulse oximetry, chest x-ray, we'll see some atelectasis or air trapping, CBC to look at their white blood cell count, right? Throat swab, PCR. Treatment for this is supportive care, hydration, humidification, ventilatory support if needed. And then in older children, we can do bronchodilators and corticosteroids. So now we're going to go over croup, also known as laryngotracheal bronchitis. This is inflammation of the upper respiratory tract, okay? This causes mucosal edema that causes increased airway resistance. Most common cause of croup, make sure you know this is very highly tested, it's going to be your parainfluenza virus and also our RSV. But the most common one is going to be your parainfluenza virus. Usually you're going to have a young child between the ages of 6 months to 3 years old, commonly found during the fall and winter, more commonly found in males and females, and it tends to follow a common cold. The patient is going to be presenting with a seal-like barking, right? So that's a seal-like barking cough. They're going to have this brassy cough, hoarseness, inspiratory stridor, okay? Hypoxia, respiratory distress. How are we going to diagnose this? We're going to do a pulse ox, heart rate, respiration rate, CBC, and then on chest x-ray, we're going to see that steeple sign, okay? So chest x-ray is going to be that steeple sign. Make sure you know this. Sometimes I'll just give you a chest x-ray and you'll see that steeple sign. So steeple sign, we want to think about croup, right? Usually it's going to be subglottic narrowing. Treatment for this is racemic epinephrine. You can also give them also either oral or intramuscular dexamethasone plus cool mist humidifiers, okay? So once again, croup, it's caused by what? Parainfluenza virus. They're going to have this seal-like barking cough. Diagnosis, we're going to do a chest x-ray. You're going to see that steeple sign. Treatment is going to be your racemic epi plus corticosteroids. Dexamethasone, for example. So now we're going to go into acute epiglottitis. This is a life-threatening bacterial infection. It's a bacterial infection of the epiglottitis. Okay, so we said that croup was what did it involved? So for croup, we said that they have inspiratory stridor, right? We said it was seal-like barking cough, right? And then for our acute epiglottitis, this is a bacterial infection of the epiglottis. It causes inflammation and swelling of the epiglottis. Some of the common causes of this is usually going to be found in a child that is not vaccinated, okay? They're not vaccinated, and the most common organism associated with these patients is going to be Haemophilus influenza type B. What if the patient's vaccinated? What's the other cause? It's going to be your Staph aureus. So make sure that you know that. Sometimes they try to trick you on that. You'll see a question stem, and then you're like, oh my gosh, I know this. This is like epiglottitis. And then it tells you what's the most common bacterial cause. And then I chose, of course, right, we thought Haemophilus influenza. And I chose that, and of course I got it wrong, okay? And which type of Haemophilus influenza? Type B, because we have different types. They'll trick you like that. They'll put A and B. Haemophilus influenza type B. Anyways, for this question stem, I chose Haemophilus influenza type B because I'm like, yeah, I know this. And then it ended up being Staph aureus because the patient was vaccinated. So if they're vaccinated, or if it's an older individual, we want to think about Staph aureus. But if they're unvaccinated, it's going to be Haemophilus influenza type B, okay? How's this patient going to present? They're going to have a high fever, sore throat. They're going to have 3 Ds, right? They're going to be drooling. They're going to have dysphagia. They're going to have that tripod position, right? They're going to be sitting like this, like trying to breathe. They're going to have dysphagia. They're going to have this hot potato voice also, and they're going to have this anxious appearance. They're going to have inspiratory stridor, retractions, cyanosis. They're going to appear toxic. These patients are in respiratory distress. Diagnosis, we're going to do an x-ray. We're going to see the thumbprint sign. Okay, so thumbprint sign, we said is for acute epiglottitis. We said the steeple sign is for what? Croup. We're going to do a throat culture, blood test, oxygen saturation test, right? For these patients, we want to admit them, do airway management, intubate them, give them oxygen. We're going to give them IV antibiotics or 3rd-generation cephalosporin plus an anti-staphylococcal agent against MRSA. Because we said another common cause of this is what? It's going to be your Staph aureus. And we can give something like clindamycin or vancomycin, and of course corticosteroids. So just for a recap, acute epiglottitis, we said, right? This is usually an inflammation of the epiglottitis. It's a bacterial infection, commonly associated with children that are unvaccinated, right? Haemophilus influenza type B. But if they're vaccinated, or if it's an adult, it's going to be what? Staphylococcus aureus. They're going to have this hot potato voice. They're going to have the 3Ds, drooling, dysphagia, distress. They're going to have this hot potato voice. They're going to have that tripod position, right? And we're going to do a chest x-ray. We're going to see what, on exam, we're going to see the thumbprint sign, right? Because we're going to have that inflammation of the epiglottis. And then for these patients, we want to make sure that we admit them. We do airway management. We don't want to stick anything down their throat that's going to make the inflammation worse. We want to protect that. So if we need to, we're going to intubate them to protect that airway. We're going to give them IV antibiotics, right? And corticosteroids. All right. So now we're going to go into alpha antitrypsin 1 deficiency. What you need to know about that is that it's due to a misfolded A1AT. Usually when it's functioning normally, it inhibits elastase, but since it's not, then it's not able to do that. So these patients will also present with lung and liver disease, okay? So if they don't have this alpha antitrypsin, there's going to be elastase that's going to be overactive, and it's going to be destroying elastic tissues, and it's going to result in emphysema and cirrhosis, okay? How's this patient going to present? They're going to have shortness of breath, rales, rhonchi, wheezing. They're going to have a barrel chest, hepatomegaly, lung infections. These patients are also prone to getting like liver disease, like I discussed. Diagnosis, we're going to do an x-ray. We're going to see hyperinflation of the lungs. They're going to have increased LFTs. We're going to do a spirometry. We're going to see decreased FEV1. And then also an FEV1/FVC that's going to be decreased. We're going to see an increased total lung capacity. On biopsy, we can also do a biopsy for them. And treatment for this is basically, if it involves like the lungs or liver transplant, it's usually a surgical treatment for these patients. Okay. And then treatment, we can also do IV pulled alpha antitrypsin. So next one, we're going to go into pleural effusion. This is due to increased fluid drainage in the pleural space. It causes increased production of fluid by cells in the space or decreased drainage of fluid. The most common cause of a pleural effusion is going to be congestive heart failure. Other causes are bacterial pneumonia, any type of malignancy like cancers, pulmonary embolism, viral diseases, cirrhosis. So we have different types of pleural effusions. This is very highly tested, so make sure you know this. We have our transudative and our exudative. So our transudative, the most common cause is going to be by far congestive heart failure, like we discussed. Other causes of transudative are going to be cirrhosis, nephrotic syndrome, peritoneal dialysis, hypoalbuminemia, atelectasis, pulmonary embolism. So you'll get a question stem, and you'll know this patient has a pleural effusion, and it'll ask you which one of these is associated with the transudative, and it'll give you a bunch of them. So you have to know that congestive heart failure is the most common one. Now, for exudative, this is going to be anything that's bacterial. So we have bacterial pneumonia, tuberculosis, any type of malignancy, viral infections, collagen vascular diseases also. How is this patient going to present? Usually they're asymptomatic. If they do have symptoms, they're going to have dyspnea on exertion, peripheral edema, orthopnea. You're going to have dullness to percussion, okay? Decreased breath sounds, and then decreased tactile fremitus, which makes sense, right? Because they have all this gunk in their lungs. Diagnosis, we're going to do a chest x-ray. We're going to see blunting of the claustrophrenic angle. They're going to have 200 milliliters of fluid. And then we want to make sure that we're getting the lateral decubitus position, right? Because we want to make sure that we're looking at that fluid. Usually CT scans are more reliable. We're also going to do thoracentesis. This is diagnostic as well as therapeutic. And then this is where we use the Lights criteria also. So we have to make sure that we're familiar with the Lights criteria. If it's transudated, we're going to see clear or straw-colored fluid. And usually with transudative, they don't meet the Lights criteria. Versus exudative, these are going to meet at least one of the Lights criteria. So these patients are going to have, with exudative, cloudy fluid. They're going to have immune cells. They're going to have a lot of protein. So high protein and high LDH is going to be characteristic of our Lights criteria. Treatment for this, if it's transudated, we're going to give them diuretics and sodium restriction. We can also do therapeutic thoracentesis. If it's an exudated, we want to do thoracentesis and, of course, treat the underlying disorder, right? If it's a cancer, we want to make sure we treat that. If it's bacteria, pneumonia, tuberculosis, and we want to make sure that we treat that. So now we're going into our bronchogenic lung carcinoma. So bronchogenic lung carcinoma is divided into two groups. We have our small cell lung carcinoma, and then we have our non-small cell lung carcinoma. So the most common risk factor for lung cancer is going to be smoking. That's about 85% of the cases is smoking. Okay, other causes are secondhand smoke, asbestos, radon, like basements, COPD. Okay, they're going to be presenting with anorexia, weight loss, night sweats, generalized weakness, cough, dyspnea, hemoptysis, chest pain, recurrent pneumonias also. We're going to diagnose these patients with a chest x-ray, and usually we see a coin lesion. And then we use a CT without contrast for staging, okay? We can also do a sputum culture, we can do fiber optic bronchoscope, and then a PET scan if we need to see how much it's been metastasized, and if it's metastasized to other organs or other parts of the body. We usually also do a transthoracic needle biopsy. This is very accurate, and it's going to tell us what type of cancer the patient has, but it's very invasive, and it's best for any type of peripheral lesion. So now let's get into each one. So we have our small cell lung cancer. This one's fast spread, and it's rarely cured with resection. It's very aggressive, so these patients have a medium survival if they're not treated. And it's usually centrally located. So how I memorize it is that S, anything that starts with S in regards to cancers is centrally located. So small cell lung cancer, centrally located. Squamous cell lung cancer, that's centrally located. So once again, anything that's S, it's centrally located when you do an X-ray. So small cell, you're going to have a central lesion, most commonly found in females. They're going to have a long history of smoking. Paraneoplastic symptoms are also associated with small cell. This is very highly tested, so make sure you know that. You have your SIADH, so syndrome of inappropriate antidiuretic hormone is associated with small cell lung cancer. Ectopic ACTH also. Eaton-Lambert syndrome, which is where the autoantibody destroy neurons. These patients have symptoms similar to the myasthenia gravis. They'll have paroxysm. They have proximal muscle weakness, diminished deep tendon reflexes, and paresthesias, but it's not myasthenia gravis, okay? The thing about myasthenia gravis, I know I'm jumping, we're going to go discuss neuro later. The thing about myasthenia gravis is that with these patients, basically they're going to have the ptosis, right? And it's going to be worse with the more you use it versus your Eaton-Lambert syndrome. It won't be worse with the use, okay? So that will not affect. So that's how you can differentiate between these. Diagnosis staging for small cell lung cancer, usually it's limited. It's usually confined to the chest. And then if it's extensive, then it's going to be outside of the chest for our staging. Treatment, like we discussed, is limited. We can do chemo and radiation. We can't really do resection for these patients because it's very aggressive, like we discussed. And we do chemo initially if it's extensive, and then we do prophylactic radiation. And then, like I said, surgery, usually not resectable. So now we're going to go into our non-small cell lung cancer. This one spreads a lot slower, and this one's more commonly than the small cell. So about 85% of the lung cancers are going to be non-small cell cancer. They will spread slowly. They can be cured with resection. So we said that anything that starts with an S, right, is centrally located, is caused by smoking. So we said that our small cell lung carcinoma, centrally located, smoking, right? And then we said that our squamous cell, which is a type of non-small, this one's also centrally located, and it's commonly found in smokers, okay? So next we're going to go into is adenocarcinoma. It's a type of non-small cell carcinoma. This is the most common type. And with this one, it doesn't start with an S, so this one's going to be peripherally located. Usually it forms glandular structures and generates mucin. It's low association with smoking. And then you have the large cell, which is usually peripheral lesions, and it can present in proximal tissue. This is the least common. How we can diagnose this? We usually do staging via the TNM, so tumor size, lymph node involvement, metastasis system, so the TNM system. Surgery is going to be the best option for non-small cell carcinoma. With metastasis, of course, these patients are not candidates for surgery. And then if it's advanced, we can do chemo. We will do chemo and radiation. Some of the complications is that the most common sites of metastasis, you have to know this is very highly tested. It's going to be your lymph nodes, brain, bone, adrenals, and liver. You tend to have superior vena cava syndrome with 5% of patients. They can have obstruction of the superior vena cava by mediastinal tumor. It's most commonly associated with small cell lung cancer. And then symptoms of your superior vena cava syndrome, it's going to be your facial fullness, face and arm edema, dilated veins over the anterior chest, arms and face, and then jugular venous distension. Okay. Pancoast tumor is also associated with these lung cancers. Usually with Pancoast tumor, it's going to be an apical tumor involving C8, T1, and C8 and T1 nerve roots. They're going to have presenting with shoulder pain that radiates down the arm. Usually this is commonly associated with squamous cell carcinoma. Symptoms is going to be pain, upper extremity weakness associated with Horner syndrome also. And then we have Horner syndrome. This is invasion of cervical sympathetic chain by an apical tumor. This patient is going to be presenting with upper facial or lower facial anhidrosis, ptosis, and meiosis. Okay, so real quick on the blueprint, there's things that are just like, remember how we discussed, there's specific diseases you need to know, and there's things that are broad, like abdominal pain, right? There's a lot of things that can fall under that. So shortness of breath, what do we want to think about when a patient has shortness of breath? So differential diagnosis, we want to think about COPD, right? They're having some type of COPD exacerbation, asthma exacerbation, pulmonary embolism, hemothorax, anaphylaxis can present with shortness of breath, inhaled foreign body, pneumothorax, pneumonia, and pleural effusion. And then we have wheezing, asthma, foreign body aspiration, cystic fibrosis, GERD, RSV or bronchiolitis, pneumonia or anaphylaxis can present with wheezing, hemoptysis, which is your blood whenever you cough. Differential diagnosis we have for this is pulmonary embolism, tuberculosis, pneumonia, lung cancer, lung abscess, arteriovenous malformation, bronchiectasis, airway trauma, foreign body aspiration, Goodpasture syndrome, and then we have pleuritic chest pain. We have asbestos, medication-induced also pulmonary embolism, myocardial infarction, pericarditis, pneumonia, tuberculosis, pneumothorax, systemic lupus erythematosus, SLE, Wegener syndrome, malignancy, and iatrogenic, like a chest tube, can cause pleuritic chest pain also. Okay? All right, guys, so we are actually done with Pulm. So why don't we go into our next topic, which is going to be neurology. So neurology is going to be 8% of your exam for your ER exam. So let's go into migraine headache. So migraine headache, with these patients, they tend to have a strong family history. So let's say that their mom had a history of migraines, more commonly found in females especially under the age of 30. And then it's the most common type of headache pain in the emergency room that you're going to see. So your classic migraine is going to be your migraine with an aura. So an aura is where they have some type of neurological symptom occur before or during the headache. So something that tells them that the headache is going to occur. But the most common type is going to be migraine without aura. So once again, you have your classic migraine with aura, but it's not as common. Migraine without aura is the most common type. Some of the causes of migraine can be stress. Also, if the patient is on oral contraceptives, menstruation also, foods with tyramine or nitrates, and they tend to last between 4 to 72 hours. This is what differentiates a migraine from all the other headaches that we're going to discuss. So think about the timeline and how this patient is going to present. So like I said, lasts between 4 to 72 hours. How is this patient going to present? It's going to be unilateral. It's not going to be bilateral, how we'll be discussing the other headaches. This is going to be unilateral. It's going to be gradual onset. They're going to have this aura like we discussed, nausea and vomiting, photophobia and phonophobia. So they have sensitivity to light and sound. Diagnosis is usually a clinical diagnosis. The mnemonic I have is POUND. So it's going to be pulsatile, 1-day duration. It's going to be unilaterally located, nausea, and then D is going to be for disabling intensity. Okay. Treatment for us, it's going to be initially we want to start with our triptan. So sumatriptan, we can also do ergotamine. We're going to give them antiemetics because most of these patients have nausea or vomiting. Acetaminophen. For prophylactic, say that this patient has recurring episodes, then we can give them something like a beta blocker like propranolol. That's actually the most common one. This is going to be the test, the answer choice on your exam. You can also give them calcium channel blockers or topiramate. And then, of course, educate them on their behavior, right? So make sure that they're sleeping appropriately, They're avoiding food that can trigger it. Caffeine can sometimes trigger this. Have good sleep hygiene. Make sure that you're drinking a lot of water. So once again, migraine headache, it's going to be unilateral. It's going to be pulsing. They're going to have photophobia, phonophobia. Okay. Cluster headache. This one is more commonly found in males, especially males between the ages of 20 to 40. This is how it's going to present on your exam. It doesn't always present like that in the ER, right? But on your exam, textbook-wise, 20 to 40, okay? Usually, patients that have alcohol will be, or just had alcohol, can present with a cluster headache. It's more commonly found in males, and it's better with activity. Symptoms, it's going to be periodicity. They're going to have this sudden onset severe unilateral pain, and they'll have periorbital symptoms. They'll have a deep burning, searing, stabbing pain. They'll have tearing, rhinorrhea also. They'll have Horner syndrome, eyelid edema, facial sweating, restless, agitated. They'll have tearing and rhinorrhea, like I said. Ptosis also. The diagnosis is clinical. And then treatment for this is initially want to start with triptans subcutaneously, but we want to make sure that we give these patients oxygen, right? We're going to give them 100% oxygen. That's usually the treatment for the cluster headache. Prophylactic, we're going to give them a calcium channel blocker like verapamil. So once again, cluster headache commonly found in males. It's going to be usually severe unilateral pain, but what differentiates it from migraines is that they're not going to have the aura. They're going to have tearing and rhinorrhea also associated with this. We're going to have Horner syndrome also. And we're going to treat this with oxygen, 100% oxygen, or your triptans, okay? And then we have tension headache. This is the most common type of headache, but usually a lot of patients that have tension headaches won't go to the ER, right? So that's why we say migraine is the most common type of headache you're going to see in the ER, but a tension headache is the most common headache in general. Usually it's commonly associated with depression, anxiety, stress. It gets worse throughout the day, and sometimes they even have stress muscles of the neck that can cause the headache, okay? Symptoms is that it's going to be a bilateral headache. It's usually described like a vise-like, that they're wearing something around their head, and that's how the pain is. It's going to be steady, aching. It's like a tight band around my head. They have intense pain around the neck or posterior head. They have tightness in their posterior neck muscles. No changes with movement with these patients. And then treatment, we want to make sure that we identify anything that's triggering and tell the patient to avoid it. Things like sleep deprivation, dehydration, hunger can cause these tension headaches. Complication is that they can have rebound headaches. Treatment for this is just NSAIDs, right? So your over-the-counter ibuprofen, aspirin, acetaminophen. We can do prophylaxis if these patients tend to have recurrent ones. So your TCAs like amitriptyline. And then we're going to go into head trauma or traumatic brain injury. So usually with head trauma and traumatic brain injury, it can result in epidural, subdural hematomas. It's usually commonly found in patients that are like athletes. So we have different types. We have our epidural hematoma and then our subdural hematoma. So with epidural hematoma, they're going to have a brief lucid interval before they start declining. Okay, so brief lucid interval, they're completely fine, and then they just start declining after that for epidural. Subdural hematoma, it's slower. They tend to have symptoms like days to weeks. And then we have our mild traumatic brain injury, which is loss of consciousness. The patient stays, they'll have amnesia, focal neurological deficit. Post-concussion syndrome, also persistence of symptoms of mild traumatic brain injury beyond typical recovery time frame. Okay. So how are we going to diagnose this? If they have a traumatic brain injury and they have loss of consciousness, we want to get a CT without contrast, okay? And then, of course, we want to make sure that we get imaging on any patient that has a worsening headache. They have repeated vomiting, drowsiness. They have confusion, dysarthria, where like they're just not speaking properly, like they just like word garbage. If they have focal neurological findings, and then with the athletes, with your concussions, for example, they need to be removed from play, and they have to undergo sideline assessment. Post-traumatic headaches, usually we want to give them NSAIDs and triptans. If it's an epidural hematoma, these patients need to go to the surgery, and they have to have emergent evacuation, okay, of the blood to prevent death. If it's a subdural hematoma, usually if this patient is stable or asymptomatic, we want to observe him. But if it's large, we want to go in there and drain it, okay? And then we have intracranial hemorrhage. With these patients, no steroids usually. If it's a large and they have a massive effect, so you want to intubate them and give them mannitol to decrease the intracranial pressure, or we can go and do surgical evacuation for our intracranial hemorrhages. So these are head trauma. This is what's going to fall under the head trauma or traumatic brain injury. So now we're going to go into concussion. So concussion, this is a minor traumatic brain injury, usually due to like head trauma if the patient hit their heads during sports, motor vehicle accidents also. They're going to be presenting with headache, dizziness, confusion, amnesia, difficulty concentrating, blurred vision, but they're not going to have any focological findings, neurological findings. So no neurological focal findings. They can have nausea, vomiting, balance problems. They're going to be irritable, depressed, anxious. They're going to have increased emotions, sleep disturbances, insomnia. They can also have brief loss of consciousness. Usually imaging is not needed in these patients. But if they do have a traumatic brain injury with loss of consciousness, then we do want to get a CT without contrast. Treatment for this is just rest. You want to make sure that they avoid sports, and then make sure that they're just observing and looking for symptoms that are like red flags. Like I said, if the nausea and vomiting is persistent, headache is persisting, then you want to make sure that they go and see their primary care doctor. Okay? So next one's going to be delirium. So delirium, make sure that you don't confuse this with dementia, which I will go in detail after this. So delirium is waxing and waning. Basically, the patient will come and go out of dementia. It's an acute presentation, and it lasts hours to weeks. Commonly found in older patients that have morbidities. Also patients that have polypharmacy. It mimics depression and dementia, but it has an abrupt onset. Versus dementia, it tends to have a gradual onset. This one has an abrupt onset. Risk factors are surgery, pain medications like opioids, if the patient's not sleeping, fatigue, if they have any type of underlying disorder like constipation, pneumonia, urinary tract infections are big ones, especially for elderly urinary tract infections. How is this patient going to present? They're going to have disorientation, visual hallucinations, agitation, apathy, withdrawal symptoms, impairment to memory or attention. We're going to diagnose them by doing a confusion assessment method algorithm. We're going to diagnose with delirium if the first 2 points in either point 3/4 are present. So whether they have acute onset, fluctuating course, and attention, which is point 2. Point 3 is disorganized thinking, and then point 4 is altered level of consciousness. So if they have any of these first 2 points and any of the 3/4 of the third point, then these patients are diagnosed with delirium. Okay. So prevention is going to be the treatment. We want to make sure that we identify people at risk. For example, those patients that are at risk for falling. We want to eliminate anything that's precipitating this delirium. Okay. We want to avoid restraints in these patients or atypical antipsychotics. If we do need to give atypical antipsychotics, then we can do haloperidol, risperidone. And then we want to make sure that we don't give benzos, because benzos will worsen delirium. So once again, delirium, it waxes and wanes. It's an acute onset. These patients are just going to be confused. We want to treat these patients. Usually, if we need to give them something haloperidol or risperidone, we want to avoid our benzodiazepines. Okay. So now we're going to go into dementia. This is going to be chronic. It's going to be a gradual decline. Okay. And they have gradual decline in more than one cognitive domain that affects either function in their language. They have apraxia, executive function, okay, problems with their language, like I said. The cause is because they have damage to brain cells. They have slow mental decline over months or years, and age is related to progressive cognitive decline. It's an insidious onset. Some of the risk factors is going to be the patient that's older than 65, if they have a family history, diabetes mellitus, hyperlipidemia, hypertension or hypotension. Head trauma is also associated with dementia. This patient is going to be presenting with mild cognitive impairment. Okay, they get lost, they have personality changes, diminished problem solving, task difficulty learning, impaired judgment, language problems, and they have gradual progressive memory loss and social problems. We're going to diagnose this by doing the mini mental status exam and the depression screen. We're going to do a CT and we're going to see cerebral cortical atrophy, ventricular dilation, and prominent cortical sulci. Treatment is usually no cure. There's usually no treatment for this. I mean, we can treat to delay it, but we can't completely treat it. Okay, so we can give things like memantine for these patients. So another topic that was on the blueprint is loss of coordination and ataxia. So things that we want to think that can cause this ataxia, which is like instability where they just can't walk, is going to be intoxication, right? Someone that is drinking a lot of alcohol. If they're taking certain medications, it can make them also have ataxia. If they have a tumor, Wernicke's, right? Encephalopathy, the trauma, a cerebral abscess, hyponatremia is a big one also, multiple sclerosis, peripheral neuropathy, especially in those patients that have diabetes mellitus, hemorrhage or infarct, Parkinson's, hydrocephalus, meningitis, and then vitamin B12 deficiency also. So another topic that's on there is going to be peripheral neuropathy. So we're going to be going through the peripheral neuropathy. So we have sciatic, right? This is usually going to involve or caused by buttock injury, hip dislocation. They're going to have decreased knee flexion. They're going to have a foot drop. And treatment for this is usually analgesics or physical therapy. We also have myalgia parasitica. This is due to a lateral femoral cutaneous neuropathy. They're going to have upper thigh numbness. It's usually found in patients that are obese and pregnant. Treatment for this is just make sure that they're using loose clothing, right? And they're having weight loss. And then we have our common peroneal. This is usually due to a proximal fibular injury. They're going to have the foot drop. Treatment's going to be an ankle splint. We have radial nerve palsy. This is going to be your Saturday night palsy, right? Drinking. Usually the patient, if it's they're on crutches, if they have any type of humeral shaft fracture, they can have the they can have the radial nerve palsy. They're going to be presenting with the wrist drop. They won't be able to extend their wrists, and treatment's going to be a wrist splint. And then we have an ulnar nerve palsy. This is going to be due to an elbow injury. They're going to have decreased finger adduction and thumb grasp. It's going to involve the 4th and 5th digit, and they're going to have 4th and 5th digit paresthesias also. And then we have diabetic neuropathy. This is a polyneuropathy. These patients present with numbness and tingling. They'll have the stocking glove pattern, and treatment for this is going to be gabapentin, Lyrica, TCAs, and tight glycemic control. So next topic we're going to go into is going to be Bell's palsy, okay? This is a weakness or paralysis of the muscles on one side of the face. It's due to damage to cranial nerve 7, so it's going to be your facial nerve, okay? And it's a lower motor neuron lesion. The cause of this is usually idiopathic. We don't know. They think it's associated with viral infections like your herpes simplex virus and your Epstein-Barr virus and Lyme disease, but we don't know the cause of Bell's palsy, okay? So with these patients, they're going to be presenting with drooping of one side of the face, and it's going to involve the entire face, okay? So they're going to be presenting with drooping. Sometimes they won't be able to close their eyes, and it's going to involve an entire face. This is how you're going to differentiate it from an upper motor neuron lesion where the forehead is not spared, okay? So if a patient comes in and they're able to flex their forehead or wrinkle their forehead, and they're having just here down where they're having the paralysis, then you're thinking about a stroke, right? An upper motor neuron lesion versus Bell's palsy. This is a lower motor neuron lesion. So they have all this is affected. The forehead is not spared. And that's how you differentiate between both of them, okay? They're going to be presenting with absence of nasolabial fold, drooping of eyelid or mouth, dryness of the eye also. They can also have hypersensitivity to loud noises, loss of taste on the anterior 2/3 of the tongue, ear pain, dysgeusia, which is going to be an impairment of taste. Diagnosis is usually clinical, and you want to make sure that we're ruling out stroke, like we said, because once again, with Bell's palsy, cranial nerve 7 palsy does not involve, does not spare the forehead. So it involves the entire part versus an upper motor neuron lesion. Like I said, it's going to spare the forehead. So the patient's still able to wrinkle the forehead, and that's what we're going to diagnose as a stroke. And we want to make sure that we are looking to rule out the stroke. Treatment, usually most of these patients recover within 6 months. If we do treatment, we can give them something like prednisone. We can also give them something like acyclovir. Prednisone will decrease that nerve inflammation. We're going to give them artificial tears also for their eye, okay, and then an eye patch also. So once again, Bell's palsy, cranial nerve 7, it causes that drooping of the entire face, and it does not spare the forehead. The forehead is only spared in your upper motor neuron lesions, which is going to be your strokes. So next one's going to be Guillain-Barré syndrome. This is an acute inflammatory and demyelinated polyneuropathy of peripheral nerves, and it's going to be ascending paralysis. Okay, that's how you can differentiate between the other ones, which we're going to discuss in a few minutes. So once again, it's going to be an ascending paralysis for your Guillain-Barré syndrome. And it's autoimmune. The most common cause is Campylobacter jejuni. So usually in your question stem, it'll say a patient that just had some type of like viral GI problem like a week ago, and now they're presenting with this paralysis in their extremities, lower extremities. And then you want to think about Guillain-Barré syndrome. Sometimes it'll ask you which bacteria is most commonly associated with this. Campylobacter jejuni. Okay. There's other causes like CMV, Epstein-Barr virus, HIV, but the most common one is going to be bacterial infection. What happens is that there's Schwann cell demyelination. Signs and symptoms, they're going to have, once again, ascending. It's going to be rapidly progressing, ascending bilateral weakness and paresthesias. They're going to have loss of ankle reflex, then patellar reflex. They're going to have distal sensory dysesthesias, numbness, back pain, progressive paralysis in legs and arms, hypoactive and then absent reflexes, loss of deep tendon reflexes. They also have cranial nerve involvement, so they'll have that double vision, difficulty speaking, and then it can also involve the respiratory system, which is why this is an emergency. And it can, if it involves it, it's an emergency, and these patients require ventilation. So these patients have loss of diaphragm nerve innervation, so they can cause a respiratory failure. How are we going to diagnose this? We're going to do a lumbar puncture. We're going to see increased cerebrospinal fluid, less than 10 white blood cell counts. Also, we can do an EMG, which is going to be widespread demyelination / nerve conduction velocity. And then we're going to check the vital capacity to rule out anything else. Okay. Treatment is going to be with corticosteroids. We can give IVIG also, plasmapheresis. These patients tend to recover over months, and they return to baseline usually within a year. Once again, the common complication with this one is going to be respiratory failure. That's due to the diaphragm, and it requires ventilation, and they need to be in the ICU for this. So once again, Guillain-Barré syndrome associated with what? Campylobacter jejuni. It's going to be a bacterial infection. It's an ascending paralysis. Okay, we treat this usually with corticosteroids, IVIG, and plasmapheresis. Next topic we're going to go into is going to be our seizures. Okay, so seizures in general is a clinical manifestation of epilepsy, and it's because there's increased depolarization. Okay, how do we stop this depolarization? We basically block the sodium and calcium channels, right? So the etiology is that neurons are synchronously active. There's too much excitation. So there is too much excitation and too little inhibition. Okay. Risk factors for this is usually a family history, perinatal injury, febrile seizures, head trauma, central nervous system infection, stroke, brain tumor. Provoked seizures are usually due to discrete temporary trigger rather than an underlying seizure disorder. So something that just provoked it, like it sounds. They're going to be presenting with jerking, moving. They might or may not lose consciousness, and they have fear, or there's fears or strange smells also that these patients can have for symptoms. So now let's go into each one, right? So seizure disorders, like we said, it's a transient occurrence of symptoms resulting from abnormal, excessive, or synchronous neuronal activity in the brain. There's too much excitation, like we said, so and then there's too little inhibition for these patients. So let's go into each one. So we have our focal or partial seizures. These are limited to one hemisphere of the brain. That's why they're called focal or partial seizures. Okay. We have our simple and our complex seizures. Simple partial seizure is going to be a seizure that the patient does not have impaired awareness. Okay. So seizure without impaired awareness, they retain awareness. They're going to be presenting with abnormal muscle movements, tingling, numbness, burning, visual disturbances like blurring, loss of vision, or hallucinations. They can also present with auditory hallucinations like buzzing, ringing. They're going to have this intense, unpleasant smell. And then Jacksonian march is usually associated with your focal partial seizures. And then we have our complex partial seizures. With this one, it's a seizure with impaired awareness. Okay? They're going to have their automatisms, so they're going to have lip smacking, chewing, pulling at clothes. They're going to have post-ictal confusion and lethargy. They don't remember what happened. And then epilepsy is going to be where the patient has recurrent unprovoked seizures. Okay, so the neurons are usually active, and they have sudden excitatory signals over and over again. With epilepsy, they're going to be presenting with jerking, moving, loss of consciousness, fears or strange smells. Diagnosis for these seizures, usually we want to prefer is an MRI with contrast or CT. We can also do an EEG, okay? And then you want to make sure that we do a thorough neurological examination. The treatment for this is usually daily anticonvulsants, so something like carbamazepine, okay? We can also give them phenytoin, and then epilepsy surgery also if needed. We do nerve stimulation. So now let's go into our next topic, which is going to be our generalized seizures. This includes both hemispheres of the brain, okay? It's bilateral diffuse cerebral cortex involvement. So with these patients, there's absent, where the patient has no motor signs that are observed, but they tend to appear like they're spaced out or they have a blank stare. It's commonly found in children, okay? And they tend to last about 5 to 30 seconds. So for example, this child will be like in class, and then they see the teacher like talking, and then like they blink out, and then next thing you know, like 30 seconds later, like the teacher's like in their face, like screaming at them, like, why aren't you paying attention, blah, blah, blah. And they're like, whoa, I don't know what just happened within like those 30 seconds that I blacked out. So they have these times where the patient will have spacing out, or they have this blank stare, commonly found in children, like I said, 5 to 10 years old. The thing about this is that you're going to see on your EEG, you're going to see symmetric 3 Hz spike and wave discharge. This is like pathognomonic for your absence seizure. So once again, your absence seizure, you're going to see symmetric 3 Hz spike and wave discharge that begins and it ends suddenly. What you need to know about absence is that the treatment is going to be ethosuximide, okay? Ethosuximide, absence seizures. Next one, we're going to go into tonic. This is where the muscles become stiff and they're flexed, okay? The patient will fall backwards, and then it's usually associated with a guttural cry. So they have a contraction of the expiratory muscles, so that's why they're having like this cry, okay, for tonic. And then we have our clonic type, which is our violent muscle contraction. So this is a convulsions, right? Jerking, they'll have this rhythmic jerking of extremities. And then we have our atonic, which is where the muscle just relaxes and they're floppy. They tend to fall forward, okay? We have myotonic, which is just short muscle twitches. And then we have our tonic clonic. This is both tonic and clonic. So they go both in stiff and jerking phases. Sometimes with tonic clonic, they can have incontinence. They'll bite their tongue. They'll have postictal confusion, aura, loss of consciousness. Their eyes will roll back. And then they'll have apnea and then clonic contractions. Diagnosis for our seizure disorders is going to be, like I said, an MRI with contrast or CT. We can do an EEG. Treatment of the generalized is usually going to be our anticonvulsants. So generalized seizure is going to be valproic acid and then topiramate or lamotrigine. How I memorize is the general goes to the VA, right? So valproic, generalized seizures. And then epilepsy surgery you can do, like I said, that's last line. So now we're going to status epilepticus. This is going to be a seizure that lasts more than 5 minutes or more than 2 seizures without resolution of post-ictal encephalopathy. Usually it's a tonic-clonic type of seizure, and this is a medical emergency because they're having this continuous convulsive seizure. Treatment for this is going to be benzodiazepines, okay? Lorazepam is preferred over diazepam. We can give it intramuscular or orally if there's no IV access. Okay. We also want to make sure that we intubate these patients. Also, we can give them IV phosphophenatoin or IV phenytoin. And then if we need to do some type of IV anesthetic, we can give them propofol or midazolam. So now we're going to go into intracranial hemorrhage. So this is a hematoma formation, and there's an enlargement that can lead to local injury and increase in intracerebral pressure. Some of the causes of this is going to be high mortality rate with intracranial hemorrhage. It's usually abrupt. They'll have neurosymptoms that are going to worsen with time, so usually within 30 to 90 minutes. It's located usually in the basal ganglia. That's about 66% of them. It can be located in the pons, that's 10%, and the cerebellum, which is another 10%. The most common causes of an intracranial hemorrhage is a trauma. Most common non-trauma causes are like hypertension, especially with hypertension. The most common location of the intracranial hemorrhage is going to be the putamen of the basal ganglia. Symptoms for intracranial hemorrhage, the patient's going to be presenting with altered level of consciousness, stupor, coma, headache, vomiting, nuchal pain and rigidity, increased intracranial pressure. With diagnosis, we want to make sure that we do a stat CT scan of the brain. We do a lumbar puncture for xanthoscromia, but we're going to do that right once if we weren't able to rule out intracranial hemorrhage. We can do a quag panel, so we're going to do the PT and PTT and INR. We're going to look at their platelets, okay? We're going to admit these patients to the ICU. We're going to do our ABCs, so airway, breathing, circulation, right? We want to evaluate to see if they need intubation. We're going to reduce their blood pressure, and then the agent of choice for their blood pressure is going to be our nitroprusside. We're going to give them mannitol to decrease the intracranial pressure, diuretics, and then of course surgical evacuation of the cerebral hematoma, okay? All right, so now we're going to go into a subarachnoid hemorrhage. Subarachnoid hemorrhage. So this is usually due to a ruptured berry aneurysm, and the most common cause is a trauma. Other causes are like AV malformations, and the most common non-traumatic, like I said, is going to be your berry or your sacral berry aneurysms. The most common location is going to be the anterior communicating artery. How is this patient going to present? They're going to say, this is the worst headache of my life. Okay, that's how they're going to present. It's going to be sudden, severe, often excruciating headache in the absence of any pharmacological, neurological symptoms. Okay. How is this patient going to be diagnosed? We're going to do a non-contrast CT scan. If the CT scan is negative, then that's when we can do a lumbar puncture. The gold standard usually is going to be your lumbar puncture. You're going to see xanthoscromia, so yellow color of the cerebral spinal fluid. We're going to do a cerebral angiogram also. This is going to tell us the cause and tell us if we need to do surgical intervention. Treatment for this is surgical clipping. We want to make sure that we control the hypertension, so calcium channel blockers for the vasospasm, nimodipine also. And then we want to make sure that we tell this patient, we give him stool softeners to avoid any straining, analgesia for headaches, and then IV fluids. Okay. So next one's going to be cerebral aneurysm. This is an abnormal dilation in the blood vessels that supply the brain with blood. It's located in the brain in the circle of Willis, and it's usually due to weak spots of vessels. The most common cause is going to be a sacral berry aneurysm, fusiform, and dissecting. Other causes can be smoking, hypertension, alcohol abuse, cocaine use, most commonly found in females and males. Also family history. Also if they have a history of polycystic kidney disease. Symptoms for unruptured is going to be usually they're asymptomatic. They can present with cerebral aneurysm, symptoms of a headache or pain behind one eye, vision abnormalities, ptosis, numb, weakness to one side of the face, speech difficulty. If they have ruptured symptoms, they're going to be presenting with a sudden severe headache, like a thunderclap headache, like we discussed, right? The subarachnoid hemorrhage, loss of consciousness, blurred or double vision, nausea, vomiting, neck stiffness or pain, confusion, and this is an emergency if it's ruptured, right? Because that's causing a hemorrhage. Diagnosis is usually going to be a CT angiography. That's going to be our initial, MRI or MRA. Okay. And then if it's unruptured, we just want to make sure that we observe him or the patient can go to surgery. And if it's ruptured, of course, like we discussed, we're going to go into surgical clipping or endovascular coiling. Okay. So now we're going to go in our TIA. So that's going to be our cerebrovascular accident, stroke. This is going to be abrupt focal neurological deficit due to ischemia. That's 85% of the cause. And then we have our hemorrhagic. So we have two different flavors. We have hemorrhagic and we have ischemic. Ischemic is the most common one, 85%. Okay, 15% is going to be hemorrhagic. This is usually sudden on onset. Some of the causes is going to be your ischemia, atherosclerosis, small vessel disease, cardioembolic. Sometimes some of the risk factors for these patients is going to be if the patient's older than 55, if they're male, if they have uncontrolled hypertension for these patients, if they had a family history of stroke, if they've had a prior stroke, also TIAs. Usually if a patient has TIA, they're more prone to getting a stroke. They have a very high likelihood. If they're diabetics, if they have hyperlipidemia, if they're smokers, AFib, endocarditis, if they had a recent myocardial infarction, they're more prone to getting a stroke. Okay, oral contraceptives, if they're obese. How is this patient going to present? They're going to be presenting with facial drooping. They're going to have arm weakness and speech difficulties. With this one, what you need to know is that how is the patient going to present depending on the artery that's involved. To be honest with you guys, I always get these wrong on questions, and I'm still working on trying to learn them. Okay, so let's go through them. So if the anterior cerebral artery is involved, the patient's going to be presenting with contralateral hemiparesis. They're going to have sudden lower extremity and trunk weakness or numbness. It's going to involve the leg and face, so they're going to have frontal lobe dysfunction. If it involves the middle cerebral artery, they're going to have face and arm weakness, decreased sensation, bilateral vision abnormalities, aphasia, neglect, inability to perform learned actions. If it involves the posterior cerebral artery, they're going to have contralateral visual abnormalities or blindness. So it's going to involve the eyes. Whenever I think about anything in the posterior side, I think about the eyes. Okay. If it involves the lacunar, it's going to cause focal motor or sensory deficits, loss of coordination, difficulty speaking. If it involves the basilar artery, they're going to be presenting with cranial nerve abnormalities, full body weakness, decreased sensation, vertigo is a big one for basilar, loss of coordination, difficulty speaking, visual abnormalities, coma. They're going to have the locked-in syndrome with basilar, which makes sense, right? Because that's like blocking almost blood perfusion through all the arteries if you think about your circle of Willis. So locked-in syndrome is where they have plesia of the head, body muscles. They're only able to blink their eyes, and they're only able to have vertical movement. So they're like stiff, and they're just able to move their eyes. That's like terrible. Okay. Vertebral, they'll have low cranial nerve deficits and ataxia. So how are we going to diagnose this? We're going to do a non-contrast CT scan. We're going to see loss of gray-white interface. We can do an MRI also. And then a CT angiography, we're going to see where the blood is being blocked. Okay. Treatment for this is going to be our thrombolytics, right? We're going to give them TPA. We want to make sure that we give them TPA between 3 to 4.5 hours. I know certain textbooks that I read like tend to differ on the time, but just make sure that we want to give them within like 4 hours of onset symptoms. We're also going to give them aspirin, and they need to go to surgery if needed to get that mechanical embolus removed. Okay. And then also we want to make sure that we're lowering and stabilizing the blood pressure, so we can give IV labetalol and IV nifedipine. So next one's going to be our transient ischemic attack, TIA. So this is the one that looks and it mimics a stroke, but it's not a stroke. If a patient does have a TIA, though, they're more prone to getting a stroke in the future if they don't get their hypertension or the hyperlipidemia or whatever caused it under control. So TIA is where the brain has no blood supply for a brief period of time, usually less within 24 hours. Blood flow is usually restored before permanent damage occurs. Some of the causes of this is going to be atherosclerosis, uncontrolled hypertension, like I discussed, hyperlipidemia, cocaine use, or oral contraceptives, arteritis, fibromuscular dysplasia, especially in your younger woman. You want to think about this one. Smoking is a big one. If they have any type of thrombophilia, cardiac disease like AFib, myocardial infarction, valvular disorders, diabetes mellitus, carotid stenosis. It's most commonly found in males, especially if they're older, greater than 55. Okay? They're going to be presenting with an upper, they're going to have like facial palsy with these patients. They'll have arm weakness, speech difficulty, transient monocular blindness. Okay? We're going to diagnose these patients with the best initial test is going to be head CT without contrast. Usually we won't see any stroke on imaging because most of them, like I said, they tend to resolve within 24 hours. And then we can also do an MRI or MRA of the head and neck. Treatment for this, we want to monitor them. This is due to risk of them having a stroke, like I discussed. So we want to make sure if they have coronary artery disease, we put them on aspirin and statins. We do a carotid endarterectomy or angioplasty. We give them beta blockers, okay? And then we also put them on heparin if they have any type of arrhythmia. And then we want to make sure that we also do stroke risk status post-TIA. So we want to make sure that after they have a TIA, we assess them to see if they are prone to getting a stroke. So how are we going to do this? We're going to do this by basically seeing if they need a hospital admission with a score of 3 or more. Okay? So if their age is greater than 60, they get a point. If their blood pressure is greater than 140/90, they get another point. If they have clinical symptoms like focal weakness, speech impairment without weakness, 2 points for focal weakness, 1 point for speech impairment without weakness. And then if the duration of the TIA was greater than 60 minutes, that's 2 points. If it was between 10 to 59 minutes, that's 1 point. And if it's diabetic, that's 1 point. So if there's a score of 3 or more of these that I discussed, then you want to admit them to the hospital. All right, guys, so next one we're going to go into epidural hematoma. I know I briefly discussed these earlier, so now we're going to go into more detail, okay? So an epidural hematoma is bleeding above the dura. It's usually active bleeding due to damage or torn vessel and a collection of blood called the hematoma. These patients are going to be presenting with increased intracranial pressure. Some of the causes of this can be head trauma. The weakest point for your epidural hemorrhage is going to be your pituitarium, and it's usually due to the meningeal artery, the middle meningeal artery, okay? So it's usually due to a middle meningeal damage that can cause these epidural hematoma. Like we discussed, they're going to be presenting with a lucid interval. So this is a slow bleed. They'll have several hours before they start having symptoms. So they'll have loss of consciousness after head trauma, nausea and vomiting, headache, muscle weakness, focal deficits. Diagnosis, we're going to do a CT scan, okay? If it's hyperdense mass, that's usually an acute one and it's more white. Also, what you need to know is what we're going to see on the CT scan. You're going to see a lemon shape or a biconvex shape. They also say like a lens shaped, right? And this is going to tell you that the patient has an epidural hematoma. It cannot cross suture lines, okay? So once again, epidural hematoma, it's going to involve what? The middle meningeal artery that's damaged to that. And it's usually on your CT scan, you're going to see a lemon shape or a lens shape, okay? It does not cross suture lines. It does not cross suture lines, okay? And treatment for this is going to be a craniotomy. We're going to have bone removed. It helps us give evacuation and removal of the hematoma. So once again, with epidermal hematoma, it's going to be due to your middle meningeal artery, and it's bleeding above the dura. You're going to do a CT scan. This patient's going to have a lemon shaped, right, on your CT scan, or it'll say like a lens shaped, and it does not cross sutures, okay? Treatment for this is going to be craniotomy. You're going to go in there and relieve that pressure and that bleeding. Next one's going to be your subdural hematoma. This is bleeding below the dura. These are very, very highly tested, so that's why I'm going through it. This is going to be rupture of the bridging veins. What happens is that blood pools and then a hematoma forms, and this causes increased intracranial pressure. This is usually commonly found in patients that have head trauma, chicken baby syndrome also, whiplash, right? Whiplash, and then alcohol abuse, and also very commonly found in the elderly because of their brain atrophy. Symptoms usually are days to weeks. The symptoms don't present as quick onset as on your epidural because this takes days a week. They'll have loss of consciousness after injury, headache, nausea, vomiting, muscle weakness, focal deficits. We're going to diagnose this with the CT scan once again, and we're going to see what? We're going to see a crescent shaped, right? Or a banana shaped. And this one crosses suture lines. We're going to treat this with, if it's small, catheter. If it's large, then you're going to go in there and do a craniotomy. Usually with subdural hematoma, remember we had like an older patient that came in. She had like a fall about a week ago, and she was like perfectly fine. She was just having some headaches, so we ended up doing a CT scan, and behold, she had a subdural hematoma. So sometimes these patients are asymptomatic, or they might have very mild symptoms. And like I said, this one presents later versus an epidural hematoma that's usually very quickly. So once again, just to go through them, once again, since this is very highly tested, epidural hematoma, middle meningeal artery damage, right? They're going to have a biconvex shape on your CT scan, lemon shape, it cannot cross the suture lines. Subdural hematoma, this is usually going to be due to the rupture of the bridging veins. It's below the dura. Symptoms are going to be days to weeks. You're going to do a CT scan, and you're going to see a crescent shape that crosses suture lines, okay? So now we're going to go into syncope. Syncope. This is a sudden transient loss of consciousness along with loss of postural tone. They have a dysfunction of bilateral cerebral hemispheres or reticular activating system in the brainstem. Some of the causes of this is vasovagal, dysrhythmia, orthostatic hypotension. Some symptoms, they have transient loss of consciousness and postural tone, confusion, but they lack a post-ictal state. Sometimes the duration for this is going to be seconds. They'll have rapid recovery following the event. And then we have our vasovagal, which is going to be a prodrome of nausea, vomiting, warmth, pallor, lightheadedness, and then diaphoresis. We're going to diagnose it with an EKG because we want to make sure that we rule out arrhythmias. We're going to do an EEG to rule out seizures also, okay? And then treatment's just usually supportive. So real quick about the syncope, we want to make sure that we always rule out any type of cardiac cause, right? I had a patient on Tuesday. He was sitting and then he got up and then he like passed out, and he passed out so bad that he hit himself. And so what we did on him, that we thought it was like orthostatic. So of course we did our EKG came back normal, and then we did our orthostatic vital signs. So we take the vital signs from the patient is standing to sitting to laying position, right? And then for our orthostatic, they have to have a change in systolic blood pressure of more than 20, and then a change in diastolic pressure more than 10, and that's usually diagnostic. And that's what this patient had. He ended up just having syncope due to orthostasis. Okay? So now we're going to go into coma. This is a state of unconsciousness in which a person cannot be awakened or fails to respond normally to stimuli. Okay? Some of the causes of this can be intoxication, if they're hypoxic, or if they're in cardiac arrest, strokes, hernias, cranial nervous system diseases, head trauma, motor vehicle accidents, hypoglycemia, drowning. Usually the patient in a coma is unable to open their eyes. They lack the sleep-wake cycle. They're unresponsive to stimuli, pain, tactile, verbal. They're usually, for their posturing, they're either decorticate or decerebrate position. The diagnosis, we're going to do our Glasgow Coma Scale, right, with a score of 3 being worst, and then 15 is going to be the best. And then how I memorize it is that any patient with a GCS score of less than 8, you intubate, right? Intubate has an 8, less than 8, you intubate. And then treatment for coma, we want to make sure that we do our ABCs, right? Airway, breathing, circulation, we give them fluids, and supportive therapy as needed. So why don't we go through real quick the GCS, Glasgow Coma Score, since this is like, I swear I have this like a question on this on every exam I've taken. So, and I still get them wrong because I still am not very familiar with it. So let's go through it. So how one of my classmates had taught it to me is that eye opening, you have 4 eyes, right? So a score of 1 is where the patient does not open their eyes at all. A score of 2 is where the patient opens their eyes to pain. A score of 3 is where the patient opens their eyes to voice. And then a score of 4 is like spontaneous eye opening, right? And then we have our verbal response. This is usually a score out of 5. 5 is being the best. 1 is none. So none verbal response is a score of 1. Incomprehensible verbal response is a score of 2. Inappropriate verbal response is a score of 3. If the patient is confused, that's a score of 4. If the patient is oriented, or if they have a normal conversation, this is a score of 5. And then our motor response, okay? Once again, 1 is the worst, 5 is the best. How I memorize it is that I think the person that taught it, I'm not very familiar with vehicles, but they said, I think like 6 motor, you want to think about a 6. That's how I memorize it. So 1 is going to be none, motor response. 2 is going to be extension to pain, so it's going to be your decerebrate. Score of 3 is going to be flexion to pain, decorticate. Score of 4 is going to be withdrawal to pain. Score of 5 localizes pain, and then score of 6 is obeys command. So once again, less than 8, we intubate. GCS score less than 3 is really bad. It's like the worst. GCS score 15 is like really, really good. Okay. So now when we go into bacterial meningitis, this is an infection of the meningeal tissues that cover the brain or the spinal cord by a bacterial organism. This is a medical emergency, and the most common type are Streptococcus pneumonia and Neisseria meningitis. Of course, there's different types depending on how old the patient is. So whether they're a neonate, and whether they're elderly, whether they're like adolescents, they tend to have different types of meningitis. So you have to make sure that you are familiar with these, okay? But the most common one is going to be Streptococcus pneumonia and Neisseria meningitis. Other causes are group B strep, that's usually like in your neonates, and then Staph aureus or other causes. So risk factors is usually for bacterial meningitis is going to be sinusitis, otitis media, since this can spread to the cerebrospinal fluid. If they have trauma injury or some type of neurosurgical procedure. Like I said, in neonates, the most common type of bacterial meningitis bacteria involved is going to be your group B strep. In infants, it's going to be your streptococcus pneumonia. College students, it's going to be Neisseria meningitis. And then any patient that's older than 50, it's going to be streptococcus pneumonia. This patient is going to be presenting with fever, nuchal rigidity, altered mental status, headache. They're going to have a stiff neck, photophobia, malaise, nausea and vomiting, confusion. They're going to have Brzezinski sign, which means that they bend their neck. And then Kernig signs, which is where they kick out their legs. So don't confuse Brzezinski with Babinski, because I always confuse these. Okay, Babinski is where you go and you basically go like this on the lower portion of the foot, and then it'll curl. That's usually a positive sign, which I don't remember for what. But don't confuse that, okay? So our Brzezinski sign is when they bend the neck, okay? And then they can also have petechiae. Usually petechiae, you'll see this in Neisseria meningitis. So if you have a patient that's it's a college student, they're sexually active, and they have like this rash on their skin, then you want to think about Neisseria meningitis, especially if they're presenting with symptoms of like fever, if they have nuchal rigidity, okay? They can also present with seizures and decreased consciousness with infection, papilledema. What are we going to diagnose these patients? We're going to do blood cultures, right? We want to do a first blood culture. We're going to see neutrophils. And then the second thing that we want to do is administer antibiotics. Third, we want to do a CT of the head and then a lumbar puncture. Okay? So remember, we do the blood culture first before we give antibiotics. Because if we give antibiotics before we do the blood culture, we won't be able to see the bacteria that's causing meningitis, right? Because we already give the antibiotics and they're going to start treating the bacterial infection. So it's going to not be efficacious. So that's why we're going to start by doing a blood culture and then we're going to do antibiotics. Treatment is steroids. We're going to give something like dexamethasone before the antibiotics. Although to be honest with you, this is controversial with some of the podcasts I've listened to, but in regards to the exam, we're going to give dexamethasone. We give antibiotics like ceftriaxone and vancomycin, right? Because we're also covering for our staff. And then we're going to give alcoholic antibiotic. For alcoholic individuals, we want to give ceftriaxone, vancomycin, and ampicillin, right? Because ampicillin, we're covering for what? Listeria monocytogenes. So now we're going to go into viral meningitis. This is an infection of the meningeal tissue in the brain or spinal cord. Once again, via a viral organism, though. Some of the common causes are going to be enterovirus. That's actually one of the most common ones that I keep reading about. Other causes are echovirus, herpes simplex virus, mumps virus. This is also known as aseptic meningitis. The patient is going to be presenting with nausea and vomiting, headache, neck pain, photophobia, malaise, fever, rash. Symptoms are usually milder than your bacterial meningitis. Diagnosis, we're going to do a lumbar puncture. We're going to see lymphocytic pleocytosis viral culture. And this is what's going to differentiate it from bacterial. So in bacterial, we're going to see more white blood cells. We're going to see more neutrophils versus viral. We're going to see more lymphocytes. Treatment is usually with empiric antibiotics. And then we start them on antibiotics because we do that until we've confirmed a viral case, because bacterial meningitis is very, very deadly. You want to make sure that this patient does not have bacterial meningitis, right? Supportive care usually, though, for viral meningitis, we can give them NSAIDs for the fever. If we suspect it's due to herpes simplex virus, or we've diagnosed this that it's due to herpes simplex virus, then we can give them IVA cyclovir. If we think it's usually due to tuberculosis, then we're going to give them the RIPE therapy, which is rifampin, isoniazid, pyrazinamide, and ethambutol. And then we're also going to give them dexamethasone. If it's due to a fungal cause, then we want to give them amphotericin, okay? So why don't we go into encephalitis? This is going to be an infection of the brain parenchyma, usually caused by a viral infection, and this is life-threatening, okay? Some of the causes of encephalitis is varicella zoster virus, herpes simplex virus, arbovirus, mumps, poliovirus, Coxsackie virus, measles. This patient is going to be presenting with alteration in mental status that lasts more than 24 hours. They're going to have a fever, focal neurological deficit, seizures, cystic cerebrospinal fluid pleocytosis. And diagnosis, we're going to do a lumbar puncture. We're going to see increased white blood cell count, mostly leukocytes. They're going to have a normal glucose. And then we want to make sure that we also do an MRI for these patients. Treatment is going to be usually supportive. We want to give them antipyretics, anti-seizure medications. We want to lower the intracranial pressure. They might need mechanical ventilation. If it's due to herpes simplex virus, we're going to give them an antiviral, which is a acyclovir. If it's due to cytomegalovirus, then we're going to give them ganciclovir with or without foscarnet. So now we're going to go into spinal cord injury, okay? So spinal cord injury is a damage that causes changes in function, loss of function to all areas that are served by the spinal cord below the level of the lesion. So we have different types. Let's go into each one. I know I briefly mentioned Cauda-Equina syndrome, but we're going to go into more detail. So Cauda-Equina syndrome is damage to the cauda-equina, also known as a horsetail. They have a narrow canal, and usually this is a motor intervention for your genitals, your anal sphincter, and your bladder. So some of the causes of this is usually due to compression, trauma, damage. The most common cause is going to be a lumbar disc herniation, spinal stenosis. Other causes are going to be ankylosing spondylitis, spondylolisthesis. Symptoms for these patients are going to have decreased bowel and bladder control, decreased sexual function like cytoanesthesia, muscle weakness, paraplegia, loss of knee reflex. We're going to diagnose these patients clinically usually, and we're going to confirm with an MRI or CT scan. Treatment for this, these patients usually need to go to surgery, so they need surgical decompression. Okay, this is an emergency, like I said. These patients will have bowel or bladder incontinence. Sometimes they say like I said, they can't even feel the toilet paper whenever they go to the restroom. Okay. Then we have Brown-Séquard syndrome. This is a hemisection damage to half of the cord. Most common involves the C-spine. You can also have vertebral fracture. It's usually due to a penetrating trauma like a gunshot wound or a stab. Sometimes it can be caused by a tumor that's growing and it's causing compression there. This patient is going to be presenting with loss of sensation, pain, temperature, or touch, and it's going to be ipsilateral, same side. They're going to have hemiplegia below the level of injury. They're going to have increased tone and muscle spasms. They're going to have ipsilateral loss of motor, vibratory, and proprioception with contralateral loss of pain and temperature sensation. We're going to diagnose this lesion with an MRI, and treatment is usually supportive, rehabilitation, corticosteroids, and these patients tend to have a good prognosis if it's treated. And then we have anterior cord syndrome. Some of the causes of this is flexion or vascular injury, crush of compression from a hematoma, or ischemia from compression. This patient is going to be presenting with complete loss of motor, pain, and temperature below the injury, but they retain proprioception and vibratory sensation. These patients will have a very poor prognosis. And then we have central cord syndrome. Some of the causes of this is hyperextension, okay? And they're going to be presenting with sensory and motor deficits, more in the upper extremities than the lower extremities. So next one we're going to go into is multiple sclerosis. So multiple sclerosis is going to be a progressive demyelination of the brain and spinal cord. It involves the oligodendrocytes. It's an inflammatory disease of the central nervous system, and it's episodic. So the cause of this is that it's autoimmune. It's most commonly found in women between the ages of 20 to 40 years old, and symptoms can progress slowly with severe remission, and they can worsen with stressful events. Some of the signs and symptoms are going to be presenting with the most common ones going to be optic neuritis. Other symptoms that they can present with are vertigo, vision abnormalities, paresthesias, weakness, urinary retention. Some of the symptoms that will be later is that they'll have worsening vision, poor movement control, dysarthria, sensory abnormalities, postural and positional instability, spasticity, increased deep tendon reflexes, and they're going to have a positive Babinski sign. What's going to be our best test for these patients is that we're going to do our best initial and most accurate. It's going to be a T2 weighted MRI. Okay. We can also do a lumbar puncture, and then on your cerebral spinal fluid, you're going to see oligoclonal bands, cerebral spinal fluid pleocytosis, and elevated IgG. Okay, that's usually what I see on your exams, is that they give you a lumbar puncture. This patient is presenting with like paresthesias, muscle weakness, and usually this is descending, right, versus ascending. And then you'll see that they did a lumbar puncture, and you see like elevated IgG, pleocytosis, oligoclonal bands, and that's why I'm like thinking about multiple sclerosis, especially if it gives you like a young woman that's presenting with this, which is what you'll commonly see on your exam, is like a young woman between their 20s or 40s, like I said. So best initial treatment for this is going to be methylprednisolone. This is going to be for acute exacerbations and plasma exchange. For their fatigue, you can give them amantadine. For their spasticity, you can give them baclofen or tizanidine. Anything that modifies the disease or your beta interferon, okay? But usually your best initial is going to be your methylprednisolone, so your steroids. So last topic we're going to go into is going to be your brain abscess. What you need to know is that the most common pathogen associated with your brain abscess is going to be Streptococcus and Staph aureus. It's usually a direct spread from your otitis media because the ear is very close to the brain, right? Mastoiditis also, which is the infection in the back. Dental infection, sinusitis, and then trauma. This patient is going to be presenting with a headache, fever, increased intracranial pressure, focal neurological findings. We're going to diagnose this with a head CT, and we're going to see a ring-enhancing lesion on your CT scan. And then treatment is usually antibiotics. We want to make sure that we surgically drain it if it's more than 3 centimeters or if it persists. All right, guys, so we are finally done with neurology. So why don't we go into our next topic, which is going to be HEENT. Okay, this is 7% of your ER end of rotation exam. So blepharitis, this is a common chronic bilateral eyelid margin inflammation. It can be anterior or posterior, okay? If it's anterior, it involves the skin and the lash. If it's posterior, it involves the inner part of the ear, the eye, right? If it's anterior, some of the common causes of the bacteria is Staphylococcus bacteria. It can also be a viral cause or some type of seborrheic infection. If it's posterior, it's usually due to dysfunction of the meibomian glands. If it's seborrheic, you usually see the scales that are like really, really greasy. How is this patient going to present? They're going to have irritation, burning pain, itching, eye discharge. They're going to have crust along the eyelashes, erythema of the eyelid margins, eyelash loss, ulceration, seborrhea, dermatitis, loss infestation, or acne rosacea. They're going to have lash involvement. If it's anterior, they're going to have that red rim. If it's posterior, they're going to have hyperemic telangiectasias. Treatment is usually supportive. We're usually going to tell them to do lid scrubs with like baby shampoo, warm compresses. So that's going to be first-line treatment. Like I discussed, usually anything that's first-line treatment is just something that is not pharmacological, unless it's something that's an emergency. So if you do need to give them an antibiotic, you can give them something like oral tetracycline or topical erythromycin or bacitracin. So next one we're going to go into is blowout fracture. This is a trauma or force to the globe. Pressure that blows at the weak orbital floor and involves the muscles. Some of the causes of this is a force or trauma, whether they were hit by a ball or they were just hit by a fist. And usually this is force or trauma to the zygomatic prominence of the soft tissue of the orbit. This patient is going to be presenting with limited gaze. They're going to have diplopia, swelling, misalignment, subcutaneous erythema also. They might have crepitus if there's gas or air present. They have restricted globe movement. Diplopia, this is because there's entrapment of the inferior rectus. They're going to have diplopia on the upward gaze and limitation of the upward gaze. Diagnosis for this is going to be usually an X-ray or CT, and treatment is usually surgery for a blowout fracture. So we're going to have allergic conjunctivitis. This is inflammation of the conjunctiva. So there's several causes. We can have seasonal allergies, right, for allergic conjunctivitis. Usually with patients that have like your atopy or asthma or eczema are more prone to getting your allergic conjunctivitis, hay fever also. The thing that differentiates your conjunctivitis allergic from your bacterial and viral is that the patient complains of itchiness, right? Why? Because you have your histamine release. That's why they have itchiness. This is an allergies. So they're going to have itchiness, they're going to have a dry eye, and it's usually going to be bilateral versus bacterial, it's usually unilateral. So bilateral, itchiness, itchy eyes. They're going to have edema injected. They may or may not have a mucate discharge. And treatment for this is usually vasoconstrictors or topical, antihistamines, or mast cell stabilizers. Okay? And then we have our bacterial conjunctivitis. This is an inflammation of the conjunctiva. It usually starts on one eye, like I said. Sometimes it's unilateral. Sometimes it can be bilateral. Starts unilateral, it'll go to the second eye. With bacterial conjunctivitis, some of the common causes, it's commonly found in like contact lens wearers. It's usually transmitted through direct contact or autoinoculation. Some of the common organisms is Streptococcus pneumonia, Staph aureus, Haemophilus influenza. Whenever we think about chlamydia or gonorrhea, this is going to be an emergency, guys. So just make sure that you know this. Ocular emergency with chlamydia or gonorrhea. If it's a neonate, usually contact with infected genital secretions is what causes this. Okay. The thing about this is that within the first few days of a neonate, like within the first 3 days, you want to think about gonorrhea. If they're if they're presenting with like profuse discharge. After the first few days, like probably after 5 days, then you want to think about chlamydial infection. This is very important because on your exam, you're going to have a neonate that's presenting on day 2 or day 3, and they're presenting with like a lot of discharge. You want to think about gonorrhea. Like I said later, if it's laid like more than 5 days, 6, 7 days, you want to think about chlamydia. So how is this patient going to present? They're going to have bright red, profuse purulent discharge. They're going to have some crusting in the morning. They said that they woke up and their eyes were like shut, right? They have this foreign body sensation. They might have some, but they will not have any photophobia or visual loss, okay? If it's due to gonorrhea or chlamydia, you can also see some corneal ulcerations or preauricular adenopathy. How are we going to diagnose this? Usually if it's something benign, right, we don't need to really do full workup, but if we're thinking about your chlamydia or your gonorrhea, then we'll go in there and do a culture and gram stain of the eye discharge. So during my pediatrics, I actually had a baby that came in with this. We went in there, we got a cotton swab, and then we swabbed that and we sent it out for a culture. Treatment for this is usually warm compressions. You can give them antibiotics like trimethoprim and polymyxin. We want to make sure that we avoid neomycin in these patients. If it's gonorrhea, like I said, this is an emergency. We're going to give them intramuscular ceftriaxone, topical erythromycin, and if it's chlamydia, oral doxycycline or azithromycin. So gonorrhea, intramuscular ceftriaxone, topical erythromycin, chlamydia, oral doxycycline or azithromycin. So next one we're going to go into is going to be our viral conjunctivitis. This is an inflammation of the conjunctiva. This is very contagious. The most common type of virus associated with this is going to be adenovirus type 3. Most commonly found in children, especially during this midsummer and fall, swimming pools, daycare. This patient is going to be presenting with profuse tearing erythema, copious clear discharge. They're going to have a palpable preauricular lymphadenopathy. It starts unilateral, but then bilateral after 3 to 5 days. They're also going to be presenting of other symptoms of viral infections. So they're going to have an upper respiratory tract infection, sore throat, fever, malaise. If it's due to herpes simplex virus, then they can have lesions or lid vesicles. For this, we want to make sure that we treat them with topical ganciclovir or systemic acyclovir. But usually if it's due to like adenovirus or your common viral conjunctivitis, then we want to make sure that we just do cool compresses, artificial tears. We can give them, if needed, like some topical vasoconstrictors, antihistamines if they have severe itching, but itching is usually associated with allergic conjunctivitis. So if you notice for viral conjunctivitis, it's cool compresses. For bacterial conjunctivitis, it's warm compresses. Make sure that you don't get these confused. I would get them confused all the time. All right, guys, so next topic we're going to go into is going to be our corneal abrasion. So corneal abrasion, the etiology for this is going to be trauma, contact lens wearers, foreign bodies, welders. The patient's going to be presenting with pain, tearing, photophobia, foreign body sensation, this gritty feeling, blurred vision, headache. Diagnosis, the first thing that we're going to do is we're going to test their visual acuity. We're going to do fluorescence staining. We're going to see epithelial defect and superficial regulation of the cornea, okay, for these patients. And then we have corneal ulcer. Some of the causes of this is going to be usually found in patients that are HIV, if they have diabetes mellitus, if they're immunocompromised, if they're contact lens wearers. And with these patients, they're going to be complaining of pain, foreign body sensation. You'll see a white spot on the cornea. There's going to be tearing, photophobia. They can have green mucopurulent exudate or ground glass edema, which will tell you that this patient has Pseudomonas. And diagnosis for this is that the first thing that we want to do is that we want to test their visual acuity. We're going to do a red eye and fluorescence stain also. Treatment for this is usually with your cycloplegics. We want to dilate the pupil. This will help relieve the pain. We're also going to give them topical antibiotics like erythromycin and then make sure that we follow up with them in 24 hours. Okay. For contact wearers, we want to think about Pseudomonas, right? So we want to make sure that we cover for Pseudomonas. We said with Pseudomonas, they're going to present with this green mucopurulent exudate ground glass edema. So we're going to give them tropomycin or fluoroquinolones and tell them not to wear contacts for 1 week. This is an emergency, okay? We want to make sure that we're referring these patients because they can lose their eye vision. Next thing we're going to go into is dacryadenitis. This is rare, usually commonly found in children. If it's in adults, we want to think about gonorrhea. They're going to be presenting with severe pain and swelling over the temporal aspect of the eyelid. Then we have hyphema. This is secondary to obstructing blood cells, hemorrhage into the anterior chamber. Blood will settle into the visible layer. Some of the causes of this is your traumatic forces. It tears vessels and it bleeds into the aqueous humor. Sickle cell also tends to give you an increased risk for hyphema for these patients. And then another thing that we need to know about this is in regards to how is this patient going to present with the hyphema. They can have pain, photophobia, blurred vision, nausea, vomiting because they have increased intraocular pressure, hemorrhage in the anterior chamber. Treatment for this is that we want to make sure we do a Fox shield. We're going to place this patient at a 45-degree angle, and this keeps the red cells from staining the cornea. We want to avoid aspirin or NSAIDs. Okay guys, so we have glaucoma. Glaucoma is increased intraocular pressure with optic nerve damage. Usually there's some type of obstruction that is occurring that is not allowing the flow of the aqueous humor to go through the trabecular meshwork. And then usually the canal of Schlemm has increased pressure in the anterior chamber. So the most common one is going to be your open angle. It's more commonly found in patients that are older than 40, if they're African Americans, or if they have a positive family history of glaucoma. It's more commonly found in these individuals. So we have our angle closure glaucoma, and then we have our open angle. So we said the open angle is the most common one, right? So the more severe one, and the one that's an emergency, and they come in and they present to you, and you need to get them referred to an ophthalmology or get an ophthalmology as soon as you can, it's going to be your angle closure glaucoma. This is an ophthalmic emergency, like I said. This is because you have closing or complete closure of that angle. So it's causing that increased intraocular pressure. So how is this patient going to present? Usually in the vignette, it's going to tell you a patient that's coming in and all of a sudden, like it's just acute. Like all of a sudden they have this painful eye, they have this loss of vision. Sometimes they'll say that the patient is presenting and they're vomiting, they're diaphoretic. On physical exam, you're going to see some like injection. So you'll see some circumlimbal injection. You'll see a steamy cornea. You'll see a fixed mid-dilated pupil. That's usually like pathognomonic whenever you read a question stem and it says it's like a fixed, like non-reactive pupil. You want to think about glaucoma. And then these patients are also going to have decreased visual acuity. They'll have tearing, and then their intraocular pressure is going to be elevated for these patients. Okay, so how are we going to diagnose them? So what we're going to do is that, of course, we want to check their visual fields, but we're going to do our tonometry. And I probably said this numerous times throughout this video. I'm currently doing my burn rotation. That's my rotation right now I'm in. And actually today I saw this done. So I saw how they actually do they check to see if there's any type of intraocular pressure, like they do tonometry. It's very interesting. I had never seen it done. I always read in textbooks, but for example, for our patients that come in with burns, they all have to be seen by an ophthalmologist or optometrist. I apologize if I butcher it. They always have to be seen by them because if they have any fire, for example, to the face, then they need to be seen by them. And so we had a patient that came in today. He had a fire to the face, a burn, and then they came in, and basically what they did is that they anesthetized the eye, and then they went in there and they kind of just like poked the eye with the patient's eye open, and that's how they checked the intraocular pressure, which is I thought was pretty interesting. So that's what you're going to do tonometry. Usually on the tonometry, you're going to see elevated intraocular pressure, right? Usually normal is going to be 10 to 22. And so anything that's more than that's going to be elevated. So how are we going to treat these patients? You want to make sure that you refer them immediately to ophthalmology. You want to start as soon as you can IV carbonic anhydrase inhibitor. This is going to help with the decreasing the intraocular pressure that they have. So usually in the question stem, I'll ask you, what's the next best step? If you have a carbonic anhydrase inhibitor on there, like for example, acetazolamide, and it's going to be IV, you need to do that, okay? So IV carbonic anhydrase inhibitor, like your acetazolamide. You can also do topical beta blockers. You can do osmotic diuresis. And usually the treatment for this, like the definitive treatment for these patients, is going to be laser trabeculoplasty. This opens up the trabecular meshwork for drainage, but you have to make sure how you read the question and what it asks you for. If it asks you what's a definitive treatment, then you're going to choose your trabecular meshwork. If it tells you what is the next step you're going to take that you've diagnosed this patient, then you're going to give them IV acetazolamide, right? Because you need to decrease that intraocular pressure. So next one we have is open angle. This is not as acute as angle closure. It's usually chronic. These patients sometimes will be asymptomatic and they don't even know they have it. This can also cause blindness in the patient. So how is this patient going to present? They're going to have defects in the peripheral visual field. Make sure you know that peripheral visual field is going to be decreased in these patients. So have increased cup to disc ratio. And sometimes they'll, like I said, present asymptomatic. Usually we don't catch these patients until they're having the symptoms of the vision loss, okay? But usually the loss of peripheral vision is what you need to know with your open angle glaucoma. Diagnosis with these patients, they can have, of course, we're going to do the tonometry for these patients, right? And then how are we going to treat these patients? They should be referred to an ophthalmologist because we want to make sure that they are being monitored closely. We can also give them some topical and systemic medications to decrease the intraocular pressure. So once again, we can do our topical beta blockers and then carbonic anhydrase inhibitors. We can also give them epinephrine and alpha agonists. But what you need to know in general for glaucoma is you need to differentiate between your closed and your angle, right? Your open angle. So your closed is going to be a lot more severe, which makes sense, right? You're closing that, you're causing more increased intraocular pressure to the eye. These patients are usually going to be presenting with acute pain. They're having trouble with their vision, they can't see, and then you're going to see a fixed dilated, it'll say usually in the question stem steamy eye. That's what I've read. And what you need to know is that you're going to do a tonometry. You need to consult as soon as you can, of course, your optometrist, your ophthalmologist, and then they need to get IV acetazolamide. Versus your open angle, it's more chronic. It's not as acute as your closed angle, but it still needs to be treated because these patients can also go blind. It's just slower, okay, more chronic. And these patients are going to be presenting with a peripheral vision loss, okay? So that is glaucoma. So now we're going to go into macular degeneration. Macular degeneration is the leading cause of permanent vision loss in older patients. So this is very commonly going to be found in patients that are older. Other patients that can present with macular degeneration, sometimes if they have drug toxicity from medications like chloroquine, you also have phenothiazine. How is this patient going to present? They're going to have gradual vision loss, and it's going to be central vision loss only, okay? See how you differentiate between those two, and that's what I would mess up all the time, is that the questions can sometimes be very vague, and it'll just say that the patient is presenting with peripheral or central vision loss, and this is where you need to distinguish them. So we said that glaucoma, especially your open angle glaucoma, it's peripheral vision loss. With your macular degeneration, it's going to be central vision loss. So we have two different types. We have our exudative and our non-exudative. So what you need to know is that between both of these, the exudative and the wet one is a really bad one. You don't want to have that. I mean, they're both bad, but this one's very severe because these patients will have severe rapid vision loss with your exudative and wet macular degeneration. Sometimes they'll just describe that you'll see some neovascularization or hemorrhages. You need to associate that with exudative. So make sure that you know that. So exudative is going to be our wet macular degeneration. You're going to see neovascularization, hemorrhages, and these patients are going to be presenting with severe rapid vision loss. And then you have non-exudative or atrophic, also known as dry. These patients are going to be presenting with retinal drusen, which is going to be round yellow-white deposits. And usually with these patients, the visual impairment tends to vary. Okay, how are we going to diagnose these patients? We're going to do an Amsler grid chart. This is going to help us see whether the patient has lost central vision loss. So once again, Amsler grid chart for your macular degeneration, and treatment for this is going to be laser photocoagulation. So make sure you know this is very, very highly tested. Make sure you differentiate between exudative and non-exudative. We said exudative is going to present with neovascularization, hemorrhages, and severe rapid vision loss. And non-exudative or atrophic is going to be shown with retinal drusen, round yellow-white deposits. Okay. So next one's going to be optic neuritis. This is going to be an inflammation of the optic nerve. The most common etiology of optic neuritis is going to be multiple sclerosis. It tends to develop in about 50% of patients that have multiple sclerosis. Other causes are infections, autoimmune diseases, irritable bowel disease, and also if they're taking certain medications, it can cause optic neuritis. How is this patient going to present? They're going to have abrupt vision loss. It's usually going to be monocular. Okay, make sure you know that. Abrupt vision loss, and it's usually monocular. Sometimes they'll try to trick you saying that it'll involve like both eyes, so make sure you know that. So abrupt vision loss, monocular. Sometimes they'll be presenting with periorbital pain with eye movement. They'll have also dyschromatopsia, which is poor color perception, and this is because there's faded dual, especially like the red tones. They'll be presenting also with symptoms of a recent flu-like viral syndrome, Marcus gun pupil also. And how do you diagnose these patients? We're going to, of course, check their visual acuity, and you're going to see that they have decreased visual acuity and color perception. You're going to do a fundoscope exam. Sometimes it can be normal. Sometimes it'll be showing you that it's swollen. And treatment for this is going to be corticosteroids, right? We want to decrease that inflammation. So next one's going to be orbital cellulitis. So orbital cellulitis, we have our periorbital and our orbital. Make sure you know that because this is very, very highly tested. I think I've gotten a question on this multiple times, whether it was during my didactic year, and then I know I got it for my pediatrics and I think in family medicine, EOR. So make sure that you know this is very, very highly tested. So once again, periorbital cellulitis is an infection of the eyelid and surrounding tissues. Orbital cellulitis is infection of the orbital soft tissue. So another way to know this is that periorbital is preseptal, so it's going to be anterior to the orbital septum, and postseptal orbital cellulitis is going to be postseptal, so it's going to be posterior to the orbital septum. So that's how you differentiate between both of them. Where is the inflammation occurring? Is it anterior to the orbital septum, or is it posterior to the orbital septum? So what are some of the causes of orbital cellulitis? Most common one's going to be your previous trauma. I've read question stems where it says that there was a little kid, he was playing baseball and the baseball hit him in the face, or they got hit in the face with a bat, or etc. So it's usually going to be some type of trauma. Other causes can be cutaneous injury. So once again, just because repetition is the key, periorbital cellulitis involves the preseptal area, which is going to be anterior to the orbital septum. With periorbital cellulitis, it's associated with an upper respiratory infection, usually infections with Staph aureus, also with Staph epidermis and Streptococcus species also. And then for orbital cellulitis, we said it's postseptal, right? So it's posterior to the orbital septum. Usually some other causes of this can be paranasal Staph aureus, sinusitis, Streptococcus pneumonia, and then, of course, anaerobes. So how is this patient going to present? They're going to have symptoms of eyelid redness, conjunctival edema. It's going to be warm to touch, tenderness. Sometimes it can start with one eyelid and then it'll involve both. They'll have tearing, fever, preseptal cellulitis. Usually they'll have signs of fever, respiratory infection, and then also they can be septic. So how are you going to diagnose these? These are emergencies, especially your orbital cellulitis ones. So with these patients, we need to do a CT. That's how we're going to diagnose them, okay? We're going to do a CT. And if a patient is complaining of pain with their eye movement, like they have pain moving their eyes, or they have decreased visual acuity or proptosis, then that's usually associated with orbital cellulitis. So the way to differentiate between both of them, like I said, is of course the location. Orbital cellulitis is going to be a little bit more severe than periorbital. With orbital cellulitis, it'll say that the patient can't move their eyes to one side or the other. And then they also have decreased visual acuity, or they have proptosis of the eye. And that's when you're like, you know what, it's orbital cellulitis. So once again, CT scan is how you're going to diagnose these patients. Treatment for them is if it's periorbital or preseptal, you're going to do amoxicillin and clavulanic acid, augmentin. That's usually your drug of choice. You can also do a first-generation cephalosporin. But if it's postseptal, right, if it's orbital cellulitis, if they're having that proptosis of the eye and they're having pain whenever they move their eye or they just can't move it at all, these patients need to be admitted to the hospital. They need to be given IV antibiotics, either second or third generation cephalosporins. Other medications that they can be given are ampicillin, sulbactam, carbapenems, or clindamycin. But these patients need to be hospitalized, and we're going to give them IV antibiotics. So now that we're done with that one, we're going to go into papal edema. Papal edema, and this one's very, very highly tested, so make sure you know how to treat it and how it presents. So papal edema, this patient's going to be presenting with a headache. They'll have a headache that's worse with coughing, nausea and vomiting, loss of consciousness. Sometimes you'll see pupillary dilation. They'll have pulsatile tinnitus. Sometimes visual symptoms are absent in these patients. And you're going to see blurred disc margins. That's usually what is associated with papal edema. Also congested disc for papal edema, phlegm hemorrhages, infections, and you're going to see white cotton wool spots. Okay, white cotton wool spots, and we're going to diagnose these with a fundoscope exam for papal edema. And what are some of the causes of papal edema? So it's usually due to a secondary cause, so things like increase in intracranial pressure, whether it's from some type of tumor, whether the patient has hypertension, they're having a hemorrhagic stroke, acute subdural hematoma, pseudotumor cerebri. So these are some of the causes of papal edema. And how are you going to treat this? We're going to treat the underlying cause. Okay? So the next one we're going to go into is going to be retinal detachment. Retinal detachment is a separation of the retina from the pigmented epithelial layer. It commonly begins at the superior temporal retinal area, and the tear can happen sometimes spontaneously, or sometimes it can be secondary to trauma. Usually these patients are going to have myopia. They'll have inflammatory changes in the vitreous, retina, or choroid. They'll be presenting with acute onset of painless, blurred, or blackened vision that occurs over several minutes to hours and progresses to complete or partial monocular blindness. Usually in the question stem, it's going to say that the patient has, they feel like there's a curtain that was drawn over their eye from the top to the bottom. So that's usually pathognomonic for your retinal detachment, is that curtain drawn over the eye. These patients were also going to be saying that they see floaters or flashing lights at the initiation of symptoms. And if you try to do a tonometer to look at their intraocular pressure, you're going to see that it's normal or it's reduced for these patients. So once again, with retinal detachment, they're going to be presenting with floaters or flashing lights. They're going to have this complete or partial monocular blindness. They're going to have a curtain that's drawn over the eye from the top to the bottom. Okay. And we're going to treat these patients. It's usually an emergency consult with ophthalmology. We're going to do either laser surgery or cryosurgery. And then the patient, if you have them in the clinic with you and they're presenting with this, you want to make sure that they remain supine with their head turned to the side of the retinal detachment. Sometimes these patients will recover, but these patients need to have laser surgery or cryosurgery for the retinal detachment. Okay. So retinal vascular occlusion is going to be the next one. This is very commonly found in patients between 50 to 70 years old. Usually they have a history of coronary artery disease. Okay. Usually when they're presenting with sudden painless monocular loss of vision. They'll have retinal pallor, retinal edema, vascular narrowing, and then usually what you'll see on the question stem, it'll say boxcar appearance. So boxcar appearance is usually associated with retinal vascular occlusion. Diagnosis, we want to make sure that we check their visual acuity. And then treatment, we can do the digital globe massage, lower intraocular pressure, and then of course make sure that we refer these patients out to go see an optometrist. So once again, retinal vascular occlusion, this is going to be sudden painless monocular loss of vision. It'll say boxcar appearance, and treatment will do the digital global massage, lower intraocular pressure, and then make sure that we refer them immediately. So now we're going to go into our foreign body of the eye. So foreign bodies in the eye. So what are some of the causes of this? Of course, any patient that has some type of injury to the eye, right? Explosion, striking metal that goes inside the eye. Signs and symptoms, this patient's going to be presenting with pain and irritation with their eye movement if it's just like a surface foreign body, but if it's like lodged into the globe, so if it's an intraocular foreign body, these patients can be presenting with discomfort and blurry vision. How are we going to diagnose this? We want to make sure that we do a thorough history. First, we want to check their visual acuity. So once again, first thing we're going to do is visual acuity. If the question asks you what's the next best step, it's going to be you want to make sure you check their visual acuity. If the patient has an intraocular foreign body, we're going to do a slit lamp, and then we're going to do also a CT or X-ray to make sure that we identify radiopaque particles. We want to make sure that we don't do MRIs in these patients, okay? Treatment for this is going to be usually with topical anesthetics like proparacaine. We can give them also polymyxin, bacitracin, erythromycin, so our topical antibiotics. And we want to make sure that these patients are following up closely with their optometrist, and then we also want to refer them out. If we want to remove them, we're going to do sterile saline irrigation. We're going to remove it with the fine gauge needle. And if it's a steel foreign body in the eye, we want to look for the rust ring, right? And we want to remove the rust ring within 24 hours. And then intraocular foreign body, if it's in the eye, these patients need to be referred emergently. Okay, guys, so now we're going to go into our acute otitis media. Acute otitis media. So acute otitis media, there's several causes, right? We have viral and bacterial. Viral is the most common cause of acute otitis media. And otitis media is usually due to an infection of the middle ear, okay? Most common cause, like I said, it's going to be viral, so make sure that you know that, even though they teach us in class so that we're always going to treat them with amoxicillin, right? Because we're covering for streptococcus, but the most common cause is going to be viral. Very commonly found in infants and children. Why? Because the angle that their middle ear makes them more prone to getting these infections in comparison to adults. And with these patients, like I said, it's most commonly found in children. The bacterial organisms that are associated with acute otitis media, make sure that you know these. It's going to be Streptococcus pneumonia, Mycoplasma catarrhalis, and Haemophilus influenza. How I memorize it is that anything that affects here is shaking my head, right? Shaking my head, shaking my head, shaking my head. So SMH, shaking my head, Streptococcus pneumonia, Marxella, and then you have your Haemophilus influenza, which are commonly associated organism with acute otitis media. But the commonly one that's going to be tested is going to be Streptococcus pneumonia. So how is this patient going to present? They're going to have otalgia, they're going to be irritable, crying, they're going to be lethargic, they're going to be pulling their ears, complaining of an earache. Sometimes they'll have fever also. When you look inside the ear, you're going to see an erythematous tympanic membrane. The tympanic membrane is going to be bulging. It'll be retracted or perforated. But usually just make sure that you know that it's going to be bulging and retracted. It'll be like still. So the tympanic membrane is going to be hypomobile. That's usually what will get you on the question stem. You're reading the question stem, you're like, you know what, this patient has acute otitis media. And then it tells you how is it going to present on once you look into the ear, like how is it going to present? And it'll try to trick you, so make sure that you put that you know that's going to be retracted, it's going to be bulging, and it's going to be hypomobile. It's not going to move, it's just going to be there still, okay? And you're going to have decreased hearing. We're going to diagnose this with tympanocentesis, but of course that's never done because it's very painful. And then treatment is going to be first line amoxicillin, okay? If the patient is allergic to penicillin, then we can give them azithromycin. Once again, first line is going to be amoxicillin, right? Because we're covering for our Streptococcus pneumonia, which is the most common cause of, one of the most common causes of acute otitis media. And then if they're allergic to penicillin, we're going to do azithromycin. So now we have acute otitis externa, so that's going to be inflammation of the external auditory canal, right? So otitis media, which makes sense, media in Spanish, medio. It's going to be the internal infection of the middle ear. And then acute otitis externa, which has a name, right? External, it's going to be infection of the external auditory canal. This is also known as swimmer's ears because patients or kids that like to swim or swimmers tend to get these infections very, very common. So some of the causes of acute otitis externa could be moist environments, if the patient had any type of water exposure, also mechanical trauma, very commonly found in diabetics. If it's found in diabetics, it's usually malignant in these patients. What are some of the pathogens that are associated with acute otitis externa? Pseudomonas is a big one. Pseudomonas likes moist, wet environments. Pseudomonas. I know I'm going to bring up my burn again, but hopefully this helps you guys just remember this, because it does for me whenever I'm studying. So in our patients that come in with burns, we, of course, when they're burned, they have wounds that are open, and sometimes they're moist, and this is like a perfect area for these environment for this bacteria to live in, Pseudomonas. And sometimes with these patients, what happens is that once if they need to go into surgery, they need to be grafted, basically grafts means is that they get skin from another part of the body and they place it on the burned area, because that burned area has no skin, right? Especially if it's your deeper burn. So they'll graft it, they'll place it on that. And with these patients, usually they have to put Xeroform, which is a type of covering on the graft or on the place where the donor site was, where they got the graft from. And sometimes these areas, if the patient's not clean, if they're wetting it, they can get Pseudomonas. And we know this because when we start peeling it off, it's green, it's just really gross, and it's Pseudomonas. This is a perfect environment for Pseudomonas to live in. So once again, this is why acute otitis externa is very commonly associated with Pseudomonas, because you have water there that sometimes doesn't get cleaned out. That's why it's very commonly found in swimmers, right, when they're swimming. That's why I'm very, very anal about cleaning my ears when I shower or when I get in. I always go in there. I know I shouldn't be doing that, but I'm always scared that I'm going to get otitis externa, because that environment in the ear canal is just a perfect environment for this type of bacteria to live in. So that's why Pseudomonas is very commonly associated with acute otitis externa. Other infections are going to be your staph, Proteus, Aspergillus also. And then how is this patient going to present? If a patient presents with a brown, yellow discharge with a very strong odor, we want to think about cholesteatoma, okay? Usually with these patients with acute otitis externa, they'll have itching, sometimes they'll have conductive hearing loss, right, because it involves the outer portion of the ear. They'll have a swollen canal. It'll be moist, tender ear canal skin with auricle movement that is painful. They'll have also discharge. During my pediatric rotation, I saw so much, and you can see the discharge from here, from the ear. It'll be edematous, and they'll have also periauricular lymphadenopathy. But usually with these patients, when you read the question stem, it'll just say that they'll have discharge to the external ear, and then whenever you move the ear, it's really, really painful for them. And treatment for this, we want to make sure that we give them otic aminoglycosides, so something like neomycin sulfate, polymyxin B-sulfate. We can also do corticosteroids, quinolones. If it's fungal, we want to make sure that we give them amphotericin B. Remember, fungal is usually associated with patients that are diabetic, so amphotericin B for fungal infections. Some of the complications of acute otitis media in diabetics, or your patients are immunocompromised, they can get malignant external otitis. And I think I said this once during my ENT rotation. It was a patient that had this, and it's really, really gnarly looking. So these patients have malignant external otitis. They'll be presenting with persistent foul oral discharge. They'll have very deep otalgia, which means painful. Their ear will be very painful, and we have to get a CT to diagnose these patients. So next one's going to be mastoiditis. This is going to be an infection to the mastoid bone. So mastoiditis. With mastoiditis, it's usually a complication of otitis media that has not been treated. So that's why it's important that we treat these ear infections, because they can go, since it's so close to the brain, it can go anywhere. And this is one of the complications of it. It's mastoiditis. How's this patient going to present? They'll have redness behind the ear. Usually they'll show you a photo and there's redness behind the ear, right here. Their pinna is going to be displaced. They'll have post-auricular pain, swelling, tenderness, fever, a bulging tympanic membrane with these patients. And then to diagnose them, we're going to do a CT scan. We're going to see coalescence of mastoid air cells due to destruction of bony septa, right? Because that bacteria is invading that area, that bone. And then treatment for this is going to be IV antibiotics, so your ampicillin, your cefuroxime. You can also do a myringotomy. Sometimes they'll do a mastoidectomy, okay? But IV antibiotics, and then of course, depending on how severe it is, mastoidectomy also. So barotrauma is going to be the next one. This is going to be an injury due to barometric pressure changes, very commonly found in your divers, especially the divers that like the deep divers that like to go really, really deep. Also airplanes, mechanical respiratory support. So usually with these patients are going to be presenting with, if it involves the external ear, they're going to have hemorrhagic blebs or ruptured tympanic membrane. If it involves middle ear, you're going to see an impaired eustachian tube. And treatment for this, of course, tell the patient to just swallow or yawn. Okay, you can also give them decongestants. If it's severe or if it's recurrent, then we can do a myringotomy or ventilating tubes where you just go in there and you put tubes in the ear, right? It's going to decrease that pressure. So that's a lot done during my ENT rotation. It was a great rotation. So that is barotrauma, okay? So if you think about it, right, you have your eustachian tube and you need to have a balance of pressure between that tube. Sometimes if there's an imbalance of pressure, that's where these patients feel like they have like a congested ear. That's how they would describe it when I was doing my ENT rotation. They feel like they need to pop their ear, or they feel like they're on an airplane the entire time. So they have like this muffled hearing. And that's because there is an imbalance between the eustachian tube. So usually what happens is if this patient, this is why we give them decongestants, right? We want to make sure that we decrease that congestion that's going on. Because if you have any type of like sinus infection, because you have all your sinuses that will connect to your ears, right? Your ear canals. So if you have any type of infection or anything that's causing like a plugging, that's why these patients can also have like trouble with their hearing. We would see a lot of patients that had like chronic sinusitis, that they had ear problems because of the same reason. And usually with these patients that, for example, that they do have like a pressure, because we would go in there and measure the pressure of the ear, and we did see an imbalance in the pressure, we would just go in there and just put tubes in there. And that's going to cause like and it's dramatic for these patients because they feel so much better. It decreases, they can actually hear now. They don't hear that muffled sound, right? Because you have the eardrum, you go in there and you put like a little tube in there, so that allows like air to go through, and you have a balance now, instead of basically covering it like this and there's not really a balance because you have pressure here, right? Or it's not draining appropriately. So yeah, that's barotrauma. So next one's going to be tympanic membrane perforation. This is going to be a hole in the tympanic membrane. Some of the causes of this are usually middle ear infections, like patients that have acute otitis media, right? So that pressure in that tympanic membrane, if these patients don't get treated, sometimes can just become perforated. And sometimes they'll just feel like they'll have so much pain, and then it just perforates and they feel so much better. Also, barotrauma can cause tympanic membrane, right? Because you have that increased pressure that's not balancing between your eustachian tube and your eardrum. And then other causes of this can also be trauma or cholesteatoma. So what are you going to see, or how is this patient going to present? Of course, you're going to look into their ear. They're going to have a hole in their tympanic brain, or sometimes they say that they feel like they have something in their tympanic membrane. You also see maybe a central marginal perforation. Sometimes they can complain of pain, so they'll say that they have acute onset of pain and hearing loss. They'll have bloody like autouria, so like discharge of the ear, bloody. Treatment for this is usually not needed. They will usually just heal by themselves, and they don't need to get antibiotics for these patients. So next one's going to be hematoma of the external ear. This is going to be an auricular hematoma, also known as your cauliflower ear, right? This can be chronic. It's usually due to a direct trauma. So like, your boxers to the anterior auricle, and very commonly found in your wrestlers, like I said, your boxers, your martial artists, And these patients are going to be presenting with thickening or induration of the pinna and external ear. Sometimes you'll see like distortion of the contours of the ear. And if it's not corrected, it can become deformed. It can cause that cauliflower ear. So that's why you want to make sure that these patients sometimes go in there and they need incision and drainage for these patients. So vertigo is going to be the next one. This is very highly tested, so make sure that you know this. Vertigo is sensation of motion or exaggerated motion when there is none. So the patient feels like the room is spinning when it's not. In these patients, some of the causes is going to be ototoxic. So if they are taking your medications like aminoglycosides, right? Those are very, very well known for being ototoxic. So your aminoglycosides are going to be your streptomycin, right? And those medications, gentamicin, neomycin, all those. Also, alcohol intoxication cause vertigo, nicotine or caffeine. If the patient's older than 50 and they had any type of head trauma, they can cause vertigo. Or if they have any debris in the inner ear. The patient's going to be presenting saying that they have like they say that they have, or they feel like the world is spinning around them. They're going to be very dizzy, drowsy, lightheadedness. They're going to have an imbalance. Also with these patients, they're going to be nauseous. And it gets worse whenever they change positions. So that's usually the key for this one, for vertigo. So with vertigo, though, we have to differentiate whether it's a central cause, something in the brain's going on, whether the patient's probably having like a stroke, a tumor, or anything, versus a peripheral cause. So peripheral cause, right? Anything that involves the ears that is just, or the ear canal where the patient is just not having a correct balance. So we need to differentiate between the central or peripheral cause. Usually with a central cause, it's gradual on onset, so it's not acute. The patient is going to be saying that they've been feeling dizzy for a while and it's getting worse, like probably days, weeks, months. Versus peripheral, it's going to be sudden onset, like this morning I woke up and it's just like I feel so dizzy. So it's going to be sudden onset, or just like a few minutes ago, I feel really dizzy. So usually with these patients, you're going to be presenting, like I said, symptoms that are brought on whenever they change position of their head. So if they tip their head back, for example, they feel more dizzy. These are questions that you ask the patient whenever you are interviewing them and they present with dizziness or like vertigo-like symptoms. I had so many patients during my family medicine rotation that would present with vertigo symptoms, and I don't know why I always had so much trouble with dizziness. Like with that diagnosis, I just had so much trouble, and I always mess it up because I didn't ask him, hey, is the dizziness worse whenever you change position? So it's really, really important that these patients are going to be presenting with symptoms that are brought on whenever they change position of their head. Another thing about this is that episodes will last less than 1 minute, and the dizziness is usually triggered by lying down or rolling over. So once again, whenever they change position. So a way we're going to diagnose this is going to be by doing the HEENT exam. It's going to be a horizontal head impulse nystagmus test of skew, okay? And then we're also going to do a Dix-Hallpike maneuver, which is going to be usually positive in these patients, and they're going to have that burst in nystagmus, right? That's, okay? So vertigo, it's really interesting. So I'm going to bring, once again, that I'm going to bring an example from the burn unit. We had a patient that came in last week. It was a gentleman that suffered an electrical injury. So he had an electrical injury, and then it was really bad that he actually passed out. He lost consciousness and he hit his head, and he had epidural hematoma. So he had a brain bleed, but it was really, really small that it didn't need to have surgery. We were just going to observe it. But the patient was complaining of dizziness, and he said that ever since he fell on his head, he's felt like he's gone, like he feels really dizzy when he stands up. He just feels like he's gonna pass out, etc. So we actually called our physical therapists and our occupational therapists are in the hospital. They came and they evaluated the patient, and they did these tests. They did the Dix-Hallpike maneuver, and they did the HEENT test to make sure that it's not anything related centrally. And thankfully with that patient, it was not. Everything was normal. It was just peripheral. So this is a way that you differentiate between a central cause versus a peripheral cause for these patients, okay, is by doing your Dix-Hallpike maneuver or your HEENT test, which is your horizontal head impulse nystagmus test of skew. Okay? Treatment for this is going to be usually, we're going to observe it, right? We can do the Epley maneuver if it's a peripheral cause. So an Epley maneuver, what it does is that it's going to basically reposition the particles that are disrupted, which is causing that nystagmus with these patients. And then this involves like moving the head in like 4 positions for these patients. So once again, to make sure that you don't mess these up, because I know I mess these up all the time. So for vertigo, we're going to differentiate between our central and our peripheral cause. Central is going to be more chronic versus peripheral is going to be more like acute. It'll be quick on onset with these patients, okay? And we're going to diagnose them. We're going to do a HEENT exam, right? Because we want to see whether it's our peripheral or central cause. And then we also want to do a Dix-Hallpike maneuver. And if it's positive, we'll see that burst of nystagmus. And then we're going to treat this with an Epley maneuver. We're going to do particle repositioning, moving the head into 4 positions. And then, of course, we want to make sure that we find the underlying cause if it's due to a central cause. So next one's going to be labyrinthitis. This is a unilateral infection or inflammation of the vestibular system or inner ear. So it's an inflammation of the vestibular system or inner ear. It's usually due to a virus. A patient will present with a history of an upper respiratory infection that just happened like a week ago. They got better, and then they're presenting with dizziness. And this is how they're going to present. They're going to present with vertigo-like symptoms after like having the flu a week ago. And so how's this patient going to present? It's going to be, once again, it's going to have acute onset of dizziness, right? Because it's going to be a peripheral cause. They're going to have nystagmus, nausea, and vomiting. They're going to feel really sick. And they'll have rotational vertigo that remains like vertigo when the patient opens or closes their eyes. They can also be presenting with hearing loss and tinnitus, which is bringing in the ears for these patients. And treatment's going to be self-limiting. Sometimes it takes a few weeks to recover, but we can help them by giving them like diazepam, meclizine, these medications that are going to help them with their symptoms, right? So it's symptomatic treatment. So once again, labyrinthitis, the patient's usually going to say, or in the question stem, that they had a history of an upper respiratory infection, and now they're presenting with dizziness. They're going to be presenting with tinnitus, so ringing in the ears, hearing loss, and then usually this is self-limiting. We can give them symptomatic treatment like diazepam, meclizine, or diamond hydronate. So foreign body of the ear, this is commonly found in children, right? Or even like your older patients that have like neurologic problems. Sometimes they'll put stuff in their ear. These patients are going to be presenting with pain. Sometimes they even have discharge from the ear. They're going to have irritation because whatever's in there, whether it's an insect. I have yet to see one of these, but I've heard stories from my classmates that have seen a bunch of these during their rotations. So if it's an insect, we want to make sure that we put lidocaine in there, okay, first. So we want to make sure that we put lidocaine first, and then we can remove it if it's an insect. And we do not want to irrigate anything that's an organic material, okay, because like foods, like beans, because these can swell. So tympanosclerosis is going to be the next one. This is a calcification of the subepithelial connective tissue of the tympanic membrane and middle ear. So once again, tympanosclerosis is a calcification of the subepithelial connective tissue of the tympanic membrane and middle ear. This patient is usually going to have a history of a chronic otitis media, tympanostomy tubes, or a cholestotoma. They're going to be presenting with progressive hearing loss. It'll say that they have white chalky patches on the tympanic membrane or middle ear. And we're going to diagnose this, usually a clinical diagnosis. You can do a CT if needed. Treatment for this is usually surgery and then also your hearing aids. So next one's going to be your acute bacterial parotitis. This is a parotid inflammation, an inflammation of the parotid gland. The most common bacterial cause of this is going to be Staph aureus. That's the most common cause of your acute bacterial parotitis. It can also be polymicrobial, but the most common cause is going to be staph. Some of the risk factors for this is going to be if the patient's older, if they had just surgery, if they're dehydrated, or if they had any type of poor oral hygiene. Symptoms for this is patients will be presenting with a firm erythematous swelling of the pre and post auricular areas. They'll have dysphagia, so trouble swallowing, purulent discharge, and sometimes they'll have systemic symptoms like fever and chills. Diagnosis, we want to make sure that we do a fine needle aspiration that's ultrasounded guided. We want to make sure that we culture and gram stain the exudate. We can do a CBC. Usually we're going to see leukocytosis, right, because it's a bacterial infection. We'll see increased amylase, which makes sense. We can do an ultrasound, and then we can do a CT scan if we think that like there's an extension of that inflammation. Treatment with these patients is usually with antibiotics, something like nafcillin plus metronidazole or clindamycin or augmentin, and then to make sure that we are telling these patients to hydrate themselves. So next topic is going to be sinusitis. So sinusitis, the thing about sinusitis is that you need to differentiate between acute sinusitis and a chronic sinusitis. And of course, it's going to be depending on how long the patient is presenting with symptoms or if they have recurrent episodes of sinusitis. So acute is going to be anything that is less than 4 weeks. Subacute, it's going to be between 4 to 12 weeks. And chronic is going to be a patient that's presenting with these symptoms more than 12 weeks. What are some of the causes of sinusitis? It's due to impaired mucociliary clearance and osteomeatal complex obstruction. There's an accumulation of mucus secretions and edema. Some of the causes of acute sinusitis is rhinovirus, like your common cold. Usually the most common cause is going to be a viral cause, okay? Parainfluenza, influenza, RSV, bacterial infections involve Streptococcus pneumonia, right? Shaking my head, anything that's involved in there. So Streptococcus pneumonia, Marxella catarrhalis, and then your Haemophilus influenza. Rhizopus, also mucor, aspergillus. These are usually found in your immunocompromised. These are your fungal infections, okay? So how is this patient going to present? They're going to be presented with fever. They'll have a discolored purulent nasal drainage. They'll have congestion. They'll be complaining of facial pain, especially in like the maxillary sinuses. So that's why whenever we see these patients, we go like this, right? See, do you have any pain here? Do you have any pain here? I did so much, not like that, but here, right? Because we have those sinuses there that get congested, and the most common one is going to be your maxillary sinus. Sometimes these patients will also be presenting with tooth pain. I actually had sinusitis once, and I had tooth pain. I thought I had a toothache, but no, I had sinusitis. So these patients will be presenting with tooth pain. So just make sure that you keep that in the back of your mind. Also, they'll be presenting with headache. They'll have halitosis, so that like nasty breath. They'll have tenderness to palpative sinuses whenever they're bending forward. And then diagnosis, we can do an x-ray. We're going to see opacification, air fluid, and thick mucus. But our test of choice is going to be CT scan. On our CT scan, we're going to see bone destruction, air fluid levels, and thick mucosa. So during my ENT rotation, we saw a lot of patients that had chronic sinusitis, or they just had recurrent sinusitis, where that would get referred to us from their primary care doctors. And the first thing that we would do for these patients is that we do a CT scan. And we would do a CT scan, and we would look at the sinuses. And sometimes, like, some of these patients just had, like, their like the nasal mucosa, like they had polyps like in their nose that were just really, really large, and they were causing obstruction, which was causing their recurrent sinus symptoms. Like whenever you looked in their nose, you couldn't see it, but you did that CT scan and you would see, right, because we have this right here, you would see just like where the air just could not go through because they had like polyps, which are like this like nasal mucosa that will grow in your nose, and it was just so enlarged that it was just blocking. Or you would see them with like a really bad sinusitis where you would see just like, it's supposed to be black here, right? Because that means it's air and that's how it should be. But no, you would see it like filled with just fluid and yuckiness. So that's why we would do a CT scan for these patients with sinusitis. So sinusitis. So once again, we're going to do our test of choice is going to be CT scan. We're going to see bone destruction, air fluid levels, like I said, thick mucosa. If it's due to like your polyps, right? I guess they're obstructing that airflow. That's why this patient is presenting with these symptoms. Another thing is not only polyps, like I said, the patient can also have like thick mucosa, like just around that is just obstructing that airflow. And this patient is why they're having these recurrent sinusitis. So treatment for this, if it's acute, we're going to treat them for 10 to 14 days. We can give them oral decongestants like pseudoephedrine, nasal decongestants, analgesics. Antibiotics first line is usually going to be amoxicillin clavulanate, right, or Augmentin. You can also do doxycycline. And then some of the complications for sinusitis if the patient is not treated is that they can get osteomyelitis, right, an infection of the bone. They can get cavernous sinus thrombosis because we have, like, our sinuses are just so close to the brain, and that bone is just so thin that it can easily go to the brain. And it was really interesting because when I saw a lot of surgeries, like nasal surgeries, and it was just amazing because you would see how thin that bone is. So that's why it can go up there and it can cause all these things in the brain. So that's why it's really important that we treat sinusitis if we think it's a bacterial cause. And then, of course, orbital cellulitis, like we mentioned earlier. So once again, sinusitis, make sure that you know that acute is less than 4 weeks, subacute is 4 to 12 weeks, chronic is more than 12 weeks, okay? We're going to diagnose these patients with CT scan. That's our choice of test. Treatment is for acute, it's going to be Augmentin for 10 to 14 days. So next one's going to be allergic rhinitis. This is inflammation of the nasal mucosa. With allergic rhinitis, we want to think about our triad, right? So our atopic disease of asthma, eczema, and then your allergic rhinitis. Sometimes when I read a question stem and it says that the patient has a history of asthma and they have eczema, and this patient is presenting with like itchy, watery eyes, I'm like, you know what, that's allergic rhinitis, right? Because if you know that triad, it can help you so much. Also, some of the causes of allergic rhinitis, sometimes they'll have a family history, allergen exposure, right, or IgE is what's causing all this like inflammation, that allergies. Patients going to be presenting with itchy and watery eyes. So whenever I think about itchiness anywhere, whether it's in the eyes, I think about allergies, right? Because you're having that histamine release that is causing all that itchiness, your mast cells. So itchiness, you want to think about allergic rhinitis. So itchiness, watery eyes, sneezing, nasal congestion, dry cough, nasal discharge. You're going to have their allergic shiners, right? Nasal salute. My sister actually has this as a child. She suffered from allergies a lot, and she would do this a lot. And she actually has that fold right here. She has that fold right here. And that's what the nasal salute is, because they would go like this a lot, and she has it. Clear rhinorrhea. They'll have pale, boggy, bluish mucosa. I've yet to see that on exam, but yes, you'll look into their mucosa and it's going to be pale, boggy, and blue. And they're going to have watery, clear discharge. So the thing, like I said, you want to know is that they're going to be presenting with itchy, watery eyes. So whenever I had a patient during my ENT rotation that I would go and see, and I had diagnosed him with it was with sinusitis or rhinitis, I always asked them, like, do you have itchiness? And if it's itchiness, and I'm like, you know what? I know it's allergic rhinitis. So it's a question you always have to ask. Treatment for this, you want to make sure that you educate them on avoiding whatever is causing their allergies. If it's a pet, if it's going to a certain area, just to make sure that they avoid that. And then also you can give them intranasal corticosteroids, antihistamines like your H1 blockers, also topical steroids, and then you can give them mast cell stabilizers like your cromolyn sodium. So anterior epistaxis. So we have our anterior and posterior epistaxis. I've seen so many cases of this in the hospital, in the clinic. So it's really important that you're familiar with these, and it's very, very highly tested. So anterior epistaxis is nose bleeding that originates from the Kieselback plexus or Kieselback plexus. This is very highly tested. So make sure you know this. Once again, anterior epistaxis is going to be nose bleeding that originates from the Kieselback plexus. It's coming from the anterior nasal septum. So some of the causes of this, the most common cause of an anterior epistaxis is going to be your digital trauma. So it's going to be a child that just picks their nose, right? Digital trauma, especially if it's like unilateral, you want to think about digital trauma. Other causes can be infection, trauma right up their head, your cocaine abusers, hypertension, allergic rhinitis, atrophic rhinitis, coagulopathy, or tumors. But usually the most common one is going to be your digital trauma. Signs and symptoms, it's usually going to be unilateral, like I said. It's just going to be involving one nostril. I've seen, all the cases that I've seen it's been unilateral. But of course, like if you hit your head or something, it can be bilateral. But it's usually unilateral. You're going to see on your exam the site of bleed. Usually if you look inside the nose, you can see it. It's very easily seen. And Treatment for this is going to be direct pressure. You're going to do ice packs. You're going to tell the patient to sit and lean forward, right? For some reason, whenever I grew up and I had nosebleeds, my mom would plug my nose and she would go like this, which is what you don't want to do. You're going to tell the patient to lean forward, okay? And then after that, basically with these patients, you can also give them nasal decongestion. So anything that causes vasoconstriction. And then finally, like you've done all that, it's not working, you're going to go in there and cauterize it with silver nitrate if you can find only the vessel that is bleeding. So if you go in there and you cauterize it, you only cauterize it if you can see the whatever's bleeding. And then nasal packing for 24 hours or petroleum packing. So once again, I'm going to discuss 2 cases that I had this. So I had a patient 2 weeks ago. She was a patient with SJS, Stevens-Johnson syndrome. Unfortunately, she got SJS from Bactrim, and she went to, prior to getting Bactrim, she went to shock, and they gave her Bactrim, and then on top of that, they gave her vasopressors, right? So they gave her epi because she was going to shock. She was tanking, so they gave her vasopressors, they gave her Bactrim, and they threw a bunch of antibiotics. So she developed SJS secondary to Bactrim. And due to vasopressors, remember in our pharmacology class, they taught us not to inject like epi in the fingers or in the penis or anything like that because it can cause necrosis. Well, it's rare, right? Well, in this patient, she got necrosis and she needed to get bilateral below the knee amputation. So she got her knees amputated and she got fingers amputated also. And poor lady, she was just, and on top of that, she had SJS, so it was just bad. So I was in the hospital. They had called us because she was having like nosebleeds. So I went in there, and of course, it was only one nostril that was bleeding. And the first thing that we did is that I closed her nose, applied pressure, and I had her sit like this. And I did that for like 10 minutes. I was sitting there with her for 10 minutes, and I was talking to her. And we did that for a while, and still, like, it did not go away. So then after that, what we did is that we packed it. So we packed it, and then we also called in ENT because she is like a SJS patient. We want to just make sure that it's not anything related to that. And what they did is that they went in there. They get these like fancy like things where they can just look, and they can see the vessels that's bleeding. They just grab like I forgot what they're called, I apologize. And they go in there and then they cauterize it, just a stick, silver nitrate stick. They will go in there and they'll just cauterize it, and it was fine. Okay, so that was just a case of anterior epistaxis. And then I'm going to say another case I had real quick. During my ENT rotation, we had an older lady that came in. She was very, very hypertensive. She was like at 120 over 120. She was like 160 over like 110, very hypertensive. And she was coming in for a nosebleed. She had been referred from her primary care doctor. She was coming in for a nosebleed, but she had not been taking her hypertension medication for the past 2 weeks. So of course she had uncontrolled hypertension. So we went in there, since it's ENT, of course, we went in there and we packed it. We packed it nasally, and then of course we restarted the patient on her hypertensive medications. I talked to her on the phone and educated her on how important it's for her to take her hypertension medications, because this may have been a cause of the bleeding, right? Because if you're thinking about it, hypertension is just when you have increased pressures, like I said before, through like a hose, right, through your vessels. So if you have increased pressure, it can cause these bleeds. And this is what I had explained to this patient. And so I told her to follow up the next day if she's not getting better, but we were going to call her anyways. Well, she ended up calling the next day, the daughter did, and saying that her bleeding had not stopped. So she came in, and we went in there, and of course, their fancy little thing, and cauterized it. That's how it was. So that's an example of anterior epistaxis. So next one's going to be posterior epistaxis. This is going to be nose bleeding that originates from where? From the Woodruff's plexus. So anterior epistaxis is from the Kieselbach plexus, and then posterior is going to be from your Woodruff's plexus. Okay? So these patients are usually going to be older. They're going to have like a significant past medical history with like comorbidities, for example, like diabetes mellitus, hypertension. They'll have atherosclerosis. Hypertension is a huge one. They're going to be presenting with profuse bleeding, hematomesis, hemoptysis, blood in the oropharynx. So you'll look in the back of the throat and you'll see the blood there. And sometimes, like when you try to look in the nares and you're like, you know what, I'm trying to see if there's a vessel, and you can't find it in these patients, you won't be able to visualize the source. And it usually involves both nares, so it's going to be bilateral nare bleeding. With these patients, to diagnose them, it requires endoscopic instruments to make sure that you localize where is the bleeding coming from. Treatment for this, we'll do a sponge pack, a balloon tamponade, and then with these patients, you have to admit these patients also. Some of the complications is that they can have a septal hematoma. This can necrose the septal cartilage and lead to perforated septum. And with these patients, they need to be drained and packed. But these patients need to be admitted to the hospital with a posterior epistaxis. You're going to do a balloon tamponade, sponge pack also. So next one's going to be foreign body of the nose. So we talked about foreign bodies in the ears. Now we have foreign bodies of the nose. So this is usually like small rocks, foods, beads, clay, toys, magnets, batteries, buttons, erasers, coins, tissue. Okay, they're going to be presenting with drainage, and usually it's going to be, once again, unilateral, and it's going to be really gross and nasty. It's going to be very smelly also. So once again, it's going to be drainage. They'll be presenting with nosebleed, sneezing, itching, trouble breathing. It'll be unilateral also. And of course, how we're going to treat it, we're going to go in there and remove it. So next topic is going to be acute pharyngitis. So the common causes of acute pharyngitis, once again, it's going to be viral. It's the most common cause. But also you have your bacterial infections like your group A beta hemolytic strep, right? This is your famous strep throat, your Streptococcus pyogenes. And how is this patient going to present? Well, if they have group A strep, they're going to be presenting with sore throat, fever. They're going to have anterior, once again, anterior cervical lymphadenopathy. When you look in the back of your throat, you're going to see tonsillar exudates, okay? They're going to be presenting with chills, dysphagia, petechiae, but they will not have any cough, okay? Make sure you know this. This is very, very highly tested, right? Your Centaur criteria is very highly tested. So once again, it's going to be anterior cervical lymphadenopathy. This is how I differentiate this between mono, because on your question stem, you have a patient that presented with mono, symptoms of like pharyngitis, and it tells you, oh, there's exudates in the back of the throat. The patient has no cough, and you're like, okay, well, and then it tells you, is this strep or mono? And you're like, well, you didn't tell me more. Like, were the exudates like white? Does the patient have like splenomegaly? Like, tell me more, and they don't. But it will say that they have posterior anterior cervical lymphadenopathy. That's how you differentiate between both of them. If it is anterior cervical lymphadenopathy, then it's going to be associated with your group A strep, your strep throat. If it's posterior cervical lymphadenopathy, then that's going to be your mono. Make sure you know that. So, strep throat. Once again, anterior cervical adenopathy, sore throat, fever, tonsillar exudates, chills, petechiae, but they won't have any cough. If they do a cough, that's not strep throat. I mean, it can, but usually it's not. Not according to the Centaur criteria. So our diagnosis, we can do the Centaur criteria. If it's positive, then we're going to do a throat swab culture, and we're going to do rapid antigen detection testing. Treatment for this is going to be with your penicillins or amoxicillin, right? What are some of the complications if you don't treat strep throat? And why it's really important that you educate your patients that they need to finish their antibiotic regimen even if they start feeling better after the first or second day. This is something that I always coach my patients on. During my pediatrics rotation, I make sure I talk to the patient and the mother or the father. It's important that this child finishes their antibiotic, they change their toothbrushes, and that they're not sharing any water or any drinks with anyone while they're infected, because this is very, very highly infectious. Because if they don't finish their antibiotic, and this is what I would tell them, that infection can go to their heart. It can cause what? Rheumatic fever. It can go to their kidneys. It can cause what? Glomerulonephritis. So it's really, really important that they finish their antibiotic regimen. This is really highly tested, so make sure you know this. How I've seen this question is that you have a patient that's presenting with post-streptococcal glomerulonephritis, right? They're having that Coca-Cola colored urine. They're having that edema of the face, and it's a child, and it'll tell you, what would you likely find in this patient's past medical history? Strep throat, okay? Or sometimes it'll give you rheumatic fever, right? This patient is presenting with rheumatic fever symptoms. It'll ask you, what was most commonly found in this patient's past medical history? A history of a recent strep infection. So how are you going to treat this once again? We're going to treat it with amoxicillin, penicillins. So what if it's a viral cause? This is more commonly found. The more common cause of acute pharyngitis is viral. It's usually going to be more insidious. They're going to have coryza. They won't have any exudates. So you look at the back of the throat, it's just inflamed. They won't have any exudates. They're going to have a low-grade fever, and we're going to diagnose this. If you need to, you can do a viral culture, even though we don't do that. Treatment is usually symptomatic, right? You're going to give them ibuprofen, Tylenol. What if it's mono? So remember we talked about the difference between strep and mono. If it's mononucleosis, they're going to be presenting with malaise. They're going to have tender adenopathy, right? And it's going to be what? Posterior lymphadenopathy. Also, they're going to have shaggy white or purple tonsillar exudates. Sometimes the question won't tell you what it is or the color. It'll just say it's tonsillar exudate. So that's how you have to know the difference is by anterior, posterior lymphadenopathy from mono. They're going to have an enlarged spleen. Sometimes they'll give that to you in the question stem, and then also jaundice. Diagnosis for these patients, we're going to do a monospot usually for these patients, okay? You're going to see reactive lymphocytes. And treatment for this is supportive. You want to make sure you tell a patient to limit contact sports, right? Because you don't want them to have any injury to that enlarged spleen that can just cause it to erupt. So, and another thing you have to want to know is that with Epstein-Barr virus, you want to avoid ampicillin, okay? You want to avoid ampicillin. Sometimes it'll give you a question stem of a patient that was on mono. You thought it was strep, right? You give them ampicillin and they had this rash. You're like, oh, that was mono. So, next topic we're going to go to is peritonsillar abscess. So peritonsillar abscess is an abscess formation between the anterior and the posterior tonsillar pillars and the superior pharyngeal constrictor muscle. So it's going to be an abscess in the tonsils. So it's usually a complication of untreated tonsillitis or peritonsillar cellulitis or mononucleosis. Also a complication, right, of our strep throat. Patient doesn't get strep throat, they can get these, doesn't get treated for their strep throat or does not finish once again their antibiotic regimen, they can get these abscesses. Very commonly found in patients that are older than 30 and commonly caused by like multiple microbes. So it's polymicrobial. That's going to be usually the etiology. This patient is going to be presenting with fever, sore throat, trouble swallowing, right, your dysphagia, pain whenever they open their mouth. Sometimes it's described as trismus. Muffled voice, so they'll have that hot potato voice, like when they talk, like they have a hot potato voice, they just can talk. That's how they're going to talk. They're going to be having also unilateral neck pain. You'll see unilateral throat fullness. And the thing about this one that will give it away when you read the questions is that they're going to have uvular deviation. So you're looking in the back of the throat, the uvula is not there, it's going to be deviated. Uvular deviation or shifting, sometimes they're going to be drooling, right, because they can't swallow. And diagnosis for this is going to be leukocytosis. You're going to do a CT scan. Also, you're going to see abscess and edema. And if you also need to do aspiration, so you're going to make sure you aspirate it and culture it to see like what the bacterial cause of this, so we can appropriately treat it. So with these patients, we want to make sure that we treat them surgically, do an IND and tonsillectomy. This is an emergency. There was actually a case, and it was a patient that came in with a peritonsillar abscess, and she was intubated but not correctly, and her airway closed, and she died. She ended up dying. And so this is an emergency. It can cause significant airway obstruction, and the patient can die. So this is emergency. So once again, treatment is going to be surgical, incision and drainage, or tonsillectomy. Antibiotics, we're going to give metronidazole, clindamycin, or penicillin. So next topic is going to be your acute laryngitis. It's going to be an infection of the larynx, very commonly found in your smokers. These patients are going to be presenting with hoarseness. They're going to have a hot potato voice also. They'll have a weak or strained voice, throat. They feel like it's like they have a tickle in the back of their throat. They're going to have this dry cough, okay? Rawness, dysphonia. They're going to have this urge or feeling that they have to clear their throat. They're going to be presenting with fever, malaise, cough that's worse at night, okay? Basically, with these patients in the question stem, they're going to be complaining of voice problems. So they're going to have like this strained voice. Or sometimes it'll say that it's like a singer also, or someone that was just giving a speech. I've read questions of like fans or whatever, rock concert, right? They're like, ah, and so they present with like that. They're like speaking really low. They can't really speak, or they're speaking like this because they have like, they lost their voice. Yeah. So if anything, I might get laryngitis after this, right? Because I've been recording this video for the past several hours. So yes. So how are we going to diagnose this? Basically, it's just a clinical diagnosis. Treatment for this is supportive, right? We're going to tell them to make sure that they rest their vocal cords, vocal rest. Dental abscess is going to be the next one. This is going to be a break in the mucosa bacteria that leads to the infection. Okay, some of the causes of this, of course, your dental caries. If they have any type of trauma, plaque collection, medical procedures, food, foreign objects, they're going to be presenting with local pain and swelling, fever, malaise. Affected teeth will loosen. They'll have a fistula in the mouth or the cheek. They'll have fluctuance. Diagnosis, usually a clinical diagnosis, but of course we can do an X-ray, CT scan. Treatment is that we're going to go in there and do IND, and then we're going to give them antibiotics, right? Make sure that they follow up with their dentist. If it's like a really, really deep abscess and it involves a root canal, then they need to get a root canal, right? I'm sorry, if it involves the nerves in the tooth, they need to get a root canal and get the tooth extracted. So next topic is going to be respiratory acidosis. So we're going to go into your urology and renal. Urology and renal, yay! I love urology and renal. I was I was able to do a rotation with a renal doctor for my internal medicine block, and so I learned so much, but I still struggle with it. I think renal is amazing, kidneys is amazing, but it's just a very difficult topic I struggle with. So urology and renal, next topic. Now, why don't we go into our respiratory acidosis? So respiratory acidosis is due to an inadequate alveolar ventilation that leads to carbon dioxide retention. So you have high CO2 and you have a low pH, which causes your acidosis. So what are some of the causes of respiratory acidosis? The most common cause is going to be hypoventilation, right? You're not able to get rid of that carbon dioxide, so you're keeping it all in. This is why these patients have increased CO2 and they're becoming acidotic, because they're not getting rid of it. Whenever we breathe in and we breathe out, we're getting rid of carbon dioxide. If a patient is not breathing at all, whether it's a trauma to the head, they're overdosed on a certain medication, and they are just, right, those like deep, very slow breathing, then these patients can develop respiratory acidosis, and it's very commonly found in these patients. Okay. Other causes of this is going to be respiratory arrest, overdose, like I said, any type of obstruction to the airway. Your patients that have congestive heart failure, pneumonia, cardiac arrest, they're going to be presenting with what? Dyspnea, trouble breathing, right? Tachypnea, because they're trying to get more air in. They'll have these slow, shallow respirations. These patients are going to be presenting with confusion because they're retaining all that CO2. They're going to be presenting with convulsions. They're going to have this warm, flushed skin. Why? Once again, because they're retaining all that CO2. They'll have ultra level consciousness or be cyanotic. And diagnosis is going to be, once again, what? Low pH, but high PCO2 because they're retaining it. Okay, but they're going to have a normal bicarb. Of course, if it's uncompensated, though. Now we're going to go to respiratory alkalosis. So respiratory alkalosis is hyperventilation that leads to carbon dioxide deficiency. Okay, so we said that respiratory alkalosis had an increased amount of carbon dioxide, right? They're retaining it. Well, respiratory alkalosis is going to be the opposite. They are hyperventilating. So they're breathing like super duper fast, and they are getting rid of all their carbon dioxide. So they have decreased amount of carbon dioxide. So low CO2 leads to a high pH, which is your alkalotic state. The most common cause is going to be hyperventilation. Patients that are in severe pain, right? Patients that have some type of trauma also to their head. If a patient is pregnant also, aspirin overdose is very commonly associated with respiratory alkalosis. And then other causes is going to be your anxiety, right? If a patient's anxious or they're having a panic attack, they're going to be breathing really, really fast. So they're getting rid of that carbon dioxide. They can present, and they are going to present with symptoms of tinnitus, ringing in the ear, vertigo, like your dizziness, dry mouth, blurred vision, rapid and deep respirations. You're going to feel lightheaded. They'll have paresthesias. Paresthesias are very commonly associated with what? General anxiety disorder, because they're hyperventilating. Hyperventilation leads to what? Respiratory alkalosis. Syncope, convulsions, coma also. Diagnosis, you're going to have a high pH, low PCO2, and the bicarb is going to be normal if it's uncompensated. Now we're going to go into metabolic acidosis. This is an excess accumulation of fixed acids through the metabolism or ingested food, or excessive loss of fixed bases. So we have different types of metabolic acidosis. You have your non-anion gap, and then you have your anion gap. You need to know the difference between both of them. What are the causes of each one? So non-anion gap is commonly caused by diarrhea, okay? Your GI bicarb loss, renal tubular acidosis, carbonic anhydrase inhibitors, whether the patient is having TPN, right, tube feeds, or rehydration, chlorine gas exposure. Some of the causes of anion gap is going to be your methanouremia. DKA is a big one for your high anion gap metabolic acidosis. Paraldehyde, acinides, lactic acidosis, alcohol rhabdomyolysis, salicylates, right? So this is where your mud piles mnemonic comes in. So your methanol for M, U is going to be uremia, D is going to be DKA, P is going to be paraldehyde, and then I is going to be your isoniazide, L is going to be lactic acidosis, and then for E, alcohol, and then S is going to be salicylates, and of course you can add rhabdomyolysis on there, and yeah, so that's going to be for your anion gap metabolic acidosis. How's this patient going to present? They're going to have the Kussmaul breathing. That's usually pathognomonic for metabolic acidosis and for DKA. So it's going to be your Kussmaul breathing. They're going to be lethargic, drowsy. They're going to be in stupor position, coma. They're going to have a headache, flushed or dry skin, right? Because these patients are usually dehydrated. They're going to have peripheral vasodilation. They're going to have fruity breath, which is usually very commonly associated with DKA. I have yet to smell that fruity breath. Nausea and vomiting, convulsions. Diagnosis is going to be what? Low pH, normal PCO2, and then low bicarb. If it's uncompensated, they're going to have a loss of bases. So now let's go into our anion gap. How do you calculate anion gap? I actually had 3 questions on this yesterday when I was doing practice questions, and I missed all of them. So anion gap. Anion gap is calculated by the serum sodium minus the serum chloride plus serum bicarb. The normal range is between 9 to 16. Anything greater than 20 is your metabolic acidosis, okay? Once again, normal range is between 9 to 16. I know textbooks tend to differ between this, but anything greater than 20 is in your anion gap, it's going to be your metabolic acidosis. So let's go into metabolic alkalosis. This is going to be accumulation of fixed bases or excessive loss of fixed acids. So you're going to have acid loss, and you're going to have high pH and high bicarb. This patient's going to be presenting with vomiting, NG tube. Some of the causes are going to be vomiting, NG tubes, diuretics, hypokalemia, Cushing syndrome, hyperaldosteronism. Usually it's very commonly associated with metabolic alkalosis. I just had a question on this when I was studying. This is very highly tested. Once again, hyperaldosteronism is metabolic alkalosis. Vomiting, right, is metabolic alkalosis. Diarrhea is metabolic acidosis. So DKA, metabolic acidosis, diarrhea, metabolic acidosis, vomiting, metabolic alkalosis. Primary hyperaldosteronism is going to be what? Metabolic alkalosis. Very highly tested. And why is it that hyperaldosteronism presents with metabolic alkalosis? Because they have increased renal secretion of bicarb, chloride, and potassium. This is why these patients present with metabolic alkalosis that have hyperaldosteronism. Signs and symptoms, you're going to have decreased respiration rate and depth. They're going to have dizziness, paresthesias, the Trousseau sign, right? Nausea and vomiting, irritability, convulsions, and coma. They're going to be dehydrated. Diagnosis is going to be, you're going to see a high pH, normal CO2, and a high bicarb on your BBG or your ABGs. This is if it's uncompensated. So they have an accumulation of bases versus or metabolic acidosis where they have a loss of bases. So once again, these are very highly tested. Make sure what they're associated with. Once again, to go through that, respiratory acidosis is due to what? hypoventilation. They're not getting rid of that carbon dioxide, so they are holding it all in. They're going to have increased CO2, but their pH is going to be low. Common causes of this is going to be any type of patient that is, for example, in a coma. They're going to have these like slow breathing, okay? And then we have our respiratory alkalosis, which is the opposite. These patients are getting rid of all their CO2, so they're going to have decreased CO2, okay? But they're going to have an increased pH. So these patients are usually commonly found in patients that, for example, it's going to be anxiety. That's very, very commonly tested. And also your aspirin, I'm sorry, not your aspirin. Yeah, it's going to be your aspirin, sorry, overdose. I can present with respiratory alkalosis. So respiratory alkalosis, your aspirin overdose. Okay, these patients are going to be hyperventilation, right? Anxiety, okay, panic disorders, all that. Metabolic acidosis, with these patients, they have an accumulation of acids and they have a loss of fixed bases. Their pH is going to be low, and then their bicarb is going to be low. Okay, we have non-ion gap and anion gap. So you need to differentiate between these two and what are the causes. Commonly causes of anion gap is going to be your DKA, lactic acidosis, and salicylates. These patients have the Kussmaul breathing, which is very commonly associated with DKA. And then we have metabolic alkalosis, very commonly associated with what? Vomiting, and also your hyperaldosteronism. We said metabolic acidosis is with what? Diarrhea. Okay, make sure you know these. So next topic we're going to go into is going to be hypovolemia. This is going to be isotonic fluid loss from extracellular space that can cause and progress to hypovolemic shock. Signs and symptoms is, some of the causes of this is going to be excessive fluid loss, either from like a hemorrhage, so a patient that got shot, decreased fluid intake if the patient is just dehydrated, or if they have third space shifting, where like the vessels are just leaky and everything is just shifting out. These patients are presenting with mental status changes, thirst. They're going to be tachycardic. They're going to have delayed capillary refill, right? Because they're volume down, hypovolemic. They're going to have orthostatic hypotension, which makes sense, right? Because they're volume down once again. They're going to have low urine output. Why? Because they're volume down. They're not getting the blood flow to their kidneys like they should be. So they're having volume down. Urine output is going to be decreased because the kidneys are not functioning like they usually do. They're going to have cool and pale extremities. Why? Because they're going to be, once again, volume down. So hypovolemic, okay? Treatment for this is going to be fluid replacement, right? We want to also give them albumin replacement, blood transfusions if they have any type of hemorrhage, your dopamine to maintain their blood pressure, and then assess fluids. So why are these patients have pale extremities? Because for example, if a patient gets shot and they're in hemorrhagic shock, for example, there's going to be blood that's going to be shifted towards the vital organs, like your brain and your heart. It won't go to areas where the body deems are not important. So that's why you get your paleness and your coolness in your extremities, because blood is being shifted towards the organs the body deems important. This is why the kidneys get shot, right? The kidneys are usually like the first ones to go, because you're not getting that blood flow to the kidneys, okay? You're not getting that volume to the kidneys. They're not being perfused, so you're having low urine output. These patients are not producing urine. So these are symptoms of hypovolemia versus a contrast, which is going to be hypervolemia. This is going to be isotonic fluid. Hypovolemia is going to be excess fluid in extracellular compartments due to fluid or sodium retention. They're going to have this is usually due to excessive intake or renal failure. Okay, so this happens when compensatory mechanisms fail to restore fluid balance, which leads to things like congestive heart failure and pulmonary edema. So these patients are volume up, right? We said that hypokalemia is what? Volume down. Hypovolemia is volume down. Hypervolemia is volume up. Signs and symptoms are going to be tachypnic. They're going to have dyspnea, right? They're going to have trouble trying to catch breath, right? Because they're volume overloaded. They're going to have crackles, rapid bounding pulses, hypertension, S3 gallop, especially in those patients that have congestive heart failure, where you have that floppy heart, right, that isn't able to pump blood out. And then you're going to have also acute weight gain, right? Because these patients are retaining all their fluid. And patients that have congestive heart failure, if they have kidney problems, we always tell them to make sure that they take their weight every day to see whether they're retaining fluid or not. So they're going to be presenting with weight gain, increased jugular venous pressure, edema. And treatment for this is usually with fluid and sodium restriction, diuretics, because we want to make sure that we get rid of all that fluid. Monitor vital signs. We want to make sure that we look at their breath sounds, monitor ABGs and labs. So I'm going to bring another example, guys, and I'm sorry. We had a patient, and we still have a patient. He's been there since like forever. He's been with us 6 months because he doesn't have anywhere to go. And so we have a patient that came in, and he has a history of COPD and heart failure. He has an ejection fraction of like 30%. So he has a history of COPD and heart failure. And basically, we're just monitoring him every day. He's been fine, but there was a specific day where he was complaining of trouble breathing. And when you went inside the room, you could see that he was really having trouble breathing. You looked at him and he was using his like intercostal muscles to breathe. And so, of course, we did an exam. We did see that he had some edema to his lower extremities. And so what did we do for him? We gave him Lasix. Okay, of course, we did a chest x-ray just to make sure to rule out anything that's bad. We did also VBG, venous blood gas, just to see how he was, if there was any abnormalities. And then we give him a dose of furosemide. So we give him a high dose of IV ×1 of furosemide, just so we can get rid of all that fluid. And then the next day we saw him and he was perfectly fine. So once again, these are symptoms of hypervolemia. Okay? So now we're going to go into our acute kidney injuries, okay? Acute kidney injuries. So we have, what you need to know about acute kidney injuries is basically where is the kidney injury occurring? So we have our pre-renal acute kidney injury, which is before you get to the kidney, just like it sounds. Your intrarenal, which is something happening within the kidney, and then you have your post-renal, which is something that's happened after the kidney. Okay, it's really important that you differentiate between the differences in your acute kidney injury. This is very highly tested. And I'll be honest with you guys, I always test really low on my urology and renal. So a quick fact real quick. I don't know when I'm going to post this video, but right now, this is during the COVID pandemic. When I was doing my rotation, my internal medicine rotation, which I ended up doing with a nephrologist, like I said, during that time, I did it in the Valley, which is the McAllen, Texas, Edinburgh, Texas. And that area, when I did it, had the highest amount of COVID cases at that time. We had a lot of deaths from COVID cases. We had nurses from all over the US come down and help us because we had so many patients we couldn't take care of. The pediatric portion of the hospital was turned into an area for COVID patients. We didn't have enough rooms for COVID patients, and we just had a lot of patients dying from COVID. So when I did my rotation with him, nephrologist, he had so many patients because 100% of patients with COVID had acute kidney injury. Once again, 100% of his patients had acute kidney injury, okay? So why? Because these patients would go into shock, okay? They were going to shock. They were not having appropriate volume going to their kidney, okay? So this is a pre-renal cause, right? And it was just shutting off the kidneys. So 100% of our patients had acute kidney injury, and it was really, really sad. These patients were having to have dialysis, etc. Anyway, so I'll get off my soapbox. Let's go back. So pre-renal acute kidney injury is going to be an injury that comes before the kidneys. This is the most common form of acute kidney injury. Once again, we have the kidney, right? We have before you get to the kidney and then after you get to the kidney. This is before you get to the kidney. So this is pre-renal. And some of the causes is going to be due to decreased blood flow to the kidneys. So the kidneys are not being perfused. Some of the signs and symptoms for these patients are going to be dehydrated. They're going to have fluid loss, renal hyperperfusion, hypovolemia. How are we going to diagnose this? We're going to do a GFR. And we're going to see a decrease in the GFR. This is because what does GFR measure? GFR measures how much blood flow how much blood is being filtered by the kidneys. So if your GFR is low, it's telling you that there's decreased blood flow, so there's decreased blood that's being filtered, right? So you're going to have a low GFR in these patients with pre-renal AKIs. You're going to have increased sodium and water reabsorption. You're going to have low urine sodium, okay? This is what differentiates this between pre-renal and your other causes. Pre-renal is going to have low sodium, okay? Low urine sodium. They're going to be oliguric, which means they're going to be producing very little urine. They're going to have high urine osmolality. It's going to be more concentrated. They're going to have an increased BUN and creatinine that's greater than 21. They're going to have metabolic acidosis. They're going to have azotemia, which is less urea and creatinine that's being filtered out. They're going to have increased white blood cells if it's due to some type of infection. So how are we going to treat these? Since we said the number one cause is hypoperfusion, we have to do aggressive normalization of volume. So we want to make sure we give fluids. We want to make sure we do volume repletion, okay? That's pre-renal AKI. Now, when we go into intrarenal AKI, intrarenal AKI is going to be an injury within the kidney's anatomical structure. So it's something that's occurring within the kidneys, whether it's affecting the glomerulus, whether it's affecting the tubes. Something within the kidney is causing that kidney injury. So this is an injury that is within the kidneys. Like I said, reabsorption and filtration is impaired. You have direct kidney damage. Some of the causes of this is damage to kidney anatomy that prevents it from functioning correctly. Nephrotoxic medications sometimes, like contrast, right? IV contrast, whether there's metastasis, whether there's radiation. Diagnosis for this is going to be a decreased GFR. They're going to be oliguric, once again, low urine osmolality, but they're going to have a high urine sodium, okay? High urine sodium. Why are they going to have a high urine sodium? Why? Because it's not being reabsorbed. The kidneys are not working, so they're dumping everything. Versus your pre-renal cause, it's nothing with the kidney. The kidney still works fine. It's just that it's not being perfused adequately, okay? So this is why in your pre-renal, you're going to have low sodium, and in your intrarenal, within the kidney, where the kidney's not working by itself, it's dumping everything out, it's going to be high. So sodium's going to be high in your intrarenal. That's how you differentiate between both of them. They're going to have elevated BUN and creatinine, abnormal urinalysis. Sometimes you'll see protein, blood casts, eosinophils. Why? Because that kidney's not working. The glomerulus is not filtering everything out. Everything's passing through it and it's spilling out. It's spilling out in your urine, okay? And then also what you can diagnose is also with the renal ultrasound. So treatment is usually going to be, if it's like something like glomerulonephritis or vasculitis, then we're going to give immunosuppressants and plasmapheresis. So other causes of your intrarenal AKI can be like your nephritic and nephrotic syndromes, right? That can lead to your acute kidney injury also. So now we're going to go into our post-renal causes. So this is an injury after the kidneys, right? So injury after the kidneys, usually it involves like the ureters, the bladder, the urethra, and it's usually bilateral because unilateral will compensate, right? If it makes sense. If one of the ureters is involved, that's fine. But if it's bilateral, that's when you have acute kidney injury. So once again, it has to involve bilateral because unilateral will compensate. Some of the causes of this is the most common cause is going to be your kidney stones, which makes sense, right? You have a kidney stone that is just causing obstruction of that fluid. It causes that kidney to be swollen, causes hydronephrosis, and the kidney isn't working as well. So kidney stones. Other causes of these can be history of cancer. If they have any type of metastatic cancer, like bladder cancer, for example, it's enlarging, it's just compressing on the ureters, causing like obstruction of outflow of the urine. These patients are presenting with hesitancy, frequency, urgency, weak stream, dribbling, incomplete bladder emptying, flank pain. They'll have a history of stones. Other causes of this commonly found in men, right, is going to be PH, so benign prostatic hyperplasia. If that prostate is really enlarged, right, it can compress the ureters, and it can cause that obstruction, and then there won't be any outflow of the urine. So that's another cause also. A spinal cord injury. This patient is going to be presenting with decreased GFR. They'll have a low urine osmolality, elevated BUN creatinine ratio, and then also an abnormal urine analysis, red blood cell counts, white blood cell counts. You'll see crystals, right, which are involved with what? Sometimes involved with your kidney stones. What's your treatment? You want to remove whatever is obstructing it. If it's cancer, if it's metastasized, you want to remove that. If it's a kidney stone, you want to remove that, right? BPH, they need to go through the TURP surgery. So you want to remove whatever is causing the obstruction to prevent severe damage, okay? So once again, pre-renal, most common cause is hypovolemia, right? The kidney's not being perfused. Intrarenal, you have your toxic causes like your, so you have your toxic causes like your certain medications that are nephrotoxics, IV drug contrast, other infections like glomerulonephritis, nephrotic syndrome, acute tubular necrosis. So something that's happening within the kidney is going to be intrarenal. And then we have post-renal, which is past the kidney, which is happening when the patient has any type of obstruction, right? So BPH, kidney stones, metastasis from a cancer. The way you differentiate between pre-renal and post-renal is that you look at the sodium, because they're going to present very, very similar. Sodium is going to be low in pre-renal. Sodium is going to be high in intrinsic, okay? Or your FeNA. So once again, sodium is going to be low in pre-renal, but it's going to be high in intrinsic because the kidney is not working anymore. Or intrarenal AKI. So let's go into our next topic, which is going to be acute interstitial nephritis. This is the presence of inflammatory cells in the renal interstitial space. This is immune-mediated injury. The most common cause is going to be caused by medications. So your antibiotics, your PPIs, your NSAIDs, your penicillin, fluoroquinolones, vancomycin, sulfonamides, and rifampin. Infection or autoimmune can also cause this. This patient is going to be presenting with a fever, a rash. It's going to be maculopapular, peripheral eosinophilia. So whenever I think about eosinophils, it's your body attacking itself, right? So they're going to have eosinophilia, oliguria, which means they have decreased urine output, right? These patients are going to be diagnosed with, you're going to see pyuria with white blood cell cast and hematuria with what? Eosinophils, okay? You're going to see a decrease in GFR, a rise in the creatinine, and then if you do a biopsy of the kidney, you're going to see low iron. Treatment is you're going to discontinue whatever is affecting it, right? That's going to be the number one treatment. If it's NSAIDs, tell them to stop taking NSAIDs. And then glucocorticoids are usually reserve beds if it's severe renal failure. So now we're going to go into ATN, acute tubular necrosis. This is prolonged severe ischemia, okay? Due to all the causes of severe prerenal disease, like shock, renal ischemia. The most common cause of intrinsic renal failure is usually, so the most common cause of acute tubular necrosis is going to be intrinsic renal failure. Usually it can be nephrotoxic or ischemic. If it's medication-induced, it's going to be your NSAIDs, ACE inhibitors, and your angiotensin receptor blockers. Why? Because they decrease renal blood flow. And the thing about acute tubular necrosis that you need to know is that on diagnosis, you're going to see these muddy brown granular epithelial casts. These are usually pathognomonic for ATN. It's going to be your muddy brown granular epithelial casts. You're going to see also free epithelial cells, fine granular casts. On labs, you're going to see hyperkalemia, hyperphosphatemia, BUN and creatinine is going to be less than 20/1. And your FeNA is going to be greater than 1%. So you'll have high sodium. Treatment is going to be supportive for these patients. So once again, acute tubular necrosis is prolonged severe ischemia. It's the most common cause of intrinsic renal failure. And usually with these patients, they're going to present with muddy brown casts. So now let's go into acute glomerulonephritis. So acute glomerulonephritis. This is an acute immunological inflammation of glomeruli that causes protein and red blood cell leakage into the urine. So it's an inflammation of the glomerulus so the glomerulus functions, how I think about it, is it functions like a basket, right? So it's a basket. Not a lot of things can go through it, okay? Or you would say some type of like filter, okay? So it's a filter, not a lot of things go through it. But when the glomerulus is damaged, that's when you're gonna have big things go through it. If it's damaged and it's porous, you're gonna have your big red blood cells going through it. You're gonna have your proteins go through it, which in normal kidneys, in normal glomeruli, it doesn't do that. So when there's any damage or inflammation or infection to that glomeruli, to that little you would say, like I said, like a basket, right? And the basket's ripped, everything's going to go through it and it's going to spill in the urine. And that's what's occurring with acute glomerulonephritis. So it's an immunological inflammation of the glomeruli, like I said, that causes protein and red blood cell leakage into the urine. Some of the causes of this is going to be IgA nephropathy. It's actually one of the most common causes of glomerulonephritis, also known as Buerger's disease. Very commonly found in young males. So usually you'll see a question stem and it'll be a patient that just had some type of upper respiratory infection or GI infection, and they're presenting with like this like Coca-Cola urine, okay, and they're having like this edema. Then you want to think about IgA nephropathy, okay, and it's usually due to IgA immune complexes. Treatment for your IgA nephropathy is going to be your ACE inhibitors and prednisone. And then we have another type of acute glomerulonephritis, which is going to be your post-streptal glomerulonephritis. I know I kind of mentioned this a little bit when we were discussing about strep throat, but post-streptal glomerulonephritis is due to group A beta hemolytic strep, okay? Other causes is impetigo. These patients are presenting with that Coca-Cola urine, like I said. They'll have facial edema. They'll have positive ASO titers. Treatment is usually supportive, and then if we suspect that the patient has an active strep infection, then we can treat it with amoxicillin. And then we have membranoproliferative glomerulonephritis, which is due to SLE or hepatitis, okay? And then we have a rapid progressive glomerulonephritis, which is going to be a rapid progression to end-stage renal disease. We're going to diagnose this with crescent formation on biopsy, and treatment is steroids and cyclophosphamide. So there's two of these that fall under RPGN, which is going to be your Wagner's granulomatosis, which is a necrotizing vasculitis. With these patients, you're going to see a positive C-ANCA, and then you have good pastures, which involves the kidneys and lung. They'll have kidney failure, and it'll present usually with a woman that is having a cough, hemoptysis, and then they have kidney failure on top of that. And they have these symptoms of glomerulonephritis, right? And you'll also see positive anti-IgM antibodies, and you're going to treat this with steroids and cyclophosphamide. Signs and symptoms overall for like glomerulonephritis, so these fall under that umbrella. So signs and symptoms for these overall is going to be your hematuria, so that Coca-colored urine, red blood cell cast, hypertension, peripheral edema. They'll have azotemia, fever, abdominal pain, flank pain. They'll have oliguria, and treatment is usually self-limited. And for the edema, we can do loop diuretics, calcium channel blockers, or ACE inhibitors, and then we can also give them steroids or cyclophosphamide. Okay. All right, guys. So nephrolithiasis is going to be the next one. This is also known as kidney stones. What's the most common location of nephrolithiasis? Make sure you know this because it's very highly tested. So the most common location is going to be your ureterovesicular junction. And it's very commonly found in males than females. So more commonly found in males, especially. Why? Because just commonly found in males. And so I was going to go more into that, but I don't want to misguide you guys. So we're just going to go into it's more commonly found in males. Also, very commonly found in patients that are dehydrated. If they have a history of hyperparathyroidism, which is where the parathyroid gland is just over-secreting calcium, they're more prone to getting these like calcium oxalate stones. Also, their diet, if they have peptic ulcer disease, irritable bowel disease, especially Crohn's, is very commonly associated with nephrolithiasis, which I thought was very, very interesting. Family history, if certain medications can also make them more prone to getting kidney stones, right? Like your certain diuretics. If the patient's obese, if they have a history of diabetes mellitus, or renal tubular acidosis. So what type of stone is the most common stone? So the most common stone is going to be your calcium oxalate, okay? Like I said, this is commonly found in patients that suffer from Crohn's, peptic ulcer disease, if the patient had a gastric bypass, ileal resection, or increased dietary oxalate. And then we have our second most common one, which is going to be your struvite. This one is the one that's commonly found in females. So we said in general, stones are just commonly found in men, but struvite are more commonly found in females. Why are they more commonly found in females than males? because they're very commonly associated with UTIs. And who gets UTIs more? Women do. So that's why struvite is more commonly found in women. These are also known as your staghorn stones or coffin shaped. They'll usually have a very alkaline pH, so very high pH, and it's usually due to urease producing bacteria, especially which one? Your Proteus mirabilis. So Proteus mirabilis is a urease producing bacteria, and this is why patients that get urinary tract infections that are associated with this type of bacterial infection are more prone to getting these kidney stones, the struvite ones. And then we have uric acid. This is like the third one. Commonly found in patients that have gout, right? Because they have increased uric acid and they have under secretion of uric acid. So they're not secreting it, it stays in their bodies with uric acid. So gout, also commonly found in patients that are dehydrated, hot climates like the summer, high protein diet, okay? And then we have cysteine. This is not very common. It is found in patients that have like an autosomal recessive disorder called cystinuria. So these patients with cystinuria are more prone to get cystine stones. And with these patients with this type of stone, it's hexagonal shape and it's semi-translucent. So how is this patient going to present? They're going to have acute onset of flank pain. They're going to have colicky pain that goes from the loin to the groin. CVA tenderness, right? So you go back there and you go like this and it's going to be positive. They'll have hematuria, which is blood in their urine. They'll be tachycardic, hypertensive, nausea and vomiting. And we're going to diagnose this but basically doing a KUB, right? We do a KUB, and then what we're going to see is the stones depending on which type it is. So which one is radiolucent? So radiolucent is going to be uric acid. This is very highly tested. Make sure that you know how they present on an x-ray. How I memorize it is that radiolucent has a U, right? So it has a U, radiolucent uric acid. So that's how I memorized it for radiolucent. This one's very highly tested. For radiopaque, it's going to be your calcium oxalate and your struvite stones, and in intermediate, it's going to be cysteine. But the one highly tested, it's going to be radiolucent uric acid. You can also do a ultrasound, but what is a gold standard? So the gold standard is going to be a CT without contrast. This is going to be the gold standard to diagnose a kidney stone, but of course, these are contraindicated in pregnancy. So what is a treatment for these patients? First step is that we want to control their pain. So we want to give them pain medication, whether it's oral or IV. We want to make sure that we hydrate these patients also. And what's tested on this is basically what is the treatment depending on what is the size of the stone. So if the stone is greater than 6 millimeters with these patients, then with these patients and they're having obstructive signs, they're pregnant, they have an infection going off, fever, they weren't able to pass urine, right? So they're anuric, which is they're not passing urine whatsoever. And they have not passed a stone after 4 weeks, or they have chills, fever, nausea, and vomiting. With these patients, they need to be hospitalized, okay? So what if the stone is less than 5 millimeters? If it's less than 5 millimeters, it's usually likely to pass spontaneously. But if it's greater than 8 millimeters, it's unlikely to pass. So these patients might need lithotripsy. And then, of course, if it's larger, like 10 millimeters or a centimeter, these patients need surgery. So make sure you know the difference once again. I know that textbooks will differ, but if it's less than 5 millimeters, these patients can go home and just make sure you observe them. Tell them to drink plenty of fluids, that they're probably going to pass them. You can give them something like an alpha blocker, which is going to help them, but usually these patients can go home. If it is greater than 8 millimeters, it probably won't be able to pass, and this patient's going to be in lithotripsy, which is basically just like moving, and it's going to help that. It's like a vibration that they have, like this type of tool that causes vibrations where the patient will be able to pass the stone. But if it's greater than 1 centimeter or greater than 10 millimeters, the patient's going to need surgery. Another thing you need to take in consideration is that your struvite stones, these are large, right? These are staghorn stones. Sometimes with these patients, they won't pass spontaneously. Sometimes they might need surgery. So also keep that in the back of your mind. So next topic is going to be cystitis. Cystitis is an infection of the bladder. It's a lower urinary tract infection. And then we have chronic cystitis also, which is persistence of urinary tract infections or more than 3 urinary tract infections a year. The thing about these though, if you have a patient that presents like this, you want to think about maybe other causes. Diabetes is very commonly associated with urinary tract infections, so make sure that you work with these patients for diabetes mellitus. So cystitis, most commonly found in women, of course, right? The most common bacteria associated is going to be your E. coli. Of course, there's different types of bacteria, but E. coli is going to be the most common one. And it's usually due to an ascending infection from either the urethra or the descending infection, like a kidney down. Complicated cases of cystitis are going to be indwelling catheters, renal calculi, enlarged prostate, neurogenic bladder, diabetics, AIDS, pregnant all males, urosepsis, hospitalization, estrogen depletion, and spinal cord injury. So these are complicated cases of cystitis, and usually these patients need to be hospitalized or they need to require a longer dose of medications, which we'll get into, and a different type of medication. So how is this patient going to present? They're going to be presented with burning, frequency, urgency, cloudy urine, nocturia, which means they're having to go to the restroom at night, hesitancy, they'll have suprapubic tenderness, hematuria, and flank pain. Usually the way you're presenting with that urgency, like they go to the restroom and nothing comes out, and they're having to go over and over and over and over again, and then they have like this pelvic pain. It's just really uncomfortable. Usually these patients will present within like the first day or the second day because it's very uncomfortable. And diagnosis for this, we're going to do a UA. We're going to see positive leukocyte esterates, positive nitrates, positive white blood cells. And then we can also do a urine culture and sensitivity if it's a complicated case of urinary tract infection. And usually on the culture, we'll see more than 10 to the 5th power CFU per milliliters. Okay. So we can also do imaging like an ultrasound in children or older patients. Treatment for this is education. We want to make sure that we educate the patient to have good hygiene, right? To make sure that if they are sexually active, to urinate after they have sex. Another thing that we can tell them is to make sure that they're not holding their urine and that they drink a lot of fluids. So they increase their fluids. And it's important that they don't hold your urine because anything that causes stasis is a great environment for bacteria to grow in. Okay, you can also tell them to avoid caffeine, alcohol, tomatoes, pelvic rest until done with antibiotics, and to make sure that they finish their antibiotics. So how are we going to treat these patients? If it's an uncomplicated UTI, we're going to give them Bactrim. It's usually for 3 days. Or if they have some type of allergy to sulfamethoxazole, then we can give them Cipro. Another alternative is nitrofurantoin for 3 to 5 days. And then, of course, our analgesic of pyridium for 2 to 3 days. If it's a complicated cystitis, then we're going to give them fluoroquinolone for 7 days to 14 days, and then repeat the urine culture 2 to 4 weeks post-completion of antibiotics to verify that the urinary tract infection has resolved and it's gone away. Okay, so I just want to go over something that's very highly tested. What is the antibiotic therapy for urinary tract infection in different age populations? So like we said, if it's an acute uncomplicated cystitis, we can give them Bactrim or nitrofurantoin. Bactrim is usually your choice for 3 days, right? If the patient has acute uncomplicated cystitis with comorbid conditions, then we can give them Bactrim, nitrofurantoin, or fluoroquinolone for 7 days. What if they have pyelonephritis? If the patient has pyelonephritis and they're mild to moderately ill, we can give them an oral fluoroquinolone or Bactrim for 7 days of fluoroquinolone and 14 days of Bactrim. If the patient is hospitalized and they have pyelonephritis, but it's acutely uncomplicated, then we're going to give IV fluoroquinolone or ampicillin, gentamicin, or 3rd generation cephalosporin for 14 days. If the patient has a complicated UTI, and they're mild to moderately ill, we can give them oral fluoroquinolone or Bactrim for 14 days. If they're hospitalized, then we're going to give them IV ampicillin, gentamicin, or imipenem, celastin, or fluoroquinolone, or any type of 3rd generation cephalosporin for 14 days. If they're pregnant, we're going to give them amoxicillin or Bactrim or nitrofurantoin for 7 days, okay? And the thing about Bactrim is that you don't give it in the 1st or late 3rd trimester. And nitrofurantoin, you don't give it in the late 3rd trimester. Okay, so next one's going to be pyelonephritis. This is going to be an upper urinary tract infection. This involves the kidneys. It's an infection of a kidney, and usually it's a sequelae of an untreated urinary tract infection. That's why it's really important that we educate our patients on the importance of getting seen whenever they have a UTI and the importance of getting treated for a urinary tract infection, because that infection can ascend and affect the kidneys. And these patients present more sick on exam. So most common organism, once again, associated with pyelonephritis, UTIs, is going to be your E. coli. Commonly associated in women, patients that are pregnant, or if they have any type of vesicular ureal reflux, especially in your children. If you have a child that's coming in with UTI, I mean, there's two things that cross your mind, okay? I'm not going to say the second one, but the first one that crosses your mind is that the patient probably has a vesicular ureal reflux, especially if they're coming in for their second or third urinary tract infection, because UTIs are not common in children. Other causes of pyelonephritis is going to be via bloodstream, IV drug use, or endocarditis. This patient is even presenting with frequency, urgency, so symptoms similar to UTI, dysuria, flank pain, CVA tenderness, nausea and vomiting, fever, shaking, chills, tachycardia, and suprapubic tenderness. These patients are going to be more toxic appearing in comparison to cystitis. Like if you do that, the CVI, these patients were like jump off the bed because it's so painful. That inflammation of the kidney is just so inflamed that is just causing irritation of those nerves. That's just causing that flank pain. So how are we going to diagnose this? We're going to do a UA. We're going to see pyuria, bacteria, and white blood cell cast, but the definitive is going to be a urine culture for these patients, and we're going to see bacterial overgrowth. We do a CBC. We're going to see increased leukocytes, right? Leukocytosis. And treatment for this, if it's mild, we're going to treat them as an outpatient. If it's severe, right, we're going to treat them as an inpatient. Outpatient treatment is going to be your Bactrim or your ciprofloxacin or levofloxacin. We want to admit anyone that's under the age of 2, if they're older, if they're uroseptic, if they have potential bacteremia, if they're immunocompromised, like your diabetics, if they have renal failure, if they have any obstruction on x-rays, or they're not responding to outpatient treatment, that we want to admit these patients, okay? And then remember that we discussed that the treatment for pyelonephritis, if it's mild to moderately ill, it's going to be an oral fluoroquinolone or Bactrim for 7 days for your fluoroquinolone and then 14 days for your Bactrim. If they are hospitalized and you want to give IV fluoroquinolone or ampicillin/gentamicin or a third-generation cephalosporin for 14 days. So if you notice, it's like the same treatment for UTI, but it's longer, right? So urethritis is going to be the next topic. This is also going to be a lower UTI. It's an inflammation of the urethra. It can either be infectious, whether through a sexual contact, or non-infectious, whether it's like an allergic reaction. So the most common cause of urethritis is going to be your gonococcal and non-gonococcal, especially like your chlamydia, okay? Other causes are mycoplasma, candida, herpes, trichomonas, E. coli. And these patients can usually also have a co-infection, especially if the patient's like young, if they're younger than 25, if they're promiscuous, if they have unprotected sex, or they have a past history of several UTIs. These patients are going to be presenting with dysuria, so painful urination, hesitancy, frequency, urgency. They'll have urethral discharge, especially if it's associated with your gonococcal and chlamydial. If it's gonococcal, it's going to be purulent discharge. If it's chlamydial, it's going to be mucoid or clear discharge. They'll have urethral inflammation, penile tip pain, scrotal pain, and swelling. So usually whenever you do a culture for chlamydia, you won't see anything in culture for chlamydia. Diagnosis is you do a UA, you're going to see leukocytes, and you do a gram stain of the urethral secretion, okay? You also do molecular testing to differentiate between chlamydia and gonorrhea and herpes. And treatment is you're going to treat with ceftriaxone plus azithromycin or doxycycline, right? Because you're treating for both gonorrhea and chlamydia. If it's not associated with gonorrhea, if it's like chlamydia, then you can do azithromycin or doxycycline. And you want to make sure that you screen these patients for syphilis, HIV, and hepatitis B, and also treat their sexual partners. So acute bacterial prostatitis is also prostatitis is a lower urinary tract infection. They'll have an inflammation of the prostate associated with a UTI. It's commonly caused by an ascending urethral infection or reflux of urine. The most common bacteria involved in acute bacterial prostatitis is going to be E. coli. There's other causes also like Pseudomonas and Klebsiella, but the most common cause is going to be E. coli. In males under 35, though, the most common cause is some type of sexually transmitted disease like chlamydia and gonorrhea. So usually patients that are older than 35, it's going to be E. coli. Younger than 35 is going to be your STDs. This patient is going to be, for risk factors, it'll be usually it's a younger, middle-aged man, a man that's sexually active, or if they have any type of neuromuscular dysfunction, your older men, it's going to be patients that have BPH, right? Or even your immunocompromised. This patient is going to be presenting with fever, chills, suprapubic or perineal pain, rectal pain. They'll have frequency, urgency, dysuria, hesitancy, poor stream, incomplete emptying. We're going to diagnose this with a urine analysis. You'll see white blood cells with hematuria. You'll see elevated white blood cells. And then if it's due to some type of BPH, then you can do a PSA, which you'll see is going to be elevated. PSA is your prostate-specific antigen. Okay. And then if you do a DRE, it's going to be tender and boggy. This is pathognomonic for prostatitis, and how you can differentiate between prostatitis, BPH, and prostate cancer is that in prostatitis, it's going to be tender and boggy. Make sure that you know that. Treatment is treatment for this is just that outpatient. You're going to treat them with fluoroquinolone or Bactrim for 3 weeks, and then make sure that you follow up with the urine culture. It's contraindicated to do a prostate massage in these patients because they have an increased risk of septicemia. Okay? So once again, initial treatment for this is ampicillin and aminoglycosides. If they're outpatient, it's Bactrim or fluoroquinolones for 3 weeks. Next one's going to be epididymitis. This is an infection of the epididymis. This is due to retrograde passage of infected urine, okay? And it's usually bacterial. Once again, this is where you have the different age ranges in regards to what is the most common cause. If they're less than 35, and it's the most common cause is going to be chlamydia and gonorrhea, so it's going to be STD related. If they're greater than 35, then it's going to be due to like BPH, UTI, prostatitis, and E. coli is going to be the most common cause for this if they're greater than 35. Make sure you know this is very highly tested. So greater than 35, E. coli. Less than 35, STDs, your chlamydia, right? Your gonorrhea. So how is this patient going to present? They're going to have fever, irritative voiding, scrotal pain or swelling on the affected side that radiates with pain that radiates along the spermatic cord to the flank. They'll have urethral discharge, scrotal tenderness, suprapubic tenderness. They'll have an enlarged prostate. And then the thing you need to know about this is that they're going to have a positive friend sign, okay? Positive friend sign, and they're going to have a positive chromosteric reflex. So what is a friend sign? So a friend sign is that they have relief of pressure and pain whenever you lift a testicle up. This is going to be positive. How I think about it is that your friend lifts you up, right? And they're going to have a positive chromosteric reflex. That's when you caress like the inner thigh, and then the testicle will rise. So this will be positive. So it'll be positive friend sign, and then it'll be a positive chromosteric reflex for these patients with your epididymitis. So how are we going to diagnose these patients? We're going to do a urinalysis and culture. You're going to see PAEA, bacteria, hematuria. You'll see urethral discharge. You can do a gram stain of that. And then also we're going to do a scrotal ultrasound. We want to make sure that they have increased blood flow to that testicle. And then if we suspect that it's an STI, we can do an NAAT. Treatment for this is usually with NSAIDs. Tell them to put cool compresses, bed rest with scrotal elevation. If it's due to gonorrhea or chlamydia, then we want to make sure we treat that with azithromycin or doxycycline and ceftriaxone. And then if it's a bacterial cause, like your E. coli, we can give Bactrim, fluoroquinolones, or cephalexin. So orchitis is going to be the next one. This is going to be an inflammation of one or both testicles. We have our acute, and then we have our chronic. If it's acute, it's less than 6 weeks. If it's chronic, it's more than 6 weeks with scrotum or testicular discomfort. Now, for this one, you need to know once again about the causes. If the patient is less than 40, or some books I've read is less than 35, the most common cause is going to be your chlamydia and gonorrhea. If they're older than 35 or 40, they're going to have urogenital malformation and bladder outlet obstruction as the causes. Viral is the most common cause of orchitis, with the most common cause being mumps. This is very highly tested. Make sure to know this. Orchitis, most common cause is going to be associated with mumps. Okay? Commonly found also in children. Patients are going to be presenting with scrotal pain, erythema, swelling, dysuria, hematuria, scrotal mass, painful intercourse, ejaculation, penile discharge, pain that's worse with bowel movements or straining. They're going to have this heavy feeling of a testicle. They're going to have a negative chromosteric sign or a positive friend sign. And then they're going to have nausea, vomiting, fatigue, headache, fever, and chills. So if you can tell the difference, because they're both going to be presenting with a painful scrotum, right? But as you can see, epididymitis is going to have both a positive friend sign and a positive chromosteric reflex, versus your orchitis is going to have a negative chromosteric sign, but a positive friend sign. So make sure you know that. That's how you differentiate between both of them. Treatment for this is that it usually goes away by itself, right? Because the most common cause is going to be a viral cause. You tell them to do some cold compresses, and then gentle scrotal support. Some of the complications of this is testicular atrophy and then subfertility. And then we have testicular torsion. This you need to know. This is going to be, I guaranteed on your exam for your ER end of rotation, so you have to know this. Testicular torsion is a twisting of testicles around the vas deferens with compromised blood supply and possible necrosis to the testicle. The most common cause of testicular loss is testicular torsion. It's usually due to an inadequate fixation of the intestines, with the most common cause being a bell clapper deformity. Okay? So if you think about it like a disco ball, it just goes like this and it wraps around itself. And that causes decreased blood flow to the testicle, and it can become necrotic, it can die, and the patient can lose their testicle. And if they have one testicle and these patients want to have children, then this is an emergency. So risk factors for this is going to be in adolescents, especially like around the age 12. If they have trauma to the testicle, congenital bell clapper, like I said, this is commonly tested. If it asks you what's the most common cause of testicular torsion, it's going to be a bell clapper deformity. And then also undescended testicles, sports, and signs and symptoms. It's going to be a sudden onset in pain. So it's going to be like it happened a few minutes ago, and they have this excruciating pain. Sometimes it will just say it's an abdominal pain. Sometimes it won't even say it's in the groin area. So make sure that you look that out for that also, not only in clinic, the ER in the hospital where you're at, but also on your exam questions, is that they don't always present with your scrotal pain. They can also present with abdominal pain. So they're going to be presenting with sudden onset of scrotal pain and swelling, pain that radiates to the groin. They'll have high position of testicles, so it'll be like a high riding testicle. They'll be presenting with abdominal pain, like I said, nausea, vomiting, fever, urinary frequency. The thing about this one is that they're going to have a negative chromosteric reflex. So you're going to do that. You're going to caress the inner thigh, and that testicle is not going to rise. It's going to be negative, right? Because it's compromised blood flow to that testicle. Friend sign is going to be negative. And then diagnosis that we're going to do a stat scrotal ultrasound Doppler. We want to make sure that there's blood flow to that testicle. And treatment for this is that they're going to need surgery, or you can do manual detorsion if it's been within 4 to 6 hours. Okay? If there's any type of necrosis present, then you're going to do an orchiectomy. But the thing you need to know about testicular torsion is that the most common cause is going to be a bell clapper deformity. They're going to have a negative front side and a negative chromosteric reflex. You're going to do a stat scrotal ultrasound Doppler. You want to make sure that you're looking to see that the testicle has blood flow. And treatment for these patients, that you can do manual detorsion, but usually these patients require surgery. So urgent incontinence is an involuntary leakage of urine and sudden sensation of needing to urinate and inability to control it. It's usually due to an overactive bladder, that is bladder contraction by the detrusor, very commonly found in older patients. Also very commonly associated with your diuretics. These patients are going to be presenting with loss of large volume of urine with small post-voidal residual. They'll have increased urgency that's interfering with their daily activities. They need to urinate suddenly and urgently. They'll have nocturia, bedwetting frequency, and sometimes they even need to wear an adult pad. Diagnosis that we want to do a UA, right? We want to rule out like a urinary tract infection. You can also do a Q-tip test. I don't think I've ever seen this done. and it's usually negative with these patients. You can do a urodynamic study. This is usually the study of choice, and then a cystoscopy also. Treatment for this is usually conservative treatment, and we want to tell the patients to avoid caffeine, to do some bladder training, have a urination log. If we do need to give medications in a female, we can give them anticholinergics, antimuscarinics, for example, like oxybutynin is one of them. And then for males, we can give them alpha blockers, beta-adrenergic, antidepressants. Okay? So urgent continence, what you need to know about this is that it is treated. It's usually conservative treatment first line. I had a question on this yesterday and I missed it because I jumped straight to the pharmacological treatment. If it asks you what's the best treatment or what's the next line, then it's going to be your conservative, okay? Conservative treatment is always the answer for everything. So conservative treatment, avoid caffeine, bladder training, urination log for your urgent continence. So now, guys, so next one is going to be stress incontinence. So stress incontinence is an involuntary leakage of urine during coughing, laughing, okay? Coughing, laughing, exercising, sneezing, okay? This is any type of pressure that causes, it's usually due to a failure of sphincter mechanism to remain closed when there is a sudden increase in the intra-abdominal pressure. So any type of increase in the intra-abdominal pressure, like I said, you're sneezing, you're coughing, is going to cause you to urinate. So very commonly found in women, especially women that had like multiple pregnancy or vaginal deliveries, especially if it's in men. Also, if it's found in men, it's usually due to a prostate surgery. These patients are not going to have any nocturia or urgency symptoms though, okay? Diagnosis, we want to do a UA, once again, to rule out UTIs, electrolytes. Treatment's going to be your Kegel exercise, so make sure that you're strengthening that muscle. Weight loss, if they're overweight. Pessaries, you can do urethral plug also, vaginal estrogen. Tell them to do timed voiding, fluid management, and then surgery, you can do a bladder lift or urethral sling. That's going to be last line. So with these questions, it'll ask you once again, what's the best next treatment? It's going to be a Kegel exercise. It's usually the answer for everything. If the patients try to Kegel exercise, they're not working anymore, then you can probably consider a pessary. They've done that and it's not working, then like you can do with surgery, but that's like last line, okay? So overflow incontinence is an involuntary leakage of urine due to overdistension of the bladder. The nerves are not telling the detrusor to empty, basically. Some of the causes of this is going to be like a neurogenic bladder, if the patient is a diabetic, if they have a history of alcoholism. Certain medications can also cause this, like your muscle relaxants, your beta-adrenergic blockers, epidurals. If the patient just had surgery also, or any type of obstruction can cause overflow incontinence. Signs and symptoms, you're going to have a high residual volume of urine. They'll have frequent or constant leakage or dribbling of urine without warning. They have difficulty initiating or maintaining a stream, incomplete emptying, and they have a desire to go to the restroom, but they can't go. They'll also have bedwetting. And how do you diagnose these patients? We're going to do a post-void residual with a bladder ultrasound or catheter. You can also do urodynamic testing. And then treatment for this is usually with catheters, right? If there's some type of obstruction, then we're going to go in there and surgically correct it. And then if it's any type of medication, then we're going to discontinue the offending medication. If it's due to some type of like, if it's due to an obstruction, right, we're going to do the surgical correction, and then sacral nerve stimulation can also be done also, but it's usually like last line for these patients. So now let's go into hyperkalemia. Hyperkalemia is too much potassium. What's our normal levels of potassium? 3.5 to 5.5. Anything higher than that is hyperkalemia. Hyperkalemia is due to a shift of potassium out of cells or impaired excretion by the kidney. Some of the causes of this is hemolysis, thrombocytosis, if the patient has renal failure. What medications can cause this? Your ACE inhibitors can cause hyperkalemia. Okay. Another medication is also your potassium-sparing diuretics like spironolactone. Hypoaldosteronism can cause hyperkalemia. Metabolic acidosis because the potassium is moving out of cells, and rhabdomyolysis. This is very dangerous and it can be very, very fatal. Why? Because it involves the heart. Okay. Signs and symptoms are going to be presenting with dysrhythmias, cardiac arrest, numbness, tingling, weakness, flaccid, paralysis also. Diagnosis, we want to make sure that we look at their potassium, we measure their BMI and creatinine to make sure that their kidneys are working. We're going to do an EKG, and what are we going to see on the EKG? We're going to see a peaked T wave, hyperkalemia, U wave, hypokalemia, peak T wave, hyperkalemia, U wave, hypokalemia. Make sure that you know that. Treatment for this is, I have the mnemonic C big K drop. So you're going to do calcium oxalate. This is going to be the first one. So B is going to be for your beta agonist. And then you're going to do your insulin and glucose. You can also do K-oxalate, sodium bicarb, dialysis, diuretics, or low potassium diet, also recommendations. So C big K drop is going to be your mnemonic for this, but usually calcium oxalate is going to be your first line. Why? Because it stabilizes that membrane, right? It stabilizes your cardiac membrane, because if it doesn't stabilize your membrane, then this is where these patients develop arrhythmias and it's very deadly. So once again, EKG, you're going to see a peak T wave with hyperkalemia. So one thing I wanted to discuss was priapism. What's the clinical intervention for priapism? If the patient has a prolonged persistent erection for more than 4 to 6 hours, this is usually a urologic emergency, okay? And we have two types. We have ischemic, which involves a low flow, or non-ischemic, low flow to the penis, right? Or we have non-ischemic, which is high flow. With ischemic, we have to do detumescence with aspiration and irrigation, phenylephrine injections, and shunt surgery. If it's non-ischemic, we just have to observe him. So once again, that's going to be priapism. And then another thing I wanted to mention was seminoma or testicular cancers. They're very commonly found in patients between 15 to 35. Your males, right? They're going to have presenting with a nodule or painless swelling of one testicle. And then we're going to do a scrotal ultrasound in these patients. The tumor marker for your seminomas is going to be your beta HCG. Okay, and then hydronephrosis. What you need to know about hydronephrosis is that we want to treat whatever is causing hydronephrosis, whether it is calculi, like your kidney stones. You want to make sure that we treat that. Lithotripsy, right, if needed. And now we are done with our renal and urology. Okay. Okay, so then we go into our next topic, which is going to be dermatology. So dermatology is going to be 5% of this exam. So let's start with cellulitis. Cellulitis is a common infection of the dermis that's due to bacterial entry via breaches in the skin barrier. It involves the deeper dermis and the subcutaneous fat. So the causes of this is because there's a portal of entry, whether it's through a wound, an ulcer, maceration between the toes, which usually sometimes involves strep, fungal infection like tinea pedis. Some of the most common pathogens, this is very highly testable, so make sure that you know this. It's going to be your group A strep. Other causes is Staph aureus, especially if it's an open wound. And then Pasteurella, if it's an animal bite. Eikenella, if it's a human bite. And then MRSA, due to an illicit drug use. Or usually if it's a purulent cellulitis, you want to think about MRSA. So once again, the most common pathogen is going to be group A strep. So since I like to bring a lot of clinic experience into these discussions, so in cellulitis is something that we see a lot. Like I've said multiple times in this video, I'm doing my rotation in the burn unit with burn patients. A lot of our patients that have really big wounds and like really deep burns, for example, like our second or third degree, or now how they are commonly known as our deep partial thickness and our full thickness burns. These patients are very prone to getting cellulitis, or just these patients in general with burns are very prone to getting cellulitis because they have such a large wound. With these patients, we want to make sure that we're always, like every day, we are changing their whatever they are dressed in. These patients are usually on bacitracin ointment. Sometimes we'll also put them on something like sulfamylene cream, which is a type of topical antibiotic cream, sulfamylene solution. These are all topical antibiotic creams, lotions, ointments that are placed on these wounds to prevent MRSA. And that's what we see on these patients. We don't evaluate them, of course, every day, but we basically put them down for rounds, which means that they're down so we can go and inspect the wounds. And this is usually like every 2 to 3 days or even daily, depending on whether we think your patient might be developing some type of bacterial infection or fungal infection. So we'll go inside the room. We'll see these patients, especially if like they're post-surgery, if their wounds, for example, were like a full thickness wound and these wounds are not going to heal by themselves, or it's going to take a really long time for them to heal, then these patients will go to surgery and they'll get a graft. So they'll get a graft from their own body. So it's called an autograft, right? Because it's a graft from their own body. Usually they pick areas that have a lot of skin. So areas like your thigh, your back, for example, they'll get these grafts and then they'll kind of just elongate it and then they'll place it on there. Or there's also allografts, which are grafts from either synthetic grafts or even grafts from cadavers. So we place these patients, the burn surgeons will place these grafts on the patient, on the wounds, and then every day, well, not every day, but for example, like if the patient went to surgery today, we'll check in 3 days to see how, for example, that graft is, and to look to see if there's any erythema. So for example, if we see a patient and we see that there's erythema around that graft, and you can see it, it's like inflamed, it's red, then we want to think about cellulitis, and usually in these patients we start treating them empirically for cellulitis. Okay, we usually look at the edges, and then sometimes what we do is we grab a pen and then we draw around the edges of the cellulitis, and then we go the next day and see whether it's expanded or if it's gotten worse. Or sometimes we'll start the patient on antibiotics and then we see that it's gotten a lot better with the antibiotics. So just make sure that you keep that in the back of your mind. Cellulitis very commonly found in anywhere where there's type of entry or damage to the skin barrier that facilitates entry from these bacterial infection. It's like I always explain to my patients when I come in and around with them, and I tell them, because they always ask me, I don't understand why, it's painful, you guys have to take, because obviously when these patients come back from surgery or when they have their burns, they wrap them up, and sometimes we have to see them down for rounds, they have to unwrap them, and sometimes it's painful for them, especially for your burn patients, especially if they have those partial thickness burns where the nerves are still there. It's very, very painful. And so for these patients, sometimes I would go in the room and they're like, I don't understand why you have to keep putting me down, etc. And I'll explain to them, or why do you have to keep applying these creams? Because some of these creams they burn, they're painful because they're antibiotic women's. And so I'll tell them the reason why we do this is because we want to make sure that you're not developing cellulitis. So we have a lot of bacteria on our skin, okay? And sometimes that bacteria, when there is an open area, they take advantage of that. And so that's why we're examining your wounds every day if needed. Like if we have one patient, for example, that I came in and I saw today, and I think they might have cellulitis, then we're going to put them down tomorrow and the following day until we see that cellulitis has resolved or that fungal infection has resolved. Okay? So how is this patient going to present? They're going to be presenting with sprained erythematous non-fluctuant tender plaque, most commonly located in the lower leg, and that's true. I see it very commonly in the lower leg. Arm, if the patient is an IV drug user, usually they'll have streaks of lymphangitis, skin erythema, edema, warmth, fever, chills, and usually it's poorly differentiated. And this is what's going to give you your differential diagnosis, or it's going to be different in comparison to erysipelas, okay? Make sure that you keep this in the back of your mind. Cellulitis, it's very commonly found in the extremities, especially the lower extremities. In addition to that, like I said, it's going to be very poorly differentiated versus erysipelas. This is very commonly found in the upper dermis. And erysipelas, this is going to be sharply defined margins. And that's how you're going to differentiate between erysipelas and cellulitis. So once again, cellulitis commonly found in the lower extremities, like especially like your legs. And then also with cellulitis, it's going to be poorly differentiated. Okay. And it's going to involve what skin. It's going to involve the deeper dermis and the subcutaneous fat. That's another thing that you need to know to differentiate from erysipelas. So treatment for this is we want to make sure that we're treating them early, because untreated cellulitis can lead to sepsis and death. This is why we're very aggressive about treating these patients, especially these burn patients in my current rotation. And then if the patient has a non-purulent cellulitis and they're outpatient, we can treat them for group A strep, so we can treat them with cephalexin. If they're an IV drug user, we're going to treat them with clindamycin, right, because we're covering for MRSA. If it's purulent, pus, or abscess, We want to cover for MRSA and strep, so clindamycin. And then we want to make sure that we also culture it. If it's fluctuant, of course, we want to go in there and incise and drain it. So incision and drain. We want to make sure that we also monitor it. That's where I said that we do the Sharpie, right? We go every day, for example, my rotation. If we suspect that they have cellulitis, then we'll put a Sharpie around it. And then we want to make sure that we treat the portal of entry, okay? And usually hospitalized patients, we want to make sure that we consider empiric MRSA treatment. So for example, for our patients, what we do is that we give them Vanc. So we give them vancomycin for their cellulitis because we were covering empirically for MRSA, right? So erysipelas, I know I briefly mentioned it, but let's talk a little bit more about this. This is a superficial cellulitis with marked dermal lymphatic involvement. It only involves the upper dermis. That's once again how you differentiate it from cellulitis. The most common bacterial cause is going to be group A strep. Other causes are Staph aureus. Signs and symptoms, it's going to be painful, bright erythema. It's going to be more raised and plaque. It's going to be sharply defined, and it may or may not present with bulla. It depends. Usually involves the lower extremities and the face. And this patient is going to present with chills, fever, headache, joint pain. They may or may not also have elevated white blood cell count. Treatment for this, we want to make sure that we monitor it, educate the patient on elevation, and then we want to make sure that we cover for strep with antibiotics, either with penicillin V, amoxicillin, clindamycin, or macrolide. So impetigo. Impetigo is a common contagious superficial bacterial skin infection. It occurs adjacent to the site of Staph aureus colonization, like the nares. Very commonly found in children, especially children between the ages of 2 to 5. Sometimes it's also secondary to epidermal breaks, pre-existing dermatosis, eczema wounds, and the most common bacteria for impetigo is going to be which one? Staph aureus. Make sure that you know this. Signs and symptoms, it begins as papules that are surrounded by erythema. It progresses to form pustules that enlarge and break down to form thick, adherent crusts with characteristic honey-crusted appearance. So that's usually how it's going to present. It'll say honey crusted appearance. What you need to know about this, that what has caught me off guard is that the most common site's going to be in the nares or in the mouth, right? It'll say it's around the mouth, this honey crust lesion, but it's not always around the mouth. I've seen questions where it describes it in other parts of the body. I saw one question when I was a child and it described it on his like abdominal area. And I was very confused because it had the buzzword like honey crusted. And then I told myself, but from what I know, it's commonly found like in the face. So I wasn't sure. And I still ended up picking impetigo and it was impetigo. So don't get stuck on the location. It's commonly found in the nares and mouth, but it can be found anywhere else on the body. So the buzzword for this is going to be your honey crusted appearance. So usually these patients will auto-inoculate themselves when they're scratching themselves. There's also a bullous form of impetigo. This is a flaccid bulla with clear yellow fluid, purulent. When it ruptures, it leaves like this thick brown crust, usually found on the face, extremities, and the diaper area also. I've seen a question on this one, so make sure that you know this. Treatment for this is usually mupirocin if it's localized. So make sure you know how to differentiate whether it's only localized and how to treat it, or whether it's spread or it's extensive. So if it's extensive, we want to make sure that we give them oral dicloxacillin, cephalexin, erythromycin, clindamycin, or augmentin. But the most common one I've seen is dicloxacillin. So once again, impetigo, okay, very commonly found in children between the ages of 2 to 5. It's going to have the honey crusted appearance, commonly found in the nares in the mouth, but not always found there. It can be found anywhere else also. If it's localized, so for example, if it's just in the mouth, then we can give them mupirocin. But if it says that it's in the mouth and in several other areas, then we want to make sure that we give them oral antibiotics like dicloxacillin. Pilonidal disease. This is an infection of the skin and subcutaneous tissue at or near the upper part of the natal cleft of buttocks. It's either acute or chronic. And the etiology, it's more commonly found in males and females. Some of the risk factors for pilonidal disease is going to be obesity, local trauma, irritation, sedentary lifestyle, prolonged sitting. Also, if they have a family history of pilonidal disease, it's very common that these patients will also get pilonidal disease. How is this patient going to present? Sometimes they'll be asymptomatic. If they do have symptoms, they'll have fever, malaise, especially if the abscess is not drained. They'll have a painless sinus opening lateral to the cleft. They'll have a tender mass drainage. Sometimes they'll even have hair that's protruding from the sinus. That's usually how it'll be described on your question stem. And diagnosis for this is usually clinical. Really don't need to do any type of imaging. During my general surgery, my doctor saw a lot of these. Sometimes when they are painful, it's very, very embarrassing and sad for the patient. So labs, though, if they have an abscess and it's not drained, right, they might have leukocytosis, so increased white blood cells. Treatment for this, we can give them antibiotics, but usually if it's an acute, you want to make sure that they go have incision and drainage and then debridement of all the visible hair. So herpes zoster shingles, this is very highly tested. I've seen it everywhere. I've seen it on my family medicine exam, EOR. I don't remember if I saw it on this one, but it's very highly tested, so make sure you're familiar with it. This is due to an eruption of latent varicella zoster virus. It passes from the skin lesion to the ganglia, right? Because that's where this virus will stay dormant. It will stay dormant in the ganglia. So etiology, it can occur in children, but it's not very frequent. It's more frequently found in adults. It's triggered by immunosuppression, trauma, tumor, or irradiation. How is this patient going to present? They're going to have a dermatomal eruption on one side of the body. So usually it'll say that they have like these vesicles that are following a line, and that's how you know it's going to be herpes zoster. It'll usually be an older male, and they're presenting with this painful rash. So once again, what you'll see is you're gonna see group vesicles on an erythematous base, very commonly found on the trunk. It's gonna be very painful. It's gonna be burning, tender. These patients may also present with paresthesias, flu-like symptoms. Also, treatment for this is gonna be bed rest, right? Because it's a viral infection. There's really not much we can do for it. Make sure that we educate them on drinking a lot of fluids, right? Manage their pain. Pain management is usually the key for these patients. We can give them antivirals, so something like acyclovir, famciclovir, valcyclovir, or even valcyclovir for these patients. But it's like something my family medicine doctor said. I had a patient that came in from family medicine. She came in like on the first day. She noticed a rash and she's like, nope, I know this is herpes zoster and I know this is shingles, so I'm going to go see my doctor before it gets any worse. So she came and she saw us, and of course my doctor diagnosed with herpes zoster early, and then what he told her was, you know what, I'm going to prescribe you these antivirals. They're not going to cure it, but they're going to lower the viral amount. Okay, so it's not going to make it as severe as shingles would be, or as severe as it may get. So, but it's not going to get rid of the symptoms. And ever since he said that, it's stayed in my mind, and it's very true. These antivirals are just going to decrease the viral load, but they're not going to really get rid of the virus itself. So this is why it's pain management for these patients. We also give them, for example, for pain, we can give them something like gabapentin. Also, that's like the common one, right, for your post-herpetic neuralgia, which is a complication of this. So we usually give them gabapentin for that, for herpes zoster shingle. And what's the best way to be able to prevent this? So the best way is with getting the vaccine, right? Preventative vaccine for your herpes zoster shingles, especially in our older adults that are older than 60, 65. We want to make sure that we give them their shingles vaccine. And it's something that I always talk to my dad. My dad's like, well, I already got chickenpox, I can't get it. And I'm like, oh, yes, you can. It stays dormant in your, what did we say? It stays dormant in your ganglia, so also root ganglia, so it stays dormant there, and it comes out whenever the patient's immunosuppressed, and it's very, very painful. Another thing I wanted to talk about this is that I had a case of a patient. She was young. She was like 23, 24 when I did my ER rotation, and she presented with herpes zoster. So in younger patients that present with like shingles, you want to think about immunosuppression, and we want to make sure that we're working them up for other things, because once again, this virus affects older individuals, but when it affects a younger individual, we want to think about immunosuppression. So that's another thing that I want to discuss. So lice, yucky, yucky, yucky. So there's three types. We have our head louse, right? The common lice that you see in the children in like elementary school. Body louse, also pubic or crab louse. This is spread by close physical contact, fomites, whether it's head-to-head or theater seats or patient even sharing like hats, right? Etiology, very commonly found in school-aged children. We want to know that it's not a vector for infectious diseases. Usually these patients, once they've eradicated, they usually tend to have OCD or delusions that they still have it. Symptoms, what you'll see on exam is that you'll see presence of live adult lice. Sometimes it'll say that you see like these white nits on the hair shaft. That's how I've seen it described on your vignettes. They'll sometimes say also immature nymphs, viable eggs. Usually these eggs are like the size of a sesame seed. They're very gross. And then another thing about this is that this patient is going to be presenting a scalp pruritus, so itchiness. So it's not always in your vignettes, not always found in children. Sometimes it'll tell you you'll have older adults. So just make sure that you also keep that on your differential when you're answering these questions, because sometimes they'll try to trick you with that. They may or may not have posterior cervical lymphadenopathy, dermatitis, oval gray or white nits, sometimes secondary infection due to possible Staph aureus, right? They're constantly like scratching themselves and they can auto-inoculate themselves. Another thing about scabies that it's very interesting is that sometimes with lice, another thing interesting about this is that with patients with lice, if they have ongoing lice for a while, they can even develop anemia, which I thought was really interesting. So that's interesting. But usually these patients are just going to have the symptoms of like you'll see the lice in their head and they'll be just like an itchy head. Okay. Diagnosis is clinical. We confirm it by seeing the lice on the head. We want to make sure that we also educate the family members to have the entire family treated, especially those who share the bed with the patient, even if they don't have lice. And then we educate them on, of course, washing their hairs, right? Not sharing any combs with these patients, hats, etc. Treatment for this, we can do knit combing. We want to make sure we educate them on washing the clothing, their bedding, their brushes, or combs in hot water. And then children can go to school also. Another thing about this, that we're going to treat them with what? With permethrin. It's going to be permethrin 3%. Okay? Permethrin 3%. Other treatment for this is like malathion, spinosad, but usually what I see is going to be your permethrin 3% for these patients. And sometimes they'll try to trick you with the dosage. So just make sure that you are familiar with the percentage, because sometimes they'll have different percentages on there and I've been tricked before. So once again, it's usually permethrin 3% for these patients. Okay? And the reason you need to know the difference is because when we go into scabies, it's going to be permethrin 5%. So once again, lice treatment for this is going to be your permethrin 3%. Other treatment for these can be also your malathion, like I said, or your spinosad. Okay. So permethrin 3% for your lice. Scabies. So scabies is caused by Sarcoptes scabii infestation. This is due to females, these scabies, right? These bugs, females will lay 3 eggs per day in burrows, and they tend to hatch in 4 days. They can survive up to more than 2 days on clothing and bedding. That's disgusting, gross, right? Etiology of this is most commonly found in women and children, especially also patients that are immunocompromised, very commonly found in your immunocompromised patients. Anywhere that's congregated, it's transmitted through direct contact or fomites. How is this patient going to present? It'll say in the vignette that there's ridges or burrows. Usually you'll say burrows. That's like the buzzword for scabies. It's going to be burrows, lineal markings, and it's commonly going to be found in the wrists, the elbows, and then in between the finger webs also. Okay? So make sure that you're looking for that in your question stem. This patient is going to be presenting of itchiness, or pruritus, excoriations, papules. They can also be found in the axilla, breast area, umbilicus, penis, scrotum, finger webs, like I said. These patients are going to be presenting with severe itching, especially at night. And they can also be found on the scalp and the head, but this is more commonly found in infants your immunosuppressed patients, elderly patients. And then diagnosis for this, it's a clinical diagnosis, but we can do microscopy. We'll do mineral oil over the burrow and scrape it, and that's when we'll see like the mites and the eggs and the fecal pellets. We can also do dermoscopy, which is where we identify the mite at the end of the burrow. Treatment for this is going to be permethrin 5%. So once again, make sure you know the percentage. Permethrin 3%, we said it was going to be for what? For lice, right? Permethrin 5% is going to be for your scabies. And this is very highly tested. Make sure you know this is a patient education. So once you've diagnosed a patient with scabies, you're going to tell them to apply the permethrin 5%. It's going to be from the neck down, okay? So it's going to be from the neck down. And usually these patients will require one more treatment. So you're going to apply it from the neck down. If the patient's older or if it's a child, then you want to make sure that we include the head, right? Because it's commonly found in these individuals on the head also. But anyone else, it's going to be from the neck down. And they're going to keep it on for about 8 to 14 hours. And they're going to repeat it in 1 week, okay? This is very highly tested. Once again, scabies, it's going to be your burrows, especially in between your finger spaces. You can see it on your wrist also, axilla. Treatment for this is going to be what? Permethrin 5%. They're going to apply it from neck down, and they're going to leave it on for 8 to 14 hours, and they're going to repeat the treatment in 1 week. So now we're going to go into our spider bites. So there's 2 spider bites you have to know. It's going to be the brown recluse spider, and it's going to be the black widow. So let's start with the brown recluse spider. Brown recluse spider, this one's very commonly found here in Texas. Since I live in the state of Texas, from San Antonio, Texas. I'm currently recording this in San Antonio, Texas. These spiders are very commonly found here, so we see this a lot. I know in certain parts of the U.S. these spiders are not found, but just make sure that you know this, just in case you know who knows. Of course, for the example, you might end up here in Texas, and then I might see you, might meet you. So, brown recluse spider, very commonly found in the Midwest or Southeast area of the U.S. Like I said, here in Texas, we see it a lot. Patient basically is disturbing the area where these spiders seek shelter. So this is why these spiders will come out. The spider, how does it look? It's going to have a violin-shaped dark brown marking on its cephalothorax. So make sure you know that. They'll describe it to you on the vignette, violin-shaped dark brown marking on the cephalothorax. This patient is going to be presenting with a macular papular exanthem. They'll have fever, headache, malaise, arthralgia, nausea, and vomiting. The thing about this you need to know in the buzzword is that they're going to have a red, white, and blue sign. Red, white, and blue sign. They'll be presenting with peripheral edema, blanching, and then a central volaceous area. So the thing about these bites is that the initial wound can progress to necrosis, and it can create a deep ulcer formation. Treatment for this is going to be your rice, rest, ice, and elevation. And we also want to make sure that we give tetanus to all these patients if they haven't had it in the past 10 years. Treatment for this is usually supportive. We want to clean the wound, cold compresses, and pain control. I think I've only seen a case of this, and this was when I used to work in the urgent care as front office, so I wasn't able to go back there and see what was the outcome, but I saw a case of this, but we have these spiders here in Texas, like I said. So the next one's going to be your black widow. The thing you need to know about black widow is that they have more neuro symptoms in regards to how the patient is going to present and how it affects us as humans. The thing about spiders is that they can bite, but usually the venom that they inject is not a large quantity that will affect us, which is a lot of things like I didn't know before starting PA school. So black widow, they're going to have more neuro symptoms. This is because they release neurotoxins. This is very painful. So this patient is going to present with severe pain. They'll have minimal local reaction, muscle cramping, nausea, vomiting, abdominal pain, dizziness, chest pain, respiratory difficulty. As you can see, these are more pain symptoms. And if the thing about bites, these black widow bites, that if it bites an individual that's older or if it's a child, they tend to have more serious and it's more severe symptoms in these patients. These patients can also present with an elevated blood pressure and heart rate with these patients. So just make sure you know how to differentiate between both of them. So once again, your black widow spider, right? It's usually the female that bites. It's going to be that black spider. They're going to have a red spot on their back. And then you have your brown recluse spider, commonly found in the southeast and Midwest area. It's going to be that spider that has that violin-shaped dark brown marking on its cephalothorax. And then a thing I learned about this, which I thought was interesting, is that they have 3 eyes. So I thought that was really interesting with your brown recluse spider. Okay? And then make sure that you know that the black widows tend to have more neuro symptoms versus a brown recluse spider. They're going to present with that red, white, and blue sign. So next one's going to be your erythematous drug reaction. This is the most common type of cutaneous drug eruption. It's due to a delayed reaction. Some of the common medications that cause your eczematous drug reaction is going to be your penicillins, your carbamazepines, your allopurinol, sulfonamides, NSAIDs, isoniazid, certain barbiturates, benzos, and tetracycline. But what you need to know are going to be your penicillins, carbamazepine, allopurinol, and sulfonamides and NSAIDs. How is this patient going to present? They're going to have usually limited to the skin symptoms, but sometimes it can involve the buccal mucosa. It tends to start from the trunk to centrifugally to the extremities. It's symmetric, and sometimes it looks like measles, but it's not. Sometimes it'll be described as more billiform. They'll have erythematous macules, infiltrated papules, pruritus. Also, so it's going to be very, very itchy, mild fever, and then it's going to be diffuse. Treatment for this is always going to be the first line, which I've gotten asked so many times during my rotations and on the exams, is to discontinue the offending treatment, right? So what medication? So whatever medication they're taking that causes this, just stop taking it. We can also give them potent topical steroids, especially since it's going to be very itchy, oral antihistamines, and reassurance. Prevention is, of course, to avoid the medication that causes the eruption. So once again, like I said, I'm doing the rotation in the burn center. The burn center where I'm at, not only do we see burns, but we see a lot of drug reactions, and we see the severe ones like our SJS and our 10 patients, which I'm going to discuss in a few minutes. We get a lot of this erythematous drug reactions that come into our hospital because they are usually transferred to us to rule out our severe diseases like our SJS and 10, right? And for example, I had a patient that presented with this like about a week ago. It was an older man. He had just started a medication for his seizures. I think it was carbamazepine. He had just started it. And then they increased his dose. He was fine on a low dose, and then they increased it. And then he presented the next day with like this rash. And so they presented it to him. They transferred him to us because they wanted to make sure that we wanted to rule out SGS and 10. So we kept him overnight. We looked at the rash, and it was just an erythematous drug reaction. So next one's going to be our Stevens-Johnson syndrome and toxic epidermal necrolysis, SJS or 10. This is what we see in the hospital where I'm at. Is we see a lot of burn patients, a lot of SJSs and 10s. It's a very, very sad disease. This is a delayed reaction, and it's a life-threatening mucocutaneous reaction. What you need to know about this is that it involves the mucosa. It'll involve the oral mucosa. It'll involve the ocular mucosa. I've seen patients where it involves vaginal mucosa. It involves the mucosa. So whenever you think about mucosal involvement, think about SJS and toxic epidermal necrolysis. And like I said, it's acute, life-threatening mucocutaneous reactions. And it's like, I always get asked this during rounds all the time whenever I go and see my patients, is that why do these patients die? Why do SJS and 10 patients die? They die because they become septic, because their white blood cell count is so low. And then another reason that they die is that they'll get a mucus plug. So like they'll have sloughing in their, anywhere that they have mucosa. So whether it's in their esophagus, anywhere, and they can die from a mucus plug. So this is what commonly kills these patients. So etiology, we don't know what the cause is. We know that it's medication induced. The pathophysiology is apoptosis of keratinocytes. It's a cytotoxic immune reaction. The most common medications that you want to know that are associated with SJS and 10, this is very commonly tested, is going to be your sulfa antibiotics. I've seen so many patients with sulfa antibiotics. And before I did this rotation, during my family medicine rotation, I would prescribe Bactrim for UTIs. Now it makes me double think it, even though SJS and 10 is very, very rare for patients to develop this when they're taking Bactrim. But still, I've seen the extreme cases of patients with 10 with SJS that suffer from being treated with Bactrim. So I just keep that in the back of my mind. That's why it's really important that you ask your patients if they have allergies to any medications. Other medications are sulfasalazine, allopurinol. which is your medication for gout, tetracyclines, anticonvulsants, right? Like your carbamazepine, NSAIDs, diazepam. How is this patient going to present? They're going to have extensive necrosis and detachment of the epidermis and mucosal surfaces, usually 1 to 3 weeks after onset of the medication exposure. So like I said, we'll have these patients that started medication about a week ago, and then they start presenting with these symptoms. We had one patient who was super young, like last week. He was 27. He came in on day 1. They transferred him to us because he had a rash, and he had just increased, once again, I think it was carbamazepine also for his seizures, and they had just increased his medication. He was taking it, and when he came in, he saw us. I remember I was like leaving that day, and he was coming in, and I told one of the PAs, I'm like, that's him. I'm like, he looks really good to be diagnosed with SJS. And so we thought we were going to discharge him the next day. Well, the next day when we saw him, he had already like mucosal and ocular involvement. It was really, really sad. And usually with these patients that have ocular involvement, they have to get consulted by ophtho. So ophtho will come in there and make sure that they're looking their eyes, and they're constantly cleaning that eye, because they have mucosal involvement and it can cause blindness because it can affect the cornea. So they're constantly going in there and cleaning these eyes and cleaning all that slough from the mucosal involvement to the eyes. So it's really, really sad for these patients, because these patients can become blind. So this patient is usually also can present with a fever, headache, rhinitis, arthralgias, myalgias. Usually they'll have symmetric eruptions starting on the face. They'll initially also sometimes start on the upper trunk, proximal extremities. They'll be more painful than itchy, and the rash can rapidly extend to the rest of the body. It's going to be erythematous, irregularly shaped, dusky red to purpuric macules that will progressively coalesce. And then they'll have also painful micturition, which is going to be your dysuria. They'll have these atypical targets. Sometimes these lesions will evolve to flaccid blisters, and they'll spread with pressure. And these are going to be positive Nikolsky sign. Okay, so I've had these patients that they come in. I had another one. Like I said, we see so many patients. It's very sad. I had another one that passed away from SJS, and she came in because she was given allopurinol for gout, and she ended up passing away. But she had a lot of other comorbidities. So for this patient, I remember when we saw her, she had her arms and like they were literally peeling off. So that's why it says that they have that positive Nikolsky sign, is that they'll have these flaccid blisters, and then like you just press on them and like the skin will sometimes like it'll slough off, and that's what the positive Nikolsky sign is that they'll having that sloughing of the skin. Like you just put gentle traction and then it'll slough off. So this is a dermatological emergency. The mortality rate for SJS is about 5 to 12%, and then for TENS, it's about more than 20% for these patients. For my hospital, whenever we have a patient that comes in with the SJS or TEN, we always biopsy every patient. In dermatology, we go and biopsy these patients. So with SJS and TEN, we want to make sure that we transfer them right to the appropriate hospital that can take care of them, like the hospital that I'm at that takes care and specializes in burn patients. I know you're thinking about it's an SJS and TEN, like why are we going to transfer them to a burn hospital? Because that's what the hospital I'm at, that's what we specialize in. We specialize in treating SJS, TEN, burn patients. Also your bullous, pemphigus vulgaris. We treat all these like extreme cases of skin reactions that can cause death in these patients. So another thing you need to know is the percentage. So SJS is less than 10% body involvement, okay? 10 is more than 30% involvement. If it's between 10 and 30%, that's going to be both SJS and TENS. So for example, if I have a patient that I saw today, 26%, we call them SJS/TENS. If it's less than 10%, right, it's going to be only SJS. If it's greater than 30%, it's going to be TENS. Make sure you know this. This is very, very highly tested. Treatment for this is that we want to make sure that we recognize it early. Like I said, we treat them early. We discontinue the offending agent. That's usually the first line thing you need to know. So if it asks you what's the next best treatment, you're going to discontinue whatever they're taking, okay? And I get pimped on this left and right in the hospital. We're going to discontinue the offending agent. Usually treatment for this is usually supportive care for these patients, and we want to make sure that we stop all non-life-threatening medications. And like I said, these patients are usually transferred to us to the burn unit or ICU, especially if they have more than 25% body surface area that is involved. So usually with these patients, we're going to give them high-dose IVIG, IV fluids, electrolytes, glucocorticoids. If they have like oropharyngeal involvement, we're going to make sure that we do oropharyngeal suction to prevent aspiration, because like I said, remember these patients suffer from mucus plugs, right? And then also ocular involvement, like I said, ophthalmology consult. If they have eye lesions, erythromycin ointment, and then we want to make sure that we treat them if they have any sepsis, because these patients very commonly die, once again, from the two causes. They have decreased white blood cell count, so they'll die from some type of other secondary infection where they become septic, which was what happened with my SJS patient that I said that had SJS due to allopurinol. And then these patients also die from mucus plugs. So once again, SJS in 10, it's an extreme, like life-threatening mucocutaneous reaction. Some of the common medications associated, it's going to be your sulfa antibiotics, sulfasalazine, allopurinol, anticonvulsants, NSAIDs, tetracyclines. And these patients are going to have a positive Nikolsky sign, right? So you'll apply tension on the skin and it'll literally slough off. These patients can present with a bulla also. Usually it'll be bulla that I've seen with these patients with SJS, and like they literally slough off. And BSA, so SJS in 10 is going to differentiate between on what is the body surface area that is involved. If it's less than 10%, it's only SJS. If it's more than 30%, it's 10. If it's between 10 to 20%, it's going to be your SJS/10s. And then treatment for this is usually just supportive. We want to make sure that we transfer them immediately to an area that a hospital that can take care of them. So next one's going to be your contact dermatitis. This is due to chemical irritant or antigen or allergen. This is more irritant related. So you'll have irritant and allergic symptoms. So irritant symptoms, it's usually due to it's localized to confined areas that are exposed, very commonly found in the hands. These patients are going to be presenting with burning, stinging that can be immediate or delay, sometimes even greater than 24 hours. They'll have erythema, vesiculation, caustic burn with necrosis. It'll be sharply demarcated. They'll have superficial edema. If it's severe, they can have vesicles, blisters, erosions, frank necrosis, and bizarre and linear configuration. Treatment for this, once again, we want to identify and remove whatever is causing the contact dermatitis, wet dressings, drainage. We want to make sure we drain the large vesicles. And then if it's severe, we can give them oral steroids or emollients. Prevention is the key. So these patients, we want to make sure we educate them on avoiding whatever caused the contact dermatitis or irritants, protective clothing. Sometimes these patients will work with whatever's causing the contact dermatitis. So sometimes they'll just need to leave their employment, but I know sometimes this is not a choice for these patients. So if it's not, just educate them on making sure that they use the protective clothing, right? Wash with water or weak neutralizing solutions, use barrier creams, and then of course, like I said, change job. So then you have your allergic symptoms. This is usually going to be an eczematous dermatitis, intense pruritus, or they have stinging pain. It's initially confined to the area and it spreads linear with atypical patterns. These patients have to have come in contact with something to cause the allergic symptoms. They're going to have well-demarcated erythema or edema, superimposed closely spaced papules or non-umbilicated vesicles. On the erythema, you'll see erythema, papules, vesicles, and erosions, and then crust and then scaling. Treatment for this, we want to make sure that we avoid, the patient avoids exposure. You can apply wet dressings also. If it's acute flares, then you can give them systemic steroids. Diagnosis, we usually do a patch test for these patients, right, to see what is causing the allergy. Usually it's negative with irritants, but it'll be positive with your allergens. Okay. So next one's going to be your atopic dermatitis. This is going to be an acute or subacute or chronic relapsing skin disorder. Very commonly found in your infants, especially between the 2 months to first few years of life. Usually they'll have a family history of atopic dermatitis, allergic rhinitis, and asthma. So, right, your triad. They'll have a skin barrier dysfunction. They'll have usually an IgE reactivity, very commonly found in males than females. This patient is going to be presenting with dry skin, pruritus, rubbing They'll have increased inflammation and lichenification. It's going to be that itch, scratch cycle. So they basically itch, they scratch, they rash, they itch, and they scratch. Also, they'll have a history of allergic rhinitis, and it's usually commonly found on the flexor surfaces. So that's another thing you need to know about atopic dermatitis and how you can differentiate it from something like psoriasis, right? So atopic dermatitis is going to be what on your flexor surfaces versus your psoriasis is usually going to be on your extensor. So that's why psoriasis is on the shoulders, the elbows, and then your antecubital fossa, like right here, it's going to be atopic dermatitis. And that's how I've seen it described on your questions. It'll say, you have this child that's presenting with this itchy rash on their near their antecubital fossa, and you're like, oh, you know what? That's what it is. That's atopic dermatitis, and they have a history of asthma and allergies. So you want to think about atopic dermatitis. This is usually a clinical diagnosis. So you want to make sure that we work them up for allergies. Usually some of the complications of this is that they have secondary infections, right? If they're constantly scratching themselves, and if they make that area, that skin area, prone or vulnerable to secondary bacterial infections. So they can get infections with Staph aureus, right? Because it's found all over the body, all over the skin. And then if it's an acute atopic dermatitis, usually it'll have a poorly defined erythematous patch, papule plaque, with or without scale, edema. Usually it'll be described like a puffy skin, erosions because this patient's constantly scratching, right? Treatment for this is we want to make sure that we educate the patient to avoid rubbing or scratching it. We can apply wet dressings or emollients, and then we can give him something for the itchiness like hydroxyzine. If we do see that they have some type of infection, then we can give them oral antibiotics covering for MRSA. But usually first line is going to be your topical corticosteroids for your atopic dermatitis. So this is very highly tested to make sure you know that's, once again, it's going to be found on the flexors, right? This patient's going to have a history of like asthma, allergies, your triad, right? And then your atopic dermatitis, very, very, very itchy. They're going to complain of itchiness. And usually for these patients, we just can give them hydroxyzine for the itchiness and then topical corticosteroids. So bullous pemphigoid. So bullous pemphigoid, make sure that you don't confuse this with your pemphigus vulgaris. Pemphigus vulgaris is going to be the severe one. Bullous pemphigoid is not as severe. How I memorize it as vulgaris just sounds like a villain. So pemphigus vulgaris is going to be the severe one. Bullous pemphigoid is not as severe. So bullous pemphigoid is going to be due to autoantibodies of parts of the hemidesmosome that are resulting in deep, tense bulla. So with these patients, you're going to have a tense, firm bulla that's going to be intact. Once again, the patho is very highly tested. So bullous pemphigoid is going to be autoantibodies of parts of hemidesmosomes that are resulting in deep, tense bulla. They're going to have this tense, firm bulla that's going to be intact. Etiology for this, it's usually commonly found in older adults. And sites, it includes the axilla, the medial thigh, the groin, the abdomen, the flexor surfaces, the lower extremity, mouth. How's this patient going to present? They're going to have pruritic, papular, or urticarial lesions with bulla. They'll have a prodrome where they have itchiness, urticaria, papular, and then they'll have this tender bulla. Sometimes they can present with oozing or bleeding. Diagnosis is that we're going to do direct immunofluorescence, and treatment is that we want to make sure that we refer these patients, of course, to germ. We give them prednisone, and then if it's like recurring, then we can do something like tacrolimus. All right, so now we're going to go into our burns. Yay, burns. I see this every day in the rotation I'm at. So burns, this is usually due to an acute wound due to an isolated, non-recurrent insult that progresses rapidly through orderly series of healing steps. So the cells are destroyed. Some of the predisposing factors for these is going to be smoking, physical disability, sensory impairment, dementia. So yeah, we have a lot of patients that come in, especially we had one patient that came in last week. He had a syncopal episode, older man, like he was like 67. He has like mild aortic regurg as a history, and he has like orthostatic hypotension. So he passed out and he fell on top of a stove that was on. We don't know how long he was passed out for, but then they found him and he came in and he had like 3rd-degree burns on his chest because he had fallen on top of the stove. That's something that we see commonly. We also see a lot of our COPDers that are smoking near their oxygen tank, so then their oxygen tank explodes and then they come in and they have like these facial burns. So we see that a lot. We see it a lot also in our diabetic patients. I've seen patients that are, especially the ones that have like really bad peripheral neuropathy. Sometimes they'll just be walking like outside or like in a fire camp, and I've seen a patient like it's just like toasting their feet and they have no idea their feet are on fire because they just don't feel it because they have very advanced peripheral neuropathy. And then of course we see a lot of like the severe ones like gasoline burns, explosions, etc. So I see a lot of patients. Commonly though, I see a lot of more male patients and females. I would say like right now we have about 17 patients. I think 2 of them are females, the majority of them are males. So burns. What we need to know about this is that there's different types of burns, okay? And I know depends on what textbook you're reading. Now they've moved, so they used to be described as 1st, 2nd, 3rd, and 4th degree. Now they're moved on to superficial thickness. You have your partial thickness, your deep partial thickness, and then your full thickness burns. And that's what we use currently in the hospital right now, is that we describe them as either superficial thickness, superficial, partial thickness, deep partial thickness, and then your full thickness burns. And that's how we describe these burns. But I'm going to go and describe each one because I've gotten questions depending on which question bank you're using of like mix. So just make sure you're familiar with both of them. So 1st degree is going to be your superficial burns. This is usually what type of burns. This is going to be your sunburns. These are very, very painful, right? Because you have the nerves that are intact. So the thing you need to know about your burns, and this is what I educate my patients like every day when I talk to them, is that the more painful your burn is, the better. And that's what I tell these patients, because sometimes when I see these patients in the morning, especially when they're coming in for the burns, they go into the shower first thing when they come into the hospital and they debride them. So they clean up all those wounds because we want to see what is the total body surface area that is involved and whether they need to be transferred to ICU or not. So I'm currently in like the step down unit, which is, we don't see very severe patients there. Usually we'll get like step down from ICU that have gotten better and they've controlled them and then they're with us. Or usually if it's like less than 10% TUSA, we'll get these patients to like where I'm at, the burn step down. And so for these patients, the first thing, no matter where they go to ICU, they'll make sure that of course that they don't have any type of inhalational injury, right? That can involve the larynx and it can cause that edema, and then just to make sure that we don't have to intubate these patients. And how do we tell that from inhalational injuries? Is that we make sure that we look inside and we look for any cinched nasal hairs. We ask the patient if they have any chest pain, any coughing, or if they were like inside a house or was burning for a long time, did they inhale any smoke, etc. So first thing they do is that they come in, if it's just a burn, they'll come into the shower and then they'll clean off these patients. It's very painful, especially if they have a large percent of burns. If they do, usually they'll call anesthesiology, which I was there once. They called anesthesiology and we put the patient to sleep while he was in the shower because he had so many burns and it was very painful. It would have been very painful to have the patient awake while we're cleaning the wounds. But usually these patients will give them like oral oxycodone or like oral hydromorphine for the pain. So they come into the hospital, they come in there, and then we're debriding these patients. Usually the nurses are there. I've done it a few times when I'm in there with the nurses, like debriding the patient. So we clean the wounds and then they bring him to the room, and that way we're able to inspect the burns and see whether they are superficial thickness, partial thickness, deep partial thickness, or full thickness burns. And then we're also able to inspect and calculate what is the total body surface area that is involved in these patients that are burned, okay? So when these patients come to the room, what I do, the first thing that I do is I go in there, and then I know this is like very cruel to do, but this is how we see whether it's a full thickness, deep partial thickness, superficial, partial thickness, any type of burn. This is how we see. So I go in there and say if they have a burn here on their forearm, I usually just like poke at it and then I'll rub my finger on it. And usually if the patient's like, and you can see them like retracting, okay, you're like, okay, that's not full thickness burn, right? Or deep partial thickness burn, because the nerves are still intact and the patient's able to feel it. Another thing that I look for the burns is going to be prominent budding. So what is that? So whenever you shave yourself and you see your hair follicles, right, you'll see the budding. That's what we see in these burn patients. So if you see that prominent budding, like budding, that means the hair follicle is still there. Okay, so that means it's not full thickness burn. It hasn't gone through the whole way. Okay, and then I also, of course, look at the wound. Is it like a beefy red color? Is it moist? If it's moist, that means that those sebaceous glands are still there. Okay, because if it's not moist, if it's just like dry and leathery, then we're thinking about maybe a full thickness burn. So it's another thing that I check for. So I go in there, I rub my finger along the wound, and I see if the patient will react to pain or not. I also look to see what's the color. Is it a moist pink color? Or is it just like a leather color? Or is it just like white? Do I see like the budding like of the hair follicles? Is it moist, like I said? And that's one of the things that we see on these patients, whether it's on the face, whether it's on the extremities or on the torso. That's something that I do every day when I see these patients. So the reason why I'm bringing this up is because this is how we're able to tell what degree of burn it is, and also when I educate my patient, what level of the skin was affected. Because remember, the deeper we get into the hair follicles, the sebaceous glands, we get into the nerves, okay? And it's like I tell my patients every day, if a burn is painful, that's good, because that means you haven't burned your nerves, okay? You haven't burned your sebaceous glands. You haven't gone through all those layers of the skin and gone to like the deepest part of your dermis, okay? So now that I've discussed that, first degree is going to be your superficial. This is only going to involve the epidermis. So this is going to be your sunburns, like I said. These patients are going to have no blisters. It's going to be very painful because you have those nerves that are still there. They'll be dry, red, and it's going to blanch. That's another thing I check, is that whether does it blanch. So when you press on it, does it blanch? And with your superficial burns, they're going to blanch. And usually these patients will peel once they heal. They won't scar. Okay, it's just a sunburn. And these patients, we don't see them in the hospital. We usually see our full thickness, our deep partial thickness patients in the hospital. Usually these patients we don't see. So second degree or your partial thickness burn, what you need to know about this one is that this involves the epidermis and the partial dermis. It can either be superficial or deep, and that's how we call them in the hospital. We call them either partial thickness or deep partial thickness, or superficial partial thickness or deep partial thickness. So that's how we describe in the hospital. So with these patients, if it's a superficial partial thickness, they're going to have blisters. It's going to be painful, red, like I said, weeping. It's going to blanch also. Scarring is very unusual for these patients. And then pigment changes can occur. This tend to heal between 7 to 20 days. So that's another thing that we do in the hospital, is that we look at the wound and the burn, and we see whether the patient needs to go to surgery or not. So if it's a full thickness burn, obviously these patients need to go to surgery, and usually the surgical treatment for these patients is that they get grafted. So they get either autografted, right, which is where you take skin from your own body, usually from the thigh or the back, and then they'll place that skin graft on the area that's burned, okay? Or they can do allograft, which is they get it from a cadaver. These are the types of grafts that we do. So that's another thing that we do in the morning when I go see and round these patients. I look at the wounds. I see how are the wounds. Are they healing? Are they on an area where I think that they can develop a contracture? What's a contracture? A contracture is when a burn heals and it causes a scar, okay? So once again, a burn heals and it causes a scar. The thing we need to know, though, about burns real quick, and I'm sorry if I'm taking a long time. I think this is just a very interesting concept, which I had never understood until I did this rotation, and now I feel like I understood burns more, because I always struggled with burns and understanding them. So the thing you need to know is that whenever a patient has like a superficial thickness burn, superficial partial thickness burns, they're going to heal by re-epithelialization, which is good, right? Versus like your more deeper burns, like your full thickness burns, sometimes even your deep partial thickness burns, these patients are not going to heal by re-epithelialization. These patients can go straight to scarring. So that's why in these wounds like your deep partial thickness wounds, your full thickness wounds, sometimes these patients need surgery, especially if they're in an area, like if they're on a wrist area and this area is prone to developing a contracture, which is like a type of scar, right? What's going to happen with the scar? Sometimes it'll heal like this, and this patient can have a contracture where they can't move the wrist. They won't be able to have that range of motion. So that's another thing that we see, is where is it located? Not only that, what if it's located on the lower extremity? I had one lady that came in last week. she had like it was like a deep partial thickness burn, and it was on her lower leg, and it was circumferential, so it was around the thigh. And this patient needed to go to surgery because once this wound starts healing, it can compress those joints, right? It can compress the blood flow, and it can decrease blood flow in the future. So this patient needed to go to surgery. So that's another thing that we also take in consideration is, where is the burn located? Is it located in an area where it can possibly cause contracture if it starts scarring? Like I said, like the wrist, the fingers, okay? So that's another thing we take in consideration whenever we see these patients, and that's another thing, and it's not going to be on your exam, but I just wanted to discuss that. So deep partial thickness. This is going to be damage to the hair follicle. It's going to be painful to pressure, blister. It's going to blister easily. It's going to be wet, waxy, dry, patchy, white to red, and it does not blanch with pressure. And that's another thing when I'm describing my burns, like when I press on it, does a patient, is it sensitive to pain, or is it only sensitive to pressure? So usually for your deep partial thickness wounds, usually they'll just be sensitive to pressure. So I'll go like this, and I can rub my hand around it, and I tell them, is it painful? They're like, no, I just feel like you pressing on it. So usually with these wounds, they're going to be sensitive to pressure, okay? Usually not pain. So 3rd degree is going to be your full thickness. This is going to involve your epidermis, dermis, and subcutaneous. These patients usually will have burn eschars, okay? They'll have like this dead, denatured dermis that's usually intact, and this one rarely heals. So like I said, these full thickness burns usually need to go to the surgery. And then we have a 4th degree. I've yet to see a 4th degree in my rotation. I've seen photos of it from the burn center, and usually these 4th degrees that we come in, especially if they're like more than 80% involved, like total body surface area, these patients usually don't make it to our hospital. So full thickness burns, this is going to, your 4th degree, it's going to be your deep, life-threatening. They extend into the fascia, muscle, or bone. They're sensitive to deep pressure only, and they never heal, okay? So how do we diagnose these burns? They're going to be expressed as your TBSA, your total body surface area. So every single patient that I see every morning, we calculate a total body surface area. And for this, we use our usually rule of 9s, right? So make sure that you are familiar with your rules of 9s, okay? So just to go over it, the anterior torso is going to be 18%, right? So if you were to divide the anterior torso into 2, to be 9% and 9%, the back is going to be 18%. You have 4.5%, 4.5%, so the whole arm is 9%, okay? And then you have your lower extremities, 9% on the anterior part of the thigh, the whole leg, 9% on the back, so 9, 9, 9, 9. Okay, that's why it's called the rule of 9s. And then another thing is that the palm's going to be 1%, your hand, palm's going to be 1%, okay? And then the groin area is going to be 1%. So make sure you know how to calculate these and you add them up. This is something that I do every day, but we actually use a Lundbrowder, which is a little bit more specific. I don't want to confuse you guys. I haven't seen this tested, so I'm not even going to mention it. But just make sure that you're familiar with your rules of 9, because it's going to tell you like half of the anterior torso is involved with like half of the arm, and you need to be able to calculate to see how much is affected from the body and see whether, well, how much is affected for the body, and be able to calculate it, because this is very, very highly tested. Another thing that you need to know is that it's different in children because children have bigger heads, but I haven't had this tested yet. So once again, to go into it, right, 4.5%, 4.5%. So the whole hand's going to be 9%. The whole upper extremity is going to be 9%. And then you have 9% on the anterior part of your leg, and then 9% on the posterior. So the whole leg's going to be 18%. We said 18% for the anterior torso, 18% for the back. Half of the anterior torso is going to be 9. Same thing, half and half. So 18, 18, 9, 9. Okay. And then the whole leg is going to be what? 18, 18. And then for the head, 4.5%, 4.5%. Okay, the whole head's going to be 9. We said the palms are usually 1, and then the perineum is going to be 1. So Continuing on to burns, minor burns or anything that's partial thickness that involves less than 10% TBSA in patients that are between the ages of 10 to 50, and then patients that are less than 5% under 10, or if they're over 50, it's considered your minor burns. Full thickness burns is anything less than 2% TBSA in a patient without injury. And then what you need to know is that these injuries cannot involve the face, hands, perineum, feet, or cross any major joints or not be circumferential. So sometimes you'll get these patients that are like 2% TBSA, and you're like, okay, 2%, it's not that much. But if it involves the face, it involves the hands, like I said, or if it involves, or if it's circumferential, like I said, the patient that I discussed, then these patients will get transferred to us, okay? And these are some of the reasons why you would transfer these patients, and they're not considered minor burns. Treatment for this, if it's a non-superficial burn, give them topical antibiotics. Also, you want to make sure that you suspect infection for your second-degree burns. And then another treatment you can do is thermal cooling, not ice, gentle cleansing, dressing with topical antibiotics, not adherent gauze, pain management. Also, for all burn patients, we give them tetanus shots, so make sure that you know that. You want to make sure you follow up with these patients to monitor for infection. That's what we do every day, like I've discussed when we're talking about cellulitis, is that we monitor these patients every day because they have open wounds, especially if they have a large percentage of body involved, like 20% or 30%. We're making sure that we're monitoring them daily, if not daily, like every 2 or 3 days, to make sure that they're not developing secondary bacterial infections. So that's another thing you need to do with these patients, is that you want to monitor them for infections. If they have increasing burn depth, what does that mean? So sometimes we'll have a patient that presents the first day, and we're like, you know what, that's like maybe like superficial partial thickness burn. And then the next day, like as the burn is developing, it develops into like deep partial thickness burns. So that's what it means with that, is that increasing burn depth also. Sometimes you won't see it on the first day, even though we try to cleanse those patients, right? We try to remove as much as we can of that dead tissue so we can see it. Sometimes they won't. It's like one of the surgeons I was with, that he said is sometimes you won't know what it is, or it won't appear until the following day. So that's why sometimes we'll keep these patients a few days to make sure that it's not something worse. Okay. And then also making sure that we're following up for any scarring or contraction, like I said, especially for your deep partial thickness burns, right? And then your full thickness burns, because we said that our superficial burns and our superficial partial thickness burns or partial thickness burns, these heal by what? Reepithelialization, versus our deep partial thickness and our full thickness burns, they don't. So these type of burns are more prone to scarring and causing these contractures whenever like they heal, right? Especially if it's like on the wrist, for example, if it's on the finger, okay? And that's why with these patients, we have rehab that works in the hospital with these patients, because they're making sure that these patients are using their joints, and they're using them that way they don't develop any type of contracture or scarring, okay? So for example, for us, what we do is that we use a lot of bacitracin ointment. So we use a lot of topical bacitracin, and usually this is what we'll discharge patients on once their wounds have healed. Of course, we don't wait until they're like 100% healed, but once these patients are stable, then we'll discharge them, and we'll have them follow up with the burn clinic, and usually they'll be discharged on your topical creams, like your topical antibiotics. Like I said, mupirocin, we have the sulfamylon. Usually we don't give this to patients that are allergic to sulfa drugs, right? Because it has sulfa. That's why it's called sulfamylon drug, sulfamylon cream, sulfamylon solution. So usually we'll discharge them on these topical antibiotics. All right, guys, so next one's going to be pressure ulcers. This is very commonly found in the bony prominences due to external compression of skin, shear force, friction, ischemic tissue necrosis. I see a lot of this in the hospital. Especially, I have a patient right now that I'm taking care of. She has a history of neck fash that was complicated by Guillain-Barré syndrome. So Guillain-Barré syndrome is, remember, they're paralyzed. Usually it's like an ascending paralysis where this patient is paralyzed from the neck down. She's able to move her head and She's able to move her eyes and speak and everything, and move her mouth and eat, but she just can't move from the neck down and anything else from there. She can't not move. And so for her, for example, she has a pressure ulcer, like she has a sacral ulcer on the back, which we're constantly managing because we haven't been able to treat it and get rid of all that exudate that she has. So for example, in her, she's bedridden, right? She's not able to move, she's paralyzed. So we're constantly changing positions with her, and then rehab goes in there and they use like these really cool tools where they change the bed position and they're able to move her just to make sure that she doesn't develop these ulcers, right? So once again, commonly found in chronically bedridden. Patients are obtunded mentally, they have decreased sensation. The complication of this is osteomyelitis, especially if it gets really, really deep, because we have different degrees, right? So if it gets really deep and involves like the fascia, the muscle, and the bone, these patients can get osteomyelitis. Diagnosis, clinical diagnosis, we do usually, we can do wound cultures, blood cultures, skin biopsy, bone biopsy if we think that it's osteomyelitis, especially if it's a non-healing pressure ulcer. Treatment for this is reposition. We want to make sure that we inspect for breakdown of the skin, minimize friction, interface air mattresses, avoid moisture, nutritional status, right? Vitamin C and zinc. Stage 1 or 2, usually topical antibiotics, moist sterile gauze, hydrogels, hydrocolloid dressings. Stage 3 or 4, treatment is usually surgical management, debridement, flaps, and skin grafts. Okay. Another thing that we've done for this patient is like we applied a wound vac, which is literally what it sounds like. It's a wound vac, and it'll go on there on the sacral ulcer. And what it does is that once we've cleaned out all the yuckiness that's in it, it promotes like, think about like when you stick yourself on a hickey, or you give yourself a hickey, it promotes that those blood vessels to come, and it helps it heal faster. So that's a whole reason why we do a wound vac on these patients. So next one's going to be urticaria or hives. This is a vascular reaction of skin that's characterized by wheals surrounded by red halo or flare. They tend to present with a transient edematous papillary or plaque. What's the etiology? It's usually idiopathic, sometimes due to infections, food reactions, drug reactions, IV administration. Very commonly found in children, especially if it's in children, you want to think about a viral infection. These patients are presenting with pruritus, so itchiness due to swelling of the upper dermis. They'll have wheals. Wheals is usually pathognomonic for urticaria. Whenever I see wheals, I think about urticaria. And usually these wheals will blend with pressure. And this is usually a clinical diagnosis. They can have acute urticaria or chronic urticaria. Acute is usually less than 6 weeks. If it's chronic or recurrent, it occurs more than 6 weeks. And in these patients, we want to assess for anaphylaxis, right? This can be a severe form. So we want to make sure that we are assessing for anaphylaxis. The treatment for this is going to be antihistamines. Usually our first generation or first line, but these are very, very sedating. So usually we use our second generation antihistamine because they're not as sedating. And then for anaphylaxis, we want to make sure that we do our ABCs, right? Airway, breathing, circulation. And first line's always going to be epinephrine for these patients that have that develop anaphylaxis. Once again, first line epinephrine. We want to make sure we also give them IV fluids, oxygen, and we monitor them in the hospital. So let's go into our viral exanthems. This is very commonly tested, so make sure that you know the etiology of each one, what group they're more commonly found, and how do they present. So we have erythema infectiosum. This is also known as fifth disease. This rash appears abruptly, commonly caused by parvovirus B19. So once again, parvovirus B19, erythema infectiosum. Make sure that you know this. Very commonly found in children between the ages of 4 to 10 years old. And the incubation period is between 1 to 2 weeks, with eruption that lasts 5 to 9 days. Usually commonly found in like your school outbreaks, especially like late winter or early spring for these patients. How's this patient going to present? They're going to have fever, coryza, headache, malaise, myalgias, pruritus, and then usually they're going to present with the bright red cheeks. They'll have these slapped cheeks. I saw this in the emergency room once. Literally the patient presented with like the slapped cheeks, and that's how usually they're going to present. And then they're going to present with like this reticular lace-like eruption. How I memorize it is that the patient got slapped by parvo, right? Patient got slapped by parvovirus, since parvovirus causes erythema infectiosum. How are we going to diagnose this? We can do a specific IgM antibody. This is going to be the preferred test, but it's usually a clinical diagnosis. Treatment, it's a viral infection, so it's going to be supportive. We just educate the mommies to make sure that they're hydrating their baby. They can use antipyretics, but it tends to go away between 5 to 10 days. And the prevention, just make sure that they have good hygiene in their hand washing. So once again, erythema infectiosum, it's going to be that slapped cheek. Literally looks like the baby got slapped. It'll start with the cheeks that are like really, really red, and then it's going to develop into a lace-like eruption, reticular lace-like eruption. It's caused by parvovirus B19. So next one's going to be your hand-foot-mouth disease, commonly found in children under the age of 5. Most common cause is going to be your Coxsackie virus. So once again, your Coxsackie virus. Coxsackie virus also causes herpangina and endocarditis, but make sure that Coxsackie virus, is associated with hand-foot-mouth disease. It starts with the mouth, then the palms of the hands and the soles of the feet. So that's why it's called the hands-foot-mouth disease, because it starts in the mouth, okay? And then it goes to the palms of the hands and then the soles of the feet. This patient is also going to be presenting with fever, sore throat, malaise, joint pain. They're going to have this bright pink macula or papule. It's going to be painful vesicles with erythematous halos, usually when you see the question stem. And diagnosis is going to be clinical. Treatment is going to be usually supportive, right? Because this is a viral infection. So once again, hand-foot-mouth disease, Coxsackie virus is what causes it. It's going to start in the mouth. It's going to go to the palms of the hands and soles of feet. What you need to know is that Coxsackie virus also causes herpangina, and it's also associated with endocarditis. You have different types, A and B. So measles is going to be the next one. This is very commonly tested. Measles, also known as rubeola, due to the measles virus. Etiology, commonly found in children. And this is usually going to be a child that has not been vaccinated, right? Usually it'll tell in the question stem that it's a mother that refused to vaccinate their child. This patient is going to present with your C's, right? Your conjunctivitis, your cough, so conjunctivitis, cough, coryza, and your Koplik spots, even though it starts with a K. Koplik spots, which are multiple blue-gray spots in the mouth, okay? And it's usually going to be in the buccal mucosa. They're going to have erythematous macules and papules that begin on the face and spread down. So that's how you can differentiate these rash from the other ones, is that this one will start in the face and it's going to spread down. They're going to have the cough, coryza, we said the conjunctivitis, and the Koplik spots on the buccal mucosa. It's going to be a child that has not been vaccinated. So diagnosis is usually clinical. We can confirm with serology, and we want to make sure that we report this to the local state departments. We can do an anti-measles IgM and IgG. Treatment is usually self-limited, right? Because it's a viral infection. It's usually supportive, so give them antipyretics, fluids. Vitamin A also is really good for these patients for measles. I think I had a question on that, so just make sure you know that vitamin A in measles. Okay? And then we have Roseella infantum. This is also known as the 6 disease. This is due to human herpes virus 6 and human herpes virus 7, commonly found in your younger infants. So your infants and toddlers between 6 months and 36 months. So this is another way that you can differentiate what it is, because this one's usually commonly found in your younger babies, like your babies, your 6 months to 36 months. Okay? How's this patient going to present? First, you're going to present with a very high fever, and then secondly, they're going to develop this macular papular rose-colored rash. And what you need to know about roseola is that it's going to start on the trunk, okay? We said rubella starts on the, it'll start on the head, so forehead, and it'll go down. Roseola is going to start on the trunk, and then it's going to spread out. That's another way that you can differentiate with these patients. And another thing that you need to know is that roseola is very commonly associated with febrile seizures because they have these very, very high fevers. Diagnosis is clinical. Treatment is usually going to be supportive, right? Hydrations, antipyretics, and if the patient's immunocompromised, we want to give them ganciclovir. And then we have rubella. This is going to be your German or 3A measles. This is a rubella virus that invades the respiratory epithelium. It's transmitted via respiratory droplets, very commonly found also in your unvaccinated patients, and it can sometimes be congenital. What you need to know about rubella is that it's associated with your PDA. It's associated with your patent ductus arteriosus. So that's why a woman that is pregnant and they have a child that has rubella, you want to make sure that you separate them because rubella can cause a lot of congenital abnormalities in an unborn baby in a pregnant woman. So how is the patient going to present? They're going to have symptoms of low fever. They'll have erythematous macular papular rash that starts on the face once again, and it spreads to the body. They're going to have lymphadenopathy. That's another thing that's going to differentiate this from rubeola. Your measles is that they're going to have lymphadenopathy. They're going to have Forchheimer spots, which are going to be rose-colored spots on the soft palate. So we said that for your measles, right, your rubeola, it's going to be on the buccal mucosa. For rubella, it's going to be on the soft palate. So that's another way you can differentiate this. And also with rubella, it's commonly found in older children. These patients can also present with mild pharyngitis, conjunctivitis, anorexia, headache, malaise, polyarthritis. Diagnosis is usually clinical. We're going to confirm it with the serological testing for IgM antibodies, and treatment's going to be usually supportive, right? Hydration, antipyretics, and then prevention with the MMR vaccine. So once again, viral exanthems, just to go through all of them because these are very highly tested. We have erythema infectiosum. This is going to be your fifth disease, right? This is going to be your bright red cheek slapped by parvovirus B19. Hand, foot, mouth disease, commonly found in children under the age of 5. It's caused by what? Coxsackie virus. This patient is going to present with, it starts in the mouth, and then it goes to the palms of the hands and the soles of the feet. They're going to have this bright pink macules and papules that are painful. Measles is going to be your rubeola, okay? Measles, rubeola, usually commonly found in patients that are unvaccinated, right? This is going to have your C's, your cough, coryza, conjunctivitis, and your Koplik spots, which are going to be your spots on the buccal mucosa with these patients. And then vitamin A is usually good for these patients with rubeola. And then this rash is going to start from the forehead, head down, right? It's going to start head, spread down. And then we have roseola, roseola infantum, just how it's called, roseola infantum. This is commonly found in like your younger patients, your infants and toddlers, usually due to human herpes virus 6 and human herpes virus 7. It's going to start with a high fever, and then it's going to develop into a macular papular rose-colored rash. That's going to start where? It's going to start from the trunk, and then it's going to spread out. And then we have rubella, also known as your German or 3-day measles. This one is commonly found in your older children. This patient is going to be presenting with lymphadenopathy, low fever, erythematous macular papular rash, and they'll have Forchheimer spots, which is going to be your rose-colored spots on the soft palate, right? Versus rubeola, it's going to be on the buccal mucosa. All right, guys, so we are done now with dermatology. So why don't we go into our next topic, which is going to be what? Endocrinology. So I'll be honest with you guys, endocrinology is one of those other subjects that I also struggle with. So please let me know if I make any mistakes. So we'll go through it together. So hyperthyroidism. This is usually due to excessive thyroid hormone. You have increased metabolism of T3 and T4 that causes your increased metabolism. Commonly found in females between the ages of 20 to 40. Usually due to like smoking, stress, iodine exposure, and also associated with amiodarone. The most common cause is going to be Graves' disease. This is your autoimmune disorder where antibodies stimulate the TSH receptor that causes overproduction of the thyroid hormone. Second most common cause is going to be your toxic multinodular goiter, which is going to be an expansion of cells due to mutation of the TSH receptor. Okay. Symptoms, usually it's going to be your goiter. This patient's going to be complaining of heat intolerance, fatigue, weakness. They're going to be very thirsty. They're going to have dyspnea, palpitations, weight loss, amenorrhea, low libido, hair loss, hyperreflexia, which means that they're going to have increased deep tendon reflexes. They'll have if they have Graves' disease, which is the most common cause, the symptom's going to be your triad. So it's going to be exophthalmos, literally like their 8 eyes look like they're bulging out of their face. They're going to have lilac, pretibial myxedemia, and then a diffused goiter. Sometimes you'll be able to palpate. The best initial test for this is going to be a TSH level, and then we can also do a T3 and T4. Okay? If they have a low TSH and a high T4, we want to think about primary hyperthyroidism, right? Because that thyroid, so the TSH is going to be low, right? Because that thyroid doesn't need to be stimulated, okay? And the T4 is going to be high, and that's going to be primary. Another test that we can do for Graves is that we can do the radio iodine uptake tests. Usually we'll see a high uptake with diffuse homogeneous. So if you see a test and then it's diffuse, it's throughout the thyroid, we want to think about your Graves' disease. Sometimes it'll just say high uptake with diffuse homogeneous. So that's when you want to think about your Graves' disease. If it says high uptake with nodular distribution, then we want to think about our toxic multinodular goiter. First line treatment with this is going to be methimazole and then PTU, okay? And then PTU usually more commonly used in pregnancy, right? Because methimazole can be toxic. How I memorize it is that meth is toxic to pregnancy. And then if it's severe, like you've tried all this and it's not going away, then we can go in and do a thyroidectomy. And then we have a thyroid storm. This is an emergency, okay? This is a potentially fatal complication of thyroid toxicosis due to hyperthyroidism after a precipitating event. So something happened in the patient, whether they had surgery, they were not being treated for their hyperthyroidism, they had some type of infection, iodine overload, or even amiodarone that moved them from hypothyroidism to like a thyroid storm. Diagnosis is going to be clinical. Basically, in these patients, you cannot measure their TSH. They have increased free T4. And treatment for this is going to be your ABCs, why you protect the airway, breathing, circulation. And we're going to administer the treatments in this order, which you need to know. First line is going to be your beta blocker because we want to make sure that we control that arrhythmia. These patients are going to be tachycardic, so we're going to give them a beta blocker first. Second line is going to be your PTU and methomoxazole. And then third line is going to be our iodine and steroids, like our dexamethasone. So once again, thyroid storm, treat them with a beta blocker. Okay, how I memorize are our P's, propanol. Second line is going to be your PTU or methomoxazole, and then your steroids like prednisone or dexamethasone. Okay. So why don't we go into the complete opposite of having very few thyroid hormones? So we have hypothyroidism. This is failure of the thyroid gland to produce sufficient thyroid hormone to meet the metabolic demands that the body has. It's very commonly found in elderly, specifically more commonly found in females and males, commonly found in patients that are postpartum, so your moms that just had their babies. Hashimoto's is actually the most common cause of hypothyroidism. Also, certain countries are deficient in iodine, very commonly found in those countries also. History of autoimmune disease or family history of thyroid disease. So how is this patient going to present? So they're going to present with weight gain, fatigue, weakness, cold intolerance, constipation. When you do those deep tendon reflexes, they're going to be delayed. They'll have brittle hair and nails, dry skin. They'll have lateral eyebrow hair loss, memory impairment, difficulty concentrating, menorrhagia, also depression, myalgias, coarse facies, bradycardia, so very, very slow heart rate, edema. Sometimes they'll even have a goiter present that you can palpate on your physical exam. They'll be very, very cold, so they'll have cold intolerance, hypothermia, okay? And so I remember for my OSCE, my last OSCE for my PA school, like the last one I just took in October, I had a patient that had hypothyroidism, and that's how she presented. She presented with heavy menstrual periods. She also presented with weight gain, even though she said she exercised a lot. She didn't understand why she was gaining so much weight. Her skin was very dry. Her nails were very brittle. So I made sure I checked her thyroid, try to see if I can feel any goiter. I looked at her skin. I also felt the temperature of her skin, checked for any dryness. And then, of course, you check those tendon reflexes to see if they're fast or slow. So in hypothyroidism, they would be decreased deep tendon reflexes. So what's the best initial test for these patients? You want to do a TSH, okay? And then we can do a T3 and T4, but usually your best initial test is going to be your TSH. So we have different types of hypothyroidism. We have our primary hypothyroidism, and then we have subclinical hypothyroidism and secondary hypothyroidism. So let's go into each one. And this depends on how your TSH and your T4 levels are going to look. So with hypothyroidism, we have low thyroid hormones in the body, right? So that means we're going to have low T4, hypo, low T4. Our TSH, though, is going to be elevated because the TSH is trying to stimulate the thyroid to create more hormones. So that's why it's yelling at it saying, hey, make hormones, but the thyroid is just not answering, right? It's like you keep calling, but no one's picking up on the other end. So that's why your TSH is going to be increased, because it's going to be telling the thyroid to work, but the thyroid is just not creating those hormones. It's not answering the phone call. So you're going to have a low T4. That's primary hypothyroidism. So what if a patient has a high TSH, but they have a normal T4? This is going to be subclinical hypothyroidism. This is very, very highly tested, so make sure that you are familiar with this. What if you have a high TSH and then you also have a high T4? You want to think about secondary hypothyroidism. What if you have a low or normal TSH and then a low T4? You want to think about secondary, tertiary, or sick euthyroid syndrome. Okay? So treatment for this is usually going to be lifelong hormone therapy, with which one it's going to be levothyroxine. Once again, treatment for hypothyroidism is going to be your levothyroxine. It's really important that you also treat patients that are pregnant with that have hypothyroidism. It's really important that you treat these patients, these pregnant women, because the baby can come out with a lot of abnormalities. So if the woman is pregnant, we want to make sure that we increase their levothyroxine to 9 doses a week, and we monitor their TSH also levels. Okay? Usually we monitor the TSH levels in 6 weeks. So once again, hypothyroidism, the most common one you're going to get tested on. You can have a high TSH, you can have a low T4. The best initial test is going to be your TSH levels, and then treatment is going to be with your lifelong hormone therapy, which is going to be your levothyroxine. So let's go into mixed edema crisis or coma. This is an extreme form of hypothyroidism. So remember how we discussed that we have hyperthyroidism and then we have thyroid storm, which is an extreme form of hyperthyroidism. Well, this is an extreme form of hypothyroidism, very commonly found in your patients that are just they don't know that they have a hypothyroidism or just not complying with their medications. So the etiology, it's rare, very commonly found once again in your older woman, especially if they have long-standing hypothyroidism, very commonly found in these women, especially during the winter, cold weather, right? Because these patients they get cold very easily because they already have very low thyroid hormones in their body. They're going to be presenting with decreased mentation and hypothermia. They're going to be hypoventilating. They're going to be hypoglycemic. They're going to have hypotension, bradycardia once more. Diagnosis is going to be clinical. So you want to think about a patient that has hypothyroidism with the extreme level, right? These patients are not going to be stable. They're going to be unstable whenever they start describing you the patient. So just not your normal case of hypothyroidism that, I've been getting weighed. It's just going to be a patient that is very, very sick. They're going to have altered mental status. They're going to be hypothermic on exam. Diagnosis is usually clinical. We can do a TSH also and a T4. The TSH, once again, is going to be what? It's going to be high, and then you're going to have your T4 levels are going to be low. Okay? So treatment for these patients, we want to, of course, do our ABCs, right? Because these patients are going to be in chronic conditions, acute conditions. Sorry, not chronic. They're going to be in acute conditions, critical conditions. That's what I meant. So we want to make sure that we secure the airway, right? We do look at breathing, circulation. We want to intubate them if the patient's not responsive. And then we want to treat whatever's underlying or causing this. Sometimes these patients are sick. Sometimes like I said, they just are not complying with their medications. So with these patients, we're going to give them IV levothyroxine and hydrocortisone. It's going to be in stress doses. Once again, IV levothyroxine and hydrocortisone. So why don't we go into thyroiditis? This is going to be an inflammation of the thyroid gland. It's the most common cause is chronic autoimmune thyroiditis like Hashimoto's or chronic lymphocytic. Once again, if it's worldwide or if it's a country that is underserved, you would think about iodine insufficiency for patients with thyroiditis. So Hashimoto's thyroiditis, like we said, Hashimoto's in general is the most common cause of hypothyroidism. Hashimoto's thyroiditis is also very, very commonly found. With Hashimoto's thyroiditis, they have increased TSH levels. This is a type of autoimmune disorder where there is an autoimmune destruction of the thyroid follicles. You have very low T3 and T4 levels. Okay, and then sometimes they'll be presenting with a painless enlarged thyroid gland. So for thyroiditis in general, they're going to have a non-tender goiter. Diagnosis is that we're going to do TPO antibody levels, which are going to be elevated, okay? We're also going to look at their antithyroid globulin, antithyroid peroxidase, which are these autoantibodies, right, against the thyroid gland. And then treatment for this is going to be with levothyroxine, okay? Prognosis is that usually hypothyroidism is usually permanent with these patients with thyroiditis. So next topic is going to be hyperparathyroidism. This is an excess or increased production of your parathyroid hormone. So if we think about the thyroid gland, right, we have the thyroid gland and you have your parathyroid glands that are also on the thyroid, okay? So they are within the thyroid. So hyperparathyroidism is usually where one of these glands is just producing way too much parathyroid hormone. So increased parathyroid hormone is going to cause what? Increased calcium, which is going to lead to hypercalcemia. So usually that's why in these patients that have hyperparathyroidism, they're going to be presenting with your symptoms of hypercalcemia and vice versa. If you have a patient that presents with hypercalcemia, you want to think about maybe they have hyperparathyroidism. You want to make sure that you rule this out, okay? So what is the etiology, okay? The primary etiology, which is the most common cause, is going to be a single parathyroid adenoma that they have that is just going crazy and it's producing all these parathyroid hormone in the body. Also, other thing that can cause hyperparathyroidism is anything that causes parathyroid hyperplasia, whether it's familial, also your MEN syndromes, right? Your multiple endocrine neoplasia, your MEN1 and MEN2A are commonly associated with hyperparathyroidism. Also, if patient has parathyroid carcinoma. How is this patient going to present? Usually they present with symptoms of hypercalcemia. Like I said, sometimes they can present with, they can be asymptomatic. So these patients are more prone to getting kidney stones, right? Because they're producing a lot of calcium in their body. More prone to getting osteoporosis, bone loss, pancreatitis, fractures. They'll have decreased deep tendon reflexes, right? So these symptoms are very similar to hypercalcemia. So remember, we think about hypercalcemia with your moans, groans, thrones, and psychiatric overtones. So groans, it's going to be your abdominal pain. Sometimes they'll have symptoms of GERD. And then we have stones, which are going to be your kidney stones, bones, your bone pain, and then psychiatric overtones. They'll have depression and memory problems for these patients. So how are we going to diagnose these patients? You want to do an electrolyte. We want to look at their electrolytes, right? We want to make sure that we measure their calcium. We measure it twice. If we confirm that the patient has hypercalcemia, then we are going to check their PTH levels. We also want to make sure that we check their phosphate, their creatinine, and also their 25-hydroxyvitamin D levels. And then we're going to see whether it's primary or secondary. So if it's primary, they're going to have increased calcium, they're going to have increased or normal PTH, and they're going to have decreased phosphates. That's if it's primary. So primary is involving the parathyroid itself. That's primary. If it's secondary, that means it's something else is causing it. So usually like a malignancy, they'll have a calcium greater than 13. Other causes can be like thyroid toxicosis, Paget's disease. Treatment for these patients, we want to make sure that we give them fluids, right? Loop diuretics can also help with calcium, okay? We want to make sure that we treat the underlying cause. One thing about hyperparathyroidism and hypercalcemia that you don't want to get confused is that we give diuretics, right? But we do not give thiazides, okay? Thiazides retain calcium. We want to make sure that we give them loop diuretics. This is going to help lose all that calcium that the patient has in their body. So do not make the mistakes. If it tells you what's the best treatment and it says thiazides and loops, it's going to be looped diuretics, okay? Loop diuretics. So furosemide, okay, not your thiazides. And then usually sometimes if it is severe, they might need surgery, so you can do a parathyroidectomy. If you've tried all this and the patient is still having repeated symptoms, they get repeated kidney stones, right? Then you want to think about going in there and surgically removing those parathyroid glands. So let's go into hypocalcemia. Hypocalcemia is low calcium levels in the blood. Okay, what are some of the causes or etiologies of hypocalcemia? Hypoparathyroidism. So hypoparathyroidism. Once again, we're talking about the parathyroid glands that are within the thyroid, okay? Most common cause of hypoparathyroidism is a patient that got their thyroid gland removed, right? Because those parathyroid glands are within the thyroid gland, so you get rid of that thyroid gland, this patient becomes hypocalcemic, okay? So hypoparathyroidism. Other etiologies of hypocalcemia is going to be magnesium deficiency. This is very highly tested, so make sure that you know this. Magnesium is associated with calcium. If the magnesium is low, the calcium is going to be low. I've had questions where to ask you what other electrolyte is going to be low, and they'll have a bunch of them listed. Make sure that you know that's going to be magnesium. Also, vitamin D deficiency. If they have any type of tissue injury, also kidney failure, right? Acute pancreatitis if the patient's septic. If they have blood transfusions, also they can present with hypocalcemia. How is this patient going to present? They're going to have tetany. Why? Because his neurons are going to be more excitable. They're going to have the Shavatsky sign. What's a Shavatsky sign? Shavatsky sign. Oh my gosh, I can't say this. Shavatsky sign. This is going to be the facial twitching. So you'll press it on the cheek and the cheek is going to twitch. I've never seen this in life, but Shavatsky signs is very highly tested. Sometimes I'll have a question and they'll say that they did that, and you need to know that's the Shavatsky sign. Also the Trousseau sign, that's where you put a blood pressure cuff and it causes like flexion of the hand. So it's going to be the Trousseau sign. Once again, these are signs of hypocalcemia. They're going to be presenting with muscle cramps, abdominal pain. They'll have perioral tingling and seizures. And this is another thing that's highly tested. Make sure you know this. On EKG, what are you going to see? You're going to see a prolonged QT interval. You can also see torsades and AFib. Once again, prolonged QT interval. That's what you're going to see on your EKG for hypocalcemia. How are you going to diagnose this? You're going to look at their calcium. They're going to have a low calcium. They're going to have low vitamin D. You want to check their albumin also. Check their parathyroid hormone to just make sure that the parathyroid gland is working and it's not related to the parathyroid gland itself, that it's not working. So that's why this patient is hypocalcemic, okay? And if you check the phosphorus and the calcium and they are both down, then you want to think about a problem with your vitamin D, okay? If there is an increase, for example, a decrease in calcium and an increase in phosphorus, you want to think a problem with possibly the parathyroid hormone. So treatment for these patients is going to be with calcium gluconate and vitamin D supplement. And if it's due to hypoparathyroidism, then we're going to give them IV or oral calcium plus oral vitamin D. Okay? So next one is primary adrenal insufficiency, also known as Addison's disease. This is a deficiency of aldosterone, cortisol, and androgens. It involves the zona fasciculata, so it involves the adrenal cortex. It's highly tested. Make sure you know this. Once again, Addison's involves the adrenal cortex. It's a deficiency of the aldosterone, cortisol, and androgens. So what are some of the causes of this? So the most common cause worldwide is tuberculosis, but the most common cause here in the States is going to be your autoimmune adrenalitis, your Addison's, right? So the most common cause is going to be autoimmune. Once again, this is highly tested. The most common cause of primary adrenal insufficiency worldwide is going to be tuberculosis, but here in the US, it's going to be an autoimmune adrenalitis. Other causes of adrenal insufficiency, secondary most common cause is going to be your glucocorticoid use, or if there is any type of trauma also. How is this patient going to present? So this patient is going to present with hyperpigmentation. It's going to be a patient that was fine, and the next day they look like they had a sunburn. They're going to be hyperpigmentation of the skin and mucosa membranes. Also, these patients are going to be craving a lot of salty food. So these patients, you go to the restaurant and they're just going to be pouring salt on their food. Okay, so they're going to be craving salty food. And these patients are also going to be, usually they are going to be very skinny. They're going to have fatigue, dizziness, confusion, fever, nausea, vomiting, diarrhea, and abdominal pain. How are you going to diagnose this patient? We want to make sure we do a BMP and we do a morning serum cortisol level. Okay, morning serum cortisol level. And then we can do also a cosentypin stimulation test. And then if needed, we can do CT of the adrenal glands and pituitary MRI. Another thing you need to know about these patients is how are their labs going to be. These patients are going to have hyponatremia, they're going to have hyperkalemia, and they're going to be metabolic acidotic. So once again, they're going to have hyperkalemia, hyponatremia, and they're going to be metabolic acidotic. Why? Because they have less aldosterone than you and me. They're also going to have low blood glucose. Why? Because they have less cortisol. Treatment for this is going to be steroid replacement with hydrocortisone and fludrocortisone. Once again, most common cause of primary adrenal insufficiency is going to be an autoimmune destruction of the adrenal gland. It's going to involve what? The adrenal cortex, we said. These patients are going to be presenting with hyperpigmentation. They're going to have also cravings for very, very salty food. We want to diagnose them by doing AM serum cortisol level. And then if needed, we're going to do a co-centropic stimulation test, okay, where we give synthetic ACTH, and then we can do a CT of the adrenals and the pituitary, because we want to see whether it's the adrenals that are affected or if it's something going on in the pituitary gland that the adrenals are just not responding to, are not responding. Okay, and treatment's going to be your steroid replacement. Once again, your labs are going to have hyperkalemia, you're going to have hyponatremia, you're going to have metabolic acidosis. So next one is going to be acute adrenal insufficiency, also known as Addisonian crisis. So this is going to be Addison's disease, but extreme. It's just going to be very extreme. It's usually due to some type of major stress, injury, surgery, or infection that the patient has that causes and throws them into adrenal insufficiency. They're going to be presenting with sudden fever, abdominal pain, vomiting, and diarrhea. They're going to be extremely dehydrated when you see them. They're going to have low blood pressure. They'll be in cardiovascular shock. They'll have syncopal episodes. And with these patients, this is an emergency. We want to make sure that we treat these patients with hydrocortisone. It's going to be in stress doses. And then, of course, any type of supportive treatment, like giving them fluids if needed. Because once again, this is an emergency. So Cushing's syndrome is going to be the next one. This involves the zona fasciculata of the adrenal cortex. This is due to elevated cortisol levels in the blood. Okay. The thing about Cushing's syndrome is that you want to know what's the difference between Cushing's disease and Cushing's syndrome. So Cushing's syndrome means that it has multiple origins. Disease, it's due to a pituitary adenoma. So what are the etiologies of what are the etiologies of Cushing's syndrome? The most common cause is going to be exogenous corticosteroids. So it's going to be outside medications that increase the cortisol levels in the body. So it's going to be a patient on a chronic dose of corticosteroids. Also, adenoma of the pituitary is another cause of your Cushing's syndrome. Signs and symptoms, this patient is going to present usually with your moon faces. So it's going to be that round face. They'll be presenting with hypertension, weight gain, abdominal striae, which is like, it looks like stretch marks on the abdominal area. Usually they're color purple. They'll have truncal obesity. They'll have that buffalo hump also, hyperglycemia, insulin resistant osteoporosis, amenorrhea, depression, easy bruising, and poor wound healing. I remember when I was doing my rotation with my nephrologist, he was telling me that one of his sisters got COVID. And she was in the ICU for a while fighting COVID, and she was giving so many doses of steroids and high dose steroids. She said by the time, thankfully she survived and she's fine, but he said that by the time she was out, she had Cushing's syndrome, that she had like the moon faces, she had the buffalo hump. So yeah, this is the most common cause is exogenous corticosteroids for Cushing's syndrome. These patients are also going to be presenting with hyperglycemia or insulin resistance, osteoporosis, amenorrhea, depression, easy bruising, poor wound healing. So I actually had a question on this the other day, and it said the patient also had acne, and I actually ended up picking PCOS, but it ended up being Cushing's syndrome. She had the moon faces, she had the amenorrhea, so I confused it. So just make sure that you read the question correctly and look at the symptoms. So this patient had the moon faces, and I completely jumped straight to the PCOS, so they can present very similar. So diagnosis, we want to make sure we do a 1 milligram overnight dexamethasone suppression test. We're going to do a 24-hour urine cortisol and then a late night salivary cortisol. We want to make sure that we check the ACTH for the source. Treatment is always going to be removal of the cause. So we said the most common cause is going to be exogenous corticosteroids. We want to make sure that we don't stop Turkey with the corticosteroids. We can't just cut off the patient from steroids because there's a lot of consequences if we do, right? We want to make sure that we taper off slowly the steroids, but we want to make sure that we do remove whatever is causing it. Because what happens if we all of a sudden just cut the patient off steroids? It can go into adrenal crisis. So that's why I'm going to make sure that we are tapering off these patients. So if the cause of Cushing's syndrome is a pituitary tumor, then we are going to go in there and do surgery, right? Other things that can cause Cushing's syndrome is lung cancer. What type of lung cancer? The small cell lung cancer is the most common one that causes Cushing's syndrome. So you want to think about that also in the back of our mind if we have a patient that presents with Cushing's syndrome and they're a smoker, for example. So of course, surgical resection is going to be the treatment for this. And if it's unresectable, then we want to make sure that we manage them medically. Okay, so next one's going to be we're going to go into our diabetes. So we have type 1 and then we have type 2. So let's go into type 1. So type 1, this is where the body is not making enough insulin, okay? Out of the diabetes, about 10%, you can correct me if I'm wrong, different textbooks, say different things, but about 10% of the diabetics are type 1 diabetics. And this is because the body does not make insulin, just doesn't make insulin, okay? That's how you differentiate between type 2 and type 1. It does not make insulin for type 1. Usually in type 1 diabetics, these patients are diagnosed as children. Although I can't say this anymore due to now we're diagnosing more children with type 2 diabetes, but usually type 1 is diagnosed at a younger age, okay? And for type 1, it's a type of 4 hypersensitivity response where the body's own T cells are attacking the pancreas and basically destroy all those beta cells in the body. So this is going to be an autoimmune disorder, like we said. It's loss of self-tolerance of the T cells, and there's pancreatic islet beta cell destruction. So insulin is just absent in the blood. Once again, no insulin in the body. So very commonly in children and young adults, like I said, but it can occur at any age. Now, sometimes you have adults being diagnosed with type 1 diabetes. They never knew they had it. This is usually genetic, and it involves HLA-DQ, HLA-D3, DR3, and then HLA-DR4. I don't think I've ever been tested on this, but just make sure that you know it on the back of your mind. So, signs and symptoms, how these patients are going to present. They're going to have polyphagia. They're going to be eating so much and they're not gaining weight. They're going to have glycosuria. They're going to have polyuria, so they're going to be going to the restroom a lot. They're going to be very thirsty, so they have polydipsia. Why are they so thirsty? It's because they are urinating so much, right? And this causes dehydration. They'll have weight loss, like I said. They'll have ketonatremia and ketouria. Also, diagnosis for these patients is a hemoglobin A1C greater than 6.5, a fasting glucose greater than 126, and or a random glucose greater than 200. And then an oral glucose tolerance test after 2 hours that is greater than 200. And these patients are usually going to have an absent C peptide. Make sure you know the diagnosis. This is very highly tested. So once again, I'll go over it. A hemoglobin A1C greater than 6.5, a fasting glucose that's going to be greater than 126, a random glucose that's going to be greater than 200, and then an oral glucose tolerance test after 2 hours that's greater than 200. So treatment for these patients is going to be lifelong insulin therapy. You're going to do a combo of rapid and long-acting insulin. Make sure that you are familiar with your types of insulin also. This is very, very highly tested. So you're going to give them a rapid one and then a long-acting one. So the one I work in the hospital, the very common long-acting one that we see is Lantus, which is also known as your insulin glargine. That's the one that we give patient QHS. So we give them before they go to sleep, so it works overnight. And then we also give them just like a regular insulin. So you're going to give them, once again, a rapid and then a long-acting insulin. And then we want to make sure that the patient's checking their blood sugar they're exercising and dieting. Other things that you need to know is going to be your dawn phenomenon and your Somoji effect. These are very, very highly tested, and to be honest with you, I still confuse them. So dawn phenomenon is hyperglycemia between 3 a.m. and 8 a.m. And the Somoji effect is going to be nocturnal hypoglycemia at 3 a.m. that leads to a surge of counter-regulatory hormones that causes high glucose levels by 7 a.m. So let's go over them for my sake, right? And your sake also. Dawn phenomenon is going to be hyperglycemia between 3 a.m. and 8 a.m. So the patient's going to wake up like at 8 a.m. They're going to have hyperglycemia. The Somoji effect is going to be your nocturnal hypoglycemia at 3 a.m. This is going to lead to a surge of counter-regulatory hormones, so they'll have high glucose levels by 7 a.m. Okay? So now let's go into diabetic ketoacidosis, DKA. So DKA is very commonly found in your type 1 diabetics, although type 2 diabetics can also get DKA. It's more commonly found in your type 1 diabetics. So DKA, it's basically what happens is that cells need energy, right? So they start using ketone bodies to get that energy. This, in return, causes an increase in the acidity of the blood, and this is an emergency. So what are some of the etiology of the causes of DKA? So triggers are going to be like infection, infarction if the patient had any type of heart attack, ischemia, intrauterine pregnancy, idiopathic sometimes can cause this. How is this patient going to present? Symptoms similar to diabetes. So they're going to have polyuria, polydipsia, polyphagia with fatigue, nausea and vomiting, dehydration. They'll have abdominal pain. They'll have loss of consciousness, dry skin, fruity breath. I've yet to smell this fruity breath. Why? Because it's due to ketone body acetone. They'll have these Kussmaul respirations, which are deep labored breathing. They'll have reduced carbon dioxide. They'll have reduced acidity because of the DKA. So just a quick case about DKA. I had a patient that came in last week. He was a diabetic, type 1 diabetic, did not go to the doctor. So when he came in, his glucose level was like 600 and something when he came in. And the reason why we were seeing him is because he lost consciousness. He passed out, went into DKA, and he passed out on top of his heater. So he had all these like burns all over his like abdominal and anterior torso. And so that's why he came to us. So that's just an example of how DKA can cause this loss of consciousness so bad that this patient was burning himself. He had like full thickness burns and deep partial thickness burns to his like anterior torso. He was burned about 20% or more of his body. And it was, I said, this is severe. So of course he came in, emergency. We had to make sure that we had the DKA under control, and then also make sure that we were treating the burns at the same time. So how are we going to diagnose this? We'll do UA. We're going to see that ketones are going to be present in the urine. They'll have a blood glucose range between 200 and 600. So that's another way that you can differentiate these patients between your DKA and HHS. So DKA is more commonly found in your type 1 diabetics. HHS is going to be more commonly found in your type 2 diabetics. With glucose levels are a lot higher in your HHS patients. Usually it can be 800, 900. It's very, very high versus your DKA patients. The blood glucose levels are not that high. Like I said, 200 to 600. The patient that we had, I think he was like 6'10 or 6'11. The patient that we had that came in with DKA, and he was like unconscious. So that's another way that you can differentiate between DKA and HHS. Also with DKA, they're going to have ketones present. HHS does not have that. So once again, with DKA, they're going to have also metabolic acidosis. They're going to have low serum bicarb and serum sodium. That's going to be low also. The serum is going to be positive for ketones, and the potassium is going to be increased. But their total body potassium is going to be decreased. So their serum potassium is going to be increased, but their total body potassium is going to be decreased. So this is why they say that this is like pseudo hyperkalemia. So treatment for these patients, since they're very, very dehydrated, we want to make sure that we first correct their dehydration. So we want to make sure that we first give them IV fluids. This is very highly tested, so make sure that you know this. Once again, first thing you're going to do is you're going to give them IV fluids. Another thing you're going to do is give them insulin, and then after you give them insulin, you check the potassium level, and then you can correct the potassium level if needed, because sometimes the potassium level can be falsely low or falsely elevated. So make sure that before you correct the potassium, you're going to give them IV hydration. You want to make sure that you rehydrate these patients, because these patients are going to be dehydrated. These patients are usually vomiting, okay? They're urinating a lot, so they're very, very dehydrated. So you're going to hydrate them first, give them IV fluids. Then we're going to give them insulin. And then once you give them insulin, then that's when you're going to check the potassium levels and see if you need to either replete that potassium or not, okay? So if you need to replace them, they're going to replace the potassium, because like we said, there's certain potassium is going to be increased, but their total body potassium is going to be decreased. Okay, so now let's go into our type 2 diabetics. This is the most common type of type 2 diabetes. And now with the years that we keep going, I feel like every year we get more and more patients that are diabetic. Of course, there's multiple causes. Diet, definitely exercise. The Valley where I went to school in, where I go to University of Texas, Rio Grande Valley, we have a lot of diabetics there. Everyone, a lot of patients, we have diabetic. We would have a patient, it would be like generations, the grandmother, the mother, the child. Even when I was doing my pediatrics rotation, you would see these like 11-year-olds with type 2 diabetes. So very, very commonly found. 90% of patients have type 2 diabetes. So what happens in type 2 diabetes? What is a patho? So in comparison to type 1, where the body does not make insulin, in type 2, the body does make insulin in these patients. But what happens is that the tissues are just not responding to the insulin, okay? So there's insulin resistance. There's B cell function that is just impaired. It's not working, and this causes increased insulin resistance. So what are some of the etiologies for this? Of course, the number one cause is going to be your obesity. So obesity, usually patients, so I've read different textbooks and they say it's very commonly found type 2 diabetics and diagnosed in patients that are older than 40, but now I don't think that's the case now. We diagnose it in patients older than 30. Even if in their 20s, we diagnose type 2 diabetes. But textbook-wise, commonly found in patients that are older than 40, patients that do not exercise, hypertension, if they have just genetics, if like their mother has diabetes, if their grandmother has a history of diabetes. And then polycystic ovarian syndrome is also commonly associated with type 2 diabetes. How is this patient going to present? They're going to have hyperglycemia. They're going to have polyphagia, so they're going to be very, very hungry. They're going to have a glycosuria, polyuria, and polydipsia. They're going to be urinating a lot. They're going to be very, very thirsty. And then also a big one that's a sign of diabetes is going to be your acanthosis nigricans. So it's going to be that velvety, like dark plaque that you can usually see it in the back of the neck. You can also see it like underneath the armpits and also in your inguinal folds. So it's like this velvety, like dark plaque that you can see on these patients. And that's what we would see a lot during my pediatrics rotation in these children that we would have that were obese. And my pediatrician would sit down and have a serious conversation with the patient and also the patient's parents and tell them how important their diet is, how important to make sure that they're not eating those hot Cheetos, all that food, and to make sure that they are bettering their diet, because diabetes is a very, very preventable disease. On top of that, if a patient has diabetes, they are able to, type 2 diabetes, they are able to treat themselves if they maintain a good diet and they have a good exercise program and they lose weight. They can basically, that's a treatment for their diabetes. Also for your patients that are pre-diabetic, same thing. So it's very, very important that we instruct these patients on that. It's a very, very preventable disease. So how are we going to diagnose this? Once again, hemoglobin A1C greater than 6.5. My family doctor described this very, very good to one of his patients. And it's stuck in my head ever since then of what is a hemoglobin A1C. And how he explained it, which I thought was marvelous, and this is why I'm sharing it with you guys. He explained it like a bowl of cereal. So you have a bowl of cereal and you have cornflakes, right? Your regular cornflakes. What a hemoglobin A1C does is that it checks how many of those cornflakes are frosted. So how many of those cornflakes are covered with sugar. And that's what a hemoglobin A1C is. And I thought that was just it was just amazing. So hemoglobin A1C, think about a bowl of cornflakes, regular cornflakes, unsweetened, and what you're checking is to see how many of those cornflakes, so the cornflakes are your red blood cells. How many of those cornflakes, those red blood cells, are covered in sugar? So how many of those are sweet, right? So that's what your hemoglobin A1C is. So a hemoglobin A1C level that is greater than 6.5% is usually a diagnostic of type 2 diabetes. Other things, it's going to be a fasting glucose greater than 126, a random glucose greater than 200, oral glucose tolerance test after 2 hours greater than 200, and then also they're going to have an elevated C-peptide, right? Versus type 1 diabetics, they have an absent C-peptide. Make sure you know that. This is also very highly tested. And then, of course, the patient has to be having symptoms of diabetes. So they're going to have that polydipsia, that polyuria. You can see the acanthosis nigricans. So these are diagnostic tests for your diabetics. What's going to be the treatment plan for these patients? The first thing we're going to do is educate them on their diet and lifestyle. So before my doctor would put these patients on, of course, unless they were severely diabetic, like if they have a hemoglobin of like 12 or 11, then he would start them on medical treatment. But if it was slightly elevated, he would sit down and educate them on their diet and their lifestyle. So diet and lifestyle is going to be your first line treatment. This is very highly tested. So if it asks you what's the first line treatment and the patient is like their hemoglobin level is not that high, you want to do diet and lifestyle. Then say that the patient has done that and they return and their glucose level is still high, their hemoglobin level is still high, then we're going to give them oral medications. So first thing we're going to give them is metformin. So metformin we're going to give. That's going to be the first line. You want to make sure that we stay away from insulin. There's so many other type of medications that you can give before you go into insulin. You have your new drug classes of medications, like your DPP-4 inhibitors. You have so many, but just make sure that you know that metformin is going to be your first line oral medication. It's very affordable with these patients and it helps them lose weight. So just make sure that you know that. And then that you educate the patient that they're checking their sugar daily to make sure that these patients are not becoming hypoglycemic. So hypoglycemia is anything less than 70. And then, of course, give them an ACE inhibitor because diabetics usually tend to ruin their kidneys. How I explained it to a patient, and when I explained it to them, the importance of why they need to adhere to their medications, because I would get a lot of diabetics during my rotations in the Valley that they were diagnosed as diabetic, they had the medications at home, but they just didn't take them. Metformin causes a lot of side effects. It causes, sometimes they get nauseous, and I can say that speaking from experience because I got diagnosed with prediabetes. I had a fasting blood glucose of 124, very closely to 126, right? It freaked me out. And I don't have, my parents are fine. They have no family history of diabetes, but my grandparents do. And I feel like I take care of myself. I feel like I can't say I eat well, but I feel like I exercise. And I was just in shock when they told me. So they prescribed me metformin. And I remember taking it and it was the worst thing ever. I had the worst side effects. I got really nauseous, I got really dizzy, so I can understand why these patients don't want to take metformin. So it's really important that you instruct them on the importance of taking metformin because, or abiding to their medications. It doesn't have to be metformin, whether you're prescribing them a DPP-4 inhibitor or an SGL2 inhibitor, regardless, they have to be compliant with their medications, because how I explain it to these patients is that diabetes is kind of like gasoline running through your body, and your kidneys are having to filter all that. Can you imagine? The kidneys are going to get tired after a while. So this is why it's very common that that diabetics develop kidney problems, chronic kidney disease. So that's why we want to make sure that with these patients also we give them an ACE inhibitor, because ACE inhibitors are kidney safe, right? So next one, we're going to go into ketotic hyperglycemia, or HHS. I know I briefly discussed this, but let's go into it more detail. So HHS is commonly found in your type 2 diabetics, right? HHS is more deadlier than DKA. And the reason why I say that, and I'm quoting a podcast that I listened to and in several videos and doctors that I've spoken to, correct me if I'm wrong, but HHS is more deadlier than DKA. The reason why is because your type 2 diabetics tend to have more comorbidities than your type 1. Type 1 diabetics are usually your young patients, right? Like we discussed, they're pretty healthy, they just have type 1 diabetes. Versus your type 2 diabetics, these patients are usually obese. They have other comorbidities like cardiovascular disease, hypertension, and then on top of that, they have diabetes. And when they go into HHS, it just puts them over. So that's why it's more deadly in your diabetics. And then HHS, like I said, more commonly found in type 2 diabetics, right? What happens is that you have these patients become dehydrated, right? And they have a hyperglycemic state. They have increased plasma osmolarity that's due to extreme dehydration. These patients are going to be presenting with polydipsia, polyuria, altered mental status, neurological abnormalities. But like I said, they are not really going to have ketosis. They can have little, but not ketosis too much. Versus your DKA, they are going to have ketosis. They're going to have those ketones, the ketonuria, so those ketones in the urine. Versus HHS, they will not have any. Or if they do, they have very, very little. And like I said, for their blood glucose, it's going to be a lot higher compared to your DKA. That's how you can differentiate between HHS and DKA, because usually in the question stem, it won't tell you the questions I've had that the patient has a history of type 1 or type 2. It'll just describe the symptoms and you're like, oh, you know what? This sounds like DKA, but I don't know. Just look for the ketones that are present. Okay, if it is, and that's pointing you towards your DKA. Also, make sure you look at the blood glucose level. We said that it usually ranges between what for DKA? We said that it's a lot lower. It's 200 to 600 versus your HHS, it's a lot higher. So your HHS, these patients are going to have a blood glucose of 600 to 2400. So it's going to be in the thousands. It's going to be a lot higher in these patients. So once again, no ketones. They're going to have a high BUN. Why? Because they're going to be very dehydrated. They're not going to have any acidosis. They're going to be hyponatremic. They'll have pre-renal azotemia with serum urea nitrogen that's elevated over 100. Treatment for this is going to be fluids, insulin if needed, and then potassium. So it's going to be very, very similar to your DKA. We're going to give them fluids, right, because these patients are dehydrated. Then we're going to give them insulin, and if we need to, we check their potassium, right? Then we can correct the potassium. But usually it's supportive measures, and these patients always get admitted. So next one is going to be our diabetes insipidus. This is a large volume of dilute urine that's greater than 3 liters per day. It's due to why? Because these patients have low antidiuretic hormone or vasopressin. They have low plasma osmolality and they have high serum osmolality. Make sure you know that this is very highly tested. Once again, low plasma osmolality and high serum osmolality. What are some of the etiologies of this? So we have different causes. We have central diabetes insipidus, and then we have nephrogenic diabetes insipidus. So central diabetes insipidus, how it sounds, involves the brain, right? So central diabetes insipidus is due to decrease in the release of the antidiuretic hormone. So up here, it's not working. It's not sending that antidiuretic hormone for the kidneys to respond to. Usually due to head trauma, neurosurgery, tumors, ischemia, infiltrative disease. Sometimes it can be idiopathic. So I'll give you an example of this. I had a patient 2 weeks ago that came into us because he was involved in a motor vehicle accident where he was ejected about 20 feet from his vehicle and he skid onto the floor. So that's why he came to us, because he had multiple friction burns and he had an epidural hematoma. So he came in, he was seen in the ICU, he was there for several weeks, and then he was transferred to us. And so we had him with us, and this patient was like urinating himself, and he was very embarrassed about it, but he said that he wasn't doing it on purpose. He kept urinating himself. He was very, very thirsty. And then he ended up having diabetes insipidus. So this is commonly associated, like I said, with the head trauma. And then you have your nephrogenic causes. So this is going to involve the kidneys. This is because the kidneys are just not responding to the antidiuretic hormone. So they're resistant to the antidiuretic hormone. It's like I said earlier, it's like the brain is calling, but there's no one there that's answering. So brain's working, but the kidneys are just not answering. That's why it's nephrogenic. Other causes of this is going to be lithium. Lithium is very commonly associated with your nephrogenic diabetes insipidus. How is this patient going to present? They're going to have polyuria, polydipsia. They're going to have increased urinary frequency. They'll have nocturia. They're going to have cravings for water and cold liquids. The best initial test for these patients is going to be a water deprivation test. And you're going to see that these patients are going to be unable to concentrate their urine. We can also give them a desmopressin challenge test. It's going to help us differentiate to see whether it's a central cause or a nephrogenic cause. So it's whether it's involving the brain or the kidneys. So if we do that and we see that there is concentration, then we want to think that there's a central cause, right? Because that means that the kidneys are responding, but there's just no production of anything. So with these patients, what are we going to do next? We're going to do an MRI of the pituitary gland, okay? So that means, like I said, we have decreased secretion of the ADH, but the kidneys are working. So what if we do this desmopressin challenge test and we don't see that there is a concentration? This is going to be a nephrogenic cause, right? Because that means that the kidneys are the ones who are just like not answering. There's normal secretion, so the brain is secreting, but the kidneys are just not answering the phone, right? They're not there, they're not working. So they have decreased action. So treatment for this, if it's central, we want to make sure that we treat the underlying lesion and also give them IV or oral vasopressin or desmopressin. Nephrogenic cause, we want to make sure we treat the underlying cause. If it's lithium, right, we're going to make sure that we discontinue it. We can also give them thiazide diuretics for nephrogenic causes, your amyloride, endomethacin, and then sodium restriction also. So now let's go into SIADH, which is going to be your syndrome of inappropriate antidiuretic hormone. So it's going to be the opposite of diabetes insipidus. So with diabetes insipidus, we have a low ADH. With this one, we have high ADH. How I think about it is syndrome of high antidiuretic hormone. Is that these patients have an increase in antidiuretic hormone production. They have an increased sensitivity to antidiuretic hormone. So what is the etiology of this? It's usually due to paraneoplastic syndrome, things like your small cell carcinoma of the lung, and then that causes your ectopic antidiuretic hormone. Other causes are stroke, tumors, trauma, infections. Certain medications like NSAIDs or narcotics can cause your SIADH. How's this patient going to present? They're going to be presenting with altered mental status. Why? Because they have usually cerebral edema. They'll have headaches. They'll be lethargic. They'll have seizures. They'll be disoriented. They'll be euvolemic. Diagnosis is going to be, usually we want to make sure that we look at their sodium levels. They're going to be hyponatremic, and they're going to have increased urine osmolality. Treatment is going to be fluid restriction, and then medication-wise, we can give them something like democlocycline. We can also give him something like tolvaptan, and then also consider hypertonic saline. We can also give him normal saline and diuretics like Lasix. So let's go into our secondary hypertension. So secondary hypertension. So we discussed that there's different types of hypertension, right? Primary and secondary hypertension. So the most common cause of primary hypertension is idiopathic. Usually they believe it's due to the diet that the patient's taking. They're probably taking too much salt. But then we have secondary hypertension where something else is causing the hypertension, like your adrenals and your kidneys. So in these patients, we want to make sure that we check the patient's adrenals and kidneys. We want to make sure that some of the common causes of your secondary hypertension is going to be things like primary aldosteronism, pheochromocytoma, Cushing's, hyperparathyroidism, and hypoparathyroidism also. So I included this because this was something I got tested in. So just make sure that you know that. So let's go into tremors. What are tremors? Tremors are rhythmic, involuntary, oscillatory movement of the body parts. It's the most common type of movement disorder. And there's different types. There's either your rest tremor, so you're resting and you're trembling, right? Or you have your action tremor when you're about to pick up something and after you're picking it up, you start trembling. So rest tremor is going to be the affected body part is completely supported against gravity. It's present at rest and it's diminished with purposeful movement. Versus your action tremor, it's going to be a voluntary muscle contraction and it's categorized into symmetrical and asymmetrical. It gets worse with movement. And then you have your physiological tremor, like fear, if you're anxious. This happens to me every time during rounds in the morning. So in the rotation where I'm at, we do rounds every morning, and I'm always trembling because I'm so nervous when I have to present the patient I'm taking care of and to explain the reason why I'm treating them and the reason why I am diagnosing them. So other causes of physiological tremors can be fatigue, hypoglycemia, hyperthyroidism, and then your alcohol withdrawal. And then you have your essential tremors. This is a very common one. It's also a very common one that is tested. So make sure that you know this. So it's going to be your essential tremors. It's very common, like I said. It progresses with age, and sometimes it can turn into a sustained disability. So it tends to commonly affect the hands. It can affect the head also. So they'll have like this yes, yes sign or no, no. They're going like this all the time. It can affect the jaw. Sometimes it can also affect the voice. Usually these patients that have essential tremors, they're going to say somewhere in the question stem that the patient has a history, family history of this, like their mom has it, or they have a genetic history of this. Treatment for these patients is first line, we want to make sure that we give them a beta blocker like propranolol. We can also give them primidone. Second line treatment, it's going to be your benzodiazepines, gabapentin, topiramate. And then it's severe, then you're going to do surgical intervention. So once again, treatment first line is going to be your propranolol and your primidone. So what are other types of tremors? Other types of tremors, we have your cerebellar tremor. This is going to be an intention tremor, right? It increases as the limb moves closer to the target and it has a large amplitude. You have your dystonic tremor. This is usually associated with dystonia. And it's a sustained abnormal posture. It can improve by touching the affected region. And then you have your orthostatic. It's limited to the legs and trunk, and it occurs only when the patient is standing. So these are your tremors. The highly tested one is going to be your essential one. So make sure you are familiar with this one, right? This one affects the hands and the head. It's bilateral, commonly found in the hands, and it's worse and it's induced with activity. Another thing about this essential tremor that you need to know is that it decreases with alcohol and it's worse with caffeine. So these patients can actually auto-medicate themselves with alcohol, and they have like a distorted handwriting also. And like I said, treatment's going to be with your propranolol and your primidone. Usually it's just propranolol. All right, guys, so we have finished endocrinology. So why don't we go into OB-GYN, which is going to be the next topic. Okay, so OB-GYN. So it's going to intrauterine pregnancy. Intrauterine pregnancy. What you need to know about this is the types of abortions that exist. So you need to know and differentiate how they're going to present on your physical exam. Okay, so real quick, let's just discuss the normal pregnancy before we get into these abnormal pregnancies. So in normal pregnancy, what's going to happen with the blood volume? That's the blood volume is going to increase. Your cardiac output is going to increase and your tidal volume is going to increase. What's going to decrease, it's going to be your functional residual capacity. The patient's systemic vascular resistance is also going to decrease. And also on the third trimester, it's normal for the patient to develop respiratory alkalosis, right? They're breathing a lot more because they have a lot of pressure. They have a big baby in there. Usually at 10 weeks, you should be able to hear the heart tone using a Doppler. And then the heart rate will increase about 10 to 15 beats per minute for the mother. The blood pressure will decrease in the second trimester for the mom, and it normalizes in the third trimester. Another thing that you need to know is that in a normal pregnancy, the serum beta HCG doubles every 2 days in early pregnancy. If it's not doing that, you want to think about an abnormality. So it has to double the serum HCG every 2 days. Another thing that's highly tested is the fundal height. So fundal height. At 12 weeks, it's going to be in the pubic symphysis. At 20 weeks, it's going to be at the umbilicus. And then at 20 to 32 weeks, how are you going to measure it? It's going to measure the height in centimeters above the symphysis, and this is usually going to give you the gestational age in weeks of the baby. Another thing that you need to know is that with a transvaginal ultrasound, you can, it's usually, an intrauterine pregnancy is visualized usually when the beta HCG is greater than 1500. If it's less than that, we can't visualize it with a transvaginal ultrasound. Now, in intrauterine pregnancy, it's visualized on a transabdominal ultrasound if the beta HCG is greater than 4,000. So just make sure that you have this in the back of the mind, because sometimes on these questions, it'll be less than these numbers, and just know you won't be able to visualize them with an ultrasound, right? Because the beta HCG needs to be greater than 1,500, for example, for a transvaginal ultrasound. And then we said transabdominal, an intrauterine pregnancy can be visualized only when the beta HCG is greater than 4,000. Okay. Another thing that I wanted to go over is basically what do you test at each trimester? One that I'm going to go over that's very, very highly tested is when do you, for these patients, do a glucose challenge test? It's going to be between 24 to 28 weeks. This is where we check for gestational diabetes for these patients. And then we screen for group B strep at 35 to 37 weeks. And if the patient is greater than 41 weeks pregnant, then we're going to offer induction of labor for these patients. Those are the ones that are very highly tested. Another one also is going to be your quadruple marker serum testing or your amniocentesis. When you do this, usually between 15 to 22 weeks. For these patients, so it'll be in the second trimester. But yeah, these are usually the ones that are very highly tested. Okay, so let's go into the abortion classification. You are definitely going to have a question on your exam for this. So like I said, make sure that you're familiar with these. How I memorize it is TIIC, and then I'll go through each one. That's how I memorize it. Another way I memorize it is the eyes open in regards to how the cervical ox is going to look. So anything that starts with an I, the cervical ox is going, cervical ox. The cervical os is going to be open. So when you do that vaginal exam, that pelvic exam, you're going to see that os, right? You're going to see that cervix, the os, whether it's going to be open or closed. And that's how you're going to be able to differentiate between these type of abortions on the question stem. And it has to give it to you whether it's closed or open, and whether there's presence of fetal tissue or not, and whether the mommy is bleeding or not, the woman. So let's go through them. Threatened. This is going to be abdominal pain or bleeding in the first 20 weeks of gestation, and the cervical os is going to be closed. There is not going to be any passage of fetal tissue. Okay? That's how I memorize it in this order. So we have T, and then we have I. Inevitable. This is going to be abdominal pain or bleeding in the first 20 weeks of gestation, and the cervical os is going to be open, right? Because the eye's open. But this patient is not going to have no passage of fetal tissue. Let's go into the next eye. Incomplete. Eyes open, right? The cervical os is going to be open. The patient is going to be presenting with abdominal pain or bleeding in the first 20 weeks of gestation. And Passage of fetal tissue, yes, you're going to see passage of fetal tissue. You'll see some products of conception that still remain in the uterus. Then we're going to go into our next C, which is going to be complete. This is going to be abdominal pain or bleeding in the first 20 weeks of gestation. Your cervical os is going to be closed, right? Because we said only the eyes open. And there's going to be complete passage of fetal parts and placenta, and the uterus is going to be contracted. So that's how I memorize it. So I just memorize the eyes open, right? Eyes open. So TIIC. T, we see threatened, right? It's not an I, so that means the cervical os is going to be what? Cervical os is going to be closed. And then is there going to be passage of fetal tissue? No. So that's how I memorize it. So both threatened and inevitable are at the top, so TI, so they're going to have no passage of fetal tissue, versus incomplete and complete, there is going to be passage of fetal tissue, so those are both at the end. So that's why I memorize it in that order. TIIC, eyes open, cervical os is going to be open. T and I are at the top, so there's going to be no passage of fetal tissue. And then we have the last two I's, which are going to be your incomplete and complete, and there is going to be passage of fetal tissue, okay? And then we have septic. This is an infection of the uterus during miscarriage, fever, and chills, usually due to what type of bacteria? Staph aureus. And cervical os, it's usually going to be open. They're going to have purulent cervical discharge and uterine tenderness. And for passage of fetal tissue, there can be none or it can be incomplete. So just make sure that you know these. So once again, these abortions are termination of pregnancy that's going to be before 20 weeks of gestation. So just to go overall, for spontaneous abortion, it's, like I said, a termination of pregnancy before 20 weeks of gestation. There's expulsion of tissue, and spontaneous is the most common complication of pregnant women less than 20 weeks. It increases with maternal age, so the risk increases with a mommy being older. Majority of them tend to occur in the first trimester, and before the 8th week, about 30% of them, they have a blighted ovum, so it's embryonic. And once a mommy has had one, or a woman has had one before, it's very likely that they are going to have another one, especially if it's consecutive. And usually the risk of miscarriage tends to decline as the pregnancy progresses. So as a patient gets further trimesters, the risk of miscarriage decreases. So what are some of the causes of abortions according to the trimester the patient's in? So the most common cause of a first trimester abortion is going to be a chromosomal abnormality in the first trimester. For second trimester, it's going to be your abnormal karyotype. There's also parental factors, things like incompatibilities like ABO or RH, right? Like the mommy and the baby are different RH, like negative or positive. Exposure to drugs, alcohol, radiation, or nicotine, medical conditions, uterine abnormalities, advanced maternal age, maternal infections. Diagnosis, we want to make sure that we establish the location of the pregnancy, whether it's an intrauterine pregnancy or not, or whether it's an ectopic pregnancy. We want to make sure that we establish the expulsion of the product of conception, whether it's partial or complete or absent. We want to make sure that we also confirm the fetal loss. We do this by doing labs. We do an ultrasound. On the ultrasound, you're going to see that there's lack of fetal cardiac activity or movement or absence of the product of conception. Labs, we're going to do a CBC, beta-HCG, sonogram, blood type, and RH, urinalysis, discharge, culture, blood culture, especially if we think about a septic abortion. So let's go into the next topic, which is going to be ectopic pregnancy. So ectopic pregnancy is going to be a pregnancy that's located outside of the uterus. It's extrauterine. The most common location is going to be in the tube, so it's going to be tubal. Other causes is going to be ovarian. It can go in the abdominal area, the cervical area, but the most common one is going to be tubal ectopic pregnancy. Some of the etiologies of this are going to be tubal factors, ovarian factors, exogenous hormones, low blood supply to the embryo. Also, risk factors is going to be if a woman just had a prior ectopic pregnancy, if they have a history of pelvic inflammatory disease, abdominal surgery, history also, if they have surgery to the fallopian tubes, tubes, endometriosis, intrauterine device placement, also failed ectopic pregnancies, smoking history. Signs and symptoms, they're going to have the triad of vaginal bleeding, abdominal pain, and amenorrhea. This is very highly tested, and that's how they're going to present. So make sure you know this classic triad: vaginal bleeding, abdominal pain, and amenorrhea. It's going to be a woman that hasn't had she just missed her period and she hasn't had this, and all of a sudden she's presenting with vaginal bleeding and severe abdominal pain. Vaginal spotting, bleeding, lower abdominal pain, pelvic pain. They'll have an adnexal mass. They can, on exam, you're going to see they're going to be guarding. So you're going to have abdominal guarding, nausea, vomiting, weakness, dizziness, also shoulder pain also, especially if they have blood in the peritoneum, they can present like that. Diagnosis, we want to make sure that we do a bimanual exam. We're going to do a sonogram, a beta HCG, right? We see that the beta HCG doubles how often? Every 2 days in a normal pregnancy. So if it's not doing that, we want to suspect an ectopic pregnancy. We also want to do a CBC. We want to do a CMP, a UA to rule out urinary tract infections. And then treatment, this is an emergency, right? We want to make sure we go in there and do a laparoscopy, methotrexate if needed. This will usually terminate the pregnancy. We can do a laparotomy. ROGAM also for women that are Rh negative. Complications of this, if the patient does not get treated, it's going to be a hemorrhage, hypovolemic shock, infection, infertility. So placenta abrupta is going to be the next one, or abruptio placenta. This is going to be a separation of the placenta from the site of the uterine implantation before the delivery of the fetus. Some of the etiologies of this is going to be usually the woman's going to have a prior history of placenta abrupta. If the woman is older, so advanced maternal age, multiparity, so if they've had numerous babies, uterine distension, trauma, smoking is a big one for placenta abrupta. Vascular deficiency, uterine abnormalities, alcohol. How is this patient going to present? They're going to have small, sometimes they'll be asymptomatic. They'll be presenting with abdominal pain, uterine irritability. But the thing you need to know about placenta abrupta and how to differentiate that between your placenta previa is that these patients are going to be presenting with painful bleeding. So it's going to be a pregnant woman that comes in. She's having like abdominal pain, and she's also presenting with painful bleeding. Okay, usually it'll tell you that the woman has a history of smoking or they were just involved in a motor vehicle accident. You want to think about placenta abrupta versus placenta previa. This is going to be painless bleeding. So they're going to be bleeding. They go to the restroom and they notice that they're bleeding. They're like, oh, I'm bleeding. Versus placenta abrupta, it's going to be very, very painful. Your abdominal pain. So diagnosis, we want to do a CBC. We want to do a PT and PTT and a fibrinogen level, right? We want to make sure that we're ruling out all those platelet disorders and blood disorders. We want to make sure that we do a blood type and Rh status also. Treatment usually is if this patient is stable, we want to make sure that we monitor them. If they're not stable, then we're going to deliver them. We're going to do a C-section. Especially if the patient is between 34 and 36 weeks, we can deliver them. If it's less than that, we want to prolong delivery, right? Because we want to make sure that the baby matures or lungs. This is an emergency, like I said. So placenta previa is going to be the next one. This is going to be a placenta that's implanted low in the uterus within the zone of dilation and effacements. Okay, so there's different types. We have our low line which is within 2 centimeters of, and then we have partial, which is partial coverage of the internal os, or complete, which completely covers the internal os. So once again, we have our low line, which is going to be within 2 centimeters of the cervical os, or partial, which is going to be partial coverage of the internal os, or complete, which completely covers the internal os. What are some of the etiologies of a placenta previa? Once again, multiparous woman, if they have large placenta, advanced maternal age. And how is this patient going to present? It's going to be a sudden, painless bleeding. We said placenta abrupta is going to be painful bleeding, right? Abdominal pain, post-motor vehicle accident. It's going to be a smoker or even a cocaine abuser. Versus placenta previa, it's going to be your painless bleeding. Diagnosis is that we're going to do a sonogram. Don't stick our fingers in there. So no pelvic exam. We want to do a sonogram. Why do we not do a pelvic exam? Because it can worsen the bleeding. Treatment for this is that We just want to make sure that we monitor them. If they are older, if the patient's greater than 34 weeks, we can deliver them via C-section if needed. But if not, we just want to make sure that we monitor these patients. So let's go into premature rupture of membranes, or PROM. This is where a patient is beyond 37 weeks of gestation and they have breakage of the amniotic sac prior to onset of labor. So they're there and then they start feeling fluids and they're like, oh my gosh, I think I'm in labor. Now, if this happens less than 37 weeks, then this is going to be PPROM. What does that mean? That's preterm premature rupture of membranes. Make sure that you differentiate that. So PROM, which is just premature rupture of membranes, is going to be a patient that's beyond the 37 weeks of gestation and they have a breakage of their amniotic sac prior to going into labor. PPROM, which is preterm premature rupture of membranes, is going to be a patient that has a breakage of the amniotic sac, but it happens before 37 weeks. I've gotten tested on this and I keep messing it up, so make sure that you know this. So put both of them to try to confuse you. So just make sure greater than 37 weeks is going to be your PROM, less than 37 weeks pregnant, it's going to be your PPROM. Okay. So etiology of this, usually sometimes infection. Sometimes a woman will have a history of having a PROM or a PPROM in the past. If they're smoking, if it's a mother that's underweight, a mom with polyhydramnios, right, too much fluid, multiple gestation, cervical insufficiency. So that's why we want to make sure that these women, if we see cervical insufficiency, we go in there and we suture it, right? Because this is a complication of that. How is this patient going to present? They're going to have sudden painless gush, steady leakage of fluid from the vagina, but they are not going to have any uterine contractions. They're just going to have all this fluid that's going to come out, but they won't be in labor. They'll be like, my water broke. Okay. Diagnosis is going to be a speculum exam. We're going to see pooling in the vaginal vault. We're also going to do a nitrazine test. Okay, this is a pH paper, and if it turns blue, then that means it's positive. This is very highly tested, so make sure that you know that. Fibronectin also, and then we're also going to do a positive Fern test. Literally looks like ferns, that's why it's called a Fern test. It's going to be positive. Treatment is if the patient is greater than 37 weeks, they're full term, we can induce them and we're going to give them antibiotics, right? Because we're protecting against what? Group B strep. So we're going to give them amoxicillin and erythromycin. If the patient is your PPROM, right? If they're less than 37 weeks, if they're between 34 to 36 weeks, we can induce them and we can give them antibiotics also. What if they are 24 to 34 weeks? With these patients, we're going to give them corticosteroids because we want to make sure that the baby develops those lung, right? It's going to also help increase the surfactant. And we're going to give them magnesium sulfate, tocolytics, antibiotics, and then observe them because we don't want to deliver them because baby is not ready yet. Okay, so let's go into postpartum hemorrhage. This is also another one that's very highly tested, so make sure that you are familiar with this one. So postpartum hemorrhage, what is it? It's a blood loss that's greater than 500 milliliters vaginal and then greater than 1,000 milliliters in a C-section within 24 hours of delivery. These numbers are very important. Etiology, most common cause is going to be your uterine atony. Other causes is going to be uterine rupture, if they had any type of laceration, retained placenta, coagulopathy, birth trauma, and retained products of conception. But the most common one is going to be what? Your uterine atony. Treatment for this, if it's a uterine atony, first thing we're going to do is a bimanual uterine massage. You're just going to massage that uterus. You're also going to resuscitate with fluids and transfusions. You can also give medications like oxytocin, methergine, or prostaglandins. If you've done all that and it's still not helping with the vaginal bleeding and it's refractory, then you can do surgical ligation, arterioembolization, or hysterectomy. If they have any type of genital tract trauma, right, when they're having that baby, then we're going to go in there and do a lag repair. If they have retained placenta, then we can do a manual removal and curettage with suction and hysterectomy if needed. So let's go into hydatiform mole. So there's two types. We have our partial or complete. So how is each one what is it? How is each one? How does it look genetically wise? So partial is your 69XXX, 69XXY, 69, or XYY. And a complete mole is going to be your 46XX or 46XY. Okay? So what are some of the etiologies of this? It's going to be your advanced maternal age. Once again, if the patient has a prior history of molar pregnancy, and also these patients with hydatiform moles are at high risk for choriocarcinoma. How is this patient going to present? The keyword that's usually associated with your hydatiform mole, it's going to be hyperemesis gravidum. So they're going to just be vomiting so much. Vaginal bleeding, they're going to have like this enlarged uterus that's just like abnormal. They're like 5 weeks pregnant and they look like they're like 20 or 30 weeks pregnant when they're not. They're going to have pelvic discomfort, pain, or pressure. We're going to diagnose this. We're going to do a beta HCG. We're going to see that it's increased, abnormally increased. We're going to do a transvaginal ultrasound. That's usually going to give us a diagnosis. We're going to see that snowstorm. That's usually what they say on your questions. Or sometimes they'll just show you a picture of an ultrasound. It looks like a snowstorm or a cluster of grapes or honeycomb. And then we're also going to do a uterine evacuation. This is both diagnostic and therapeutic. So that's going to be the treatment for hydatiform mole. It's going to be a uterine evacuation. Usually a DNC is preferred. Okay. So next one's going to be amenorrhea. This is going to be a lack of menstruation. There's different types. So we have a primary or secondary. Primary is going to be a woman that's never had a period before. So it's going to be a woman, for example, a teenager that's like 16 or 17, and they've never had a period before. And sometimes they won't even develop like breasts or anything, or sometimes they do develop breasts, but they just never had a period before. And so that's another topic that we need to discuss. And then you have your secondary. So secondary amenorrhea means that they've had a period before, but all of a sudden they just stopped having periods. So the most common cause of secondary amenorrhea is going to be what? Pregnancy, right? They're having periods and then all of a sudden they're not having periods anymore. So what are some of the causes of this? Sexually active, oral contraceptives, weight loss, exercise, stress. If the patient is also not eating well, like nutrition, certain disorders can also cause this. For example, anorexia can make a woman have amenorrhea. If they have any type of systemic disease. So like I said, primary is going to be no menarche by age 13 without secondary development of like breast or anything like that, or no menarche by age 15 with secondary development. So they're 15 and they have breasts, and they have also pubic hair, but they just have not had a period yet. So signs and symptoms, you're going to have delayed secondary sexual development, outflow obstruction, sometimes why? Because they might have an imperforated hymen. And if they have mullerian agenesis, usually the uterus is going to be absent in both mullerian agenesis and androgen insensitivity. We're going to diagnose this because we're going to do a beta HCG just to make sure that they're not pregnant, right? We're going to do an FSH and LH level just to make sure that they are producing that, right? Their body's producing that. And then a karyotype analysis to rule out any type of genetic disorder. And then secondary, right? Most common cause, like I said, if this is going to be pregnancy, secondary is usually a woman that's been menstruating, and then they have absent menses for at least 3 cycles or 6 consecutive months. Once again, menses that's absent for at least 3 cycles or 6 consecutive months. Etiologies of this: pregnancy. I know I keep saying this, but this is very highly tested. Also hypothalamic problems with just like the thalamus itself is just not working. Pituitary adenoma, polycystic ovarian syndrome is also very commonly associated with amenorrhea, galactorrhea, Asherman syndrome. So Asherman syndrome, right? Woman that just Asherman syndrome. And then certain medications, infections also. Signs and symptoms, they'll have enlarged uterus, they'll have fetal heart sounds, right? If they're pregnant. If it's galactorrhea, they're going to have galactorrhea. If they have menopause, and that's why they went into amenorrhea, then they're going to have like an atrophic vagina. We're going to diagnose them by what? Doing an HCG once again. We're going to do a TSH just to make sure that the patient does not have any type of thyroid disorders. We're going to do a prolactin level or progesterone challenge test to just make sure that their uterus is working, like it's responding to hormones there. And then of course we want to make sure that we also do an estrogen and progesterone challenge test, and then in the FSH and LH levels. And then we want to treat whatever is causing, right? And then we also want to make sure that we educate the woman on the causes of unopposed estrogen, especially in your women that are postmenopausal. We don't want to give them estrogen because why? Because it can lead to cancer, especially uterine cancer. And if the woman is also postmenopausal, make sure that we are educating them about the importance of preventing osteoporosis, right, and having to treat that if needed. So next we're going to go into is dysmenorrhea. This is going to be painful menstruation. So it's menstrual pain that prevents normal activity and requires treatment. We have primary and secondary causes. Primary, it's basically there's no pathology. There's no underlying cause that is causing this dysmenorrhea. It's usually due to increased prostaglandins, and what this causes is that it increases uterine contractions, very commonly found in your younger patients. They'll have increased leukotriene levels. So once again, primary, really no pathology or structural pathology. Secondary is that they do have a pathology, so they'll have endometriosis, which is one that's very commonly associated with dysmenorrhea. They'll have adenomyosis, pelvic inflammatory disease, cervical stenosis, fibroids, right, your leiomyomas, polyps, adhesions. If the patient's older, also if they're mid-20s. How's this patient going to present? They're going to have cramps, pelvic or low abdominal pain. It radiates to the back and legs. They're going to have a headache, nausea, and vomiting. It'll be cyclic, so it comes and goes, and it tends to occur just before the patient starts their menstruation. And it's so bad that the patient just misses school, they can't go to work, they just really can't function. Diagnosis is usually going to be a clinical. Usually if we suspect that it's due to a secondary cause, then we want to make sure that we are working them up to treat whatever is causing this, but usually we don't work them up if we think it's a primary cause. So if it's a really, really young girl, like a 14 or 15-year-old that just started her menstruation, we wouldn't really work her up, versus if you have a woman and they're like 33, 34, and they're having pain, and you do the pelvic exam and you like feel like rockiness, right? You want to make sure that we rule out things like fibroids. So treatment for this, first line is going to be NSAIDs because they have this anti-prostaglandin activity. So something like naproxen. We also educate them on applying local heat. We can also give them oral contraceptives. It usually helps with dysmenorrhea. And then laparoscopy, if this patient has severe dysmenorrhea and they've tried everything, oral medications like we said, and they're not responding to treatment, then we can do a laparoscopy. So let's go into dysfunctional uterine bleeding. Dysfunctional uterine bleeding. So we have dysfunctional uterine bleeding, which is usually due to a non-pathological cause. So it's usually a diagnosis of exclusion for these patients. Some of the etiologies are usually certain medications, coagulation disorders also. This patient is going to present you with abnormal bleeding patterns. So they'll have, sometimes it'll say that they spot throughout their period, or they get their periods and then sometimes they don't. And they'll say that they're passing clots or have a heavy flow. They can also present with symptoms of anemia, especially if the patient's been bleeding for more than 7 days. They'll be presenting with menorrhagia, hypermenorrhea, metrorrhagia, polymenorrhea, which means that they're just menstruating so much. Oligomenorrhea is that they're menstruating like here and there, it's like scant. And then also they'll have postcoital bleeding. And then diagnosis, we're going to make sure that we always do a beta HCG on every woman, right? Because we want to make sure that we rule out pregnancy. We're going to do a CBC since this woman's been bleeding for a really long time. We want to make sure that the patient is not anemic. We can do a pelvic sonogram and an endometrial biopsy also if the woman's greater than 35 years old. We want to look for any type of endometrial hyperplasia where that endometrium is just really enlarged, and that's why these patients are bleeding intermittently. Okay. And then treatment is just want to make sure that we control the bleeding. So we can give them something like oral contraceptives or monthly progesterone or an IUD. And then if needed, we can do a DNC, but this is usually not first line for these patients, or a hysterectomy or endometrial ablation. If like the patient is just, they don't want to have children anymore and they've tried everything and it's not working. So what if it's an acute or severe bleeding? We want to make sure that we give them a high dose estrogen. If it's extremely severe, then we're going to give them something like a GnRH agonist, and it's going to be usually short term, like leuprolide, right? So that's going to be dysfunctional uterine bleeding. Usually if it's a hemoglobin less than 7, that's when we're usually going to transfuse these patients, because these patients can become anemic, especially if they've been bleeding for like 7 or 8 days straight and they're just bleeding so much. So endometriosis is going to be the next one. This is endometrial cells that are present outside of the uterus. It's a very common cause of pelvic pain in adolescents. And some of the complications of endometriosis is infertility. So the etiology is usually women that have early menarche, commonly found out some patients that have never had a baby before. If they have a family history of it, like their mom suffered from endometriosis. The sites that are more commonly associated with endometriosis are going to be your fallopian tubes, your ovaries, your posterior cul-de-sac, right? These patients with the posterior cul-de-sac can present with like rectal pain, also broad and uterosacral ligaments, colon, and then even the bladder. Signs and symptoms are going to have dysmenorrhea, so painful menstruation. They're going to have dyspareunia, so they're going to say that they have like pain whenever they have sexual intercourse, especially in deep penetration. They'll have dyschezia, also infertility, premenstrual pain throughout early menses. Asymptomatic, so dyschezia is that they have pain whenever they have bowel movements. Palpable nodules, also you'll be able to feel that, especially if they're present on the posterior cul-de-sac. Usually also you'll feel like a retroverted uterus on your pelvic exam. Also they may have constipation. Diagnosis is usually a clinical diagnosis. If you want to do a definitive diagnosis, then we're going to do a laparoscopy. We're going to do a tissue specimen. So make sure that you read the question. I've gotten tricked by this. If it tells you what's a definitive diagnostic test, it's going to be a laparoscope, but we usually don't do that, right? Because it's too invasive. So treatment for this is going to be surgical ablation of the visual lesions, hysterectomy with oophorectomy. Also, medication-wise, we can give them oral contraceptives. This is going to help suppress the ovulation. We can also give them progesterone. This is going to suppress the GnRH and ovulation. And then we can also give them GnRH agonists if needed. So next one is going to be your polycystic ovarian disease. This is going to be a hormonal disorder where the ovaries develop numerous small collections of fluid follicles and they fail to regularly release eggs. So it's the ovaries, they're filled with like all these like little clear, you would say, little balls, right? Very commonly found in women of reproductive age. Some of the complications of PCOS and why it's important that these women get treated, it's because it can cause infertility, and it's usually associated with type 2 diabetes like we discussed earlier. This patient is going to present usually with infrequent or prolonged periods. They're going to have weight gain. Also, sometimes it'll say that they have acne. It'll say also that they have like facial hair. Diagnosis, we're going to look at their androgen levels. They're going to be very, very elevated. Treatment is that we want to make sure that we manage the infertility, right? We can give them oral contraceptives, make sure that we manage their hirsutism, their acne, and then of course their obesity. Most of these patients are obese, so make sure to educate them on the importance of lifestyle changes. And then medication-wise, we can give progesterone, metformin, and Clomid. Metformin is very, very commonly used for PCOS, and then Clomid is going to help with that ovulation. So ovarian cysts, these are fluid-filled sacs within the ovary. Majority of these are benign, and it's very commonly found in women of reproductive age. It's usually due to hormonal imbalance. Signs and symptoms are usually be asymptomatic. They'll have bloating, lower abdominal pain, low back pain. They'll have dyspareunia, which is painful sexual intercourse. They'll have severe pain if usually these rupture or torsion occurs, and they can have they can present in a very, very critical condition. So they'll be vomiting, they'll be in a lot of pain. They'll have syncopal episodes if any of these cysts torts or they twist. So if you have a cyst on your ovaries and it's very, very large, it's very likely that it contorts or they can burst. And usually these are emergencies. Just how in testicular torsion, the same thing can happen in ovarian torsion. I've had these cases before where women present and they're just in so much pain, and then you see that they have like this ovarian torsion, and these are an emergency because these patients need to go to the surgery. Diagnosis is usually going to be a pelvic ultrasound, and like I said, if the cyst ruptures, this is usually pain management, and if needed, they're going to go and get surgery. And I had like a cystectomy and oophorectomy. So ovarian torsion. This is when an ovary becomes twisted around the tissues that support it. What causes is that it cuts off blood supply to the organs, and it's a very painful condition. It's an emergency. Usually the patient's going to have a history of an ovarian cyst. They're going to be presenting with severe, sudden, like acute, sudden abdominal pain. You're going to have this abdominal cramping, nausea and vomiting. Treatment's going to be a surgical laparoscopy, laparotomy. And if it's necrotic, like it already cut blood flow to that ovary, then oophorectomy or a salpingo oophorectomy is usually going to be needed for these patients. But we want to make sure that we prevent that. So that's why these patients need to be treated as soon as possible. Vulvovaginitis. This is going to be an inflammation of the vagina and the external genitalia. This patient is going to be presenting with vaginal irritation, pain, and pruritus, so itchiness. It's usually due to a disruption of the normal vaginal ecosystem. So you have good bacteria that exists in a woman, right? I'm a woman, you would say. I'm a woman. In your vagina. So you have good bacteria that lives there. Sometimes there's a disruption in it. Usually there's an increase in amount of your normal bacteria. So sometimes you even have an alteration of your vaginal pH. Sometimes you have a decrease in your lactobacilli, or like I said, growth of other bacteria. And this is what causes your vulvovaginitis. So what are some of the causes of this? There's different causes. So if it's not STD related, usually some of the causes is because a woman's not very hygienic, right? So poor hygiene, or even if they're too hygienic, like very, very hygienic. And that's why they say that they do not recommend for women to douche themselves, because like I said, you have good bacteria there. And when you do that, you disrupt that good bacteria. So even excessive hygiene can cause vulvovaginitis. Chemical irritants like bubble baths and soap, tight clothing, pinworms. I know that's gross, right? Some other causes of vulvovaginitis, you have your Candida albicans, your yeast infections. This is very commonly found in your diabetics, type 2 diabetics. So if you have a woman that presents and they get multiple yeast infections, like 5 or 6, that's not normal. You want to work them up for diabetes, because yeast infections are very commonly associated in diabetics. Also, yeast infections are commonly associated in your pregnant woman. Oral contraceptives also will increase a woman's risk for Candida albicans. Also, antibiotic treatments. So after a woman completes like a dose of antibiotic treatments, they usually get a yeast infection. So that's why when I was doing my rotations, whenever I had a woman that presented with a urinary tract infection and we gave them Bactrim, I always offer to give them fluconazole if needed, because there's certain women that will usually just develop a yeast infection after they took Bactrim, because it just disrupts, once again, that normal flora that you have in your vagina. Also certain like panty liners. So how's this patient going to present with Candida albicans? They're going to have a vaginal discharge. It's going to be what color? It's going to be white and clumpy. It's going to be described like a cottage cheese discharge. It's going to be, the patient's going to be presenting of itching, burning. They'll have painful urination. And you're going to diagnose this by doing a KOH test, and you'll see like yeast budding. Treatment for this is usually, you can do a miconazole cream for 3 days, or you can just give them like a single treatment of oral fluconazole or diflucan just like once, and it'll get rid of it. So next one's going to be your bacteriovaginosis. This is caused by your Gardnerella bacteria. So once again, bacteriovaginosis, or BV, Gardnerella bacteria. This is usually an alteration of your normal vaginal bacterial flora. It's the most common form of vaginitis, and it's not due to sexual activity. So you can't get this. You cannot get BV from having sex. So with these patients, they're going to be presenting with this fishy vaginal discharge. It's going to be like a milky, homogeneous, malodorous, irritating discharge. It's usually like this thin gray discharge. Sometimes it can be white, but it's not your cottage cheese like your yeast infections. This is just going to be like a thin gray fishy odor discharge. These patients, you diagnose them, you can do the AMSL criteria, so they're going to have a positive whiff test. Their pH is going to be greater than 4.5, and they're going to have positive clue cells. That's pathognomonic for your BV. It's going to be your positive whiff test and your positive clue cells. Treatment for this is usually with flagyl, so you can do metronidazole. And then we have our STDs, trichomonas. This is a flagellated parasite. It looks so beautiful under the microscope. I think it looks like a kite. It's very beautiful. And it's so gross that these parasites can cause like this green, disgusting vaginal discharge. So trichomonas, it's a sexually transmitted flagellated parasite. This patient's going to be presenting with a frothy discharge. It'll say that the patient has like a strawberry cervix, or sometimes it'll say it's like you'll see punctate lesions on the cervix on your pelvic exam. They're going to have like this green yellow discharge. I had a patient with this once. She came in with abdominal pain, but she didn't tell us about her vaginal discharge. She was very embarrassed about it, so she didn't tell us. She just told us that she had abdominal pain, and we did a CT scan. We did an x-ray. We were trying to rule out even an ultrasound, like the upper abdominal ultrasound, just to rule out things like appendicitis and cholecystitis, and everything was negative until my doctor was like, where is the abdominal pain specifically? And she was like, just overall. And she's like, well, where does it hurt more? She pointed to her pelvic region, and we ended up doing a pelvic exam, and yeah, she ended up having a trichomonas. And yes, it's like this like green discharge. It was a green discharge. That's all I'm going to say. But yeah, green discharge and green yellow discharge. So diagnosis for this, we can do a microscopy, even though we don't do that really in reality, but book text wise, right? And for your exam microscopy, you're going to see this motile trichomonads plus increased leukocytes. Like I said, these parasites are beautiful under the microscope. They look like kites. They're purple. Well, what you use, you stain them, but they're like purple and they look like kites. They're just beautiful. During my parasitology class, it was like one of my favorite parasites to look at under the microscope. So we're going to treat this with metronidazole, and we want to make sure that we test the partners and we treat the partners also. And then we have your atrophic vulvovaginitis. This is very commonly found in your menopausal women, right? Because these women are not producing your estrogen anymore, which helps them with that vaginal lubrication. And so they just have this like atrophic, dry vagina. So it's because of lack of estrogen. They're going to have this dryness, itching, dyspareunia. And then on your exam, you're going to see this like dry, pale, and shiny vagina. Treatment for this is usually with estrogen. You can use lubricants and moisturizers. With these women, we want to be careful with estrogen, right? So usually we'll do topical estrogen for these women. So next one's going to be chlamydia. This is an infection. It's commonly found in women that are sexually active, right? So you're a woman of reproductive age. And all women under 25 get a test annually for chlamydia, because chlamydia is the most common STD in the US, and it's a gram-negative bacteria. These patients can present either asymptomatic, or if they do have symptoms, they're going to present with this mucopurulent cervicitis. They're going to have this friable cervix, and they're going to be complaining of post-coital bleeding and intramenstrual bleeding. Diagnosis is going to be with an NAAT. We're going to do a GenProbe intracervical swab. We can also do an ELISA or PCR with urine. Treatment's usually going to be with azithromycin, or you can do doxycycline, and we want to make sure that we treat both the patient and the partner. Also, we want to make sure that we test for gonorrhea, because usually gonorrhea and chlamydia come together. So you don't really usually get one, you usually get both of them, but you really don't need to treat for gonorrhea. You just want to make sure that you test them for gonorrhea. So these patients, usually if they're pregnant and they're symptomatic, you want to make sure that we treat these patients with penicillin and cephalosporins. If these patients do not get treated, they can develop pelvic inflammatory disease. So it's really important that we treat these patients. because some of the complications of this is, like I said, pelvic inflammatory disease, Fitzhugh syndrome, Reiter syndrome, trachoma conjunctivitis, premature labor. So I was watching a documentary the other day on Ellis Island, and a lot of the immigrants that would come had trachoma conjunctivitis, and sometimes they wouldn't be let into the US. They had to be returned back to their home because they had trachoma conjunctivitis. So I thought that was just really interesting. So gonorrhea, this is going to be an infection, bacterial infection once again. It's caused by Neisseria gonorrhea. This is a gram-negative diplococcus. Make sure you know that, because sometimes it'll just describe the bacteria and you need to know what type it is, whether it's chlamydia or gonorrhea. This is the second most common STD in the US, commonly found in your young adolescents. How is this patient going to present? They're going to have 3 to 5 days post-exposure. Sometimes they may be asymptomatic. If they have symptoms, they'll have like malodorous discharge. If it's a woman, they're going to have cervical motion tenderness. They'll have pustular and petechial skin lesions. If you see this, you want to think about gonococcal bacteremia, okay? And septic arthritis can also occur with gonorrhea, so these patients can get endocarditis or meningitis, but it's very, very rare. We're going to diagnose this with an ELISA or a DNA-specific test and NAAT, so we want to make sure we do a cervical swab combined with chlamydia and a urine test, and then a gram stain also. Treatment is going to be ceftriaxone, and on top of that, we want to make sure that we treat for chlamydia, because chlamydia is the most common STD, and it's usually associated with gonorrhea. So with gonorrhea, we want to make sure we treat the gonorrhea with ceftriaxone, and on top of that, we're going to treat for the chlamydia. So we're going to do ceftriaxone plus doxy or azithromycin for these patients. Okay. So pelvic inflammatory disease. This is an infection of the upper female genital tract that causes significant inflammation. The most common cause sites are going to be your uterus and your fallopian tubes. The most common pathogens associated with PID is going to be your chlamydia and gonorrhea. That's why, like I said, it's really important that we treat these patients for this. Risk factors for this is going to be if a patient has multiple sexual partners, if they have unprotected sex, if they have a history of sexually transmitted infections. On diagnosis, you're going to see an elevated white blood cell count, ESR, and CRP that are also sometimes elevated, so we can do this also. We do a positive culture. We're going to do a culture for gonorrhea and chlamydia. Sometimes it's going to be positive. And then, of course, we're going to do our pelvic exam, right? So how are we going to treat these patients with PID? So with PID, it depends on whether the patient's an inpatient or outpatient. So if the patient comes in and they're toxic appearing, right, they're hypotensive and they just look really, really sick, then we're going to admit them. We're going to do cefotein 2 milligrams every 12 hours and doxycycline 100 milligrams every 12 hours. If we're treating the patient as an outpatient, we're going to do ceftriaxone 250 milligrams intramuscular, so we're going to give them a shot. And we're also going to give them doxycycline 100 milligrams twice a day for 14 days. That's going to be outpatient. This is a common one that gets tested, so just make sure that you know that. So how do we say PID is going to be present? They're going to have cervical motion tenderness, right? They're going to have that chandelier sign. They're going to have that lower abdominal pain and tenderness, abnormal bleeding, vaginal discharge, fever, chills, nausea, and vomiting, okay? The reason why I'm repeating this is because this is very highly tested. What are some of the complications of PID? Fitzhugh-Curtis syndrome. This is where it spreads to the abdomen. It causes perihepatitis, and then on top of that, you have PID. It can also cause a tubal ovarian abscess, which is very, very severe, and then it can lead to infertility, right? So it can cause ectopic pregnancies. So let's go into mastitis. This is going to be an inflammation of the breast tissue, very commonly found in your breastfeeding women. Most common cause is going to be your Staph aureus. This is highly tested, so make sure that you know that. It'll be a woman that presents, she's having mastitis, and it'll ask you what's the most common bacteria that causes this, Staph aureus, because Staph aureus is found on the skin. This patient is going to be presenting with unilaterally swollen wedge area breasts. That's how usually it'll say on the exam. Wedge area breasts, they'll have pain, redness, induration, hardening, fever, malaise, and chills. Treatment is rest, fluids, give the patient oral antibiotics, something like dicloxacillin or cephalosporin, right? It's going to cover your Staph aureus. And then you want to make sure that you can tell the patient if they're pregnant, if if they just had their baby, to continue frequent breastfeeding. So it's okay if they continue breastfeeding. This is a question I had on my exam, so make sure that you know this. So if the patient has mastitis, they can continue breastfeeding. It's safe for them to continue breastfeeding. Abscess. This is sometimes a bacterial infection that can cause pus to collect in the area near the nipple and areola, so a breast abscess. Some of the causes of this is breastfeeding mastitis. The most common bacteria we said was what? Staph aureus. This patient's going to be presenting with a warm, tender erythema, and it's going to say indurated or fluctuant mass. That's how you differentiate that between mastitis and a breast abscess. And I've said this because it's gotten me before. So it's going to be a fluctuant mass. It's going to be indurated. They may or may not have nipple inversion or discharge from the nipple. These patients are presenting with a fever, chills, malaise, lymphadenopathy, and diagnosis is that we want to make sure that we do aspiration of the discharge and we send it for culture and sensitivity. Treatment is going to be antibiotics, and if it's not responsive to the antibiotics, then we want to suspect inflammatory breast cancer. All right, guys, so let's go into the next topic, which is going to be our psychiatry. So psychiatry, we have major depressive disorder. So the thing about psychiatry, and if you see my previous videos for the psychiatry end of rotation, is that, and I said this in that video too, is that with psychiatry, what you need to know is that it's all about timelines. So in psychiatry, and according to their the book, which I apologize, I don't remember the name, which will come to me, the DSM-5. So the DSM-5, it is according to timelines. So a patient has to have these symptoms for a certain amount of time to be placed into this diagnosis. Now, is that done in real life? No, it's not. When I did my rotation, I rotated with my psych doctor for like 2 months, and he never used the timeline. And it always confused me so much because I was so strict on the timelines because that's how I studied it. I'm like, if it's not within this timeline, it's not that diagnosis. Or if it goes over the state, it's this diagnosis. But in regards to your exam-wise, make sure that you know the timelines. So starting with major depressive disorder, they have to have at least one episode of depressed mood, no history of manic or hypomanic episodes, and the depression has to be recurrent. Some of the causes of depression, usually it's unknown, and it's very commonly found in women, more women than male. And these patients tend to have a recurrence also, as I said. So with these patients, the thing you need to know is that they have increased REM sleep, okay? And usually it's not due to a substance for these patients. And how are they going to present? They have this depressed mood, they have sleep disturbance, they have loss of interest or anhedonia, they have guilt feelings, energy loss or fatigue, concentration problems, appetite, weight changes, psychomotor retardation or agitation, and then suicidal ideations. How I memorize it is mnemonic SIGI caps. So you have S for lack of sleep, right? So they can either have increased sleep or just insomnia. So sleep. The next one is your I, so SIGI caps, SI. I is going to be irritability. G is going to be guilt, okay? E is going to be energy, so you're going to have lack of energy. C is going to be concentration. They're going to have decreased concentration. Appetite, you usually have decreased appetite, or although you can have another type of depression where they have increased appetite, but usually on your questions it'll be decreased appetite. P is going to be for your psychomotor retardation or agitation, and then S is your suicidal ideations. So once again, SIGI caps, SIGE CAPS. That's a mnemonic that I use, and that's what's helped me differentiate how to diagnose these patients. They have to have more than 5 of the ones that I told you in order for them to be diagnosed with major depressive disorder according to the DSM-5. So we have specific ones of specific types, subtypes you would say, of major depressive disorder. We have melancholic. So with these patients, usually it's going to say that they're in the dark room, that they're very sad, they're listening to music, and they're tearing. You have your atypical features also. So like I said, they have increased weight, they have increased appetite, and they're just sleeping a lot. So increased sleeping. So that's your atypical, where everything's increased rather than decrease. So just make sure that you keep that in the back of the mind if you're reading a question stem and they have increase rather than decrease. You want to think about possibly an atypical type of major depressive disorder. You also have seasonal pattern, which tends to happen during fall or winter. Interestingly, for these patients with seasonal pattern of depression, is that if they go out and they get light, they feel a lot better. So that's why it's more commonly found during spring or winter, fall and winter, because these patients are inside, right? They're not really going out and getting light as much as they used to. So diagnosis, like I said, it has to have more than 5 of the Siggy caps, like we discussed, for at least 2 weeks. And they have to have more than one symptom that's either depressed mood or anhedonia, which is loss of interest or pleasure, okay? These have to be there. So once again, they have to have more than 5 of the ones I discussed for at least 2 weeks, and at least more than one of these symptoms have to be either depressed mood or anhedonia. So treatment for these patients is, first line is usually your SSRIs. These are very, very safe medications. So your SSRIs, like your sertraline, okay? Second line is like your TCAs. We tend to avoid these because they have a lot of like side effects, like they're cardiotoxic, but TCAs are usually your second line. And then like say you tried like SSRIs and your TCAs and this patient is still having refractory depression, then you can go into your MAOIs, which are your monoamine oxidase inhibitors. These have a lot of side effects, so we usually stay away from them. And then on top of that, you have to be in a very, very strict diet, so you can't drink wine or certain cheeses because it can interact with the medication. So that's why like we stay far away as we can from those. And then you can also give them, if needed, you can do ECT, like which is your electroconvulsion therapy. Usually this is only if a patient, you've tried all your medications, you've tried psychotherapy and everything, and this patient is still not responding to treatment, then you can do this. Also, like you can do it in women that are pregnant that can't take certain medications. And it's actually very, very safe. So you can do electroconvulsion therapy in these patients that have like suicide, they're suicidal, they're not being managed well on the medications, or just have side effects to the medications also. And then with major depressive disorder, we always make sure that we rule out things like hypothyroidism, right? Or cancer. So whenever we have a patient like that, we want to make sure that we rule these things out. So once again, major depressive disorder, the Siggy caps, right? We said S was for trouble sleeping, I was for lack of interest, G was for guilt, E was for lack of energy, C was for lack of concentration, and then we said A was appetite, which is going to be decreased, P is your psychomotor retardation, and then S is going to be suicide. So they're going to have 5 out of 9 of these. They're going to have these symptoms going on for more than 2 weeks. First line treatment is going to be your SSRIs. It's better if you do SSRIs and cognitive behavioral therapy. They're a lot better together. But of course, if you can't do that, then you can do SSRIs. But usually SSRIs and cognitive behavioral therapy are the best when used in conjunction, and this patient gets better from both of these. So next one's going to be suicide. Suicide. So with these patients that are suicidal, we want to make sure that we have caution with these patients, because usually patients sometimes will get more energy after taking certain medications for depression, like your SSRIs. So they get more energy after being treated like for their depression pharmacologically. So they have more energy to complete their suicide attempts. So for suicide, the mnemonic I have is sad persons. So you have S is going to be your sex. It's more commonly found in males for suicides. A is going to be for age. More patients that are more commonly to complete suicide is going to be your young adults and your patients that are older. D is going to be for depression. P is going to be for a previous attempt. This is the highest risk factor for suicide. So if you have a question and it asks you what's the highest risk factor that this patient is going to complete the suicide, it's going to be a previous attempt. So make sure that you know that. So that's your P. And then your E is going to be ethanol use or drug abuse. R is going to be for rational thinking loss. And then they're going to be like psychotic. S is going to be sickness. So if they have like a medical illness, especially like a terminal illness like cancer. And then your O is going to be organized plan. Your N is going to be no spouse or social support. And then your other S is going to be that they've stated a future intent. So these are going to be your mnemonic for these patients. Also very commonly found in your medical professionals also. This patient is going to be presenting with a recent attempt of completing a suicide. They're also going to be stating that they have suicidal thoughts, and they also have a plan to commit their suicide. They'll have admission of thoughts upon questioning. They'll demonstrate also behavior wanting to commit suicide. They'll have ideation, so thoughts about killing themselves. They'll have intent, so you're going to ask them, usually like during my psychiatry rotation, every morning I would run on patients and I would ask them like, do you have any thoughts of wanting to harm yourself? And then they would say yes. And I'm like, are you planning to do that, or how are you planning to harm yourself? And then sometimes I would get a patient that says like, no, I think about it, but I'm not going to do it. Or sometimes I would say a patient say, yeah, I'm going to hang myself. So that's why you always ask about their ideations and then if they have an intent or a plan on doing it. Okay? So plan, like, do you have the plan? So also we want to make sure that we assess the homicidal ideation, but that's assessed separately. So I always ask them, do you have plans of, do you want to harm someone else? And then if they do say that they want to harm someone else, it's really important that even though you have your patient confidentiality in these situations, well, no, especially if they're very serious of wanting to harm someone else. So in these patients that have homicidal ideations, or if they have a serious suicidal ideation with intent and plan, then we're going to detain them on emergency evaluation. Okay? We want to make sure that we take all threats seriously and never identify with the patient. Okay? So let's go into our bipolar. So we have bipolar 1 and 2. The difference between this is on the symptoms and on the length. So make sure you know this. Bipolar 1, some of the etiologies is usually biological, environmental, psychosocial. Genetic factors is very commonly associated with bipolar. So if you have a family member that has bipolar, it's very common that that person's family member or child is going to also get bipolar disease. So once again, high genetic factor. More commonly found for bipolar 1 is more commonly found in men and women. Okay. And with these patients, they are usually non-functional. They will have a manic episode. So they have to have a full manic episode to be diagnosed with bipolar 1. So they have to have a full manic episode. Even if it happened years ago where the patient was hospitalized or was put in jail because they did something, that is a full manic episode. Okay. Treatment for this is usually with lithium. This decreases suicidal risk. You can also give him like anticonvulsants or atypical antipsychotics for acute mania, but usually lithium is going to be your first line treatment for bipolar 1. And like I said, for bipolar 1, it has to be occurring for more than 1 week to be diagnosed with bipolar 1. So with bipolar 2, this is usually a recurrent major depressive disorder with hypomania. So these patients do not have a manic episode, a full manic episode. These patients are just going to have hypomania, okay? And these patients are able to function. Versus bipolar 1 disorder, these patients are not able to function. More commonly found in men than women. Like I said, this is usually chronic, but they're functional. They have a better prognosis than bipolar 1. They'll have a history of one or more major depressive disorders and at least one hypomanic episode. Treatment is going to be lithium. And then for bipolar 1, what you need to know is that they are going to have symptoms that are going to be present for more than 4 days without significant impairment. So these patients are not going to have any psychotic features. Okay, so treatment, like I said, is lithium. If the patient is depressed, you can give them something like Seroquel or lamotrigine, but just know that for bipolar, it's usually your lithium. So I wanted to share with you guys real quick a mnemonic I have for bipolar. So I have the mnemonic dig fast. So D is going to be for distraction. I is going to be for indiscretion. G is going to be for grandiosity. F is going to be for flight of ideas. So they have like these racing thoughts. A is going to be for activities. So they're going to have increased activities that are like very, very dangerous. I've read questions where it says that you had a patient that was spend like $30,000 just gambling on one day. S is going to be sleep deprived, and then T is going to be for talkativeness. So they're going to have like this pressured speech. So dig fast. That's the mnemonic I have. So hopefully this will help. Like I said, for bipolar, they need to have bipolar 1 more than 1 full manic episodes, and then more than 3 of the symptoms that I discussed for more than 1 week. And then for bipolar 2, they need to have symptoms from the dig fast criteria that I stated, and they have to be lasting for more than 4 days. But these patients do not have impairments, so these patients are able to go back to work and are able to function, versus your bipolar 1, these patients are not functioning. Okay, and like we said, bipolar 1 is going to be your full manic episode. So they have to have a full manic episode to be diagnosed with bipolar 1, versus bipolar 2 is just hypomania more than anything, and also major depressive disorder. So they're depressed also. So let's go into generalized anxiety disorder. This is a persistent excessive anxiety, hyperarousal alert. They may or may not have somatic symptoms, very commonly found in females, and it tends to be genetic. It tends to begin in childhood, and usually the age that it's usually manifested, it's at age 30. These patients are presenting with anxiety. They're going to have restlessness. They're going to have fatigue. They're going to have impaired concentration, irritability, muscle tension, insomnia. They'll have excessive anxiety and worrying about various activities for more than 6 months. They'll have difficulty controlling their worry, so they're worried about everything. And it's associated with more than 3 of the following symptoms. So the mnemonic I have for that is Macbeth frets constantly regarding illicit sins. So M is going to be for your muscle tension. F is going to be for your fatigue. R is going to be for your restlessness. So we said Macbeth frets constantly regarding. R is for restlessness, illicit. I is going to be for irritability, and then sins we said, right? So the S for these patients is going to be usually for your lack of sleep. So these patients tend to have trouble sleeping also with your, so they have insomnia. So that's my mnemonic. So these patients tend to have more than 3 of these symptoms from your Macbeth frets constantly regarding illicit sin. So they have more than 3 of these symptoms to be diagnosed with generalized anxiety disorder, and it has to be occurring for more than 6 months. Treatment for this is usually psychotherapy and pharmacotherapy, which is best, like I said, if you combine both of them for both depression and anxiety, it's great. So cognitive behavioral therapy and psychotherapy. So if you want to give them something for their acute anxiety attacks, and you can consider something with like benzodiazepines, but of course we want to make sure that we stay away from this. My psychiatrist during my psychiatry rotation was like a stickler when it came down to benzos. So if he did give him benzo, he gave him a very, very low dose of a benzo, and he just told them to take it whenever they had that acute anxiety attack. But usually for long-term treatment, he would put him on like an SSRI or SNRI. His favorite SNRI was venlafaxine, but you can give him SSRIs like fluoxetine for your generalized anxiety disorder. And like I said, it's better if you do pharmacotherapy, and then on top of that, you also do psychotherapy. So panic attack and panic disorders. This is usually a recurrent, unpredictable episode of intense fear response without an identifiable trigger. It's usually associated with genetic cause with this. They'll have psychosocial factors, more commonly found in females and males. And it's a chronic condition. This patient is going to be presenting with dizziness, disconnectedness, derealization, depersonalization, so they feel like they're detached from themselves. The palpitations, paresthesias, numbness, abdominal distress, intense fear, like they're going to die, losing control, or going crazy. Patients will also be presenting with chills, chest pain, sweating, shaking, shortness of breath. So that's why it's important that if you have a patient that presents like this, you want to rule out heart attack, right? So you'll get an EKG on these patients. And with these patients, the diagnosis is that for panic disorder, they have to have 1 or more panic attacks followed by more than 1 month of continuous worry about getting another attack, or change in behaviors where they're avoiding whatever triggered that attack. So if it was like walking onto a bridge, they're avoiding that because they know it's going to trigger another panic attack. Versus a panic attack is just a single episode. A panic disorder is when the patient has already had a previous panic attack and they are worried that they're going to get another attack. So a treatment for this is usually with your medications and cognitive behavioral therapy. Like I said, it's going to be the most effective treatment. First line is going to be your SSRIs. If you want to give them something acute, just for like an acute attack, you can give them a benzo. And usually we start them on benzos because this is going to help bridge the gap between the SSRI. And so this will allow the SSRI to kick in. Because remember, SSRIs usually take up to like 4 weeks to start having effects on the patient. So that's why usually we'll start them on a benzo and then don't refill the benzo. Just keep the patient on an SSRI because we want to stay with benzos, right? Because they have a lot of side effects and they tend to be addictive. So next one's going to be social anxiety disorder, also known as your social phobia. This is a fear of scrutiny or fear of acting in a humiliating or embarrassed way. It's the most common disorder in females, second most common in males. It's an excess fear of specific situations or objects out of proportion to any actual danger or threat. Usually they'll be exposed to a trigger and this will usually cause like this fear response. So these symptoms have to be occurring for more than 6 months to be diagnosed with a social phobia or social anxiety disorder. So these patients tend to avoid the situation or object when possible, and they will tolerate it, but usually with a lot of anxiety. They have significant social or occupational dysfunction. Treatment is usually cognitive behavioral therapy. If we need to give them like an oral medication, then we can do an SSRI or SNRI if they have very debilitating symptoms. And then, like I said, benzos as needed only. And then beta blockers, we can give them also for performance anxiety. So next one is PTSD, post-traumatic stress disorder. This is multiple symptoms or after exposure to one or more traumatic events. This is very life-threatening. Some of the etiologies of this is going to be a threatened death, serious injury, sexual violence. For me, for the burn unit, I have a lot of patients with PTSD. Because of the burn, especially if it's like your patients that present with more like 20% of their body burned, or if they had a significant other that was burned, they tend to have PTSD, and it's really, really sad. I have a patient right now with PTSD, and she has nightmares at night, just like reliving it over and over again. So it's really sad. And in these situations, we consult psychiatry, so psychiatry will come and see them also. So, like I said, with PTSD, it's going to be any trauma that occurred at any time in the past that is causing their symptoms. Said threatened death, sexual violence, more commonly found in females and males. These patients will re-experience their events. Like I said, this patient does. They'll have memories, nightmares, flashbacks. They'll be hypervigilant. They'll have exaggerated startle response. They'll be irritable and angry, impaired concentration. They'll have insomnia. And these symptoms have to last for more than 1 month. If it's less than 1 month, then it's going to be your acute stress disorder. If it's greater than 1 month, then it's going to be your PTSD. Diagnosis is usually the patient has to directly experience or witness a trauma. So the patient doesn't have to go through the trauma. The patient can just be there and have seen the trauma and can get PTSD. Treatment for this is usually cognitive behavioral therapies. We can give them also SSRIs and or SNRIs. And then we have acute stress disorder. So the thing about acute stress disorder, it's the same as PTSD, but the time length is less. So remember we talked about psychiatry being all about lengths. So with acute stress disorder, these symptoms last less than 1 month. So if they have a patient and they present with symptoms of PTSD, they're having these nightmares, they had this trauma, they're hypervigilant, but the symptoms have been going on for like 3 weeks, it's acute stress disorder. Once it's been going on for more than 1 month, then it's PTSD. So acute stress disorder, like we said, less than 1 month. And treatment for this is usually cognitive behavioral therapy. We can give them medications, but usually they're not indicated because it tends to go away right after a month. So next topic is going to be our schizophrenia. Schizophrenia. This is a thought disorder that impairs judgment, behavior, and ability to interpret reality. Okay, and it's a lifelong disorder. It's also known as split mind. Etiology, more commonly found in men than women. It's a very strong genetic predisposition, so if like the father had it, it's very common that the child might have it. It's due to increased dopamine activity. Signs and symptoms, so you have your positive and negative symptoms, and then you also have your cognitive symptoms. So these patients don't even know that they're sick. We have our positive symptoms, which are going to be your hallucinations, delusions, bizarre behavior, disoriented speech. Negative symptoms are going to be your flat, blunted affect, anhedonia, apathy, alogia, lack of interest in socialization. Social isolation is lacking. They'll have cognitive symptoms, which are impairment in attention, executive function, working memory, poor work, and school performance. For phases, it's going to be present in 3 phases. You have your prodromal, psychotic, and residual phase. Prodromal is going to be a decline in function that precedes the first psychotic episode. The patient's usually going to be socially withdrawn. They're going to be irritable. They're going to have physical complaints. They're going to have declining work and school performance. They're going to have newfound interest in religion or occult. And then you have your psychotic symptoms. This is usually where the patient starts getting these perceptual disturbances, delusions, and then they have disordered thought process or thought content. And then they have these residual phase where the patient it occurs following episodes of active psychosis or have mild hallucinations and delusions, social withdrawals, and then they'll start getting their negative symptoms. So how are we going to diagnose these patients? So they have to have at least one of the following symptoms. They have to have delusions, hallucinations, disorganized speech, and they have to have functional deterioration. So at least one of the symptoms has to be one of these, and they have to have 2 or more of the following symptoms: delusions, hallucinations, disorganized speech, grossly disorganized or catatonic behavior, negative symptoms. And these symptoms have to be present for at least 6 months. Okay, that's the timeline, 6 months. Anything less than that is something else, which we'll be discussing. Treatment for this is usually with antipsychotic therapy. Usually for these patients, we want to make sure that we do our second generation antipsychotics or your atypical antipsychotics, right? Because these are safer. They have fewer extrapyramidal side effects. Okay. So that's why we prefer our newer atypical antipsychotics or second generation antipsychotics. And then, of course, behavioral therapy. So let's go into schizotypal disorder. This is a pervasive pattern of eccentric behavior and peculiar thought patterns. They're perceived as strange or odd. Etiology, usually family traits tend to predominate in first degree relatives of those patients with schizophrenia. It's usually chronic. They're going to be presenting with ideas of reference or have like these odd beliefs, magical thinking. So something like clairvoyance, telepathy, fantasies, superstitions. I had a question once on a patient that said that she was outside and she thought she could tell people's futures, and she was outside with like a glass ball, and she was going up to people saying that she could tell them their future, and that was an example of schizotypal. So that's why they have like fantasies, superstitions, inconsistent with culture norms, unusual perceptual experiences, or have bodily illusions, suspiciousness, inappropriate or restricted affect, off or eccentric appearance or behavior. They'll have few close friends or have an odd thinking or speech. Diagnosis is usually with a pattern of social deficits marked by eccentric behavior, cognitive or perceptual distortions, and discomfort with close relationships. So they need to have 5 or more of the symptoms that I discussed. Odd behaviors can also include involvement in cults or strange religious practices. Treatment is usually with psychotherapy. You can also give them low-dose antipsychotics. Once again, which one? It's going to be your second generation, your atypical, because these have less extrapyramidal side effects. They treat both negative and positive symptoms, and they're safer. So then we have delusional disorder. This is a fixed belief where the patient lacks insight. These patients have delusions, but they're not bizarre. So it's not going to be a delusion that they said that there's aliens that are living in his house, right? It's going to be a delusion like, I think that there's someone outside my house spying on me, or I think my husband is cheating on me. So it's going to be delusions that are not crazy, or they're not bizarre. So types of delusions, example, like I said, the CIA is watching me. You have different types. So let's go into each one. You have your erotomanic type. This is a delusion that a person thinks that another person is in love with them. So, for example, they think that Justin Bieber is in love with them, right? You have your somatic type. These are usually physical delusions. During my psychiatry rotation, I had a patient that came in that was 100% sure that he was infested with parasites, and there was parasites in him, and he would scratch his skin so much that sometimes he would dig like really deep into his skin, and so we had to restrain him. But he was 100% sure that he had parasites in him, because he said that he could feel them and he saw them. And then you have your grandiose type. These are delusions of having great talent. Your jealous types, delusions of unfaithfulness. Persecutory type, delusions of being prosecuted. And then there's an unspecific type. And then a mixed type where they have more than one delusion. So diagnosis is where the patient has one or more delusions for at least 1 month. They do not meet the criteria for schizophrenia, and they function, okay? So treatment for this is usually you can give them antipsychotic medications, cognitive behavioral therapy, support therapy, usually no group therapy, right? Because if these patients have the type of persecutory type that they just don't trust anyone, this would not be a good type of therapy for them. Prognosis is that these patients, they have a better prognosis than your patients with schizophrenia, and about 50% of them or more tend to recover. So next we're going to go into brief psychotic disorder. So once again, psychiatry is all about timing. So brief psychotic disorder is very common to delusional disorder. So they're going to have these psychotic symptoms, but it's going to be only from 1 day to 1 month. So it's going to be less than 1 month. So these patients will usually go back to their regular level of function. Usually it's due to a reaction to extreme stress if they're assaulted sexually. Treatment for this is usually brief hospitalization where you stabilize the patient and then they're fine. Supportive therapy, you can give them antipsychotics if they develop psychosis, but usually they don't need them. If they're agitated, you can give them benzodiazepines. So once again, just to go through them, schizophrenia is a lifelong psychotic disorder, right? The patient has to have the symptoms for within 6 months. And then schizophreniform is going to be symptoms of schizophrenia that we discussed, but the symptoms are going to be between 1 to 6 months, okay? So less than 6 months, schizophreniform. Greater than 6 months, it's going to be schizophrenia. Schizoaffective, it's going to be your schizophrenia plus a mood disorder. Schizotypal is a personality disorder like we discussed. They're going to be paranoid, odd. They're going to have magical beliefs. They lack friends. And then we have our schizoid. This is a patient that likes to be alone. So they have solitary activities, lack of enjoyment from social interactions, but they're fine. They function fine. They have no psychosis. They just like to be alone. So the questions that I've gotten, I had one that it was a lab technician that likes to work in the lab and just by himself, and he had schizoid. So next one's going to be your ADHD, attention deficit hyperactivity disorder. This is usually due to persistent inattention, hyperactivity, and impulsivity. So the thing about ADHD is that you have different flavors. You have your inattentiveness, you have your hyperactivity or impulsivity, or sometimes you can have combined. So just make sure that you're aware of that. It's more commonly found in males, usually due to several factors, genetic and environmental factors also. Not very commonly found in your adults, but adults are still diagnosed with ADHD. In adults, though, if it is diagnosed, it's more the type of inattentiveness than the hyperactive one that you would diagnose in your children. So it tends to have tend to be related with oppositional defiant disorder, conduct disorders, and then another thing that you need to know that for girls, the most common flavor or type that you would say is your inattentiveness. For boys, it's going to be your hyperactivity. So signs and symptoms, if it's inattentiveness, they fail to give close attention to details, they have careless mistakes, difficulty sustaining attention, does not appear to listen, they struggle to follow instructions, difficulty with organization, they avoid and dislike tasks that require a lot of thinking, they lose things, they easily get distracted, they are very forgetful in daily activities, hyperactivity, impulsivity, they fidget a lot with their hands and feet, they just can't sit still, they squirm in their chair. When I did my pediatrics rotation, you would see the child was just like, they couldn't stay still in the room. They were like jumping and jumping everywhere. They act like they're driven by a motor. They talk excessively, and that's actually how I've seen it on a question stem. It's literally says they act like they're driven by a motor. They talk a lot. They blurt out answers. They interrupt and intrude others. So these patients have to have at least 6 inattentive symptoms and or at least 6 hyperactivity or impulsivity symptoms to be diagnosed with ADHD. The symptoms have to be present for more than 6 months in at least 2 or more settings. So they have to be present, for example, in both school and at home. They can't only be present at school. They have to be present in more than 2 settings to be diagnosed for ADHD, and it has to be present for more than 6 months. Usually the onset is prior to age 12, but like I said, it can be diagnosed in adulthood. Treatment for this is usually your stimulants. It's going to be your methylphenidate and your dextroamphetamine. If the patient, like the mother, does not want a stimulant, because during my pediatric and my psych rotation, that was one concern that you had a lot of mothers that they hear that stimulants are bad for the brain. You can give them a non-stimulant like atomoxetine that's very, very safe. I've also had questions on these, so just make sure that you know the difference. First line, it's going to be your stimulants, and they are safe drugs. And usually it's going to be your dextroamphetamine or your methylphenidate. If they do not want a stimulant, then you can give them something like atomoxetine. It's a non-stimulant medication. So let's go into autism spectrum disorder. This is going to be an impaired social communication or interaction. The patient has these restrictive, repetitive behaviors, more commonly found in males. And signs and symptoms tend to present between 12 to 24 months. Usually it's a chronic condition with these patients. You also have a different type of, you have Asperger that falls under the autism spectrum disorder, but these patients that have Asperger's are very, very, very smart. They're able to function. Signs and symptoms, inability to hold conversations. They have decreased eye contact. That's usually how you'll read on the question, is that the child would just not look at anyone. You talk to the child and they don't look at you. They'll have lack of interest in peers, preoccupation with unusual objects, rigid thought patterns. So they do these things over and over and over again. Or sometimes it'll say that they put these cars like in a certain pattern, and they like patterns. Hand flapping, hypersensitive to particular textures. They tend to have problems with social interaction and communication. They have these restrictive, like I said, repetitive patterns. That's usually how you're going to diagnose them. Treatment, there's really no cure for these patients. It's just early intervention, like behavioral therapy, psychoeducation. You can give them low dose atypical antipsychotics, especially if they have like if they start acting out for these patients. Domestic violence is another one. It's an abuse between spouses or partners that can take several forms, either physical, sexual, or emotional. It's very commonly associated with alcohol abuse and most commonly lived in violent homes. The abuse and abusers most commonly lived in violent homes. Physical abuse or battering most often perpetrated by a male onto a female partner. Women can batter men, and then it also occurs in same-sex relationships, but it's more commonly in a male hitting a female. Diagnosis is really no gold standard for these patients. Treatment is usually counseling and informing the patient that they can seek care and they can go to a women's shelter, but we do not need to report it. Versus like your elderly abuse and your child abuse, we are mandated to report those cases, but in these cases we don't. We just try if we can to speak to the wife or the individual alone, and then try to help them seek care. And so once again, it's not mandatory reportable. So another one is going to be substance use disorders. This is a problematic pattern of substance abuse, more commonly found in males. And usually it's alcohol and nicotine. And these patients are usually using more than originally intended. They have this persistent desire or unsuccessful cut down on use. So have significant time that's spent on obtaining it, using it, recovering from the substance, craving the substance, failure to fulfill obligations. They have continued use despite social and physical problems. They have a decreased life activities due to substance abuse, and they use it in dangerous situations like driving and mood symptoms. Tolerance, need for increased amounts of substance to achieve desired effect or diminished effect of using the same amounts is what tolerance is. What is withdrawal? Development of substance-specific symptoms due to cessation or reduction when heavy and prolonged use. Diagnosis, they tend to have impairment and distress that is manifested by at least 2 symptoms within a 12-month period. So they have to meet this in order to be diagnosed with substance use disorder. So on exam, you're going to see patients with dilated or constricted pupils. They'll have needle marks. They'll have a nasal septum perforation if they have cocaine use, cardiac dysrhythmias, pathological murmurs, malnutrition with severe dependence. You have bulimia nervosa, which is another topic. This patient is going to present with a recurrent episode of binge eating, okay? They have a perception of self-worth that is influenced by body weight and shape. So a way to differentiate between bulimia and anorexia is that bulimia, they have a BMI that's normal, versus anorexia, their BMI is usually less than 18. Sometimes it's 17, 16. If it's severe, it's like less than 15. Bulimia, it's going to be a normal BMI, because anorexia, you have also your binge eating, and then you have your restricting type, right? So restricting is that the patient is not eating. They're not intaking anything, and they're doing it on purpose because they want to lose weight. And then you have your binge eating, where they eat a lot and they go and they throw up, okay? So just because they're binge eating doesn't necessarily mean, and they're throwing up, does not necessarily mean that they're bulimic. If their BMI is less than 18, then you want to think about anorexia. Versus bulimia nervosa, these patients have a normal BMI. They just binge eat and they vomit. So bulimia nervosa, they have recurrent inappropriate attempts to compensate for overeating and prevent weight gain. So they'll use laxatives, they'll vomit, they'll use even diuretics, fasting, excessive exercise. These patients will have dental erosions. They'll have the Russell signs, which are going to be the calluses on the back of the hands, right? Because they're constantly vomiting, and that's due to like the acid burn from the stomach. And these symptoms have to occur at least once a week for 3 months. And like I said, these patients are usually a normal weight or overweight. Now, can a patient with anorexia have dental erosions and Russell sign if they are the anorexic binge eating type? Of course they can, right? So this is not only, these symptoms are not only for bulimia nervosa, they can also be for your anorexia, binge eating type. Okay, so how you're going to differentiate them is that you have a BMI that's normal or greater than normal, is going to be your bulimia nervosa. If your BMI is less than 18, then you want to think about your anorexia nervosa. Treatment for bulimia is usually with antidepressants and therapy, so you can do cognitive behavioral therapy. And then your antidepressants are going to be your SSRIs. So your first line is going to be fluoxetine. So SSRIs are effective in bulimia, okay? For anorexia, they're not as effective. So for anorexia, we want to focus on making sure that we are refeeding the patient, right? But not too quickly, because we don't want to cause what? Refeeding syndrome. Refeeding syndrome was something that was very commonly found in your patients that came back from the concentration camps during World War II. So those patients that came back from the concentration camps, we fed them a lot, caused refeeding syndrome, and these patients died. So that's why it's really important in these patients that are anorexic, you want to feed them, but slowly. You don't want to cause refeeding syndrome, because it can cause this electrolyte imbalance, and these patients can pass away from that. So bulimia nervosa, like I said, fluoxetine, and your cognitive behavioral therapy. The thing about bulimia nervosa is that we want to avoid bupropion. Why? Because it lowers our seizure threshold. Just make sure that you know that we never give bupropion to your bulimics or your anorexics. So another thing I wanted to discuss was alcohol withdrawal. So with alcohol withdrawal, we want to make sure that we give them benzodiazepines, right? Why? Because we're going to prevent seizures. We also make sure that we want to give them thiamine, folate, and glucose for these patients. Lorazepam, we're going to give them for seizures, and then if they have psychosis, we want to give them haloperidol. And for psychosis, the thing that we want to watch out for is that if we give a patient haloperidol, we want to watch for extrapyramidal side effects and tardive dyskinesia. So we want to make sure that we reverse this with benztropine and Benadryl, because haloperidol can cause these symptoms. All right, guys, so we are done with psychiatry. So when we go into our next topic, which is going to be hematology. Okay, so iron deficiency anemia. This is the most common type of anemia. The thing we need to verify for a patient that's older, if they're presenting with iron deficiency anemia, we want to make sure that we look for colon cancer. Okay, so iron deficiency anemia in older patients, we want to think about colon cancer. Okay, so iron deficiency anemia is a type of microcytic anemia. It's a type of microcytic hypochromic anemia. So what you need to know is that there's different types of anemia depending on the MCV. So MCV between 80 to 100 is normal, but you can have your normocytic anemias that fall between that range of 80 to 100. If it's more than 100, you want to think about your macrocytic anemia. Anything less than 80 is going to be your microcytic anemias. So in this case, for iron deficiency anemia, we're looking at an MCV that's going to be less than 80, right? So the etiology for this is found in children, pregnancy, especially also women that have very heavy menstruations, like we discussed earlier. If they're menstruating too often, also they can get iron deficiency anemia, very commonly found in your vegans, so dietary intake if they have any type of eating disorder, celiac disease, right, because your intestines are not absorbing the nutrients that they should, bariatric surgery, colorectal cancer like we discussed. How is this patient going to present? They're going to be presenting with fatigue, pallor, tachycardia, palpitations, dyspnea. They're going to have a smooth tongue, also known as your glossitis. They're going to have these brittle spooning of the nails. They're going to have cholonychia. They'll have pico. So I had a patient that came in. I remember during my pediatric rotation, I had a child that came in, and the mom was concerned because she all of a sudden was eating dirt, and this was not something that was common to her. And so we ended up doing, of course, looking at her iron panel, CBC, and she ended up having iron deficiency anemia. So that's another way that they can present also. So diagnosis, it's going to be a microcytic anemia, like we said, MCV less than 80. They're going to have a low hemoglobin, low serum iron, low reticulocyte count, low ferritin, but they're going to have a high TIBC. So they're going to have a high total iron binding capacity because it's there. It's waiting to bind to iron, but there's nothing there. There's nothing to bind to. So that's how I think about it. You want to make sure that in these patients, once again, if they're older, like in their 50s, 60s, you want to think about colorectal cancer, so you want to make sure that we rule this out. Treatment is usually ferrous sulfate, usually oral. You can also give it IV, but it's usually oral. And then make sure that you educate the patient on increasing their dietary iron. So thalassemias, we have different type. We have thalassemia A. This is lack of alpha chains, and they have excess beta chains. Usually with alpha thalassemia, they have these teardrop cells. This is a type of microcytic anemia, so it's going to be an anemia with MCV less than 80. This is another way that you can differentiate between the types of anemia. Usually they'll give you like a lab and you look at the MCV, and that's how you can, if you know that thalassemia, for example, is a microcytic anemia, you want to look at the MCV. If it's less than 80, you can rule it in. If it's greater than 80, then you can rule it out. So treatment for this is going to be folic acid, blood transfusions, bone marrow transplant, commonly found in your Asians for thalassemia A. Then you have your thalassemia B. So with thalassemia B, it's going to be your lack of beta chains. So whatever the letter is, that's what they're lacking. So if you notice thalassemia A is lack of alpha chains, thalassemia B is going to be your lack of beta chains. They have excess alpha chains in thalassemia B. They have these teardrop cells. usually commonly found in your Mediterranean individuals. They can also get coolie anemia, which is severe form. These patients are going to be presenting with dyspnea, jaundice, pallor. Diagnosis is going to be a microcytic anemia, right? Their MCV is going to be less than 80, and treatment is going to be iron transfusions. Usually also you can do a splenectomy and then genetic counseling. And then we have our aplastic anemia. This is a type of normocytic anemia. So the MCV is going to be between 80 and 100. So for aplastic anemia, this is a very rare disease. It's usually due to damaged bone marrow and stem cells that causes deficiency of all three blood cell types. So it causes a deficiency in your red blood cells, your white blood cells, and your platelets. So that's why it's called pancytopenia, because they have a deficiency in all three blood cell types. Etiology is usually an inability of the stem cells to generate mature blood cells. Other causes are parvovirus B19, Epstein-Barr virus, hepatitis, HIV, radiation, certain medications, idiopathic, autoimmune disorders. Diagnosis, we're going to do a CBC. We're going to see normocytic anemia, right? So the MCV is going to be between 80 to 100. They're going to have pancytopenia, decreased reticulocytes, increased EPO, so erythropoietin. We're going to do a bone marrow biopsy. We're going to see a normal or empty fatty marrow or dry tap. Treatment is usually going to be your hematopoietic cell transplantation. This is going to be a definitive treatment for your aplastic anemia. So then we have hemolytic anemia. This is anemia due to destruction of red blood cells by autoantibodies on the red blood cell surface. Autoimmune hemolytic anemia. So you have different types. So you have your warm, which is idiopathic, and then you have your cold type, which is an infectious type. So let's go into each one. So from hemolytic anemias, you have that umbrella, and under that umbrella follows the autoimmune hemolytic anemia, which we're going to discuss. So for autoimmune hemolytic anemia, usually the onset is insidious or acute. They'll present with pallor, fatigue, activity intolerance, jaundice. If it's severe, they'll have cardiac symptoms like tachycardia, bounding pulses. Diagnosis, you'll see that they have an increased LDH, they have an increased indirect bilirubin, they have a low H&H, and then if it's warm hemolytic anemia, then what you're going to see is that they're going to have a positive IgG, plus they'll have a C3d. If it's cold, they'll have a positive C3d. On peripheral smear, you're going to see spherocytes for your hemolytic anemia, and treatment's going to be with corticosteroids, monoclonal antibody like rituximab, immunosuppressions. Splenectomy is usually the definitive treatment because this is going to reduce the hemolysis. So with how we think about anemias is that you have a problem with production or destruction. So iron deficiency anemia is a problem with production, right? When we're thinking about hemolytic anemias, these are a problem with destruction. So that's how I think about these, is that there's a problem with either production. So in your macrocytic anemias, right, your vitamin B12 deficiency anemias, your folate deficiency anemias, that's a problem with production. But in your normocytic anemias, like hemolytic anemias, like the ones we're discussing, that's a problem with destruction. So that's why the treatment for your hemolytic anemia, for example, for your autoimmune hemolytic anemia, the definitive treatment is going to be a splenectomy, because that's going to decrease the hemolysis that is occurring. It's going to decrease the hemolysis. So this is why for autoimmune hemolytic anemias, like we discussed, this is a problem with destruction. And getting rid of the spleen is going to decrease the spleen from destroying these red blood cells, which is making the patient anemic. So under that hemolytic anemia umbrella, we also have hemolytic disease of the newborn. This is anemia by fetal or neonatal red blood cell destruction due to the maternal antibodies. So the mom's own antibodies are attacking the baby's fetal red blood cells. So that's why they develop anemia. It's usually due to Rh incompatibility. So Rh negative mommy is exposed to Rh positive babies, red blood cells, and that's what happens. The thing about this is that it does not affect the first pregnancy, but it does affect the second and third, and then so on pregnancies. Why? Because on the first pregnancy, the body gets primed, so they're ready. okay? They're getting prepared, they see it, they get prepared, and then by the time the mommy has a second one, they're already ready and they attack. So that's why it doesn't affect the first pregnancy, but it's going to affect the second and third pregnancy. And once again, since this is very highly tested, you need to know that it's going to be an Rh negative mom that is exposed to an Rh positive fetal red blood cell. Or even if the mom is Rh negative and the dad's Rh positive, you have to make sure that we treat these patients. Okay, so signs and symptoms: jaundice, hyperbilirubinemia, especially in the first 24 hours, kernicterus, pallor, lethargy, tachycardia, tachypnea, hydrops fetalis. Diagnosis is going to be with an Doppler ultrasound. We want to do an antenatal testing, Coombs test, blood typing, look for the incompatibility, right, for these patients. And then treatment's going to be your hematopoietic agents like epoetin alpha, iron supplements and blood cell transfusions, phototherapy, and IVIG. So the next one we're going to go into is going to be your sickle cell anemia. This is genetic. What happens is that there's a point mutation of the beta globin gene that causes your HBS. So with these blood cells, they're abnormally shaped. So they look sickle shaped, or they look, how I would describe it as like not the full moon, but when the moon is half, that's how they look like. And if you think about it, when they're going through the vessels, right, these types of blood cells are more commonly prone to get stuck. And they get stuck more commonly in the smaller arteries, right? So since these blood cells are sickle shaped, they're abnormal, they have decreased lifespan because they are constantly being removed by the spleen. So it causes hemolysis. Very commonly found in your African Americans, especially your males. These patients have increased risk of infection. Why? Because they tend to auto-infarct their spleen. So what happens is that they auto-infarct their spleen. So their spleen is not working anymore. Usually by the age of like 30 or 20, they've already auto-infarcted their spleen. And the spleen is responsible for your immune system, right? Creating all those little guys in your body that are going to fight off all the infections of viruses. And if you don't have your spleen, these patients are more prone to getting like bacterial infections, especially like your encapsulated bacteria, your streptococcus. So that's why it's important that in these patients with sickle cell anemia, we are vaccinating them against bacterial infections. And we are giving them their vaccinations because these patients are more prone to getting infections because the majority of them had already auto-infarcted their spleen. So another thing you need to know is that this is autosomal recessive. It's another thing that's very highly tested. So once again, autosomal recessive. This patient is going to be presenting with fatigue, delayed growth, activity intolerance, infections, joint pain, fever, jaundice, hypersplenism, splenomegaly, if they have their spleen still there, hepatomegaly. On peripheral smear, you're going to see sickled target cells. They'll have a decreased H&H, so hemoglobin and hematocrit. They'll have decreased red blood cells. You'll see reticulocytosis. So the body is still making those new red blood cells because all the red blood cells are getting destroyed. So a definitive diagnosis is going to be a hemoglobin electrophoresis. And treatment is usually oxygen, fluids, pain control, especially if they have these like acute sickle cell crisis or acute chest syndrome. Folic acid, iron, antibiotics like penicillin, like we said, for infections, since these patients are more prone to getting your encapsulated bacteria infections, red blood cell transfusions, and then immunizations like we discussed to prevent infection. I can probably make a whole video on sickle cell anemia because I just find it so interesting. Another thing that's very interesting is that with sickle cell anemia, like we said, it's more commonly found in African Americans, very commonly found in the country of Africa. Sickle cell anemia protects patients, individuals, from getting malaria, which is very interesting. So malaria is endemic in the country of Africa, right? It's carried by your mosquitoes. It's a parasite. It's very deadly. There's different types of malaria. So malaria, in patients that have sickle cell disease, they're protected from getting malaria. So of course, there's been like I hear a lot of podcasts, I watch a lot of YouTube videos because I find infectious diseases very interesting. So there's been scientists that have been saying that maybe the body has still kept this gene going on for these patients that have sickle cell disease, because it's a type of protective measure to protect them against malaria, because malaria has been going on for years, for hundreds of years, one can say. And so that's what they think. So I just find that very interesting with malaria, is that patients with sickle cell disease are protected from malaria because that parasite has trouble infecting those sickle cell shaped red blood cells. So I just thought that was interesting. Okay, so the thing about sickle cell you need to know is that they have these sickle target cells, right? These patients are very prone to getting infections because most of them had already like auto-infarcted their spleen. So we want to make sure that we vaccinate these patients against like encapsulated bacteria, like I said, Streptococcus pneumonia, so your pneumonia vaccinations. And then whenever these patients get like acute chest syndrome, it's very, very painful. We want to make sure that we're giving them IV fluids and pain medications. So let's go into sickle cell crisis. This is going to be pain from an acute vaso-occlusive crisis. So like I said, these red blood cells are sickle cell shaped. They're not sphere shaped, or they're not shaped normally. And so what happens is that when they're traveling in the vessels, right, they're more prone to get stuck, especially in your smaller arteries. So they're more prone to get stuck there. And when they do, they cause these sickle cell crises. The cells sickle and they cause vasoocclusion. They get stuck in the blood vessels. So some of the causes of this is going to be elevated altitude, so patients have less oxygen. If the patient's dehydrated, if they're stressed out, hypoxic, or if they're acidotic, these things tend to put a patient that has sickle cell anemia into sickle cell crisis. So I have questions on them. I think I had one question where it said that there was a child that had sickle cell and they wanted to go to a high altitude. What would you tell them? So just make sure that you are familiar that anything that's elevated altitude that has less oxygen can cause acute sickle cell crisis. So how's this patient going to present? They're going to have acute pain in their small bones. Why? Because they have this vaso-occlusion, swelling of the hands and feet, right? Because we have these vessels that are a lot smaller here, so they're more prone to getting stuck here. The patient's also going to be presenting with dactylitis. They'll have stroke, moya, TIA, seizures, MIs, multi-organ failure, avascular necrosis, splenic infarct, right? Because we said due to splenic sequestration of backup of the blood, acute chest syndrome. Treatment is usually going to be oxygen and fluids, and then this is going to be done to manage pain. If needed, we can give blood transfusions and cell transplantation, but it's usually just oxygen and fluids and making sure we're giving them pain medication like opiates. So now we're going to G6PD anemia. So this is an X-linked anemia. It's due to a lack of protection for red blood cells. So red blood cell damage occurs, very commonly found in your African American males. This patient is going to be presenting with abdominal pain, dark urine, jaundice, pallor, splenomegaly. Sometimes these patients don't even know they have that until they take a certain medication and it throws them into G6PD anemia. So for example, your sulfonamide medication, certain medications. Diagnosis is that you'll see bite cells, Heinz bodies, high reticulocyte count, high bilirubin. Treatment's usually going to be with your folic supplements or your iron supplements. If it's an acute episode, we want to make sure that we hydrate them, and if needed, we can do transfusions. Vitamin B12 deficiency. This is going to be a macrocytic type of anemia. So once again, vitamin B12 deficiency, we said a macrocytic, so it's going to be greater than 100, right? Very commonly found in your vegans. You have your pernicious anemia also, which is a type of autoimmune anemia. This patient is going to be presenting with slow onset pallor, glossitis, anorexia, diarrhea. The thing about vitamin B12 deficiency and folate deficiency, because they present very similar, the only way sometimes you can diagnose is by doing the labs, right? But in regards to symptom-wise, is that vitamin B12 deficiency is going to present with neurological symptoms versus folate deficiency is not going to present with neurological symptoms. So just make sure that you know that. I actually was diagnosed with vitamin B12 deficiency anemia like a year ago. And yes, I had those symptoms. I did not have the full onset like ultramentositis, but I did have some tingling and numbness and like paresthesias and like my fingers and my lower extremities, and I was freaking out. And yes, it ended up being vitamin B12 deficiency. So these patients, like I said, they'll have paresthesias, ataxia, weakness, they'll have these neuro symptoms. Labs, we're going to see that they have a low B12. It's usually a megaloblastic anemia, right? It's going to be an MCV that's greater than 100. And treatment is usually going to be an intramuscular vitamin B12 monthly. You can also give them oral cyanocobalamin and hydroxycobalamin. And then we have folic acid deficiency, very commonly found in your alcoholics. Okay, these patients, like I said, are going to present similar to vitamin B12 deficiency with your pallor, glossitis, anorexia, but they will not have any neuro symptoms. You're going to, labs, you're going to see a megaloblastic anemia, right? MCV greater than 100. They'll have a normal vitamin B12, but they're going to have a low folic acid. Treatment's going to be with your folic acid 1 milligram oral once a day. Hemophilia A. So hemophilia, how I think about them is that they love to bleed, right? Hemophilia A and hemophilia B is differentiated between what coagulation factor is missing. They present similar, both of them, but the way you're going to diagnose them is depending on the factor they're missing, and that's how you're going to treat it, is that you're going to replace that factor. So hemophilia A is a deficiency of coagulation factor 8. So this is both of the hemophilias are hereditary X-linked recessive, and they're very commonly found in men. Also very commonly found in patients with liver failure, vitamin K deficiency, and then DIC. These patients are going to be presenting with easy bruising. They'll have ecchymosis, hematomas, prolonged bleeding, GI bleeding, hematuria, and epistaxis, and usually it'll say hemorrhosis on your question stem. So it says that they have like an inflamed like joint or knee. That's usually what it says, and it's like red, or hemorrhosis. You want to think about hemophilia. It's usually like pathognomonic like buzzword for hemophilias. Diagnosis, we're going to do a platelet count, right? It's usually going to be normal. We're going to check their PT and PTT. So their PT checks their extrinsic and common pathway. This is going to be normal, right? Because it's missing factor 8, and factor 8 is found in the intrinsic pathway, right? So the PTT is going to be prolonged, not the PT. So that's what you need to know, is that for your hemophilias, your platelet count is going to be normal, your PT is going to be normal, but your PTT is going to be prolonged because they are missing factor 8 for hemophilia A and factor 9 for hemophilia B. We're going to confirm the test by testing the specific factor activity. So for example, in this case for hemophilia A, factor 8. And then treatment for hemophilia A is going to be, we're going to supplement the missing factor. So we're going to give cryoprecipitate or desmopressin. So cryoprecipitate is a recombinant factor 8. So we're replacing the missing factor, factor 8 for hemophilia A. And then we're going to educate the patient on avoiding contact sports and any medications that can promote bleeding like aspirin. So hemophilia B is going to present the same way like hemophilia A. This patient's going to have, right, your hemorrhosis, easy bleeding, but hemophilia B involves deficiency of coagulation factor 9. It's also known as Christmas disease. We're going to confirm the test by doing a specific factor activity. So in this case, it's going to be factor 9, right? We said the PTT is going to be prolonged in both hemophilias, but the PT and the platelet count are going to be normal. Treatment for hemophilia B is going to be recombinant factor 9. And then once again, we're going to tell the patient to avoid contact sports and any medication that can promote bleeding like aspirin. Next one's going to be von Willebrand disease. This one's very highly tested, so make sure you're familiar with this one. This is due to deficiency of von Willebrand factor or factor 8. So factor 8 carries von Willebrand factor. So etiology of this is liver failure, vitamin K deficiency, DIC. It's the most common congenital bleeding disorder, and it's very commonly found in Caucasians. So usually on the question stem, it'll say that the uncle or their dad or the brother also has this bleeding disorder. And that's where you're like, you know what, it's von Willebrand's, because von Willebrand's, it has a very, very high association with congenital bleeding. So health maintenance for these patients, just make sure you tell them to avoid aspirin, right? Anything that's going to make them bleed more because they're already missing that von Willebrand factor. They're going to be presenting with mucocutaneous bleeding, epistaxis, gingival bleeding, cutaneous bruising or ecchymosis, menorrhagia, hemarthrosis. Diagnosis, we're going to do a platelet count, a PT, and a PTT. We're going to look at their von Willebrand factor and antigen. And treatment is usually with desmopressin or von Willebrand factor concentrate. Next one's going to be DIC or disseminated intravascular coagulation. So what happens is that there's widespread clotting and it depletes all the clotting factors. And signs and symptoms, patients can present them with shock, sudden occurrence of bleeding, petechiae, ecchymosis, peripheral gangrene, thrombosis. They'll have decreased platelets and fibrinogen. They're going to have a prolonged PT and PTT. They'll have an elevated D-dimer, right, because they're clotting. Treatment for this is what we want to treat whatever is causing the DIC and support the organs. So if they're hypoxic, make sure that we are placing the patient on a ventilator, right? If they have a clotting factor depletion, we want to make sure that we're transfusing the patient. Complications of DIC is usually clotting and bleeding. And then if it's clotting, they'll have ischemia and necrosis and organ damage, usually to the kidneys, liver, and lungs and brain, right? Because when you're clotting, you're not getting blood perfusion to that organ, and that's why you're going to have a failure of these. So polycythemia is the next one. That's when the patient has many cells in the blood. This causes an increase in red blood cells, white blood cells, and platelets. Etiology is that they have decreased plasma volume, increased hematocrit. Primary cause of this is that they have decreased EPO, so things like polycythemia vera or erythrocyte receptor mutation. Secondary causes can be like hypoxia or an erythropoietin secreting tumor. So how is this patient with polycythemia going to present? They're going to have bruising, bleeding, erythromelalgia, so red. Their feet are going to be red and painful. They'll have aquatic pruritus, which is itching after a hot shower because they're releasing all this histamine release. And that's usually how they're going to present with polycythemia vera, is you have a patient that just got out of the shower and all of a sudden they're very, very itchy with polycythemia vera. They're also going to be presenting with tortuous renal veins, visual disturbances, headaches, dizziness, tinnitus, deafness, vertigo, gout, hepatosplenomegaly. And then diagnosis for this is usually with a CBC. You're going to see increased red blood cell, white blood cell, and platelets. And then on an x-ray, if there's a secreting tumor, you'll see that also. So that's where we do x-rays. And then, of course, look at their erythropoietin levels. Treatment's going to be with phlebotomy. We can also give them aspirin. And then complications, if polycythemia is not treated, is that they can get Budd-Chiari syndrome, get stroke, or develop myocardial infarction. So thrombocytopenia, this is going to be a decrease in circulating platelets in the blood, usually less than 100,000 ml. Some of the causes of this is decreased production or increased destruction or even medication induced. So we want to think about medications like heparin, right? We can have heparin-induced thrombocytopenia, which is very commonly associated with your heparin. How is this patient going to present? They're going to have petechiae, they're going to be bleeding, they'll have epistaxis, they'll have melena, hematemesis, GI bleeds, hematuria. Diagnosis is going to be with a CBC. You're going to see decreased platelets, bone marrow, aspiration. Another way you can diagnose thrombocytopenia. Treatment is platelet transfusions. We want to make sure that we place the patient on bleeding precautions. So avoid any type of invasive procedure that can make the patient bleed even more. Tell them to use like a soft bristle toothbrush. And then avoid any medication that can cause interference of coagulation. So leukemias. So leukemia is a cancer of the white blood cell. There's 4 types. So how you differentiate them is depending on whether it involves a myeloid or the lymphoid cell origins. Okay, and then also each type of leukemia is very commonly found in certain type of patients and ages. So for example, ALL is the most common pediatric cancer. It's the most common type of leukemia in children. I had a question on this during my pediatric end of rotation exam. I was towards the end and I was running out of time. All I read was that it said it had immature lymphoblast and it was a child that had it. So I chose AL. That's an easy point, just if you know and you're able to make those connections between age and then also the common type of leukemias that exist in regarding to what patient population it's affecting. So like I said, ALL is acute lymphoid leukemia. It's the most common pediatric cancer. It's a proliferation of immature lymphoid cells, so it involves your B and T cells. It's due to radiation exposure. It's very commonly found also in Down syndrome after the age of 5. How is this patient going to present? They're going to present with rapid onset of fatigue, fever, pallor, bone pain, joint pain. They're going to have lymphadenopathy. Usually that will give it away. And also bleeding. So they'll have this petechiae, it's purpura, epistaxis. They'll have gingival bleeding, menorrhagia, ecchymosis, anorexia, and then sometimes if they have a mediastinal mass, it's associated with your T cells. How are you going to diagnose this? You're going to do, you're going to see some immature white blood cell. So you'll see blasts in the blood smear. They're going to be greater than 20%. So it's going to be your key, right? If you look at the labs and it tells you it's a child, they have this gingival bleeding, they have lymphadenopathy, joint pain, fever, and it's like rapid in onset. And then you look at the labs and it says that most of the white blood cells that you see are blasts and they're immature white blood cells, and it's greater than 20% on a blood smear. You want to think about anything that is acute. And then in these cases, you want to think about acute lymphoid leukemia for these patients, okay? So another thing that you'll see is pancytopenia, and you're going to do a bone marrow biopsy for these patients. Treatment's going to be with combination chemotherapy, central nervous system prophylaxis, and stem cell transplants. Patients tend to have a very good prognosis, which is a good thing. So let's go into acute myeloid leukemia. This is very commonly found in your older patients, 50 to 60s. It's due to sometimes and associated with radiation exposure for these patients with AML. Also very commonly found in patients that have Down syndrome before the age of 5. Signs and symptoms: rapid onset fatigue, fever, bleeding, headache, confusion, dyspnea, pallor, purpura, petechiae, epistaxis, gingival swelling and bleeding. On diagnosis, you're going to see once again your immature white blood cells. The blasts are going to be in the blood smear, are going to be greater than 20%, right? Because this is acute. And you're going to see pancytopenia. You're going to do a bone marrow biopsy. For these patients, what you need to know is that you're going to see positive hour rods. So hour rods are associated with AML. Just make sure that you know that. How I think about it is hour rod starts with A, right? AML starts with A, and that's how I think about this. Treatment is going to be combination chemotherapy. Sometimes you can do an allogenic stem cell transplant also if needed. So once again, to differentiate between ALL and AML, AML is more commonly found in your older patients, right? We said it was between the ages of 50 to 60, versus ALL, it's more commonly found in your children. Both of these affect patients that have Down syndrome. But what you need to know is a patient population. Also, that what you're going to see on your blood smears is that you're going to see blasts, and they're going to be immature blasts, immature white blood cells, and they're going to be greater than 20% for both of them because it's acute, right? Okay, and that's how you'll be able to differentiate between both of them. Another thing is that AML is going to tell you that there is positive hour rods. Another one that you need to know is that a CML. CML is associated with what? Your Philadelphia chromosome. So if you see a Philadelphia chromosome, that is going to be your CML versus your CLL. CLL is another type of cancer that's very commonly found in your older patients. And with these patients, they tend to have also a very good prognosis with your CLL. So once again, just to go over it, ALL more commonly found in children, right? It's a type of leukemia. You'll see a lot of more immature blasts, more than 20% for both ALL and AML. AML is going to be found in your older patients. You're going to have hour rods for these patients. And then for CLL, you'll see smudge cells on your, when you diagnose these patients, you're going to see smudge cells. That's what's pathognomonic for CLL. It's more commonly found in your older patients and has a very good prognosis. And then CML, you're going to see your Philadelphia chromosome. So these are all type of leukemias. These are the buzzwords that you need to know that are associated with them. How I memorized CML is like CU in Philadelphia. So that's how I memorized it, the Philadelphia chromosome CML. Okay. So now we're going to go into Hodgkin's lymphoma and non-Hodgkin's lymphoma. So what you need to know about these is which one is associated with your Reed-Sternberg cells. So it's going to be your owl eyes. So that's going to be your Hodgkin's lymphoma. Make sure that you know that. It's going to be your Reed-Sternberg cells, owl eyes. That's what you're going to see on your CBC for Hodgkin's lymphoma. So Hodgkin's lymphoma is a malignancy of the lymphoid tissue. It's the third most common type of malignancy in children, but it tends to have a bimodal peak in both children and adults. So it can be found in both children and adults. The cause is idiopathic. They think that Epstein-Barr virus is somehow involved with Hodgkin's lymphoma. It's very rare in children under the age of 5, and this patient is going to present with a painless, firm mass or lymphadenopathy. Usually it's going to be in the supraclavicular area and in the cervical area for these patients. They're going to be presenting with hepatosplenomegaly, and they'll have B symptoms. So they'll have fever, they'll be having night sweats, unintentional weight loss. Usually the weight loss is going to give it to you. So if you read a question and it says patient has weight loss, and then on top of that, they have painless lymphadenopathy, and it's supraclavicular or cervical, then you want to think about a malignancy. You want to think about Hodgkin's lymphoma. And then diagnosis is going to be a tissue biopsy on CBC. Like I said, we're going to see those Reed-Sternberg cells. It's going to be owl eyes. Sometimes they'll just give you a picture. On chest x-ray, you're going to see a mediastinal mass. And treatment's going to be with chemotherapy or low-dose field radiation. Prognosis is that Hodgkin's lymphoma has a better prognosis in comparison to non-Hodgkin's lymphoma. So just make sure that you know that Hodgkin. If you want to, obviously we don't want to have any of these, but out of the two, Hodgkin's lymphoma is a better one to have. Okay. So let's go on to the next one. It's going to be non-Hodgkin's lymphoma. This is going to be a malignancy of the lymphoid tissue. It's the third most common type of malignancy in children. There's different types. You have your B cell type, which is also known as your Burkitt lymphoma. You have a T cell type, and then you have your large cell type. So causes of this, it's usually idiopathic. Once again, they think it's involved possibly with Epstein-Barr virus. It's very malignant, and it's very commonly found in whites, so very commonly found in your Caucasians, also very commonly found in your males more than females. How is this patient going to present? They're going to be presenting with symptoms similar to Hodgkin's lymphoma, so it's going to be your fever, drenching night sweats, unintentional weight loss, and if the patient has a Burkitt type of lymphoma, which involves the B cells, we said they're going to have involvement of the abdomen. Diagnosis is we're going to confirm with the tissue biopsy, right? And we also want to examine the pleural and peritoneal fluid. We're going to do a CBC, electrolytes, CSR, ESR, and then a chest x-ray. We're going to see a mediastinal mass. Treatment for this is going to be with systemic chemotherapy, radiation, methotrexate, doxorubicin. These are all your cancer medications. And then the prognosis is very bad for this because it metastasizes very quickly with this one. So once again, with Hodgkin's lymphoma, make sure that you know it's associated with the Reed-Sternberg owl eyes. It has a better prognosis in comparison to non-Hodgkin's lymphoma. Non-Hodgkin's lymphoma has a worse prognosis because it can diffuse very, very quickly. And the best way to diagnose these is going to be with a tissue biopsy. Okay, great. So now we are done with hematology.